Hi guys, welcome back everyone. So there were some technical glitches, so that's why we couldn't go live on time. Now that the things are sorted, so let's get going. Okay, so we will be spending around 3 to 4 hours trying to cover the important topics from medicine. This is not an exhaustive discussion, so if you want to study in detail about any topics, I have a lot of videos on the YouTube, you can go through that. This is mainly meant for the FMGE students who are about to give the upcoming exam. So I want to keep it crisp and concise, trying to touch the important points and not into the unnecessary details or nitty-gritties. Okay, so let's start with the cardiology. Now, what are the important topics from cardiology? You are certainly expecting one question on either pulse or JVP. So important topics from cardio includes pulse and JVP. You're expecting one question between them, either on the pulse or on the JVP. Almost every exam has a question on JVP. If not, then it is pulse. Then you're expecting one question on valvular heart disease. Valvular heart disease. Trying to ask you to either just pick up the diagnosis based on the murmur description, or sometimes they are asking named murmurs. So that is one question that we are expecting. Another question we are going to get from heart failure. This question is most likely going to be from the pharmacology, but sometimes it can be from medicine. So heart failure is also an important topic for us. Okay. Apart from that, we might also get questions on cardiac tamponade versus constrictive pericarditis, asking you to differentiate between cardiac tamponade and constrictive pericarditis. And then you might also expect questions on ECG, but among the ECG, AV blocks are the important topics. Apart from that, the PSVT versus atrial fibrillation. So these are going to be the important topics from cardiology. So let's start addressing one by one. So we'll first begin with the pulse. First, let's understand the normal pulse waveform. Normal pulse waveform looks like this. In the normal pulse waveform, you have one upgoing limb which is called as the percussion wave. This will be called as the percussion wave. They will ask you what is the reason for this percussion wave. And then we have another upgoing limb called as, this one will be called as tidal wave. So from physiology they might ask you what is the reason for this tidal wave. And then you have one more wave, this one. This is called as dicrotic wave. Dicrotic wave. So percussion wave, basically pulse is a wave which is triggered by the ejection of blood by the left ventricle into the aorta. So during systole, when left ventricle pushes the blood into the aorta, it triggers a pressure wave. That pressure wave is traveling through the blood vessels as your pulse. So percussion wave is primarily the main wave which is due to the left ventricular ejection of blood into aorta. Blood into aorta. So as the left ventricle ejects the blood into the aorta, it triggers the pressure wave. But when we eject the blood into the aorta, we stretch the aorta. And as an aorta gets stretched, because there is an equal and opposite reaction from every action, the aorta recoils. The recoil of the aorta increases the pressure inside the aorta and you get another wave which we call as tidal wave. So tidal wave is due to recoil of aorta. Recoil of aorta. So you eject some blood into the aorta, trigger percussion wave, aorta gets stretched, aorta recoils and gives you one more wave, that is tidal wave. Now from where the dicrotic wave is coming? As the pulse wave travels through the blood vessels, there will also be a reflected wave coming from the periphery, because everything should have an equal and opposite reaction as per the physics. So reflected wave from periphery produces another wave which we call as dicrotic wave. The point to note here is that reflected wave that is coming from the periphery, we also call it as the peripheral vascular resistance. So in technical words, we would say dicrotic wave is due to peripheral vascular resistance. Is due to peripheral vascular resistance, or PVR. You can also call it as systemic vascular resistance or SVR. This is your normal pulse wave. MCQ is what we are expecting here. What is the reason for percussion wave? What is the reason for tidal wave? What is the reason for dicrotic wave? Okay. Now, between the first tall mountain and the second tall mountain, you have a deep notch. This notch is called as dicrotic notch and it corresponds to the second heart sound. So they have also asked this, what dicrotic notch corresponds to. Dicrotic notch corresponds to the second heart sound. So this is going to be your dicrotic notch. This notch is the dicrotic notch and it corresponds to the second heart sound. Corresponds to second heart sound. All of these are important physiology MCQs. Now from this we should also understand that this pulse has a peak. This peak is nothing but your systolic BP and the peak of dicrotic wave is your diastolic BP, right? So this corresponds to the peak of this wave corresponds to systolic BP and this peak corresponds to diastolic BP. Okay. Now the peak is directly going to be proportionate to the stroke volume. If I eject more blood into the aorta, it produces stronger pulse wave. If I eject less blood into the aorta, it produces weaker pulse wave, right? Okay, so that is basic that we need to know. Now coming to what can be asked from medicine. Mostly in medicine they have asked 2 or 3 important MCQs on the pulse. The first and most commonly asked pulse MCQ is pulsus bisferiens. Pulsus bisferiens. So what is pulsus bisferiens? The name says it. Bis means 2. So normally we have one peak that comes in the systole and one peak that comes in the diastole. But some individuals you will see 2 peaks in the systole and then one in the diastole. Getting 2 peaks in the systole is what we call as pulsus bisferiens. Pulsus bisferiens. 2 peaks in systole. In systole. We will call it as pulsus bisferiens. Now where do we get this pulsus bisferiens? Pulsus bisferiens is encountered in patients with aortic regurgitation, HOCM, and sometimes in patients with AS plus AR. AS plus AR. These are the causes for the pulsus bisferiens. If you ask me, sir, I can remember only one from the pulse, what it should be, then I would always say remember pulsus bisferiens, because they use it as a clue for HOCM in many MCQs. Okay. The next one is pulsus parvus. I will address the pulsus paradoxes also a little later. Pulsus parvus. Pulsus parvus simply refers to low pulse peak. This peak, if it becomes smaller, we will call it as pulsus parvus. So low pulse peak, we will call it as pulsus parvus. And as I have already told you, your pulse peak is going to be proportionate to stroke volume. So less the stroke volume, less the peak of the pulse. So any condition where there is decreased stroke volume, it is seen. Okay. Then you have this pulsus et tardus. Pulsus et tardus refers to peak appearing late, delayed peak. Instead of peak appearing here, it appears little late. Then we will call it as delayed peak. Delayed pulse peak is pulsus et tardus. Tardus means slow. When you say somebody is tardive, that means he is very slow, lethargic. So pulse is slow, lethargic and appearing late. We will call it as pulsus et tardus. This is seen in patients with left bundle branch block. In patients with LBBB, left bundle branch block. Okay. Then comes the second most commonly asked MCQ from the pulse, that is pulsus parvus et tardus. It's not et tardus. My team has done a small typing mistake. It is pulsus parvus et tardus. Means it is a combination of 2 pulses, pulsus parvus and pulsus et tardus. Parvus plus et tardus means low peak, late peak. Low and late peak. You will call it as slow rising, late peaking pulse. This is typically encountered in patients with severe aortic stenosis. It's a hallmark of severe aortic stenosis cases. So pulsus bisferiens and pulsus parvus et tardus you can't afford to forget. Both of these are important MCQs. Smooth specialist, this is live. Okay. So now pulsus paradoxes is the next thing that I want to address. Pulsus paradoxus. Now what is this pulsus paradoxus? Pulsus paradoxus refers to drop in systolic BP by more than. So first, those who are not aware should know that normally systolic BP decreases during inspiration. By up to 10 millimeters of mercury. Why does that occur? Because during inspiration, right side of the heart gets more blood, left side of the heart gets less blood. So if left heart is getting less blood, it ejects less. If it is ejecting less amount of blood into the aorta, BP decreases. That's why during inspiration, we have relatively lower BP. How much difference we can expect? If the systolic BP during expiration, I'm just giving you example, during expiration is 120 millimeters of mercury, then during inspiration it can drop up to 110 millimeters of mercury. That's fairly normal. So our BP is not same throughout inspiration and expiration. But in certain conditions, there will be more than 10 millimeters of mercury decrease in systolic BP. That is what we call as pulsus paradoxus. So pulsus paradoxus refers to more than 10 millimeters mercury decrease in systolic BP during inspiration. Now, what conditions we can get it? There are a lot of conditions that we can get it, but for an exam going student, what I want you to remember is the cardiac tamponade. More than 10 millimeters of mercury drop in systolic BP during inspiration is typically encountered in patients with cardiac tamponade. Apart from that, there are some other conditions. If you can remember, you can remember. If not, it's okay. So what are those other conditions? You can have that in right ventricular myocardial infarction, right ventricular MI. You can also develop pulsus paradoxus if you have acute severe asthma and some other cases of right heart failure. But the most important one to remember is your cardiac tamponade. Okay, so this is about the pulse. Pulsus Bisferiens, 2 systolic peak. What should come to your mind? HOCM. Okay, and then pulsus parvus et tardus, slow rising, late peaking pulse. The pulse amplitude becomes small and the peak appears late. So amplitude is small and it is appearing later than normal, right? This is what we call as pulsus parvus et tardus. Okay. So now after completing the pulse, let's go to the JVP. Reddy, I'm not able to understand what you want me to do. Like the graphs of A and E. Okay. So you wanted the graph of pulsus Bisferiens and pulsus parvus et tardus. Okay, sure. Yeah. So first let me sketch the normal pulse waveform. This is going to be my percussion wave and this is going to be my tidal wave, and then this is going to be my dicrotic wave, and this is how the pulse ends. Okay. So this is percussion wave due to left ventricular ejection. This is tidal wave due to aortic recoil, and this is dicrotic wave due to the reflected peripheral wave or peripheral vascular resistance. This is going to be the normal for me in white color. And now if I develop, let us say, pulsus Bisferiens, how is it going to look like? The pulsus Bisferiens will have 2 peaks in the systole. So if I get 2 peaks in the systole, it will be called as pulsus Bisferiens. And how my pulsus parvus et tardus is going to look like? If this is the normal pulse, let us say this is the normal pulse, then the pulsus Bisferiens the pulsus parvus at Tardus will have a small peak. So this peak appears small and it appears late. So you have a late appearing small peak, and this is what we call as pulsus parvus at Tardus. Parvus at Tardus. So here you have small and late peak. So in terms of time, it has appeared late. In terms of height, it is small. In terms of height, it is small. Here you have two peaks instead of one. Okay. So that's about our pulse. Now let's go to the JVP. If not from the pulse, you are expecting one question from the JVP. So first let's understand the normal JVP waveform, and then we will talk about the abnormal JVPs. So in the normal JVP waveform, we have an A wave, that is the first ascending limb, and this A wave is due to atrial contraction. It is due to atrial contraction. Easy to remember, it is A for A. A wave is due to atrial contraction. Okay. So now with respect to cardiac cycle, what does it corresponds to? It corresponds to the active filling phase of cardiac cycle. So in the cardiac cycle, we have an active filling phase, and it corresponds to that. Active filling phase of cardiac cycle. It corresponds to the active filling phase of cardiac cycle during the diastole. During the diastole, first we do passive filling that amounts for 70% of the filling of the ventricle, and then 30% filling occurs actively. That is what this A wave corresponds to. A wave also corresponds to the P wave of ECG, because when we give an electrical impulse to the atria to contract, then only it contracts. So that atrial wave of depolarization is P wave, and a result of that electrical impulse is the contraction of atria that produces the A wave on the JVP. Okay. Then we have one small notch. After the A wave, you start getting a descending limb, and we call this descending limb as the X descent. This will be called as X descent. This is X descent, and X descent is due to atrial relaxation. It is due to atrial relaxation. Easy to remember again, give emphasis to the X, atrial relaxation, atrial relaxation. And then in between the X wave, you suddenly have one small wave coming up. We will call this wave as C wave. And C wave is due to tricuspid bulge into the atria during isovolumetric contraction. This is due to tricuspid bulge into right atrium. And this corresponds to the isovolumetric contraction phase of the cardiac cycle. Isovolumetric contraction phase of cardiac cycle. Easy to remember again, C, think of C, the cusp bulge. C wave is due to cusp bulge into the right atrium. Then you have one V wave. This next ascending limb is the V wave, which is due to venous filling from the superior and inferior vena cava. Blood starts filling the atrium. We will call that as venous filling. Again, easy to remember, V for V. V wave is due to venous filling, venous filling. And then next descending limb is the Y descent. This is our Y descent. And Y descent corresponds to atrial emptying, or in terms of cardiac cycle, it actually corresponds to the passive filling. The active filling phase was A, the passive filling is Y descent. So Y descent is due to atrial emptying, due to atrial emptying. The way to remember it is give more stress on the Y component of emptying while reading it. Emptying. Atrial relaxation resulted in X descent. Atrial emptying resulted in Y descent. Atrial emptying resulted in Y descent. Atrial relaxation resulted in X descent. And in terms of cardiac cycle, this corresponds to the passive filling phase of cardiac cycle. It corresponds to passive filling phase of cardiac cycle. again asking you the key points. A wave is due to atrial contraction or active filling phase of cardiac cycle. X descent is due to atrial relaxation. Atria contracts, pressure inside of the atria increases, you get A wave. After that, atria starts relaxing, that's why you get this X descent. During X descent, the tricuspid valve bulges into the atria, that gives you this C wave. After atria is relaxed, it is empty, now it starts receiving the blood from superior and inferior vena cava, so that produces the V wave. As blood fills the atria, the pressure starts increasing. And after the blood fills the atria, in the next cardiac cycle, it does the passive filling. So when blood passively leaves the atria, pressure drops, and that's why you get this Y descent. Okay. Now what abnormalities that are routinely asked in the exam? They will ask you, where do you get absent A wave? Where do you get fused CV wave? And where do you get canon A wave? These are the most commonly asked MCQs. So where do I get absent A waves? A wave is due to atrial contraction. If atria does not contract, A wave will become absent. When atria does not contract if it is going through atrial fibrillation, right? So absent A wave is typical of atrial fibrillation. Atrial fibrillation. In atrial fibrillation, atria is only fibrillating or kind of shaking. It is not contracting. That's why you notice absent A waves. Now, where do I get tall A waves? So to understand tall A waves, we have to look at the basic anatomy of the right side of the heart. So if this is my right atrium, this is my right ventricle, and this is going to be my pulmonary artery. And this is where I have the pulmonic valve. This is pulmonary artery, this is right ventricle, and this is where we have the tricuspid valve. Now, when atria contracts, when this atria contracts to push the blood through this tricuspid valve, you are building the pressure inside the atria, and that is what is giving you the A wave. But if this tricuspid valve opening is narrow, then the blood transfer cannot occur easily. Pressure in the atria increases even more than before. The A wave becomes tall. So you can have tall A wave if you have tricuspid stenosis. And let us say the tricuspid valve opening is fair, it's not narrow. Then when I pass the blood to the right ventricle, what if the right ventricular cavity is small? Then also the atrial pressure increases. When can right ventricular cavity become small? If you have concentric type of right ventricular hypertrophy. When do you get concentric type of right ventricular hypertrophy? Generally, if you have long-standing pulmonary hypertension. So we can say all of these conditions can cause tall A wave. Tricuspid stenosis, concentric type of right ventricular hypertrophy, and pulmonary hypertension. All of these will cause tall A waves. So tricuspid stenosis, concentric RVH, and pulmonary hypertension. Okay. Then comes canon A waves. The canon A waves and tall A waves are basically both tall A waves. The difference between tall A waves and canon A waves is the canon A waves are intermittently tall. They are not always tall. That's the difference between the tall A wave and canon. So sometimes they can ask you image based questions. So let's get an image of canon A wave done. So if I have, let us say this is normal JVP waveform. Let us say this is normal JVP waveform. In that you have this A wave going up, then you have an X descent coming down. In between you have a C wave because of the tricuspid bulge. And then when veins fill the atria, you get V wave. And then when atria does the emptying or passive filling, you get Y wave. This is your normal JVP. Now how the tall A wave in the JVP is going to look like? It is going to look like this. This is going to be the tall A wave of JVP that we are talking about. Every A wave will be tall. If I have tricuspid stenosis, every time the atria contracts, the tricuspid valve rudges, pushing of the blood to the right ventricle, and you will have tall A wave. So this is a tall A wave, this is a tall A wave. Now what is canon A wave? Intermittently tall A wave. So how canon A waves look like? Let us say this is one tall A wave. Rest of the JVP is like same as this tall A wave that we had seen here. But then the next A wave need not be tall. It may be small, like regular. And then intermittently once in a while you encounter a tall A wave. Like another A wave became tall now. So this is how the graph looks like. We call it as canon A waves. So this is one A wave. This is another, this is another, this is another. So in that case, this will become X descent, this will be C wave, this will be V wave, this will be Y. Same here, X descent C V Y, X descent C V Y, A again. This is going to be the X descent, this is C. It's continuing, but as we see here, you notice that one A is tall and the remaining two are small, and then again a tall A wave. So if you get intermittently tall A wave, these intermittently tall A waves is what we call as the Canon A waves. These are our Canon A waves. Where do we get it? We get it in patients with AV dissociation. It's a condition where atria and ventricle are contracting simultaneously against each other. So you're not able to transfer the blood. Then in that case, the A wave becomes tall. But in the next cycle, atria contracts and ventricle receives the blood, the A wave will be normal. So Canon A waves are typically encountered in AV dissociation. Typically encountered in AV dissociation. Just give me 1 second, guys. Not one tall, intermittently tall, we can call it as Canon A waves. So where do we get Canon A waves? We get Canon A waves in AV dissociation, atrioventricular dissociation. Means atrial rate and ventricular rate are different. That is what the AV dissociation means. Now the question is, where do I get AV dissociation? You get AV dissociation in number 1, the first answer is going to be complete heart block or third degree AV block, complete heart block. Second, AVNRT, which is a type of PSVT, paroxysmal supraventricular tachycardia. Third, if you have ventricular tachycardia or ventricular fibrillation. These are the 3 conditions where you get AV dissociation, and then intermittent tall A waves can appear. And these intermittent tall A waves can be seen on the patient's neck, because whenever the A becomes tall, the JVP becomes distended. And the regular A waves, the JVP goes back to the normal size. So we will call this as frog sign. Frog sign. If you see visible tall A waves as Canon A waves on the neck, we will call it as frog sign, because frog's neck also behaves same. So we call this as frog sign. Frog sign is originally described in AVNRT, but now you can also apply it to the other cases where you get Canon A waves. Now prominent X descent. Where do I get prominent X descent? Whenever you have a tall A wave, the X descent by default becomes steep or prominent. The more tall the A becomes, X descent becomes even more steep. The taller it becomes, the X descent goes on becoming steep or prominent. So prominent X descent is encountered in any condition with tall A wave. Any condition with tall A wave. Okay. 1 second, guys. Next is the prominent Y descent. This is what I want you to remember. The prominent Y descent is encountered in patients with constrictive pericarditis. This is an extremely important point, repeatedly asked MCQ. We use it for a differentiation between cardiac tamponade and constrictive pericarditis. We will have a separate table trying to compare both. So for now, just remember, prominent Y descent or a steep Y descent is encountered in constrictive pericarditis. And this prominent Y descent that we get in constrictive pericarditis, we also call it as Frederick's sign. It's called as Frederick's sign. A direct MCQ, where do you get Frederick's sign? You are answering constrictive pericarditis. Then fused CV wave and prominent V wave, both are encountered in the tricuspid regurgitation. This can also be one of your image-based question. This can also be one of your image-based question. You get this in tricuspid regurgitation. Tricuspid regurgitation. So how this is going to look like? So in tricuspid regurgitation, what happens is the blood is regurgitating back into the right atrium from the right ventricle during systole. So imagine this is your right atrium, this is your right ventricle, and this is your pulmonary artery. Here you have the tricuspid valve and it is not closed properly. So blood is going to regurgitate back from the right ventricle to right atrium during systole. And at this point of time, when the blood regurgitates, actually the atria is supposed to be receiving the blood from the superior and inferior vena cava, the venous filling phase. During that time, I am pushing extra blood into the right atrium. It is receiving the blood from the veins, which is giving you this V wave, and on during that time, if I give extra blood, the V wave becomes taller. From where this extra blood is coming? It is coming from the regurgitation. So the resultant graph looks somewhat like this. You will have a wave, and then X descent, and then C, and after the C, because the regurgitation starts, the blood starts filling the atria, the pressure starts going up. So you get this C directly leading to a tall V, and then you have the Y descent. So here you have a wave, X descent, this is the C, but after C, you are directly having the V, which has become tall. So this is what we call as fusion of C with the V, fused CV wave and tall V wave. This is your fused CV wave and tall V wave. Collectively, you see them in patients with tricuspid regurgitation. I have already told you one named sign in JVP, which was called as Frederick sign, the steep Y descent of constrictive pericarditis. This fused CV wave is now called as Lancisi sign, another named finding. One more thing, the Cannon A waves visible on the neck, we call it as frog sign, right? So tall A waves, where all I'm getting, tall A waves we are getting in patients with tricuspid stenosis. Tall A you are encountering in tricuspid stenosis, right ventricular hypertrophy, pulmonary hypertension. Cannon A waves you are getting in patients with AV dissociation. These are your Cannon A waves you are getting in patients with AV dissociation. Intermittently tall A waves, like in case of complete heart block, ventricular tachycardia or ventricular fibrillation, or AV NRT. In complete heart block, the ventricular rate is decreased, atrial rate remains normal. So you have a difference created in the rate. In case of AV NRT, atria has developed a form of tachycardia. So atrial rate has increased, ventricular remains normal. In case of ventricular tachycardia and ventricular fibrillation, atrial rate remains normal, but ventricular rate is increased. So in all these cases, there is a separation of rate of atrial contraction and ventricular contraction. So when two chambers are contracting at different rate, sometimes they contract together, and whenever they contract together, you get a tall A wave. Okay, so that completes the major questions that can be asked from the JVP. In the recent times, they have focused more on the constrictive pericarditis versus cardiac tamponade differentiation on the basis of JVP. We will study that with a little more detail. Okay. Now, the next topic that we are interested is valvular heart diseases. Now, what can be asked from the valvular heart diseases? Most commonly, they give you a story, means patient's symptoms, and then the murmur or some additional findings, and then you have to diagnose which valvular heart disease it is. Or once you make a diagnosis in your mind, then they may be asking what is the most likely cause for this condition, or what is the definitive treatment for this condition. So it always begins with the diagnosis. So I will give you a question. Let's see if we can answer, and then I will tell you how do we approach this circumstance. So I have one question here. We have a 48-year-old male with dyspnea and fatigue as the symptoms, and on examination, this fellow had a mid-diastolic murmur at left lower sternal border, or they can also write it as left lower parasternal region. Now, which of the following is false about this condition? Following is false about this condition? Option A, may hear opening snap. Option B, murmur increases on inspiration. Option C, okay, slight change. Let me say we have heard that in the fifth intercostal space medial to midclavicular line. Fifth intercostal space. Murmur increase on inspiration. Murmur increases on expiration. D, rheumatic heart disease is the most common cause. Now, can anybody tell me what is the diagnosis here? This is what the valvular heart disease questions are going to look like. What's the diagnosis in that case? Once we make the diagnosis, answering rest of the questions becomes easier. So there's a simple, easy template to approach these kind of questions. So there are 3 levels of information that can help us to establish the diagnosis. Okay. Dr. Bala MD, very good, very good. Yes, I think some of you got the diagnosis pretty right, spot on. Good. So what are the information that we're using for diagnosis? First level of information that we can look in the question is right side of the heart versus left side of the heart. Because whenever you have valvular heart diseases, one of the organ gets congested. If you have left-sided heart diseases, ultimately pressure buildup leads to pulmonary congestion. So you can have dyspnea as the symptom. And if you have right-sided valvular lesions, ultimately the congestion leads to liver and the veins. So you'll have raised JVP and hepatomegaly, ascites, pedal edema, typical right heart symptoms. So you should see the symptoms and decide whether you have raised JVP, hepatomegaly. If these symptoms are there, then it is right heart disease. And if you have dyspnea, PND or orthopnea, then it is left heart disease. So when I see this question, I do understand that this patient has dyspnea and fatigue. So it is less likely to be right heart disease. There is no talk about raised JVP, hepatomegaly or ascites. So I should be thinking about left heart disease, and left side has only 2 valves, aortic valve and mitral valve. So I should be thinking about aortic stenosis, aortic regurgitation, mitral stenosis, mitral regurgitation. Okay. Then next level of information that we can look at is the murmur. And when we look at the murmur, well, we can definitely by heart what murmur is heard in which condition. But instead, I first want to see from which area this murmur is coming. So in the murmur, the nature of the murmur is important for sure, but I am also looking at the area of auscultation from where I am hearing this murmur. So if I am hearing this murmur, mostly questions mention the area of auscultation. And we know that each valve has an area earmarked on the chest where the murmur is best heard. Now this area is actually the mitral area. So when I look at the area, it already tells me that this murmur is coming from the mitral valve. So my differential diagnosis narrows down now. I am already ruling out the aortic stenosis, aortic regurgitation. I am only left with mitral stenosis, mitral regurgitation. Right? After that, the nature of the murmur. If I know that mitral stenosis causes diastolic and mitral regurgitation causes systolic murmur, sorted, I will reach the diagnosis. Okay. Another thing that can hold your hand, the third information is that the murmurs of the right side of the heart increase on inspiration and the murmurs of left side of the heart increase on expiration. This is because right side of the heart gets more blood flow during the inspiration, left side of the heart gets more blood flow during expiration. So right heart murmurs increase on inspiration. Okay, I will write that later. Okay, because anyway, we will apply to this question. Okay, so now we will take 5 minutes, come back to this question. Anyway, most of you have already got it right, but those who are kind of not very sure, we will go through the areas of auscultation and some basic rules of auscultation on the murmur, and then we will come back and approach this question. That way, no matter how twisted or complex the question comes, you should be able to deal with it. So when it comes to the areas of auscultation, on the right second intercostal space, we have one area of auscultation, and that's going to be aortic area. Right second intercostal space is going to be your aortic area. It is going to be aortic area. The left second intercostal space is going to be pulmonic area. So if the question says there is a murmur which is heard in the left second intercostal space, it is only talking about PS or PR. If the question says there is a murmur heard in the right second intercostal space, it's mainly talking about aortic stenosis, because this is aortic area. And then this left lower sternal border, also called as the left parasternal region, is going to be your tricuspid area. So if the murmur is best heard here, that means you're dealing with either TS or TR. And then this is the apex, the tip of left ventricle, which is usually situated medial to midclavicular line in the fifth intercostal space. Fifth intercostal space, medial to midclavicular line. And this becomes your mitral area. This is going to be your mitral area. So if the murmur is heard at the apex, it is coming from mitral valve. Either MS or MR are going to be your diagnosis. So you should always be aware of these areas of auscultation to be able to diagnose valvular heart diseases in MCQs. Okay, so now tell me which area this murmur is coming from. This murmur is coming from the mitral valve. So I have to think about mitral stenosis and mitral regurgitation. Nothing else I should be thinking in this question. So already your differential diagnosis is narrowed down. You're more sure about it because you know the symptoms are of left side of the heart, plus the area of auscultation is also pointing towards the left heart pathology. Now only thing is it MS or is it MR? For that, if I can literally by heart few murmurs, I'm sorted. Okay. And we should also keep in mind that the murmur of aortic stenosis or like murmur of aortic valve pathology and murmur of pulmonic valve pathology will be same, because in the cardiac cycle, same time aortic and pulmonic valve open, same time they close. And the murmur of mitral and tricuspid valve pathologies will be same, because in the cardiac cycle, the same time open and the same time close. So murmur of aortic stenosis and pulmonic stenosis is ejection systolic crescendo decrescendo murmur. Ejection systolic crescendo decrescendo murmur. Now what do I mean by crescendo decrescendo? Ejection systolic, systole occurs between S1 and S2. So you're expecting the murmur between S1 and S2. And the murmur in the systole, we have these three phases. You have an isovolumetric contraction. After that, you have rapid ejection, and then you have slow ejection. So we are ejecting the blood from the left ventricle into aorta during the systole. First we contract the left ventricle. After the contraction, the aortic valve opens. And when the valve opens, it can, if it is stenosed valve, it can make a noise which we call as click. We call it as click. So you can hear one click. Followed by that, the blood starts moving through the narrow orifice in the aortic valve. Like if this is the left side of the heart that we are looking at, first we contract the ventricle to open the aortic valve, and when I contract, the aortic valve opens. And as this valve opens, sudden tensing of this valve makes the noise. That noise is your click. And after that, the blood starts passing, first through rapid ejection and then through slow ejection, through this narrow orifice. That is where it experiences the turbulence, and that creates a murmur. And because in the rapid ejection phase, the blood is ejected with increasing velocity, and then the ejection velocity goes on decreasing, the murmur intensity also goes on increasing and then goes on decreasing. This is what we call as the crescendo decrescendo murmur. Why are we calling it as ejection systolic? Because the murmur is heard in the ejection phase, not before that. That's why it is called as ejection systolic murmur. Same murmur you will hear in AS and PS. But the difference is, in AS, you will hear the murmur best in the right second intercostal space, which is the aortic area, and in PS you will hear it in the left second intercostal space, which is the pulmonic area. Now what extra points we need to remember? You need to know what is the most common cause for aortic stenosis, and you should also need to know what is the most common cause for pulmonic stenosis. The most common cause for aortic stenosis in young individuals is different and overall is different. Okay, so overall it is the age-related calcification, age-related calcific degeneration or calcification. In young individuals, it is due to bicuspid aortic valve. Aortic valve is a tricuspid structure, but some people are born with only two. That becomes the reason for aortic stenosis in young. Elderly, with aging, the aortic valve gets calcified. The most common cause for pulmonic stenosis is congenital. It can co-occur with other disorders like tetralogy of Fallot, which you are aware of. One of the component is pulmonic stenosis, Noonan syndrome. These are all congenital causes. So PS is mostly you need to be born with it. Now, in case of AR and PR, you are getting the same murmur. What is the murmur that you are getting in AR and PR? The murmur that you are getting in AR and PR is early diastolic murmur. You are getting a early diastolic murmur in AR and PR. You get a early diastolic decrescendo murmur. So murmur is heard in the initial part of the diastole and its loudness goes on decreasing before it vanishes. So you get early diastolic decrescendo murmur. So this murmur is going to occur between S2 and S1 because diastole is occurring between S2 and S1. And in the diastole we have three phases: isovolumetric relaxation, passive filling, and active filling. Now where do I hear the murmur? I mainly hear it in the isovolumetric relaxation. So when ventricle is relaxing in the early part of diastole, the blood that was ejected into the aorta starts dropping back, right? So you are getting this early diastolic decrescendo murmur. Okay. Now if they ask you what is the most common cause for aortic regurgitation, most common cause for aortic regurgitation, right now it is going to be hypertension. Hypertension dilates the aorta, and by dilating the aorta it stretches the aortic valve, and then the valve will not be able to close properly because it is stretched, and that can lead to regurgitation. The most common cause for pulmonic regurgitation is going to be pulmonary hypertension. If systemic hypertension causes AR, the pulmonary hypertension will cause PR. Okay, pulmonary hypertension will cause PR. Now coming to the mitral stenosis and tricuspid stenosis, the murmur is going to be same. What is the difference then? The murmur of mitral stenosis will be heard in mitral area, which is fifth intercostal space medial to midclavicular line. The murmur of TS will be heard in the tricuspid area, which is the left lower parasternal region or left lower sternal border. And what is the nature of the murmur? This murmur is going to be a mid-diastolic murmur with a pre-systolic accentuation. So you get a mid-diastolic murmur with pre-systolic accentuation. Pre-systolic accentuation. Now what does that mean? So when we look at this, let us take the example of mitral stenosis. So what happens in mitral stenosis? Your mitral valve opening is narrow. So now when I start the diastole, first I do isovolumetric relaxation. I am relaxing the ventricle to lower its pressure so that I can open the mitral valve and start receiving the blood. During this point of time, mitral valve is not open yet and you will not hear any murmur. But the mitral valve does open after the isovolumetric relaxation. So after S2, I will have this isovolumetric relaxation. So ventricle is relaxing to lower its pressure. And once the ventricle has lowered its pressure, lower than that of atrial pressure, the mitral valve opens. But when this valve opens, it is stiff and stenosed. This sudden tensing of the stiff valve can make a noise. So you might hear a noise here because of the opening of the mitral valve, and you will call this noise as opening snap. You will call it as opening snap. So in ASPS you get click. which is nothing but the sound of opening of the valve. But if the valve opens in diastole, like the mitral valve or tricuspid valve, they don't make as loud noise as the valves that open in systole. That's why we will call it as snap. This is snap. It's not very loud noise. This is click. It's very loud noise. So systolic valves, if they open, they make a loud noise, then we will call it as click. Here the diastolic valves, when they are opening, they don't make as loud noise as that, so we are calling it as snap. And once it opens, the blood starts moving through first passive filling and then active filling. So as the blood moves through the passive filling, it experiences the turbulence because the opening is narrow, it starts producing the murmur and we start hearing it in the passive filling. Okay, so whatever is the loudness in the passive filling, that loudness increases in active filling because in active filling atria starts contracting, and as atria starts contracting trying to push the blood through smaller opening, it creates even more turbulence. So the murmur intensity increases and this murmur now becomes even more louder. And this increase in the loudness in the active filling phase is what we call as the pre-systolic accentuation. Means after this systole starts, right? Between S1 and S2 you have systole. So just before that the murmur became louder. We call it as pre-systolic accentuation. Now the points to remember: the most common cause for mitral stenosis is RHD, and so is for the tricuspid stenosis. The most common cause for tricuspid stenosis is again RHD. Okay. So this is about mitral stenosis and mitral regurgitation. Now talking about MR and TR, both of them produce pan-systolic murmur. They produce pan-systolic murmur, means a murmur that stretches from S1 all the way to the S2. Pan-systolic. Now many students do get confused, like I had a lot of queries last year when, sir, you had told about pan-systolic murmur but that option was not there in the question, because pan is also called as holo. So holosystolic or pan-systolic are same. So here murmur will literally run from S1 all the way to S2. The most common cause for the mitral regurgitation is going to be left ventricular dilatation of whatever reason, dilated cardiomyopathy or the ischemic heart disease. And the most common cause for the tricuspid regurgitation is going to be right ventricular dilatation. Most common cause for MR is LV dilatation, and most common cause for TR is going to be right ventricular dilatation. Okay, clear? I want you to literally memorize if you have no idea about the valvular heart diseases, because you can use this information to deal with 1 marks from cardiology. Okay, what extra information I need to know? There are some extra points to know. The first one is the murmurs of the right side of the heart, that is right heart murmurs increase on inspiration. Right heart murmurs increase on inspiration. Why? Because right side of the heart gets more blood flow from the superior and inferior vena cava during the inspiration, and more the flow, more the turbulence, more the murmur. So when I say right heart murmurs, I am referring to PS, PR, TS, TR. These murmurs increase on inspiration, and this increase in the right sided murmurs on inspiration is also called as De Carvalho or simply Carvalho sign. De Carvalho or Carvalho sign. Okay. Then second, the left heart murmurs increase on expiration. Increase on expiration, because left heart receives extra blood flow during expiration. So that means AS, AR, MS and MR are likely to increase on expiration. Okay, there is no specific name given for this observation. Okay. Then the third point is certain murmurs increase when you increase the venous return and decrease when we decrease the venous return. In fact, most of the murmurs with few exceptions. So all murmurs increase on increasing venous return, means if you make the more blood to come to heart through the veins, all the murmurs increase. And if you do something to decrease the blood flow to the heart, less blood flowing through the valves, less the murmur. So all the murmurs increase on increasing venous return and decrease on decreasing venous return. Decreasing venous return. So what increases the venous return to heart? If you do passive leg raising, if you raise the leg of the person, because you are now gravitationally facilitating emptying of the blood of the veins of the lower limb into the circulation, and it comes to the heart, venous return increases. Passive leg raising. Another thing that can increase the venous return is squatting. If you squat, you contract the calf muscles and that pushes the blood towards heart. Squatting. What decreases the venous return? Standing. If you stand, suddenly blood gets pooled in the lower limb veins and you can decrease the venous return. Standing. And another thing that can decrease the venous return is Valsalva. When you try to exhale with the closed nose and mouth, you build intrathoracic pressure. So if the intrathoracic pressure increases, it blocks the blood flow from superior and inferior vena cava towards the heart. So Valsalva, particularly strain phase of Valsalva and standing, decrease the venous return. The question is, if all the murmurs decrease or if all the murmurs increase, then what's the point of knowing it? Well, there are exceptions. So these maneuvers do help us to identify those outliers or exceptions. What are the exceptions? The murmurs of HOCM and murmur of mitral valve prolapse, they behave opposite of it. On increasing the venous return, these murmurs decrease, and on decreasing the venous return, these murmurs increase. So we can use this information to identify HOCM and MVP in a given question. Okay, clear? So now that we know all of this, let's see if we can answer that question. So we had a 48-year-old person, and when I look at the complaints, these complaints or symptoms are suggestive of left heart disease. There is no talk about the raised JVP, hepatomegaly or ascites. So I'm already not thinking about among the all possible valve pathologies. I'm sure this is not likely to be PSPR. This is not likely to be TSTR. These are out. Now I'm only thinking about MS, MR and AS, AR at the level of complaints. And then when I go to the murmur, I look at the area of auscultation. Area of auscultation makes it very clear that this is a mitral area. So that means I am not thinking about AS, AR anymore. I am left with MS and MR. And from the table, now we have the idea that a patient of MR will have pansystolic murmur and a patient of MS will have mid-diastolic murmur. So because this murmur is mid-diastolic, the MR is ruled out. So I am left with mitral stenosis as my diagnosis. And once the diagnosis is made, we can address the rest of the thing. So diagnosis here is mitral stenosis. And once we have established the diagnosis, we can answer the question. May hear a opening snap? Yes, in MS and TS we hear opening snap. In AS and PS we hear the ejection click. Click in ASPS, opening snap in MSTS. So opening snap can be heard. So this is a true statement. It's not false. Then murmur increases on inspiration. What did we write now? The right-sided murmurs increase on inspiration. Left-sided increase on expiration. So this is a false statement. Murmur increase on expiration? True. Left-sided murmurs increase on expiration. And what is the most common cause for mitral stenosis? It is the rheumatic heart disease. So this is also true. So we get our answer in option B. Most of you had picked it up, so that's good. Okay, so this is going to be our approach to valvular heart disease. One last bit of information to add. There are certain named murmurs, and FMG has a tendency to directly ask, where do you get this particular named murmur? So we should be aware about those murmurs with name. Named murmurs. So the first named murmur that we are talking about is called as Graham-Steele murmur. I think just a couple of exams back they had asked it in the FMG itself. Graham-Steele murmur. This is nothing but the murmur of pulmonic regurgitation, which is the early diastolic murmur of PR is called as Graham-Steele murmur. Okay. Then you get something called as Austin-Flint murmur. Austin-Flint murmur. This is encountered in patients with aortic regurgitation. Aortic regurgitation. Okay. Then there's also something called as Carey-Coombs murmur, which is heard in patients with acute rheumatic fever. In acute rheumatic fever, due to involvement of mitral valvulitis in acute rheumatic fever, right? We call it as Carey-Coombs murmur. Then we have one more murmur. Okay, let's talk also about something called as a Gallawerdins phenomenon. Gallawerdins phenomenon. Gallawerdins phenomenon basically refers to, now when we have aortic stenosis, the murmur of AS gets referred to the carotids and the apex. Like if this is the aorta, this is left atrium, and this is left ventricle, and this is where you have the aortic valve. This aortic valve is narrow. So when you produce a murmur here, because of this passage of blood, the murmur gets conducted to carotids, and it can also flow retrogradely back towards the left ventricle, the apex. So if you hear that AS murmur in the apex, we will call it as Gallawerdin phenomenon. AS murmur conducted to apex or referred to apex. It's called as Gallawerdins phenomenon. Okay. Then the Carvalho sign or D Carvalho sign, as I've already told you, this is nothing but increase in right heart murmurs on inspiration. On inspiration. Last one is Dockey's murmur. This is murmur due to LAD stenosis. When blood passes through stenosed LAD, we will call it as Dockey's murmur. Murmur due to left anterior descending artery stenosis is going to be your Dockey's murmur. So we are expecting one question between pulse or JVP. Can be image based questions, so just go through what we have discussed. Then we are expecting one question from valvular heart diseases. It may be a straightforward question asking you which of the following is not a diastolic murmur or a systolic murmur, or they might give a name and ask where do you get this murmur. Or it may be a clinical vignette where from symptoms, area of auscultation and the nature of murmur, you have to diagnose what is the valvular heart disease. Beyond that, it might also ask you what are the most common causes or what is the definitive management. Okay, so that completes our valvular heart diseases. Next, we will also talk a little bit about certain abnormal heart sounds. Okay, we have already discussed opening snap and click. We know where do we get them, right? Opening snap are sounds heard because of the, both of these are sounds of opening of stenosed valves. Stenosed valves. Opening snap is heard in mitral stenosis and tricuspid stenosis, and click is heard in aortic stenosis and pulmonic stenosis. In addition to that, one extra thing you have to remember is click can also be heard in mitral valve prolapse. Okay, now comes the S3 and S4. S1, S2 you already know, S3 and S4. So normally when valves close, they produce S1 and S2. Closure of aortic and pulmonic produces S2. Closure of mitral and tricuspid produces S1. But when we transfer the blood from the atria to ventricle, we don't produce any sound normally. But pathological conditions, you might start producing sound. So when we do passive filling into the left ventricle, if the left ventricle is dilated, it can produce a sound, and we will call that as S3. So S3 is the sound produced by passive filling. It is the sound produced by passive filling into dilated compliant LV, compliant left ventricle. And let us say the LV was not dilated, so you will not hear S3. But after the passive filling, you do active filling, right? Now atria actively contracts to push the remaining blood, you produce active filling. But during active filling, if the ventricle is small ventricle we get when we have this concentric hypertrophy. Then this forced pushing of blood into a small ventricle can also produce a sound. We will call that as S4. So S4 is a sound produced by active filling. S3 is passive filling, S4 is active filling into small non-compliant LV as in case of concentric hypertrophy. As in case of concentric left ventricular hypertrophy. Now tell me where my left ventricle gets dilated so that I can hear S3, and when do I get concentric LVH so that I can hear S4? Well, you can have dilated left ventricle in patients with dilated cardiomyopathy and in patients with systolic heart failure. Systolic heart failure. Systolic heart failure most commonly occurs in ischemic heart disease patients. And you can get this concentric LVH in patients with hypertrophic obstructive cardiomyopathy or HCM, and also concentric hypertrophy is most commonly caused by hypertension. In hypertension you get diastolic heart failure. Diastolic heart failure. Okay. And because S3 is passive filling occurs first and after that active filling occurs. So S3 can be called as a early diastolic sound. Early diastolic sound, and S4 is going to be a late diastolic sound. It's going to be a late diastolic sound. They might also ask you image based questions on this, so let's put that down also. Okay, so if this is going to be my S1, this is going to be my S2, this is going to be my S1 again. So both S3 and S4 are diastolic sounds because passive filling, active filling both occurs in the diastole. So where will I hear S3? After isovolumetric relaxation, the mitral valve opens and you start filling the blood into the ventricle. That occurs, that phase is passive filling. After that, active filling. S3 is heard in the initial part of passive filling. This is where we are going to hear S3. That's why it's an early diastolic sound. And S4 is the sound of active filling. So you will hear it in the active filling. So that becomes your late diastolic sound. Okay. So for S3 you need a dilated left ventricle, and for S4 you need a concentric left ventricular hypertrophy. Extra point to note, S3 can be physiological. Can be physiological in pregnancy, children and athletes, while S4 is always pathological. It's always pathological. Until and unless you develop concentric LVH, you will never hear S4. S3 can be physiological in children, pregnancy and athletes. Pregnancy and athletes. Okay, so that completes everything related to the basic clinical cardiology. Now let's take one important topic, that's heart failure. Now what is heart failure? Heart failure simply refers to the impairment in left ventricular filling or ejection. So impaired left ventricular filling. If I am not able to fill the blood into the left ventricle during diastole, you can say heart is failed. Or I am able to fill but I am not able to eject out from the ventricle to aorta, then also we will say heart failure. Impaired LV filling or ejection is called as heart failure. Now how do I diagnose heart failure? Heart failure certainly has symptoms. If I have right heart failure, what symptoms I am expecting? If I have right heart failure, I will have raised JVP, hepatomegaly, ascites. These are typical symptoms of right heart failure. And if I have left heart failure, I will have dyspnea, because lungs get congested if left heart fails, dyspnea, orthopnea and PND, and paroxysmal nocturnal dyspnea. Extra point to note, PND is the most specific symptom of left heart failure. Most specific symptom of left heart failure. Okay. Now how do I diagnose? Because in valvular heart disease also you will have the same symptoms, like in case of mitral stenosis, mitral regurgitation, I will have congestion of the lung. In case of AS, AR also I will have congestion of lung. So you will have similar symptoms. If I have TSTR or PSPR, I can have similar symptoms. So if the valve is reason why we are not able to achieve the filling or ejection, then technically that's not heart failure, right? So then in that case, how do I diagnose? I can't diagnose it merely based on the symptoms. I have to prove that heart is under stress. How do we prove that? Whenever the chambers are stretched in the heart, there will be production of certain substances like natriuretic peptides, and we will use them as the biomarkers of heart failure. So if you have signs and symptoms of heart failure, plus if you have increased either BNP levels or N-terminal pro-BNP levels, the B-type natriuretic peptide levels, then you will call it as heart failure. So these are the biomarkers of heart failure. Like how you have troponin T and CKMB for biomarkers of heart failure. Troponins and CKMB for the myocardial injury. Similarly, for heart failure, BNP and NT pro-BNP are considered as biomarkers. Okay. Now, once the heart fails, we classify them into heart failure with reduced EF, preserved EF, and mid-range EF. So, basis EF, we have classified the heart failure. So, we'll call it as heart failure with reduced EF if EF is less than 40%. Less than 40%. And if the heart failure is there but the EF is more than or equal to 50%, we will call it as heart failure with preserved EF. Heart failure with preserved EF. If EF is more than or equal to 50%. This has been asked as an MCQ. When do you call it as heart failure with reduced EF? When ejection fraction is less than 40%. We will call it as preserved EF if the EF is 50% or higher. Anything in between, we will call it as heart failure with mid-range ejection fraction. Mid-range ejection fraction. What is normal ejection fraction? Normal ejection fraction is 60 to 70%. So as long as it is closer to normal range, you will call it as heart failure with preserved. And if it is quite low, less than 40, heart failure with reduced EF. Now coming to the management of heart failure. Apart from treating the underlying cause like hypertension, ischemic heart disease, whatever is the underlying cause, there are certain things that we do to increase the survival of the patients. A patient with failed heart generally don't live as much as a normal individual lives. So what treatment improves the survival in a patient with heart failure? So first class of drugs that have shown significant survival benefit is going to be ACE inhibitors or ARBs, angiotensin receptor blockers or ACE inhibitors. Okay, I should tell you that whenever heart fails, once you have heart failure, there are two major changes occurring in the body. One of them is decreased stroke volume, because heart has failed, it's not able to eject the blood well. The stroke volume is going to be less. And there will be increased atrial pressures. Increased atrial pressures. So decreased stroke volume tends to decrease the blood pressure, or mainly systolic BP, and because the BP is dropping, body will have some counter regulatory mechanisms. So it will lead to activation of sympathetic nervous system and renin angiotensin aldosterone system, so that you can cause vasoconstriction and increase the blood pressure which is dropped. But unfortunately, both of these, sympathetic nervous system and RAS, cause more harm to a failed heart. I will not get into the detailed discussion, but we should be aware that RAS and sympathetic nervous system are harmful if your heart is already failed. It just worsens the heart failure. And that's why we need to block the sympathetic nervous system and RAS. So I will block sympathetic nervous system with beta blockers, and RAS has two components, angiotensin 2 that I will block with ACE inhibitors or ARBs, and aldosterone that can be blocked with spironolactone. And the increased atrial pressures, they will result in release of natriuretic peptides. Natriuretic peptides means we are talking about ANP, BNP. And this BNP itself we are using as the marker of heart failure, right? So once these are produced, as the name says, natriuretic peptides, they will increase the sodium and water excretion. So they unburden the heart. These peptides are beneficial, while ANP, BNP and like the sympathetic nervous system and RAS were harmful. These are beneficial in patients with heart failure. That's why we want to facilitate these and block these. How will I facilitate the natriuretic peptides? We know the natriuretic peptides get broken down to inactive peptides by an enzyme called neprilysin. The enzyme is called as neprilysin. Pharmac people are very much fond of neprilysin inhibitors. So if I block the neprilysin, then breakdown of ANP, BNP is stopped and you can have more ANP, BNP in the circulation and you get the the benefits that it can offer. So neprilysin can be inhibited by a drug called sacubitril. Sacubitril is a neprilysin inhibitor, right? So we can use neprilysin inhibitor. We can block angiotensin 2 with ACE inhibitors or ARBs. We can block aldosterone with spironolactone, and sympathetic nervous system can be blocked by beta blockers. So that's why these are the drugs we are going to use. Now when it comes to ACE inhibitors or ARBs, in a patient with heart failure with reduced EF, we prefer using a combination of ACE inhibitor or like ARB and the neprilysin inhibitor. This combination is preferred over ACE inhibitors or ARB. What is ARNI? ARNI refers to a combination. It's a drug combination of angiotensin receptor plus neprilysin, inhibiting both. Neprilysin inhibitor. You inhibit angiotensin receptor as well as neprilysin inhibitor. Okay, the currently available combination, can anybody give me the ARNI that is currently available in India? ARNI available in India is going to be combination of valsartan, which is a ARB, plus sacubitril, which is the neprilysin inhibitor. So sacubitril is neprilysin inhibitor and valsartan we know it is going to be an ARB. Valsartan is an ARB. A patient can tolerate, we prefer ARNI over just the ACE inhibitor or ARB. After that, we will try to block the sympathetic nervous system with beta blockers. Beta blockers. You should tell me which beta blockers are approved for use here. Jaideep Meethghate, very good. Beta blockers. The third one is going to be spironolactone. Spironolactone, which is going to be a mineralocorticoid receptor or aldosterone antagonist. And there is a fourth category of drug. Now we call it as golden 4 pillars of heart failure management. The beta blockers, only 3 are currently approved for this indication. So you should be aware of this. Pharmacology straight questions have appeared on this. Which of the following beta blocker has shown the mortality benefit in heart failure? So you can remember this with the Melbourne Cricket Board as the mnemonic. So M stands for metoprolol. Metoprolol. Melbourne Cricket Board, carvedilol for C. Board, bisoprolol. So these are the 3 beta blockers which have been studied and proven to be beneficial. Okay. The last class of drugs that we are using is going to be SGLT2 inhibitors. SGLT2 inhibitors. SGLT2 inhibitors make you lose sodium and along with that glucose and water in urine. So they also have a bit of diuretic kind of properties. By doing so, they reduce the blood pressure, they reduce the burden on the heart, and studies have shown that they increase the survival. So all these drugs are usually prescribed to a patient with heart failure, and we call it as the golden 4 pillars of heart failure management. What are we calling them as? These are the golden 4 pillars, or in simple words, 4 pillars of heart failure management. Some extra points we need to be aware of. So all the drugs that we spoke about, the 4 pillars reduce the mortality, right? So those are going to be your ARNI over ACE inhibitors or ARBs, plus your beta blockers, plus your spironolactone, plus your SGLT2 inhibitors. They all reduce cardiovascular mortality in heart failure patients. They reduce the risk of death, increase the survival. But inotropic agents, inotropes like digoxin and whatever newer inotropes you are aware of, all of them increase cardiovascular mortality in the long run. If at all we use digoxin, we use it only for a short period of time during acute worsening of heart failure. We don't use it for long time because they increase the risk of death. This is a potential MCQ asked many times. They can ask again also. So you should be aware. Okay. So that completes our heart failure. Next comes the constrictive pericarditis versus cardiac tamponade. So first let's talk about constrictive pericarditis. What is constrictive pericarditis? In constrictive pericarditis, the pericardium has become stiff. It is not letting the heart expand during the diastole. And because of that, there is abrupt cessation of the diastolic filling in the passive filling. So basically what has happened is, if this is your heart we are looking at, and when we want to fill the blood into this heart from the atria to ventricle during the diastole, first we start doing the passive filling. As we start doing the passive filling, the ventricle starts expanding because we are filling the blood into it, it starts expanding. And then when we do active filling, it expands further. So at the end of diastole, the ventricle is in its maximum size. Now let us say after completing the diastole, the ventricle wants to become this big size when we complete the diastole. But unfortunately, the pericardium above it, on it, has become stiff. And this stiff pericardium cannot expand as much as the ventricle wants to expand. Ventricle wants to expand till here. But let us say pericardium can only expand, let's say this is the limit that pericardium can expand. So in that case, my passive filling can only run till the ventricle reaches this size. It can't continue beyond that. So passive filling gets abruptly halted. That's the essence of understanding constrictive pericarditis. So constrictive pericarditis is where you have stiff pericardium that results in abrupt cessation of. This results in abrupt cessation of passive filling. Now whenever you suddenly stop something which is moving, it jerks. And that jerking of sudden stopped ventricle produces a sound which we call as pericardial knock. So this abrupt cessation of passive filling produces pericardial knock. Pericardial knock. Very, very important point, because the same clinical features of pericarditis, constrictive pericarditis, can also be encountered in cardiac tamponade. But if you're hearing the knock, then you know this question is about the constrictive pericarditis and not about the cardiac tamponade. And because you are abruptly stopping the passive filling, you could not complete the passive filling. So overall volume of blood filled into the right ventricle decreases. More blood stays back in the right atrium. And because of that, the right atrial pressure increases. And if the right atrial pressure increases, you will have raised JVP, right? Eventually hepatomegaly and ascites and pedal edema. So this will result in decreased right ventricular filling and raised JVP. And when we look at the JVP here, you will have a tall A wave because more blood in the atria, and when it contracts, it produces taller A wave. You will have tall A wave. And whenever A wave is tall, by default, the X descent becomes steep. You will have steep or prominent X descent. And here passive filling is occurring. The wave of passive filling is Y descent. Passive filling is occurring, so Y descent will be there. In fact, it becomes prominent. You will have a prominent or steep Y descent. Prominent or steep Y descent. This point helps us to differentiate constrictive pericarditis from cardiac tamponade. In cardiac tamponade, you will not have Y descent. Y descent will be absent. Okay, and I think we have already discussed this. The prominent Y descent is also called as Frederick's sign. Frederick's sign. And if the right ventricular filling is less, then from the right ventricle, the amount of blood that goes to the lungs and then eventually comes to the left side of the heart is going to be less. So this can lead to decreased LV filling. And if the LV filling decreases, you can also develop hypotension. This can lead to hypotension. So hypotension can be encountered even in constrictive pericarditis patients. But what differs is you have raised JVP and hypotension here also, there also, but on auscultation in cardiac tamponade you get the muffled heart sound, here you get pericardial knock. On the cardiac tamponade, JVP shows absent Y descent, here you get prominent Y descent. So these 2 points will help you to differentiate between constrictive pericarditis and cardiac tamponade. Now, what are the common causes for constrictive pericarditis? The most common cause in India for constrictive pericarditis is going to be tuberculosis of the pericardium. And the most common cause worldwide is going to be recurrent acute pericarditis. Recurrent acute pericarditis. If the patient goes through recurrent episodes of acute pericarditis, the pericardium becomes fibrous and that's how it becomes stiff. Okay. And if you ask me how do we treat, the pericardium is stiff, it is not allowing the passive filling to completely occur, suddenly stopping it midway. So you treat them like you remove the pericardium. Pericardium is the limiting factor here. Remove it. No more cessation of the passive filling. You can do the full normal passive filling. Problem sorted. So we go for pericardial stripping. Pericardial stripping. Remove the pericardium. Now talking about the cardiac tamponade. What exactly happens in cardiac tamponade? In cardiac tamponade, there is too much of fluid in the pericardium that compresses and collapses the right ventricle. So if you have fluid in the pericardium, that's not cardiac tamponade, that is pericardial effusion. But when this fluid puts pressure and makes the right ventricle to collapse, we will call it as cardiac tamponade. Let us say this is my pericardial space. So in this space, I start filling the fluid. And when I fill the fluid into this space, if the pressure exerted by the fluid makes the right ventricle collapse, then it is cardiac tamponade. Until then, it is just the constrictive pericarditis. Until then, it is just the pericardial effusion. So this fluid will start exerting pressure on the ventricle. Left ventricle being strong and muscular, it doesn't collapse easily, but right is not that strong, so it collapses easily. And once the right ventricle collapses, now you call this as cardiac tamponade. And now this right ventricle is collapsed, so it can't relax, it can't expand itself. So if it can't do the isovolumetric relaxation, passive filling is not possible. So in cardiac tamponade, passive filling does not occur. So if the pericardial fluid leads to RV collapse, there will be no isovolumetric relaxation, and if there is no isovolumetric relaxation, there will be no passive filling. This is the difference between tamponade and constrictive pericarditis. In constrictive pericarditis, passive filling occurs till suddenly it gets stopped. So passive filling is going on. That's why you will have the Y descent. The Y descent is the wave of passive filling. But in cardiac tamponade, no passive filling is possible. Whatever filling you do, actively, forcefully, you have to push in this collapsed chamber. Passively, it can't take any blood. And if there is no passive filling, you will have no Y descent. No Y descent. Okay. So if there is no passive filling, there will be decreased RV filling, and rest of the things are same. If there is decreased RV filling, you will have raised JVP, as I've already told you, and you will also have decreased LV filling, resulting in hypotension. So you get hypotension here also, there also. You get raised JVP here also, there also. But the differentiating features are, when you auscultate, fluid is not a good conductor of sound. So when you try to auscultate heart sounds, this will muffle the sounds and you hear muffled heart sounds. You hear muffled heart sounds. Okay, and on the JVP you will have tall A wave, steep X descent, but absent Y descent, absent Y descent. So these points are going to help us differentiate between constrictive pericarditis and cardiac tamponade. And I think you know the raised JVP, muffled heart sound and hypotension put together, we call it as the Beck's triad. Okay, so what is missing from Beck's triad in constrictive pericarditis? You have raised JVP, you have hypotension, but you don't have muffled heart sounds here. Instead, you have pericardial knock. Okay, so here is a table that helps you to differentiate between cardiac tamponade and constrictive pericarditis. In tamponade, you will have absent Y descent. Here, both are present. In fact, Y is steep. That's what we have called as Frederick's sign. Okay. Then pulsus paradoxus. We have already discussed this in the pulse. More than 10 millimeters of mercury systolic BP drop during inspiration is pulsus paradoxus. You usually encounter that in cardiac tamponade. Okay. Then Kussmaul's sign. What is Kussmaul's sign? JVP decreases during inspiration. That's normal. But if JVP fails to decrease during inspiration, we call it as Kussmaul's sign. You get that mainly in constrictive pericarditis. Failure of JVP to decrease during inspiration. Failure of JVP to decrease during inspiration is Kussmaul's sign. During inspiration is Kussmaul's sign. Okay, so we'll take one question on this and then we will move forward. So here is our question. Just give me 1 second. My phone switched off, so I may not be able to get your comments. Okay, so here we have a question. A 48-year-old presented in a state of shock following road traffic accident. Okay, on examination, patient's BP is 60/40, so he is in hypotension. Okay, and you also notice raised JVP, or instead many times in FMG exam they mention it as distended neck veins. That's your raised JVP. And on auscultation, heart sounds were heard faint, that is muffled heart sounds. Heart sounds heard faint, that's muffled heart sounds. Which of the following is false about the condition? Following is false about the condition. So option A, you will have absent Y descent. Option B, hemopericardium. Option C, pulsus paradoxus may be present. Option D, Kussmaul's sign is very common. So can we try to answer this question? First, let's understand what's the diagnosis. Diagnosis is straightforward, right? The Beck's triad is here in this question. The patient has got distended neck veins, that is raised JVP, hypotension is there, and also muffled heart sounds are there. So Beck's triad is there, and because we have the Beck's triad, the diagnosis becomes Beck's triad is present, so diagnosis becomes cardiac tamponade, not the constrictive pericarditis. Now answer this. Which of the following is not encountered in patients with cardiac tamponade? In cardiac tamponade, Y descent is absent. That's a classical finding. So this is true statement. The most common cause for cardiac tamponade is hemopericardium, because to collapse the right ventricle, I need to have sufficient fluid accumulated there. So any other simple like nephrotic syndrome and all, we will not accumulate so much fluid easily. But trauma, bleed, you can bleed 1 liter, 2 liter into the pericardium. So you can easily end up with collapse of the right ventricle by fluid, and that's your hemopericardium. In fact, that's the most common cause for cardiac tamponade. Pulsus paradoxus may be seen. Yeah, more than 10 millimeters of mercury systolic BP drop during inspiration is typically encountered in cardiac tamponade. So this is also true. While Kussmaul sign is rare in cardiac tamponade and it is usually present in constrictive pericarditis, not in cardiac tamponade. So option D becomes our correct answer. This is a false statement, so that becomes our answer, right? Okay, so that completes our constrictive pericarditis versus cardiac tamponade. Please remember these points because in last 3 or 4 years, almost every exam or every alternate exam, there is one question asking you to differentiate between cardiac tamponade and constrictive pericarditis. So this table and the approach that we have discussed, please keep that in mind. Now going to the next part, the rheumatic fever. Mostly here questions come from the diagnostic criteria. Now, what is acute rheumatic fever? It is an infection-triggered autoimmune disorder, right? It is the post-infection multi-organ autoimmune disorder. So, of course, that begs the question. When you say infection, which infection? It is the group A beta hemolytic streptococcal infections. Group A beta hemolytic streptococcal infection. And if it is multi-organ, again comes another question. What is the most commonly affected organ? Now in the world of echocardiography, we are able to detect the cardiac involvement easily. In the past, cardiac involvement could be detected only by echo was not readily available. So only when it becomes clinically apparent we used to detect. So that time we would say cardiac involvement is not very common. But now that echo is there, we can do it for all patients and we know that cardiac involvement is the most common. Clinically may be apparent or it may be subclinical, but cardiac involvement is most common. So most commonly affected organ is going to be heart. Heart is the most commonly affected organ. Okay, so what are the other organs are affected? You can have the musculoskeletal system, and when musculoskeletal system gets affected, that's the second most commonly affected, you get migratory polyarthritis. Arthritis that jumps from one joint to the next, migratory polyarthritis. You can also have the involvement of skin. So what manifestations you get in the skin? You can get subcutaneous nodules and a rash which has a red edge and central clearing. We will call it as erythema because the redness. Marginatum, it looks like there is a margin. Erythema marginatum. That's the skin manifestation. You also have the nervous system involvement. It affects the caudate nucleus of the basal ganglia and produces what you call as Sydenham's chorea, dance-like involuntary movements. So it produces Sydenham's chorea due to caudate nucleus involvement. Okay. Apart from that, you can have other systemic manifestations. What are the systemic manifestations we can expect? Fever, right, and elevated inflammatory markers. So after a throat infection, if patients present with any of these symptoms, we will be thinking about rheumatic fever. Now for diagnosis, what criteria we are following? We are following revised zones criteria. We are following revised zones criteria. So within that, we have certain major criteria and minor criteria. The major criteria you can remember with a mnemonic cases. Like if you have rheumatic fever, you have cases. Cases are your major criteria, where C stands for the involvement of heart or carditis. A stands for involvement of joints, arthritis, the migratory polyarthritis. S stands for subcutaneous nodules, one major criteria. There is one more S, which is nothing but Sydenham's chorea. Sydenham's chorea. And E stands for erythema marginatum, erythema marginatum. These are going to be your major criteria. Okay, the other criteria like your raised ESR or CRP, fever, monoarthralgia, single joint pain, and prolonged PR interval. These are going to be your minor criteria. These are going to be your minor criteria. Okay, few extra points, and then we will come back to the diagnosis and management. The extra points is the involvement of heart. Involvement of heart in case of acute rheumatic fever. It affects all the components of the heart. Generally, it causes what we call as pancarditis. Pancarditis. So you will have pericarditis. You can have myocarditis. You can have endocarditis. You can also involve the conducting system of the heart. Literally everything in the heart gets affected. And you can also have the valves. It causes involvement of valves. So pericarditis presents with chest pain. Myocarditis, the inflammation of the myocardium makes it not contract well, so it can lead to heart failure. It can present with heart failure. Okay, endocarditis, you know the manifestations of endocarditis, like you can have splinter hemorrhages and fever and other symptoms. Valve involvement leads to valvulitis. The most commonly affected valve is going to be mitral valve, followed by aortic valve. So what it can lead to? It can lead to, mitral valve involvement can lead to mitral regurgitation. Aortic valve involvement can lead to aortic regurgitation, right? And conduction system involvement can lead to AV blocks. And when AV blocks occur, the first degree AV block can lead to prolonged PR interval, and that's what we are using as one of the minor criteria. Okay, so these are all the manifestations we can expect in rheumatic fever. Now, if I have to diagnose a case of rheumatic fever according to the revised zones criteria, I will require 2 major criteria or 1 major plus 2 minor criteria. So one of the simply asked question is, can we diagnose rheumatic fever without the involvement of heart? Yes, why not? Because it says 2 major criteria or 1 major and 2 minor. So what if I have fever, raised ESR, 2 minor done, and I have Sydenham's chorea, 1 major done, sorted, right? According to the criteria, that is also rheumatic fever. Okay. Now, when it comes to management, it's like symptomatic treatment plus antibiotics. Antibiotics are mainly for eradication of the carrier state of streptococcal infection and then prevention of future infections, because every time you get a group A beta hemolytic streptococcal infection, you can get rheumatic fever. So symptomatic treatment is like NSAIDs and all for fever, arthralgia and all. Plus, if they have developed this Sydenham's chorea, the drug of choice is valproate. Asked already, so you should be aware. And NSAIDs, and if there is valproate for chorea. The antibiotic of choice is going to be injection benzathine penicillin. 1.2 million units intramuscular once in 3 weeks. If valves are involved, lifelong. If valves are not involved, relatively shorter duration. Okay, so that completes the key points that we need to know about the rheumatic fever. Most commonly asked MCQs from this are about the criteria. Which of the following is not a major criteria, or which of the following is a minor criteria, or they will give the story and then they will ask you how many more criteria are required before we call this patient as having the rheumatic fever. So sometimes they might mention that patient has carditis, and like there is involvement of valve, and now how many more criteria are required. So one of the option will be 1 major, another option will be 2 minor, C is both A and B, D something else. So A is also right. You already have 1 major from carditis. If I get 1 more major, sorted, or if I get 2 minor, then also sorted, right? Okay. So after this, now we will progress to the neuro part. Now in the neurology, what are the important topics? So from the neuro, the important topics that I am expecting are, number 1, you are getting 1 question from headache, either from medicine or from pharmacology, mainly asking you to diagnose headache. Okay. Apart from that, we are also expecting 1 question on the current stroke management guidelines, because they have been revised in the recent times, stroke management guidelines. Then you may get 1 question on either myasthenia gravis or GB syndrome. Invariably you get 1 question between them. So these are the important topics from headache. Apart from that, from neuroanatomy, you are expecting 1 or 2 questions. Those questions are mostly going to be from the brainstem lesions. So in the anatomy, sir will cover. Please don't miss that, because strongly I'm expecting that there will be a question, one question on the brainstem lesions. Okay. Now before we begin more discussion, let's touch a little bit of physiology, and then we will start with the remaining important topics from neurology. Repeatedly asked template again, the differentiation between upper and lower motor neuron lesion. So we know that there is one motor neuron bringing the motor signals from the motor area of the brain to the spinal cord. That is our upper motor neuron. Another taking that signal from the spinal cord to the neuromuscular junction, that is going to be our lower motor neuron. So whenever you have upper motor neuron lesion, you will have spasticity and hyperreflexia. So we are trying to use some basic parameters like the tone, deep tendon reflexes and plantar reflex, and presence of atrophy and fasciculations. Weakness will be present whether upper motor neuron is damaged or lower motor neuron is damaged. The brain will not be able to communicate with your muscle. Okay, so those who are not aware of the neuroanatomy, let me tell you, if this is the brain, in the brain just anterior to the central sulcus, we have a motor area. This is what we call as motor area. This is where the motor command signals originate. Motor command signals originate. This is Brodmann area number 4. So from here, the motor neurons bring the signal through the brainstem. This is brainstem. Then this is going to be your spinal cord, and then from the spinal cord, a lower motor neuron. So this is going to be your upper motor neuron, and in the spinal cord you have lower motor neuron that takes the signal to the neuromuscular junction, and then the muscle contracts. So whether I cut the upper motor neuron or the lower motor neuron, I will lose control on the muscle and I will have weakness. But when we examine tone, it is the lower motor neuron which is constantly stimulating and keeping the muscle in a partially contracted state, which we call as tone. So lower motor neuron is responsible for tone, and this upper motor neuron tends to suppress the tone. So if lower motor neuron is damaged, it is responsible for tone. If it is damaged, the tone will decrease or disappear. Upper motor neuron is actually suppressing the tone. So if I damage it, suppression is gone, the tone increases. So upper motor neuron lesion leads to hypertonia. The specific type of hypertonia that we get here is called as spasticity. It is called as spasticity. And in case of lower motor neuron damage, we will end up with hypotonia, decreased tone. And we can also call this as flaccidity. The muscles are no longer partially contracted, they all become flabby. That's why we use the term flaccidity. Okay. Then when it comes to the deep tendon reflexes, again lower motor neuron is part of the reflex arc. So whenever you hit the tendon, the signal goes to the spinal cord through a sensory nerve, and then spinal cord sends a motor signal through lower motor neuron to contract the muscle, and the reflexes get executed. So lower motor neuron is responsible for reflex as well. So if I damage the lower motor neuron, the reflexes will diminish or disappear. So you can have hyporeflexia if there is lower motor neuron lesion. And upper motor neuron is actually acting as a suppressor of this reflex. So if I damage the upper motor neuron, suppression is gone, reflexes become exaggerated. So you will have hyperreflexia. Hyperreflexia. Now plantar reflex, when we stroke the feet from the outer lower edge and then move upwards and medially, the normal response we get in adults is flexion. The great toe goes into flexion, other toes become crowded. This is what we call as a flexor response. But if the upper motor neuron is damaged, you get opposite of it. The great toe goes into extension, other toes open out, fanning of other toes. We will call it as an extensor response. So in upper motor neuron lesion, you get extensor plantar response, which is also called as Babinski sign. It is called as Babinski sign. But if the lower motor neuron is damaged, you still retain the normal reflex, which is going to be flexor response. Okay. Then atrophy and fasciculations. Atrophy and fasciculations are hallmarks of lower motor neuron lesion, because normally your muscle has two levels of contractions. One which is already there, always there, that is the tone. That is our tone. On top of that, whenever we do voluntary work, both the cases the voluntary work is gone, the muscle cannot contract, we have weakness. But in case of UMN lesion, the resting contraction state is increased, spasticity is there. So that protects the muscle from developing atrophy. But in LMN lesion, that is also gone. Neither the muscle is doing any voluntary work, nor it is able to do the tone related work, the partial contraction. So that's why it becomes atrophied easily. It is relatively less common or rare in case of upper motor neuron lesion. Okay. So this is one table from which either from physio team or from medicine team you may get one question. Okay. Now let's start with the first major topic, that is myasthenia gravis. Now what is myasthenia gravis? Myasthenia gravis is a neuromuscular junction disorder. And if you are talking about neuromuscular junction disorder, we should also be able to tell whether it is a presynaptic neuromuscular junction disorder or a postsynaptic neuromuscular junction disorder. Okay, so basically how the neuromuscular junction works, we create acetylcholine and store them in vesicles inside the nerve terminal. This is the nerve terminal, the end of the lower motor neuron, nerve terminal, basically the end of lower motor neuron. We have stored acetylcholine in them. Whenever we want to contract this muscle, we send a signal from the brain. That's an electrical signal. The signal travels all the way to reach the end of the lower motor neuron. Once the signal reaches here, remind you, it is an electrical signal. The moment the signal reaches here, I have to release the acetylcholine. So I have to convert the electrical signal to a chemical signal. So how will I couple it? This coupling is achieved by something called as voltage gated calcium channels. It's there in the name, right? What is the name? Voltage gated calcium channels. So these are your voltage gated calcium channels. They will open only when the voltage of this membrane increases beyond a certain threshold. When that increases, whenever I send a signal from the brain, then only voltage increases. So once that occurs, the calcium flows in from the extracellular fluid to the nerve terminal, and this calcium facilitates rupture and release of acetylcholine. So once these vesicles rupture, we release the acetylcholine, and once I release the acetylcholine now gets into the nerve terminal. Once it comes to the synaptic cleft, on the other side of the synaptic cleft we have these acetylcholine receptors. These are primarily the nicotinic type of acetylcholine receptors. Nicotinic acetylcholine receptors. And once the receptors get activated, the muscle contracts. Okay. And once the muscle contraction is done, this acetylcholine, this is going to be your acetylcholine particles. This acetylcholine gets broken down by the acetylcholine esterase, so that the muscle does not continuously be in a contracted state. So acetylcholine gets broken down to choline and acetate by acetylcholine esterase. This is how a neuromuscular junction works. Now in our body, we can produce antibodies against the acetylcholine receptors, blocking its functioning. Then we will call it as myasthenia gravis. Similarly, we can also produce antibodies against the voltage-gated calcium channels, blocking its function. So calcium cannot come in. So if calcium cannot come in, I can't release acetylcholine, I can't contract the muscle. We will call that as Lambert-Eaton syndrome. So Lambert-Eaton syndrome, the antibodies are affecting the nerve side. Myasthenia gravis, the antibodies are affecting the muscle side, right? So that's why myasthenia gravis will be considered as post-synaptic, while Lambert-Eaton will be considered as pre-synaptic, right? So myasthenia gravis is a post-synaptic neuromuscular junction disorder. Post-synaptic neuromuscular junction disorder. Okay. Now, in case of the myasthenia gravis, what kind of disease it is? Is it an infectious disease, congenital disease? Is it an autoimmune disease? Yes, we are talking about antibodies which are targeting your own protein. So it has to be autoimmune disorder. It is an autoimmune disorder. Autoimmune disorder. It is more common. Being an autoimmune disorder, of course, it will be more common in females, that too middle-aged, and patients with thymomas. If you have thymus gland tumors, there is increased risk of developing myasthenia gravis. Okay. Now, the hallmark of myasthenia gravis is repeated use of muscles makes it more weak. Use of muscles worsens weakness. While in case of Lambert-Eaton, repeated use of muscle strengthens the muscle rather than making it more weak. That's the classical difference between the two. And all our diagnostic tests are going to rely on this. Repeated use of muscles worsens the weakness. Okay. Now, what antibodies are present in a patient with myasthenia gravis? Of course, we know the most common antibody that is present in myasthenia gravis patient is going to be anti-acetylcholine receptor antibody. Anti-acetylcholine receptor antibody. This is the most common antibody. It is present in more than 85% of cases. Okay, but apart from that, some patients can also have the second most common antibody. They may not have this acetylcholine receptor antibody. The second most common antibody is anti-muscle specific kinase or anti-MuSK antibody. Some people may not have this also because this is present in around 10% patients. The remaining 5% patients, you will have another antibody which is called as anti-lipoprotein 4 receptor antibody. This is the least common antibody. Okay, now in myasthenia gravis, you have a sequential involvement of muscles. So what is the earliest affected muscle? The earliest affected muscle in myasthenia gravis is going to be levator palpebrae superiores, because the more we use the muscle, as I have already told you, it becomes more weak, right? Levator palpebrae superiores is constantly used for blinking, so it becomes the weakest first. So you end up developing ptosis. Ptosis is going to be your earliest symptom. Okay. After that, yes, ptosis is going to be the earliest symptom. Okay. After that, extraocular muscles are also constantly used to see here and there, here and there. So they fall next. So after this, you have extraocular muscles involved. So that results in diplopia. After that, you might have involvement of large muscles which are there in the proximal body parts. So you can have proximal muscle involvement. The proximal muscle involvement can lead to proximal myopathy or proximal muscle weakness. Okay. After that, you can have the facial involvement, facial muscles. Facial muscle involvement can lead to drooping of face. If you have facial palsy, one side the face droops, the other side pulls it. But now bilateral, because this is not a unilateral disease. So both the sides the face droops. No side is pulling it. Both the sides just droops. So you will have drooping of face. And the drooping of face, these patients, if you ask them to give a smile, they can't give you an electric bright smile. They can't lift the lateral edge of the lips. So they can only lift the center a bit, showing the teeth. And now we call that finding as myasthenic smile. Myasthenic smile. Once upon a time, we used to call it as the snarling face, because their face looks like the snarling expression of a dog, but then it is gross, so we don't use that term anymore. We call it as myasthenic smile. This is the sequence of progression of the disease. If the patient has presented early and you have only involvement of the head neck region, that is ptosis, diplopia and all, you will call it as ocular myasthenia gravis. But once they present with the involvement of rest of the body, you will call it as generalized myasthenia gravis. Now for diagnosis, what investigations we do? There are a long list of investigations. We will learn it from the MCQ perspective. The most sensitive one and most specific one. The most specific one is finding the antibody, that is anti-acetylcholine receptor antibody. If clinical feature is suggestive of myasthenia gravis and you find the antibody, well, it is a case of myasthenia gravis only. You don't think about anything else. Yes, the most sensitive one is going to be single fiber electromyography. Tensilon test is not routinely performed because in tensilon test we are giving an acetylcholine esterase inhibitor. So when I inhibit the acetylcholine esterase, I am not only selectively inhibiting it in the neuromuscular junction of the skeletal muscles, it also inhibits in all other locations where acetylcholine esterase activity is there. And by inhibiting acetylcholine esterase everywhere, we build up acetylcholine everywhere, and acetylcholine is part of the parasympathetic nervous system. So you activate parasympathetic nervous system, so that can lead to various complications, like you can have a constricted pupil, you can have increased secretions. This is what we call as cholinergic crisis. So we can push the patient to cholinergic crisis, and because that risk is there, we generally don't do it routinely. Only in selected circumstances we do the tensilon test. Okay, we will talk a little about the single fiber electromyography because that is where the exam seems to be going into right now. Okay, so what do we do in single fiber electromyography? So in single fiber electromyography, you try to stimulate one single muscle fiber repeatedly, and you will see the muscle's action potential. The more force it is generating with the contraction, proportionately action potential that results will be high, right? So if you notice that the muscle action potential after each stimulus goes on decreasing, that means the force of contraction went on decreasing, that means you have myasthenia gravis. But if the muscle's action potential goes on increasing, that means it is likely Lambert-Eaton syndrome, right? So on repeated stimulation, if you have decreasing compound muscle action potential, we will call it as decremental response. And if you have increasing compound muscle action potential, we will call it as incremental response. Incremental response. You should also be aware that this decremental response is also termed a little differently. Like if I give a stimulus and go on recording the muscle action potential, let us say first stimulus was like this, and then the second action potential turned out to be like this, the third like this, third next like this, action potential went on decreasing. So this is what you call as decremental response. Here, this was a probably full contraction of the muscle. Then the muscle progressively started contracting partially. Eventually, it stopped contracting, right? These partial contractions are also called as jitter in English. Jitteriness. That's not a full contraction, just a jitter. So I can say there is decremental response, or I can also say increasing jitter. Instead of contractions becoming full, they started becoming jittery. So they also address decremental response as increasing jitter. Increasing jitter is nothing but decremental response, and the vice versa is true. Decreasing jitter means incremental response. So instead, if the graph looks like the mirror of it, first was a jitter, next was a jitter, I stimulated again, jitter. Eventually, it started becoming full contractions. So these were jitters, these are full contractions. So the jitter went on decreasing. Decreasing jitter. So they can use any of these terminologies. You should be aware. The decremental response is classical of myasthenia gravis, while you get incremental response in Lambert-Eaton syndrome and also botulism. Also botulism. Okay, clear? So now once we have diagnosed, when it comes to the management of myasthenia gravis, here basically there are antibodies which are blocking the acetylcholine receptors. Okay, and now basically there is a competitive inhibition of the acetylcholine receptors by the antibodies. So I want to make the acetylcholine win instead of antibodies. How can I make the acetylcholine win? I have to decrease the antibodies, increase the acetylcholine. So how will I increase the acetylcholine? We know that if I block acetylcholine esterase, acetylcholine will increase. So we use acetylcholine esterase inhibitors. Plus, how can I decrease the antibodies? We can decrease the antibodies by giving the steroids or immunosuppressants, because antibodies are produced by B lymphocytes and plasma cells. So if I suppress them, they don't produce the antibodies. That's why the general management of myasthenia gravis primarily focuses on number one, acetylcholine esterase inhibitors to increase the acetylcholine, and the drug of choice here is going to be pyridostigmine because it is long acting and doesn't cross the blood brain barrier. So that's going to be your drug of choice. Second, you can use steroids or immunosuppressants to decrease the antibodies. And then many patients have thymus gland abnormalities. Like if you have thymoma, getting rid of the thymoma reduces the disease severity, and maybe you can become drug free. At the same time, patients who have this acetylcholine receptor antibody positive myasthenia gravis, acetylcholine receptor antibody positive myasthenia gravis, their antigen against which actually body is producing antibodies is sitting in the thymus gland itself. So even in these positive patients, removal of the thymus gland is useful. That's why selected patients we might consider thymectomy if patient has thymoma, or if patient has anti-acetylcholine receptor antibody positive myasthenia gravis aged less than 55 years. Higher age, the surgical risk is high, so that's why we don't go for it. But if you have a tumor, you have to go for it even if the person is elderly, because the mediastinal tumor can compress mediastinal structures. So even if myasthenia gravis doesn't harm the patient, the thymoma can kill the patient. So that's why thymoma is there, we operate it regardless of the age. But if thymoma is not there, you have this antibody positive, then we consider thymectomy up to the age of 55 years, not beyond that. Okay, so that completes our myasthenia gravis. Few points about Lambert-Eaton syndrome. Lambert-Eaton syndrome is also a neuromuscular junction disorder, but it is presynaptic NMJ disorder. Presynaptic neuromuscular junction disorder. Here in Lambert-Eaton syndrome, it is not an autoimmune disorder, rather it is a paraneoplastic syndrome where a cancer is producing the antibodies and not your immune cells. Which antibody is produced? You have anti-voltage gated calcium channel antibodies. Anti-voltage gated calcium channel antibodies. And as I've already told you, it's not autoimmune, it is paraneoplastic syndrome. And because it's a paraneoplastic syndrome, they can ask you a question, what is the most common cancer that is associated with Lambert-Eaton syndrome? It is the small cell lung cancer. Small cell lung cancer. How do I diagnose it? We can rely on the single fiber electromyography. Single fiber electromyography, if it is myasthenia gravis, will show a decremental response or increasing jitter. This is your decremental response. And if I have Lambert-Eaton syndrome, this is a response I get. We get incremental response. Incremental response. Okay, so that completes our myasthenia gravis versus Lambert-Eaton as well. The next neurotopic we have is GB syndrome. Now, what is GB syndrome? Myasthenia gravis was a disease of neuromuscular junction. GB syndrome is a disease of peripheral nerves. It's a polyneuropathy, or rather polyradiculoneuropathy. And the reason for this is again autoimmunity, but this autoimmunity is triggered by your own, it's triggered by an infection. So can I say that this is an infection triggered autoimmune polyneuropathy? The most common infection responsible for this is going to be Campylobacter jejuni. Most common infection responsible is Campylobacter jejuni. But other infections are also known to trigger. COVID, Mycoplasma pneumoniae, long list. Even some vaccines have been implicated in triggering the GB syndrome. Okay. Now here, you do get certain antibodies in GB syndrome. Let me put a separate slide because they have started asking questions on the antibodies. So what are the antibodies we are getting in GB syndrome? So in case of myasthenia gravis, we had 3 antibodies. Anti-acetylcholine receptor antibody, the most common one, anti-MuSK antibody, the second most common one, and anti-lipoprotein 4 receptor antibody, the least common one. Right? Here also we have certain antibodies. The first antibody is going to be anti-ganglioside M1 antibody. The second one is anti-ganglioside D1A antibody. And the third one is anti-ganglioside Q1B antibody, right? So these are the antibodies that we get in GB syndrome. And depending on which antibody is produced, the spectrum of the disease changes. If you have anti-GM1 antibodies, these antibodies actually target the myelin sheath. They cause demyelination. So it produces a type of GB syndrome called as acute inflammatory demyelinating polyneuropathy. We will call it as AIDP, acute inflammatory demyelinating polyneuropathy. So the nature of injury here is going to be demyelination. But if I am producing anti-GD1 antibodies, these antibodies cause the injury to the axons, not the myelin. So you will develop 2 possibilities. One is called as AMAN. The other one is called as AMSAN. Both are axonal injury type of GB syndrome. AMAN stands for acute motor axonal. It's there in the name, acute motor axonal neuropathy. AMSAN stands for acute motor plus sensory axonal neuropathy. Both are axonal injury. So if at all they ask you which one of them is actually a pure motor variant, right? This is one with its pure motor variant. There is no involvement of sensory neurons here. All other variants have involvement of sensory also. Okay. Now anti-GQ1B produces something called as, here it predominantly affects, it causes the demyelination as well as axonal injury. Demyelination more than axonal injury. But it only affects the sensory neurons. It doesn't affect the motor neurons. That is peculiarity of it. It is like opposite of the AMAN. AMAN only affects motor neurons. Anti-GQ1B antibodies only affect the sensory neurons, and we will call this as Miller-Fisher syndrome. Miller-Fisher syndrome. Okay. Now, what is most common variant? The most common variant is going to be AIDP. AIDP is the most common variant. Miller-Fisher syndrome is not very common. It is rare. Miller-Fisher syndrome is the rare variant. Okay. Now, how do I remember which antibody for which variant? This is a simple trick. You know, in India, there are category-based reservations for pursuing education or jobs and all. So there is one category, general merit, and other categories, right? So in terms of population, the largest population is the one that belongs to general merit category. So most common category among population is general merit. Most common type is AIDP. So for the most common type, you have the most common antibodies, the general merit. And in India, whenever you go to malls, airports and all, where we have to follow the queue, we rarely follow the queue, right? So for rare thing, we have queue antibodies. We rarely follow the queue. So if you remember that, then for the pending types, you can use GD1 as the antibody. In terms of prognosis, the worst prognosis is carried by Aman and Amsan, poor prognosis. AIDP carries good prognosis, Miller-Fisher syndrome carries good prognosis. Why Aman and Amsan carry poor prognosis? The reason is simple. Here you have injury to the axons. It is difficult for the body to heal axonal injury. It is easy to remyelinate. That's why we tend to see better response in AIDP. Miller-Fisher syndrome, both are there, sir, axonal injury as well as demyelination. So why are you saying that this has good prognosis? Well, remember, the common cause for death in GB syndrome is the ascending paralysis reaching the respiratory muscles and causing respiratory muscle paralysis. So causes for death in GBS. Death in GBS. Number 1, respiratory paralysis or respiratory failure. If your respiratory muscles are not able to contract, you can't breathe, right? That's one of the cause. That is the most common cause for death in GB syndrome. Second, because it's a polyneuropathy, even the autonomic nervous system can get affected. So you lose the control on the heart rate and you can develop the arrhythmias. So arrhythmias due to autonomic dysfunction is the second most common cause for death. The second most common cause for death in patients with GB syndrome. Okay. So in case of Miller-Fisher syndrome, it is predominantly affecting sensory neurons. It is not affecting motor neurons. No motor involvement. So if there is no motor involvement, I will not develop respiratory muscle paralysis. So if I am not developing respiratory muscle paralysis, I may not die. That's why the prognosis is good, right? So this carries poor prognosis. This carries good prognosis, and so is the AIDP. This carries good prognosis. Miller-Fisher syndrome, if it is only affecting sensory, what manifestations we can expect? So in Miller-Fisher syndrome, one of the extremely common finding is developing sensory ataxia. So these patients have sensory ataxia. Why do they have sensory ataxia? Because the sensory neurons are damaged, motor neurons are not damaged, and the proprioception, the positioning of joints that brain is constantly getting information from, is also helping us maintain our posture. But once the sensory information to the brain is gone, we will not be able to maintain the balance. You will have sensory ataxia, and if the sensory neurons are damaged, even if you try to do the reflex examination, the information is not going to the spinal cord. Motor neurons are fine, they can send a signal for the muscle to contract, but the signal is not going to the spinal cord first, that you are hitting the tendon. So you will develop areflexia, sensory ataxia, areflexia. Okay, and you can also have the weakness of eyeball muscles, so ophthalmoplegia. This is collectively what we call as the triad of Miller-Fisher syndrome. There is no or minimal motor weakness, minimal motor weakness. And if there is no motor weakness, the prognosis is generally good. Okay. So now we know the different types of GB syndrome, and we can also predict which type this GB syndrome is going to behave like based on the antibodies. If it is GM1, AIDP, general merit, AIDP, most common. Q is rare, Miller-Fisher syndrome, the rare variant. GD1 for Aman and Amsan. So if I have a GB syndrome patient with GD1A antibody positivity, then I know this patient is not likely to do well, right? We can predict the prognosis. Jaideep, good, very good. Okay, now comes the diagnosis. How will I diagnose? Well, we diagnose with the help of clinical features and laboratory investigation, and collectively we have a criteria named as Brigton's criteria. It's called as Brigton's criteria. It's actually a scoring based criteria, but I will keep it simple. What can be asked in the exam? So according to Brighton's criteria, there are 5 parameters listed, and based on the presence or absence of these parameters, we come out with the different levels of confidence for diagnosis, like definitive diagnosis, possible diagnosis, probable diagnosis and all. Not required for the exam. We just need to know what are the criteria listed here. The first one is rapidly progressing ascending paralysis. Rapidly progressing ascending paralysis. Patients with GB syndrome, because peripheral nerves, whenever peripheral nerves get affected, there is a sequential involvement of longest neuron first, followed by next longest, followed by next longest, and the longest neurons are going to the distal body parts, the ones that are going to the feet, ones that are going to the hands, so they get affected first. And then the next longest, then the next longest, so it creates the perception of ascending paralysis, rapidly progressing ascending paralysis. Point to note here is the progression lasts for less than 4 weeks. Progression lasts for less than 4 weeks. Less than 4 weeks. If you have progression lasting for more than 4 weeks, you start thinking about something else as the diagnosis and less likely to be GB syndrome. And because it is a lower motor neuron disease, so always keep in mind GB syndrome is peripheral nerve disorder, and you know this from our basic neuro that in the peripheral nerves we have lower motor neurons. Upper motor neuron is there in the pyramidal tract, in the spinal cord and brain. In the nerves we have the element. So it's an element disease, and because it's an element disease, in the element disease we will have decreased tone and decreased reflexes, right? This is basically a element disease. So you will have hypotonia, which is also called as flaccidity, and you will have decreased or absent reflexes. We will call it as hyporeflexia or areflexia. So these are your clinical parameters used in the diagnostic criteria, plus 2 lab parameters. What are those? One, you can do nerve conduction studies, which can tell you whether there is demyelination injury or axonal injury. So it can also help you to identify the type, whether it is AIDP or AMAN or AMSAN. So nerve conduction studies suggest you of either demyelination, as in case of AIDP, or axonal injury, as in case of AMAN or AMSAN. Okay. The last one is CSF. So basically these are, GB syndrome is an antibody mediated autoimmune disorder. There is no cell mediated autoimmunity. So that's why in the CSF only antibodies increase. The cells in the CSF remain normal. But in all other conditions, like if you talk about meningitis, meningoencephalitis, meningitis be it viral, bacterial, fungal, tubercular, you have cell count and protein both increasing. The relative degree of increase in the protein might vary. Like in viral there is minimal increase. In case of bacterial and tubercular there is maximal increase, but proteins, cell count both increase. So they are always going together, hand in hand. But in this case, being a pure antibody mediated disorder, you will have antibodies are basically immunoglobulins, they are proteins. So in the CSF protein increases but cell count doesn't. This phenomenon we will call it as albuminocytological dissociation. Dissociation between albumin, that is protein, and the cells. So on CSF we get albuminocytological dissociation. Lot of MCQs on GB syndrome mention this albuminocytological dissociation in the description, so that helps you to pick up the GB syndrome as the diagnosis, right? So this is what we call as Brighton's criteria. 3 clinical parameters, 2 lab parameters. So with the help of this, once you have established that this is a case of GB syndrome, how will we manage? Basically, the antibodies that body has produced, the GM1, GD1, GQ1, these are the ones which are causing either demyelination or axonal injury, and that's why neurons one after the other are losing the function. If I remove these antibodies from the patient's body, then the ongoing injury stops, and then maybe body will start recovering or healing. The myelin remyelination starts, axonal injury slowly, Valerian regeneration starts. So my goal is to mainly remove the antibodies which are already formed in the body. Steroids have no role here because steroids suppress production of antibodies, but already produced antibodies will still continue to cause the damage to the neurons. So that's why the best bet is to remove the already formed antibodies. How we can remove? we can remove the already formed antibodies by one, either you can go for plasma exchange or plasmapheresis, we will call it as PLEX, or you can give IV immunoglobulins which can neutralize the antibodies, right? So this is the mainstay of treatment for GB syndrome. But also remember, what is the most common cause of death? These patients can die because of the respiratory failure. So we need to monitor them for developing respiratory failure. Once the respiratory system fails, after that ventilator is the treatment till their nerve functions and muscle function recover. But I should not wait for the blood oxygen levels to drop and then intubate. I should preemptively intubate before I reach that stage, and I can predict who will require ventilator by regularly monitoring the FVC, forced vital capacity monitoring. And if the FVC becomes less than 15 ml per kg, that is where intubation and mechanical ventilation is indicated. This is a potential MCQ. At what FVC level the current guidelines recommend to put the patient on ventilator? Later his saturation may drop, but before the saturation drops, we should ideally place him on ventilator when the FVC is less than 15 ml per kg, right? So that completes our GB syndrome management. Okay, the next topic we have is stroke. Now, what is stroke? Stroke refers to focal or global neurological deficits of vascular origin. Means when you have a blood vessel problem resulting in loss of function of some part of the brain or all of the brain, we will call it as stroke. So there are two types of stroke in that case. We have ischemic stroke, where the blood vessel is blocked by either atheromatous plaque or the clot, that is ischemic stroke, or the blood vessels can rupture and bleed, that will be hemorrhagic stroke. What is more common? The ischemic stroke is more common. Ischemic stroke cases are accounting for 85% of the stroke patients. Hemorrhagic stroke cases account for around 15% of stroke cases. Okay. Now there is also a term called TIA. So what is TIA stands for? TIA stands for transient ischemic attack. Now what is transient ischemic attack? So there is a clear description. If two of the there are two parameters, if both the parameters are met, I can call that patient as having transient ischemic attack. What are those? Focal or global neurodeficits improving within 24 hours plus no infarct on imaging, then you will call it as TIA. Means both the parameters should be there. Let us say someone developed one right-sided hemiplegia and after 2 hours he improved. But when we get a CT scan done, there is a large infarct sitting there. We will not call that as TIA. That will still be considered as stroke because infarct is visible, then it is stroke. But if patient recovers and on the imaging you find no left behind damage, no infarct is visible, then we will call it as TIA. Within 24 hours without infarct, that's the important point. So in one of the FMGE there was a question. So they had mentioned that patient improved within 6 hours or something. And they had also mentioned as one sentence that patient had a right MCA tertiary infarct. And they are asked what is the diagnosis. Ischemic stroke, hemorrhagic stroke, TIA. More than 90% students jump to label it as TIA because symptoms have improved within 24 hours. 6 hours is the time that this patient had taken. But because infarct was there, it becomes acute ischemic stroke, not the TIA. Okay. Now the patients with TIA are at increased risk of developing stroke. And we can use the scoring system called ABCD2 score to predict the risk of stroke. So they will only ask you what are the components of this ABCD2 score. It is pretty easy to remember because it itself is a mnemonic. A here stands for age, B stands for blood pressure, C for clinical features, D for duration of symptoms, another D for diabetes. That's why ABCD 2. Okay, so age more than 60 years, 1 point. BP more than 140/80, 1 point. Clinical features, if patient has unilateral weakness, means hemiplegia, 2 points. But if he has speech impairment without weakness, 1 point. Those are clinical features. Duration of symptoms, how long the symptoms lasted before showing the recovery. If it lasted for more than 60 minutes, 2 point. 10 to 59 minutes, 1 point. If recovery occurs within 10 minutes, 0 points. And if patient is diabetic, 1 point, right? So points you have to remember is what are the components of ABCD2 score. They will ask which of the following is not a component of ABCD2 score. So just a simple mnemonic, so we can remember that. Now, when do I consider that as the high risk? So remember, if the score is more than or equal to 6, we will count it as high risk of stroke. You already have TIA. Now, if the score is more than or equal to 6, you have a high risk that you will end up with stroke in the near future. Okay. Now, this is not important ABCD2 imaging. It's more of for the INI-CT. So, I just want you to remember the regular ABCD2 score. Now comes the stroke. As we have already learned, the stroke can be ischemic or hemorrhagic, and we know I can't treat both the strokes the same way. If it is ischemic stroke, I need to take steps to re-establish the blood flow. If it is hemorrhagic stroke, I need to take steps to prevent the further blood loss into the brain. So poles apart treatment, so I need to have the clarity. Okay. So whenever we are suspecting a case of stroke, early recognition is very, very important, and then quickly sorting out whether it is ischemic or hemorrhagic is very, very important. So for early recognition, it's not me recognizing early that matters. It is the patient's family members who need to recognize it early. Because once they come to me, I can quickly examine and recognize, but if they come to me quite late, then me recognizing in 5 minutes makes no sense if they recognized after 24 hours, right? So that's why early recognition by laymen is facilitated by educating them about something called as BFAST algorithm. So what BFAST algorithm says? The BFAST algorithm says B for balance, E for eyesight, F for facial asymmetry or drooping of the face, A for the arm weakness, S for speech impairment. If patient or patient's family members notice any of these findings in them, like he's having issues with balance or some issues with vision, or one side face is drooping, or one side arm is not able to lift, or he is having speech issues like not able to understand speech, that is Wernicke's aphasia, not able to produce speech, that is Broca's aphasia, then without wasting the time they should get the patient to hospital. T here stands for time. So this is for the layman to recognize stroke early. And once such patients come to the hospital, even the clinician cannot spend a lot of time examining, so we also have to recognize the stroke early. So as clinicians, we can recognize the stroke early by a sign called as Barry's sign or pronator drift sign. This is the also called pronator drift sign. It is the earliest sign of stroke. Even before a detailed examination can show there is muscle weakness, this can help you to quickly recognize the stroke. This is the earliest sign of stroke. So basically what we do is we ask the patient to hold their hands outstretched in supine position, and whichever side is weak, that side they will not be able to hold it in supine position. The hand starts drifting down and it starts pronating. This is what we call as pronator drift sign. Pronator drift sign. This is for the clinician to quickly recognize. Once you have recognized that this patient is having stroke, patient's family members recognize with BFAST, you recognized with pronator drift sign or Barry's sign, and then you have to approach further. At this point of time, it is stroke. Whether it is ischemic or hemorrhagic, we don't know, right? We have to investigate. So what is the investigation of choice? Once you have a case of stroke clinically apparent, we go ahead with the non-contrast CT. Non-contrast CT, and if feasible, this is current 2026 updated guideline. If feasible, if you have the facilities, along with the CT, go ahead with CT angio. CT angio. If not, at least get the non-contrast CT done. If the CT shows bleed, if bleed is present, that means it is hemorrhagic stroke. CT is highly sensitive for detection of bleed. So if bleed is present, it is hemorrhagic stroke. And if there is no bleed, you don't have to see the infarct. If there is no bleed, it is counted as, because CT confidently rules out hemorrhagic stroke, we can count it as ischemic stroke. So if there is no bleed, it is ischemic stroke. Okay. Now if it is hemorrhagic stroke, the management is mainly by the surgical team, so we leave it to the surgeon. But if it is ischemic stroke, we have to manage in medicine, medical management, right? So how do we approach further? If you have a case of ischemic stroke, if you have a case of ischemic stroke, there are a few things that we can do in the emergency room. In the emergency room, you have to assess their airway, breathing, circulation, and also equally important is we have to assess the GCS. If the GCS is less than 8, patient may not be able to protect their airway. They are at risk of, they are at increased risk of aspiration pneumonia, and that's why they should be put on, we should be intubated, and if required, put on mechanical ventilator. We have to go ahead with intubation to prevent aspiration, Anesthesia also, you might have studied about this. This is an important MCQ point. At what level of GCS intubation is indicated in patients with stroke? Okay. Then you have to also consider administration of antiplatelets. Okay. That too, you might think of using two antiplatelets, dual antiplatelets, aspirin and clopidogrel. Generally, we give it for first 21 days, but you should give only if patient is not a candidate for thrombolysis. If the patient is a candidate for thrombolysis, you should not be administering the antiplatelets, at least at the presentation, because giving thrombolytics plus antiplatelets both together increases the risk of major internal organ bleeding. 24 hours after thrombolysis, you can reassess whether to start the antiplatelets now. But in the initial stage, you will not give if the patient is going for thrombolysis. If you are not doing thrombolysis, you can administer antiplatelets. Okay. You can also administer statins in the emergency room. But this is not the definitive management. This is part of the basic stabilization. The definitive management is you have a blocked blood vessel, you need to open it. So how can I open that blocked blood vessel? The definitive management of ischemic stroke is going to be revascularization, means opening the blocked blood vessel. There are two ways you can do that. So let us say this is one blood vessel, and inside that I have this block. Either I can dissolve this clot by giving thrombolytic agents, or just like the angioplasty that we do for the heart, I can pass a wire and retrieve this clot out. So when I put a wire and retrieve the clot out, we will call it as, either you can call it as mechanical thrombectomy, that had been the traditional word for many years. Now current guidelines use the term EVT. It stands for endovascular thrombectomy, means from inside the blood vessel you are removing the clot, you are not cutting the blood vessel to remove the clot. So it's called as endovascular thrombectomy, EVT or mechanical thrombectomy. Which one is better, or which one gives better result? The definitive management is going to be revascularization, and the EVT gives better result than thrombolysis. The success rate of thrombolysis is less than 50% cases. Same applies to the heart, right? So there also the angioplasty has better success rates than thrombolysis. That's why for the heart, the preferred treatment is going to be angioplasty and not thrombolysis. Only when angioplasty is not feasible, we go for thrombolysis. But in case of stroke, the scene changes a bit. This EVT is not possible for all blood vessels, because brain's blood vessels are quite tortuous. So I can't reach every possible location in the brain with the guide wire. In the heart, right coronary artery, left coronary artery, all the blood vessels we can reach with the guide wire. So we can do angioplasty for almost all blood vessels in the heart. I can't do that for the brain. So if there is a occlusion of a large blood vessel where our guide wires can reach, then we can do EVT. But thrombolysis does not have that limitation. Success rate is less, but thrombolytic agents through blood can reach everywhere, right? So that's why even now, when the patient presents, we start with the thrombolysis, and if it is a suitable candidate for EVT, we go for endovascular therapy, right? That's why I said when we are diagnosing initially, if feasible, in the same sitting, get the CT angio also done, because CT angio tells you which blood vessel is blocked, and then you can decide whether the endovascular thrombectomy is feasible or not. If it is feasible, you can go ahead with it. If not, anyway, thrombolysis is there for you. Okay. So now coming to the approach that we will be following here. What decides the next move is the presentation since onset of stroke. Presentation since stroke onset. Okay, so if the patient has presented after 24 hours, by that time all the area supplied by that particular blocked blood vessel would have become infarct. There is nothing to save, everything is dead. So there is no point in doing anything specific. Revascularization is not useful after 24 hours. So in that case, we will only go for the secondary prevention. This stroke is done, I can't do anything. I can try to prevent future episodes of stroke by giving antiplatelets and statins. If they present within 24 hours, yes, revascularization is useful. Within 24 hours, revascularization is useful, because by that time, some amount of brain tissue may be still alive that I can try to save by opening the blocked blood vessel. Revascularization is useful. But what should be my strategy? Should I go with thrombolysis or mechanical thrombectomy? That depends on how many hours within the 24-hour range, how many hours after the onset of stroke the patient has presented. So if they have presented within 4.5 hours, okay, so we will go ahead with thrombolysis first. We will go ahead with thrombolysis first. It is the safest window for thrombolysis. But in 2026, the guidelines have stretched the window to 9 hours. Up to 9 hours, we can go for thrombolysis. But after 4.5 hours, we are trying to weigh the benefits and risks. Within 4.5 hours, we are going ahead with thrombolysis if there are no contraindications. But if it is 4.5 to 9 hours, 4.5 to 9 hours, we will consider thrombolysis if I still have a reasonable amount of brain tissue which is not dead. If a large part of the brain tissue is dead, there is nothing much to save, then I don't want to take the risk of giving thrombolytic agents and then cause the patient to bleed and die. So what investigations can help me to do that? We can either go with the diffusion weighted imaging or perfusion imaging. And if they show that there is large area of the brain that can be saved, we will call that area of the brain that can be saved as penumbra. So if you have a large penumbra that can be saved, then I will go ahead with the thrombolysis. If there is large penumbra present, then you can go for thrombolysis. So within 4.5 hours, you know that there will be large area of the brain which is still not dead, so you will definitely go ahead with thrombolysis. After 4.5 hours, you want to ensure that the risk that I am taking is worth. So you will do a diffusion weighted imaging or a perfusion imaging to show that there is large penumbra present. It's worth taking this chance of giving the thrombolytic agents. Okay, and if patient present after 9 hours, 9 hours up to 24 hours, in that case, thrombolysis is not a safe bet. So only thing that remains now that I can offer for the patient, I know revascularization is useful, but thrombolysis is not safe bet. We can do up to 9 hours. So I can go ahead with EVT. But EVT is feasible only if the block is there in the blood vessel where I can pass the guide wire. So I need to know now. So you have to go ahead with CT angio. If it is already done in the initial stage itself, then good enough. So you already know where is the block. If not, do it now. And if the CT angio shows large vessel occlusion, if large vessel occlusion is present, then you go for the EVT. Now the question is, what comes as large vessel occlusion, where the EVT is possible? So right now, EVT is possible if you have a internal carotid artery block. Easily you can reach there. If you have the M1 part, the first part of middle cerebral artery block, or if you have block in proximal ACA, or you have block in basilar artery, these locations we are able to do the endovascular therapy. Rest of the locations, the endovascular thrombectomy is not feasible as of now. In the future, the technology might make it feasible, but right now it is not feasible. So for all those cases where revascularization cannot be offered, we have to rely on the secondary prevention. Nothing much can be done for this stroke. Okay. So major change, the thrombolysis can be done up to 9 hours. Potential MCQ this time. Okay. So that completes our stroke. Now we will move to the nephrology. In the nephro, there are like most of the questions from nephrology actually come from your pathology, asking you to diagnose post-streptococcal glomerulonephritis, IgA nephropathy, or FSGS, HIV-associated nephropathy from the pathology slides or the descriptions. We will stick to the medicine. Pathology, Dr. Ranjit will cover. So in medicine, mostly questions are going to come from CKD and its complications, or acute kidney injury. Okay. So let's first start with the acute kidney injury, AKI. Now what do you mean by acute kidney injury or AKI? AKI is defined as either number 1, your serum creatinine increases by more than or equal to 0.3 milligrams per deciliter within 24 hours. Or your serum creatinine becomes more than 1.5 times baseline. Whatever was the previous value, it becomes more than 1.5 times of that within a period of 1 week. Then we will call it as acute kidney injury. Or the third one is related to urine output. Urine output, normally how much urine output we produce? Around 0.5 ml per kg body weight per hour. That's the minimal urine output that we produce. But if it drops less than that, 0.5 ml per kg per hour, for a period of, like sustainably it is low for a period of more than or equal to 6 hours. For a period of more than or equal to 6 hours, we will call it as acute kidney injury. Like let's take some examples. Let us say there is an individual with a creatinine of 1 milligram. Okay. So if it becomes 1.4 milligram, 0.4 milligram increase. Okay. So it satisfies the first criteria. You can say, it is a case of AKI. Let us say instead, his creatinine has not jumped by that in 1 day, but slowly it is increasing, and it becomes from 1, it becomes 1.5 on day 5. On day 1 it was 1, and on day 5 it has reached 1.5. It did not satisfy the first criteria, but now it satisfies the second criteria. Within 1 week it has become 1.5 times the original value. Original was 1, it has become 1.5. Then also it is AKI. Or let us say creatinine is not showing much change, but patient is having reduced urine output, and like we have put a Foley's catheter and we are monitoring like a post-surgical patient, and from last 4 hours he has not produced any urine output, like last 6 hours he has not produced any urine output. That is clearly less than 0.5 ml per kg per hour. Or let us say he is 50 kg individual, and 0.5 ml per kg means he should produce at least 25 ml of urine per hour. We are constantly monitoring the Foley's, and in last 6 hours he has produced, let us say, only 50 ml urine. So 6 hours, 25 ml per kg per hour should be 25 into at least 150 ml of urine he should have produced in 6 hours to say he is producing 0.5 ml per kg per hour, but it is quite less than that. So then also you can call it as AKI. Now if you have acute kidney injury, we will be classifying them into 3 categories: pre-renal, post-renal and renal. So we will classify the AKI into pre-renal, post-renal and renal. Renal and post-renal. So acute kidney injury and rise in creatinine need not always be because of the damage to kidney. Sometimes it can be because of reduced blood supply to kidney. Because see, basically what is the job of kidney? We are giving, if this is a nephron that we are looking at, this is going to be your one nephron, DCT, PCT, and a tuft of capillary here called glomeruli, and an afferent arteriole brings the blood to it and efferent arteriole takes the blood from it. So afferent arteriole brings the blood, and once the blood comes to the glomeruli, we will filter into the Bowman space, and that filter is what we call as glomerular filtrate, right? That is your filtrate. The rate at which we are filtering is glomerular filtration rate. So filtrate comes into the Bowman space, and then filtrate starts traveling down the tubules. Okay. But if I am not bringing sufficient blood to the glomeruli, then I will not be able to filter. So basically my blood has a lot of unwanted substances which we want to excrete. Like this blood is having creatinine, urea, excess potassium, all of this. We want to excrete. But for the kidneys to excrete it, first it should be brought to the kidney by blood. If I am not bringing the blood to kidney, then how can kidneys filter this? Right? So if there is renal hypoperfusion, if sufficient blood is not being delivered to kidney, they can't filter even when they are structurally normal. That is your pre-renal AKI, right? That's your pre-renal AKI. So pre-renal AKI occurs because of reduced renal perfusion, decreased renal perfusion. So in what conditions we can get it? If the patient is having hypotension, blood going to kidney comes down, or hypovolemia. Hypovolemia, of course, will have hypotension, or renal artery stenosis. Renal artery is narrow, so it's not able to bring the blood to the kidney for perfusion. Renal artery stenosis. Pre-renal AKI are the most common causes for AKI. So after a loose stool, if the patient's kidneys lose the function, it's mainly because of pre-renal AKI. Because you have lost a lot of fluid, you are dehydrated, renal perfusion is decreased, so that's why kidneys are not able to filter it. Okay. Post-renal, if you talk about, post-renal is due to the obstruction of the urine outflow. Like once the kidneys produce the urine, this goes to the bladder, as we know, and from the bladder we excrete it out. But if I have bilateral ureteric calculi, then I can't drain the urine out from the kidneys. You will end up with decreased urine output. Or if I have the bladder outlet obstruction, here it can be because of a prostatic cancer, right? Or any localized other causes, we can have impaired urine drainage. That will be post-renal. So post-renal can be encountered if you have bilateral ureteric calculi or bladder outlet obstruction, either because of bladder cancer or prostatomegaly. Bilateral bladder outlet obstruction. Okay. Now comes the renal. Renal, we have a long list of possibilities. And you do get MCQs from the renal, like path medicine integrated. Because if I'm injuring the kidney, there are so many sites of injuries that we can do for the kidney. Means I can injure the glomeruli, all your glomerular disorders, IgA nephropathy, post-streptococcal glomerulonephritis, FSGS, RPGN, they are all glomerular disorders. I can also injure the tubules, or all these nephrons are held together by connective tissue surrounding that. So I can also injure the connective tissue. So renal damage can be either at the site of glomeruli, So glomerular disorders are one set. Then you can also cause the damage to the renal tubules. Those are tubular injury or tubular disorders. And apart from that, the adjacent connective tissue, we will call it as connective tissue means interstitial nephritis. Interstitial nephritis. So these are the three sets of disorders that can cause renal injury and cause AKI. So renal AKI can be glomerular, interstitial and tubular. Interstitial nephritis is usually because of drug allergies. Interstitial nephritis is usually due to drug allergies. Drug allergies are the most common causes for the interstitial nephritis. Okay. And if you talk about the tubular causes for acute tubular necrosis, the tubular causes can be ATN, acute tubular necrosis, or drugs. Okay. And then comes the glomerular disorders. Can you name at least few glomerular disorders that present as acute condition? Because we are talking about AKI, we are not talking about CKD or chronic renal disorders. Which can present acutely? Minimal change disease, that's nephrotic syndrome, that's chronic, not acute. Yes, post-streptococcal glomerulonephritis, IgA nephropathy, these are your acute glomerular disorders. PSGN, IgA nephropathy, these are your acute glomerular disorders. Okay, so these are all causes for AKI. So we know the criteria for diagnosis, we know the causes. Now what teachers are expecting in the MCQs, they are not asking you to diagnose post-renal obstruction because that's imaging. Get a CT done, you can identify the stone, you can identify the bladder outlet cancers. Okay, what they want is whether you can differentiate between pre-renal and the renal particularly tubular, and whether you can identify interstitial nephritis from the patient's story. Okay, so let's see if we can differentiate between the pre-renal and the acute tubular necrosis. How do I recognize that this is a glomerular disorder? Glomerular disorder, if it is causing AKI, presents with the nephritic clinical picture. So glomerular disorders will have either nephrotic, but of course nephrotic is always a chronic. AKI, if you're talking about, they present with nephritic picture. Right? So we are not talking about nephrotic here because nephrotic present as chronic condition, but nephritic picture, PSGN, IgA nephropathy, they can present with it. What are the features of nephritic syndrome? They will have hypertension, they will have pedal and periorbital edema. Along with that, a patient of nephritic picture will have, when they are going through the glomerulonephritis, they will have hematuria. Hematuria with the hallmark of the nephritic picture is presence of dysmorphic RBCs. Dysmorphic RBCs. So whenever RBCs are passing through these injured glomeruli, they lose the shape, right? They get damaged and they become dysmorphic, and those dysmorphic RBCs will now be excreted in the urine. So dysmorphic RBCs is the hallmark of the glomerular disorders. Okay. Along with that, you might also have proteinuria. You might also have proteinuria. Nephrotic syndrome patients will also have hypertension, edema and proteinuria. The proteinuria will be in the nephrotic range. When do you call it as nephrotic range proteinuria? When it is more than 3.5 grams per day, or in 24 hours they are excreting more than 3.5 grams of protein. Less than that, it falls in the nephritic range of proteinuria. Okay. Now, if I have interstitial nephritis, what are the clues that I can get? Interstitial nephritis patients have drug allergy, so they will have eosinophils. Allergy means eosinophils. So they will have eosinophils in the urine. Eosinophiluria. Eosinophils in the urine. Okay. Now comes the tubular injury. How will I identify tubular injury in a given question? If it is glomerulonephritis as a cause for renal AKI, I can easily identify because glomerular injury has characteristic features. What are the characteristic features? You will have hematuria, proteinuria, and dysmorphic RBCs. In addition to that, the glomerular injury patients will have RBC casts. They will have RBC casts in the urine. The tubular injury patients will also have casts. Those casts can help you to differentiate between a glomerular disorder and tubular disorder. What cast they will have? They will have renal tubular epithelial cell cast, RTEC cast, or muddy brown cast. Muddy brown cast. So basically, what are these casts? Casts are sheets of Tom Horsfall protein. Normally, very low molecular weight Tom Horsfall protein gets filtered, and they can travel through the tubules, and in the tubules they can settle there to form a sheet. This sheet is called as hyaline cast. That is normal. Hyaline casts are normal, but these hyaline casts can get impregnated with other substances. Like I already have a hyaline cast formed here. There is one hyaline cast sitting here, and now that I have developed the glomerular injury, RBCs will be coming in the urine. So these RBCs will get embedded on this cast, and then it becomes RBC cast. And if I have tubular injury, normal hyaline cast is already sitting here, and these tubules are injured, so these tubular epithelial cells get shed, and those epithelial cells will come and occupy this cast, and then it becomes renal tubular epithelial cell cast. If you have pyelonephritis, you have infection, there will be WBCs, those WBCs will come and get impregnated here, then it becomes WBC cast. Okay. And the same renal tubular epithelial cell cast that we are talking about here, those epithelial cells can disintegrate or go into apoptosis and release lipofuscin as a pigment, and when they release lipofuscin, it takes the brown color and then it becomes muddy brown cast. So renal tubular epithelial cell cast caught early is a fresh cast. Catch them late, it becomes muddy brown cast. So these points help us to localize where is the injury if I have a renal AKI. But what is examiner's interest? Examiner's interest is not in that. Examiner's interest is in asking you to differentiate between pre-renal AKI versus acute tubular necrosis. I will never have a confusion between pre-renal AKI and glomerular disorders. A pre-renal AKI patients will not present with hematuria, dysmorphic RBCs, proteinuria and all. Only increasing creatinine and decreased urine output. Drug allergy is a total different thing. So if you have interstitial nephritis, you will have eosinophils in the urine. And also I forgot to tell you, these patients will also have, because drug allergy, right? They will also have rash. So if a patient presents with rash after taking some drugs, and then your creatinine is going high, and you see eosinophils in the urine, that's a typical story of interstitial nephritis. The most common class of drugs responsible for interstitial nephritis are beta-lactam antibiotics. So in the MCQ, the story might go like this. This patient has been given beta-lactam antibiotics. After that, he has developed a rash, creatinine is high, urine output is low, and when urine analysis is done, you are not getting any of these RTEC cast or features of glomerular injury. Rather, you are getting eosinophils in the urine. That's a potential clue. Diagnosis done. It is interstitial nephritis. If they ask you which is the most likely drug that was prescribed for this patient, you will go ahead with beta-lactam class of antibiotics like penicillins. Now, how do I differentiate between the, so real confusion comes when you have tubular injury and pre-renal AKI, because in both the cases you are not seeing much abnormalities on urine. Maybe sometimes the epithelial cast, but otherwise urine analysis is not going to reveal much until and unless I specifically look for more details. So then how do I differentiate? There is something that helps us to differentiate. It is called FeNA, fractional excretion of sodium. So what happens is in pre-renal AKI there is decreased renal perfusion. Less amount of blood is coming to the kidneys. And if less amount of blood is coming to the kidneys, what kidneys think? Oh, BP is low, that's why we are getting less amount of blood. So by default, kidneys activate RAS. So in pre-renal AKI, you have activated RAS. And when I activate RAS, like the story goes like this. If there is renal hypoperfusion, On one side it is causing the acute kidney injury pre-renal type, and the other side it is also activating RAS. And once the RAS is activated, in that RAS you have this aldosterone. Aldosterone gets to work on the renal tubules. And what aldosterones do, they go to the renal tubules and increase through the ENaC channel, increase the sodium and water reabsorption. So you start reabsorbing a lot of sodium and water if you have pre-renal AKI. And when you reabsorb sodium and water, what happens? The amount of sodium you are excreting in urine comes down. You're not excreting much urine because now kidney thinks your BP is low, we need to reabsorb most of the salt, so you excrete less salt. So what percent, like the amount of salt I gave to the kidney, and out of it how much percentage it excreted. If I look at it, we figure out that in case of renal hypoperfusion, we are absorbing most of the sodium, we are excreting very minimal quantity. So excretion of sodium decreases in pre-renal. But if I have tubular injury, then what happens? The kidneys are not activating RAS, filtration occurs normally, and sodium and water reabsorption occurs in tubules. But if I am damaging the tubules are necrosed, I will not be able to reabsorb sodium. So I start excreting a lot of sodium. So in case of tubular injury, sodium loss is increased because you are not able to reabsorb. The site of absorption is damaged. But in case of pre-renal, activated RAS means you reabsorb a lot of sodium. That's why we will take the help of how much sodium is being excreted. We will call that test as fractional excretion of sodium. We will call it as fractional excretion of sodium. In case of pre-renal AKI, we are excreting less than 1% of the sodium that we give to the kidney. It will be less than 1%. In case of acute tubular necrosis, we are not able to reabsorb, so we are excreting more than 2% of the sodium that we are giving to the kidney. This is the most important investigation to differentiate between pre-renal AKI and acute tubular necrosis. Beyond that, there are other features that help us, but this is the most important investigation. What else helps us is in pre-renal AKI, because we are reabsorbing most of the sodium and water, we are excreting concentrated urine. So you will have increased urine specific gravity, and you will also have increased urine osmolality because you are reabsorbing the water, leaving behind only solutes, so it becomes concentrated, high specific gravity and high osmolality. In case of acute tubular necrosis, you are not able to reabsorb, right? So you are excreting a lot of water, so water becomes dilute, urine becomes dilute, so your urine specific gravity will be decreased, urine osmolality will be decreased, and you will have decreased urine osmolality because you are excreting dilute urine. Here, because you are reabsorbing most of the water, you can end up with oliguria. Tubular injury patients might even end up with polyuria because you are not able to reabsorb, so you are excreting a lot of urine. So these points do help you to differentiate. If you can remember everything, good. If not, just remember FeNA. Less than 1% means less than 1% of the sodium that reaches the kidney is being excreted, pre-renal AKI, aldosterone is working there. And if more than 2% of the sodium that reached the kidney is being lost in the urine, then you are not able to reabsorb, then it is acute tubular necrosis. Okay. So that completes our AKI and approaches to some of the sub-causes of AKI. Next, we are going to talk about the CKD, chronic kidney disease. Now, in terms of CKD, what is CKD? If you have abnormal renal functions lasting for more than abnormal renal function tests lasting for more than 3 months, then we will call it as CKD. So if creatinine is elevated and it remains elevated for 3 months or higher, then it is CKD. Urine output is low for 3 months or higher, then it is CKD. Now what can cause this? The most common cause for CKD, responsible for overall 2/3 cases, is going to be diabetic nephropathy. Diabetic nephropathy. And the second most common cause why your kidneys can chronically fail, second most common cause is going to be hypertensive nephropathy. Hypertensive nephropathy. There are other causes for CKD like the chronic glomerulonephritis, lupus nephritis, FSGS. All the other causes account for very tiny cases, tiny number of patients with CKD. Most of the patients who are now on dialysis waiting for renal transplantation are either having diabetic nephropathy, hypertensive nephropathy, or a combination of both, because diabetes, hypertension often coexist, right? So other causes, you can have chronic glomerulonephritis, lupus nephritis, autosomal dominant polycystic kidney disease, right? So these are other causes. Now in the CKD, they are going to ask you mainly the complications of CKD. Once the kidneys fail, what are the complications we are expecting? So one of the complications we can expect is fluid overload, because you're now oliguric, you're not able to excrete the urine, so you develop fluid overload. Liquid is not coming out, starts accumulating in the body. So that can lead to various complications like pedal edema, ascites, pericardial effusion, pleural effusion, can lead to dyspnea, lot of complications. Okay, then second problem we are expecting is kidneys are playing an important role in the potassium homeostasis. Kidneys are the ones which are excreting excess potassium. If they are not able to do it, potassium starts accumulating, you can develop hyperkalemia. And hyperkalemia can reflect on the ECG in the form of tall T waves, and we call these tall T waves as peaked T waves. Peaked T waves. And then flattened P wave. So T becomes tall, P becomes flattened. You will also have widening of QRS, wide QRS. And then in severe hyperkalemia, you can develop sine wave. Sine wave can lead to cardiac arrest. So that means hyperkalemia can become a reason for cardiac arrest. Okay, so what are the ECG changes we are talking about? Your P wave becomes, like if this is a normal ECG that I am looking at, let us say this is the normal ECG that we are looking at. So what happens in hyperkalemia is your P becomes relatively flattened. Okay, QRS becomes widened, and the T becomes tall and sharply pointed. So you are getting this flat P or stunted P, you are getting wide QRS and tall peaked T wave. So these are the basic ECG changes you get in hyperkalemia, and these patients, especially when the QRS goes on widening, P disappears. So now imagine there is a wave where you don't have the P, you only have a wide QRS and T. So this wave is what we call as sine wave. And if the sine wave has appeared, patient is about to arrest anytime soon. Okay. So we need to manage that for sure. Okay. Apart from that, patients of CKD also develop anemia because erythropoietin is required to stimulate the marrow to produce RBCs and hemoglobin, and erythropoietin comes from kidney. If kidney is damaged, you are not able to produce erythropoietin, so you develop anemia. Okay. What other complications we can expect? Urea level starts building up, you are not able to excrete urea in the urine. So urea can lead to what we call as uremia. Uremia can cause hemolysis, that also contributes to anemia. Uremia can cause pericarditis, uremic pericarditis. Uremia can cause intractable nausea and vomiting. Patients struggle to eat once they develop uremia. And it can affect the brain function. We call it as uremic encephalopathy. Uremic encephalopathy. So these are the complications we can anticipate if you have CKD. One last complication, in fact two important ones. One of them is CKD affects the functioning of the bone. We call it as CKD related mineral bone disease. CKD related mineral bone disease. And the last one is the regulation of acid-base balance. Two organs are playing an important role. One of them is your respiratory system, the other one is your kidneys. In the body, the major acid produced is carbon dioxide. So excreting the carbon dioxide is the function of the respiratory system, right? But then at the level of kidney, it can play with the bicarbonate, and kidneys are also capable of excreting the acids. So when kidneys are not able to do that job, we can develop metabolic acidosis. So renal failure can produce metabolic acidosis. So these are the complications we are expecting in CKD. Now what questions I can expect? Hyperkalemia had been a standard template. So how do we manage the hyperkalemia is one question. They can ask you the mechanism of anemia in CKD or the management of anemia in CKD. Okay, then they can also ask you about the uremic pericarditis, also the mechanism of CKD related mineral bone disease, and of course ABG. Every exam there will be one question, right? So after this we'll go to the ABG, but first we will address some of these complications. So if you have hyperkalemia, how do you manage? Hyperkalemia management. So if you're having hyperkalemia, number one, you have to offer potassium restriction to the patient. Tell them don't eat potassium rich food like fruits. Number two, if the potassium is very high leading to ECG changes and the patient might develop cardiac arrest, we need to protect the heart. That's the first step. Whenever you have severe hyperkalemia, first protect the heart, then think about lowering the potassium. How do I protect the heart? By giving IV calcium gluconate. Calcium gluconate blunts the impact of hyperkalemia on the heart. So you can use this as a cardioprotective strategy. It's a cardioprotective strategy. Okay, third, चलेगा अभी या चेंज करना पड़ेगा? Okay. हाँ ठीक है guys, just 10 seconds because we are running the marathon for quite some time. The mic might shut off, so we will just change the next mic and then we'll continue. Just 1 minute. Okay. So calcium gluconate is mainly stabilizing the cardiac membrane, so it's a cardioprotective strategy. Okay. After that, you can use IV insulin along with dextrose. Now, how this helps? And you can also give salbutamol nebulization. Both of them work with the same principle. They shift potassium from extracellular compartment to extracellular fluid to the intracellular compartment. So your blood potassium gets shifted inside the cell, so blood potassium level comes down. Okay, and then we can also consider giving the potassium binding regimen. So if we add potassium binders to the patient's intake, then whatever potassium that has come through the food in the GIT tract, that will get bound to these potassium binders and we will prevent its absorption. We will lose them in the stool. So one of them is kyaxalate, which is basically a potassium binder. So these are the steps we can take to treat hyperkalemia. If that doesn't work, all of these measures don't work, yes, we can do the job of the kidney with the help of machine, that is going to be dialysis. So one last bet is dialysis. So initially we try to manage with this. If that does not help, we go for dialysis. Okay. Next comes the anemia of CKD. Anemia of CKD. It is due to mainly erythropoietin deficiency. Erythropoietin deficiency is the main reason for anemia of CKD, but beyond that there are other contributory factors that we should be aware. So what are the contributory factors? You know, as I have already told you, high urea leads to severe intractable nausea and vomiting, and because of that the patients can have a reduced intake. So iron deficiency and other nutritional deficiency is almost always encountered in most of the patients. So it's mainly EPO deficiency, erythropoietin deficiency. But in addition to that, there can be nutritional iron deficiency, and then uremic hemolysis. As I've told you, high urea causes hemolysis, so there is also increased destruction. And patients of CKD also are more prone to develop bleeding. So bleeding somewhere can also be a contributory factor. If they're asking what is the main reason, it is the erythropoietin deficiency. Why am I listing the other causes? Because when it comes to treatment, if the patient also has an added iron deficiency, and if I stimulate the bone marrow with erythropoietin, it will still fail, because to make RBCs we need the iron. So if I don't have iron, I can't make hemoglobin, I can't make RBCs. That's why all patients of CKD, first step is to assess the iron store. If the iron store is adequate, start with erythropoietin. If not, first replenish the iron store and then start the erythropoietin. Okay, clear? Now if it is pure EPO deficiency, no other contributory factor, what kind of picture I will get? In that case, I will get normocytic normochromic anemia. It's like any other anemia of chronic disease, normocytic normochromic anemia. But if added iron deficiency is there, you will end up seeing microcytic hypochromic anemia. So when it comes to the management of anemia of CKD, we will begin by first iron store assessment. So if iron deficiency is present, and if there is no iron deficiency, if there is no iron deficiency, you progress with the erythropoietin or darbepoietin therapy, because kidneys are not able to produce it, we will give it from outside. But if iron deficiency is present, in that case, first iron replacement. And of course, we are not relying on oral iron replacement here. We always go ahead with the injectable iron replacement like ferric carboxymaltose. And after the iron replacement is done, then we go ahead with erythropoietin or darbepoietin therapy. This is going to be our anemia of CKD. Okay. Next comes your CKD related mineral bone disease. CKD MBD or CKD related mineral bone disease. So what happens in CKD? So in CKD, just give me 1 second because I'm not getting updated with the comments. Yeah, iron sucrose or ferric carboxymaltose can be used. Ferric carboxymaltose is better tolerated in terms of administration and the risk of anaphylactic reactions in comparison to iron sucrose. But yes, iron sucrose is much more cheaper. But depending on the patient's affordability and circumstances, we can use sucrose or ferric carboxymaltose. Nowadays, we prefer using ferric carboxymaltose. Okay. So whenever we have CKD, kidneys are not able to excrete the phosphate. So there is CKD results in impaired phosphate excretion. Impaired phosphate. Prashant Kumar, okay. We'll complete the CKD MBD and then we will take a 10 minutes break and then we will resume again. Okay, so there will be impaired phosphate excretion and that will result in increased fibroblast growth factor 23, FGF23. Last INI-CT they had asked the question on this. What is the earliest marker of CKD related mineral bone disease? It is going to be increased FGF23. Earliest marker, because you have impaired phosphate excretion, but before that blood level reaches the range where you can say there is hyperphosphatemia, even before that you will see FGF23 going high. Earliest marker of CKD related mineral bone disease. Eventually what happens? Impaired phosphate excretion leads to hyperphosphatemia. Hyperphosphatemia. And once hyperphosphatemia develops, hyperphosphatemia will lead to, because increased phosphate and decreased calcium stimulate the parathyroid gland to produce parathormone. So there will be increased parathormone production. This increased parathormone production, we will call it as secondary hyperparathyroidism. Why are we calling it as secondary hyperparathyroidism? Because if the gland itself is problematic, gland itself is unnecessarily producing excess parathormone because of a tumor or hyperplasia, we will call it as primary. The gland is normal here. It is being made to produce more parathormone because of hyperphosphatemia. That's why we are calling it as secondary hyperparathyroidism. Okay. Once the PTH increases, PTH has various sites of action. So one of the site of action is bone. So what PTH does to the bone? It will activate the osteoclasts and increase the bone resorption, trying to squeeze the calcium out from the bone. This is how the bones are becoming weaker. Okay. So there will be increased osteoclastic activity. And this results in increased bone turnover and formation of what you call as brown tumors in the bone. If we get an X-ray done for the spine, if they're having the CKD mineral bone disease, you can also see something called as a Rugger Jersey spine. Okay. Then the parathormone also works at the level of kidneys. So parathormone facilitates the reabsorption of calcium more from the kidney. You will have increased renal reabsorption of calcium. So you will excrete less urine in the calcium. Urinary excretion of calcium decreases, reabsorption of calcium from urine increases. That's how you're trying to get more calcium back into the blood. Third site of action is your intestines. So parathormone also increases the intestinal absorption of calcium. You will absorb more calcium from the intestine. But we should remember here that the parathormone do not directly act on the intestine to absorb the calcium. It is the vitamin D which actually facilitates the absorption of calcium in the intestine. That's why whenever we give calcium, we also give vitamin D along with that to facilitate the calcium absorption. Then what is the role of parathormone here in calcium absorption? Well, parathormone actually activates stimulates the kidney to produce a hormone or an enzyme, not hormone, an enzyme which converts inactive vitamin D to the active vitamin D, and that active vitamin D is the one which is actually facilitating the intestinal absorption of calcium. And which is that enzyme? The enzyme is 1-alpha hydroxylase. 1-alpha hydroxylase. But unfortunately in CKD what has happened? Kidneys are damaged, so you are not able to produce 1-alpha hydroxylase. So CKD also leads to decreased production of 1-alpha hydroxylase by kidney. And if you have less 1-alpha hydroxylase, you are not able to convert the 25 hydroxycholecalciferol, the inactive form of vitamin D. You are not able to convert that to 125 dihydroxycholecalciferol, the active form. This conversion is lost. That's why you will have decreased intestinal absorption of calcium. So this will result in hypocalcemia. This will result in hypocalcemia. So this hypocalcemia is also activating the parathyroid gland to produce more parathormone. So you have two reasons for hyperparathyroidism here. One, decreased production of 1-alpha hydroxylase by the kidney resulting in hypocalcemia. Number two, hyperphosphatemia, because you are not able to excrete the phosphate. Both together increase the parathormone levels. The increased parathormone level is now trying to fight back to give you more calcium in the blood, but in the process it squeezes the calcium out of the bone, makes the bones weak. We will call it as CKD MBD, or CKD related mineral bone disease. Okay. Now if I have to treat it, how can I treat it? One, yes, I have to reduce the phosphate intake. I can't do anything to increase the phosphate excretion, but I can reduce the phosphate intake. So there is dietary restriction of phosphate, and we have phosphate binders. Just like how we had the potassium binders, we have phosphate binders. Okay, one. Second, I have to suppress the parathormone production. If I suppress the parathormone production, then the bone breakdown comes down. How do I suppress the parathormone production? I can trick the parathyroid gland to believe that sufficient calcium is there in the blood and you don't need to produce it. Right? How do I trick it? Well, simple. So if I have to manage the CKD related MBD, number one, we have to phosphate restrict the patient, phosphate restriction. Number two, you can use phosphate binders that bind the phosphate and stop it from getting absorbed. An example is sevelamer. Sevelamer is a phosphate binder that we can use. Number three, you can tell the parathyroid gland that there is sufficient calcium in the blood, you don't have to produce, by giving vitamin D, vitamin D3 plus calcium supplementation, so that whatever calcium you are getting gets absorbed in the intestine. For absorption we need vitamin D. So you are telling the parathyroid gland that okay, we are building the calcium level, so you don't have to work. Plus we can use calcimimetics. Calcimimetics, because on the parathyroid gland we have calcium sensing receptors called CASR, CASR. If I can create a substance that actually behaves like a calcium and tells the CASR that okay, I am there, then parathyroid gland need not produce the PTH, right? So calcimimetics are basically mimicking the calcium on the receptors of the parathyroid gland. The receptor is calcium sensing receptor. So they mimic the calcium on the calcium sensing receptors, and the drugs are like cinacalcet or etacalcide. So these are the calcimimetics. Those can be given to tell the parathyroid gland that okay, so these act like calcium on the gland and tell them that okay, we are there, so you don't have to release the parathyroid hormone so that bone doesn't get broken down. Right? This is how we are going to manage the CKD related mineral bone disease. Okay, now we'll go for a 10 minutes break. Once we're back, we will resume our discussion. We will have some discussion on the ABG because we are anticipating one question there, and then we will take the rheumatology topics. Okay, 10 minutes and we will be back. Guys, welcome back, and I hope I'm audible. So just give me a thumbs up if I'm audible to all of you and you're able to see me. Okay, so we were talking about CKD complications. We have covered some of them. The most important thing that we need to address now is going to be the metabolic acidosis, and for that we should be able to detect the metabolic acidosis in the ABG. So we'll spend some time understanding the ABG. Just give me 1 second. I will connect with the YouTube. Okay. Just 1 minute before we go to ABG, we will also learn the indications for dialysis in CKD. There can be questions on that as well. So indications for dialysis, initiation of dialysis in CKD patients. Well, there is one absolute indication which is going to be uremia. If you have very high urea and it is leading to complications, you have to initiate dialysis. There is no conservative treatment available for uremia. So if you have uremia, like if you have uremic symptoms like pericarditis, encephalopathy, then you have to go for dialysis. To go for dialysis. This is an absolute indication. This is an absolute indication. Everything else is a relative indication. Means you can try to manage them conservatively. Right? We just learned that hyperkalemia, we can have calcium, we can give calcium gluconate, dextrose with insulin, salbutamol nebulization, potassium binders. If I have metabolic acidosis, you can even give sodium bicarbonate. So you have conservative steps first. When they fail, you go for dialysis. But if uremic symptoms, directly go for dialysis. There is no other way to manage them. So remaining all are relative indications. Like fluid overload, you can give diuretics. If diuretics don't work, then you go for dialysis. Hyperkalemia, you have anti-hyperkalemia measures. When they don't work, you go for dialysis. Metabolic acidosis, you can give bicarbonate. When that cannot correct the pH to acceptable range, then you go for dialysis. So these are relative indications. While uremic complications are absolute indications. Okay. Now let's go to the most important part, ABG. Now in the ABG, let us take one or two examples and then learn to approach them. So I'm giving you one ABG picture here. So where the pH of the person is 7.38 and PaCO2, let us say it is 100, okay, let me keep it as 28 millimeters of mercury, and bicarbonate here is 15 millimoles per liter. Sodium of the patient is 140 milliequivalents per liter, and the chloride of the patient is 100 milliequivalents per liter. This is one ABG. I have another ABG here. pH is 7.5. PaCO2 is 10 millimeters of mercury, and bicarbonate is 12 milliequivalents per liter. This much data we have on the second ABG. Okay. So now tell me, the ABGB, what is the diagnosis? ABGB, what's the diagnosis? Is it metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis? And then we will come to ABGA. So you are all familiar with the simple approach, right? We begin by looking at the pH. if the pH is less than normal, it is acidosis, and if it is more than normal, we will call it as alkalosis. So here the pH is more than normal. Okay, so those who are not aware, let me write the normal ABG parameters. What are the normal ABG parameters? The pH is supposed to be in the range of 7.35 to 7.45. That's normal, right? And in case of PaCO2, it is similar number, 35 to 45 millimeters of mercury. And bicarbonate is supposed to be 22 to 26 milliequivalents per liter. Okay, so here pH is more than normal, so you can certainly call it as alkalosis. So you have alkalosis, and once you encounter alkalosis, you know you will follow the Rome or ROMS approach to identify whether that is whether that is metabolic or respiratory. You will assign a direction to the pH, whether it is increased or decreased, and you will assign the direction to the PaCO2, not the bicarbonate, PaCO2, whether it is increased or decreased. PaCO2 normally is 35 to 45, it is decreased here. According to the Rome or ROMS criteria, if they are in the opposite direction, it is respiratory opposite, metabolic same side. So by default, this becomes pH more than 7.45, so alkalosis, and pH and PaCO2 are in the opposite direction, so respiratory. Diagnosis becomes respiratory alkalosis. That's easy. But what about this? Is it normal, no acid-base disorder, or there is an acid-base disorder? What do you think? Himalayan, yes, absolutely right. This was respiratory alkalosis. But what about this? pH is in the normal range. So can I say this is normal, no acid-base disorder? No, I can't say that, because when I look inside the ABG, PaCO2 is not normal, bicarbonate is not normal, only pH appears normal. So it is basically a compensated acid-base disorder. Means whenever, okay, let's get back to some basics. In our body, the main acid is carbon dioxide, which is produced by the tissues as end product of the Krebs cycle and metabolism. Carbon dioxide, when dissolved in water, it becomes carbonic acid, that is H2CO3. H2CO3. This H2CO3 can dissociate into H plus and bicarbonate. And you know what? According to the chemistry, anything that can donate a proton, that is H plus, is an acid. So because this H2CO3 can donate a H plus, it is an acid, right? We call this as carbonic acid. So the major acid in the body is the carbon dioxide, and major base is bicarbonate. Now the balance of the acid and base is giving you the pH of 7.35 to 7.45. Now imagine one circumstance. We are weighing in a weighing scale. Let us say we are looking at a weighing scale, and in one of them we have placed carbon dioxide, which is basically acid, and in other one we have bicarbonate, which is basically the base. Their perfect balance gives you the pH range of 7.35 to 7.45. If base increases, you have alkalosis. If acid increases, you have acidosis. Now, let us say for some reason I have carbon dioxide buildup in the body. I am not able to exhale the carbon dioxide. My respiratory system has failed. So carbon dioxide is increased. If carbon dioxide increases, the weighing scale starts tilting towards acidosis because this has become heavy. Now if I have to counter this, what should I do with the base? Should I decrease the base or increase the base? Should I decrease the base or increase the base? Just imagine holding a weighing scale. So this side is becoming heavy because more carbon dioxide is added. So I have to make the other side also heavy so that the base gets, the scale gets back to balance. So every time acid increases, the bicarbonate increases to compensate for it. So that the pH is brought back to the normal range. And the same thing I can say, if I increase the base, we tilt towards alkalosis, then I can increase the carbon dioxide, that is acid, so that the scale gets tilted back to normalcy, right? So if the compensatory mechanism is strong enough to push the pH back to normalcy, then we will call it as fully compensated acid-base disorder. Let us say I have too much of carbon dioxide, so pH is now dropped down to, let us say, 7.2. Then the kidney starts conserving the bicarbonate, reduces the bicarbonate excretion. So then slowly pH starts correcting back. Let us say it has come to 7.3, not fully normalized yet, right? Still you have the pH in the abnormal range, not fully normalized, but it is making an effort to get it normalized. That means you have partial compensation. But if I am accumulating acid, but base is not increasing at all, accumulation of acid has resulted in an acidic pH, base is not compensating, base is not rising at all, then we will say non-compensated abnormality. So when do we call it as fully compensated? When the counter mechanism has normalized the pH, we will call it as fully compensated. If the counter mechanism has shown improvement, like shown the change required, but has not normalized the pH, partially compensated. No movement from the compensatory arm, then uncompensated abnormality. Okay, that is one terminology we need to have clarity. Second, from this experiment we also understand that if I increase the acid, to counter that I have to increase the base. If I decrease the base, to counter that I have to decrease the acid. So whatever is the primary abnormality, the compensatory change follows the same direction, right? So 2 points we have learned. Point number 1, the primary abnormality and compensatory change follow same direction. If PaCO2 is increasing, to counter that bicarbonate has to increase. If bicarbonate is increasing, to counter that PaCO2 has to increase. If bicarbonate is decreasing, to counter that the PaCO2 should decrease. This is what the meaning of this statement. Second, if the compensatory change gets the pH back to normal, change normalizes pH, then we will call that abnormality as fully compensated abnormality, fully compensated acid-base disorder. Let us say carbon dioxide increases, to compensate for that bicarbonate increases, and if the bicarbonate increase is sufficient, then your pH may be normalized. So if pH is normalized, then it is fully compensated. But when you look inside the ABG, you will notice that carbon dioxide and bicarbonate both are increased. They are not in the normal range. Okay, clear? So that means this pH is not fully compensated. This is not a fully compensated acid-base disorder. But this is, when I see bicarbonate and PaCO2, they are abnormal, but pH is normal. Then I can call this as fully compensated. So we will build an algorithm that you can apply to any such question, so that you can deal with all the ABG questions. So whenever you get an ABG question, first thing I want you to see is look at the pH. Okay, if the pH is clearly outside the range, means if the pH is less than 7.35, then you know it is clearly acidosis. And if it is less than 7.35, you can't call it as fully compensated for sure. pH has to be normal to call it as fully compensated. And if it is more than 7.45, it is alkalosis. This much we know. But if the pH is in the normal range, that is 7.35 to 7.45, now two possibilities are there. What are those two possibilities? One, either you don't have any acid-base abnormalities, fully normal, or you may be having fully compensated acid-base abnormality. That's why when I get this pH, I will see PaCO2 and bicarbonate values. If they are also normal, then there is no acid-base disorder. no acid-base disorder. Means everything is normal, pH is normal, bicarbonate is normal, PaCO2 is normal, so I'm not thinking about any acid-base disorder. But if they are abnormal, that means you have a fully compensated acid-base disorder. Either PaCO2 is increased or decreased, or bicarbonate is increased or decreased, then you have fully compensated acid-base disorder. And diagnosis becomes fully compensated acid-base disorder. Now, in case of fully compensated acid-base disorder, how will I identify whether the primary abnormality was acidosis or alkalosis? We should also keep in mind that when the compensatory change occurs, it will never, like let us say I am increasing carbon dioxide, so then pH has dropped down to less than 7.35, and when I start adding bicarbonate, the compensatory change will never overshoot the primary change. Means it can bring this pH back to a max of mid-range, means less like 7.4. It will not take it beyond 7.4. To take it beyond 7.4, I need to add a base beyond the degree of acid accumulation. That body doesn't do. So we can use 7.4 as the cutoff. On this side of the pH, less than 7.4, you will count it as acidosis if it is fully compensated. And if it is more than 7.4, you will count it as alkalosis. So if the pH is in the normal range but PaCO2 and bicarb are abnormal, then you will look at the pH again. But this time, our range of reference is not 7.35 and 7.45, absolute number of 7.4. So if now it is less than 7.4, then you will call it as, and if it is more than 7.4, you will call it as alkalosis, and less than 7.4, you will call it as acidosis. Okay. Approach is clear so far? So this is going to be our step 1. Based on the pH, deciding whether it is acidosis or alkalosis, even when it is fully compensated. Now what is going to be my next step? Step number 2 is to, once we have decided acidosis versus alkalosis, step number 2 is to know whether it is metabolic or respiratory. So step number 2 is metabolic versus respiratory. So for that, basically we are following the ROMS. So what ROMS says, you have to assign the direction to pH and PaCO2. pH and PaCO2. If both of them are in same direction, if they are in opposite direction, it is respiratory. If both of them are in the same direction, then it is metabolic. Respiratory opposite, metabolic same, right? That's the mnemonic. So now let's take this knowledge and apply to the two problems that we had seen. So let's first approach this ABG. Simple. What is the first step? See the pH. This is what the algorithm says. See the pH. Here it is more than 7.45. So my diagnosis becomes alkalosis. So pH wise, I have come to the diagnosis of alkalosis. After seeing the pH, we have to see whether it is metabolic or respiratory. So for that, we have to assign a direction to the PaCO2 and pH. pH compared to normal, it is increased here, and PaCO2 normal is 35 to 45, compared to normal it is decreased here. So they are in the opposite direction. pH is going up, PaCO2 is going down. They are in the opposite direction. Respiratory opposite, metabolic same. That's ROMS. So that makes it as, because they are in the opposite direction, respiratory is the one which follows opposite. So that becomes respiratory alkalosis. So diagnosis here going to be respiratory alkalosis. Now, can we identify what is the primary abnormality here and what is the compensatory change? So when we see, we know the bicarbonate is also decreased here. Normal bicarbonate is 22 to 26, that is also decreased. Okay. So is PaCO2 the primary abnormality or the bicarbonate the primary abnormality? Is bicarbonate decreasing because PaCO2 has decreased, or is PaCO2 decreasing because bicarbonate is decreased? Well, the answer for that lies in what are we blaming. So if you are blaming respiratory, then carbon dioxide becomes the primary abnormality. According to ROMS, if the conclusion has turned out to be metabolic, then the primary abnormality will be labeled as bicarbonate. So here the primary abnormality is PaCO2 decreasing, and to compensate for that, the HCO3 is decreasing. Okay, and because HCO3 is decreasing, we will call it as there is compensation going on. Carbon dioxide decreased, HCO2 is responding by decreasing. So compensation is going on, but not sufficient enough to correct the pH back to normal. So what we learn here, compensation is there, but not strong enough to get the pH back to normalcy. So we will call it as partially compensated. So diagnosis here becomes partially compensated, partially because pH is not normalized, but compensated because bicarbonate is decreasing in response to decreasing PaCO2. So we will call it as partially compensated respiratory alkalosis. This is the full diagnosis. Of late they have started touching the chords of full diagnosis, so we should be aware. They are not restricting to simple diagnosis of respiratory alkalosis. Now coming to this picture, what is the first thing we should see? pH. pH is 7.38, so it is in the normal range. So if we encounter pH in the normal range, we should see what is happening to carbon dioxide and bicarbonate. If they are also normal, then fair, no acid-base disorder, but they are abnormal, then we have a fully compensated acid-base disorder sitting there. Now I have to unmask it. So when I see here, pH is low, pH is normal, but PaCO2 and bicarbonate are decreased. They are not normal. So that means we have a fully compensated disorder here. What is it? We will figure out. But there is certainly an acid-base disorder present which is fully compensated. And once we have a fully compensated acid-base disorder, now our pH range shrinks to 7.4. Less than 7.4, we will count it as acidosis. More than 7.4, we will count it as alkalosis. So here it is less than 7.4. So it will be counted as acidosis. So I will add the tag of acidosis. And once it is acidosis, now I have to decide metabolic or respiratory. So for that again we have to assign the directions to pH and PaCO2. Please remember, in case of fully compensated, the pH cutoff is 7.4. So we have to see whether it is less than 7.4 or more than 7.4. So it is definitely less than 7.4. That means pH is decreased. And when you look at the PaCO2, PaCO2 also is decreased. Normal is 35 to 45. So both are in the same direction. Both are in decreasing direction. So according to RAMS, respiratory opposite, metabolic same side. So this becomes metabolic because they are in the same side. So we will revise our diagnosis now to fully compensated metabolic acidosis. Now once we have come to the conclusion that this is fully compensated metabolic acidosis, now we have to identify what is primary abnormality and what is the compensatory change. As I have already told you, if you are blaming respiratory, you blame carbon dioxide. If you are blaming metabolic, you have to blame kidney, the bicarbonate excreter or reabsorber. So if it is metabolic, you should look at the bicarbonate. Bicarbonate will be the primary abnormality. So here bicarbonate has decreased. Okay, to compensate for decreased bicarbonate, carbon dioxide is also decreasing. So PaCO2 is a drop in PaCO2 is the compensatory change. It is the compensatory change. Understood? So this is how we reach the diagnosis of ABG disorders. Now if we have metabolic acidosis, there are some additional things that we need to know. Because metabolic acidosis can occur because of two reasons. One, the decrease in the base. But sometimes metabolic acidosis can also occur because of addition of extraneous acids in the body. Extra acid addition in the body. Like for example, you have diabetic ketoacidosis. So in diabetic ketoacidosis, keto acids are produced in the body. So that's an extra acid added to the body. Or if I am taking salicylic acid intake, like aspirin toxicity, an acid is being added to the body. Or ethylene glycol poisoning, some acid is being added to the body. So we can identify whether it is just the abnormal regulation of the base and acid in the body that is causing metabolic acidosis, or an extraneous acid is being added to the body by calculating the anion gap. Anion gap. So if you have metabolic acidosis, you have an additional step, that is to calculate the anion gap. So how do we calculate anion gap? And you know, like we do get a lot of questions on anion gap. So normally, ideally speaking, there should be no anion gap. Why? Because in the body, the positively charged and negatively charged substances, are the ions, are an equal number. Because otherwise, if you have disparity in the charge, the electrons flow and literally you become a battery and like an electrical current. So we always achieve that homeostasis. Positive and negatively charged ions in our body are in equal number. Then from where this anion gap is coming? Anion gap is coming from the unmeasured anion, because when we measure anions and cations through blood test, we are not measuring all the anions and all the cations that exist in the body. So anion gap is basically the gap because we are measuring some anions, some cations. Okay. So what are the cations we are measuring? The cations we are measuring is mainly the sodium. Sodium is positively charged, that's the main cation. But am I measuring the calcium? That's also cation. Am I measuring the magnesium, Mg+2, Ca+2? We are not measuring them, right? So anion gap is the difference between measured anions and measured cations. It's not the true gap that exists in the body. Okay, sodium. And then the main anions, the negatively charged anions that we measure are chloride and bicarbonate. Chloride and bicarbonate. So this is cation and these are anions. If I measure every possible cation, every possible anion, the gap should be 0, but because we are measuring some here, some there, we get a gap. So this gap is normally normal anion gap is 8 to 12 milliequivalents per liter. That's the normal anion gap. If, like, let us say I am adding salicylic acid to my body, I take some 10 aspirin tablets with the intention to kill myself. So I am adding salicylic acid to the body, right? So they become salicylate, which is again an anion. So when we add some anion in the body, these bicarbonates or chloride shift, mainly chloride shifts into the intracellular compartment. Okay, let's try to understand this. So we have perfect balance of cations in the body and anions in the body. Okay, now you add an extra acid from outside, you add into this system. This acid is usually like salicylate, it becomes a negatively charged substance. So you are adding some extraneous negatively charged substances. So let us say I added some extra acid. So when I add this extra acid, the other anions shift into the intracellular compartment, or we clear them. Okay. Thus we achieve the balance again. But once you have achieved the balance, when you go to the measurement, this time when you measure here, you are getting only 4 molecules of anion. So you created a gap, right? You created a gap. This gap is actually filled by this extra acid that we have added. So whenever you get an acidosis where you have an increased anion gap, that means this acidosis is not because of the imbalance of base acid in your own body, but an extra acid being produced or added to your body. Okay. So if the gap is more than 12, if anion gap is more than 12, you will call it as high anion gap metabolic acidosis. All you have to think is an extra acid being added to the body. And if it is less than 12, you will consider it as non-anion or normal anion gap metabolic acidosis, HAGMA and NAGMA. So can we calculate this anion gap also for this patient, because this ABGA has metabolic acidosis. So you have to also calculate the anion gap. So to calculate anion gap, I need sodium, chloride and the bicarbonate values. So sodium is mentioned here 140, right? So sodium is 140, that is our cation, minus anions are chloride is 100 plus bicarbonate, which is 15. So how much the gap I am getting here? 140 minus 115. So that's equal to 25, yeah, 25. So 25 milliequivalents per liter is the anion gap. So that this 25 that we are seeing, normal is 12. So that 13 extra we are seeing, no, it's actually because those 13 amount of anions have shifted to intercellular compartment, because from outside we have added some acid. That's why you are creating that gap, right? So that means this case is a fully compensated metabolic acidosis that can be called as high anion gap metabolic acidosis. So if they are giving you questions, they give something similar to this, and then they will ask you which of the following is least likely cause, or which of the following is the most likely cause. So once you recognize that this is high anion gap or normal anion gap metabolic acidosis, then you have to be aware of the causes so that you can identify whether it is this particular cause is likely or not. So what are the high anion gap metabolic acidosis causes? There is an easy mnemonic to remember. The mnemonic is mud piles: methanol, uremia, diabetic ketoacidosis, fenformin and parahaldehyde exposure, INH and iron therapy, lactic acidosis, ethanol or ethylene glycol, and salicylic acid poisoning. The same thing you can remember with other mnemonic, like gold mark is another mnemonic. It's the same. Mud piles is the popular mnemonic, so just remember that. I generally don't make an attempt to remember as well, because it's simple. In all these examples, you see something extra is being added. Methanol is added, urea, extra amount of urea is added. In diabetic ketoacidosis, ketone bodies are added. These are drugs which are added. Lactic acidosis, extra lactic acid is added. Ethanol is added to body, or ethylene glycol is added to body, or salicylic acid is added to body. So when an extra acid gets added to body, you develop high anion gap metabolic acidosis. So that also means that uremia is causing high anion gap metabolic acidosis. That means the acidosis of CKD is going to be high anion gap metabolic acidosis. Okay. Then what are the causes for non-anion gap metabolic acidosis? The mnemonic is used part: urinary diversion, okay, small bowel fistula, diarrhea, pancreatic fistula, Addison's disease, renal tubular acidosis. These are all the non-anion gap metabolic acidosis. The mnemonic is used part. If they are asking MCQs, right, the most commonly what do they ask is, so remember this, the CKD and diabetic ketoacidosis, these both are high anion gap metabolic acidosis, while the renal tubular acidosis, RTA, renal tubular acidosis is where your kidneys are either not able to excrete the H plus ions or not able to reabsorb bicarbonate. So there is nothing extra being added there, just the abnormality of H plus excretion or bicarbonate reabsorption. You end up with renal tubular acidosis. In that case, it will be non-anion gap metabolic acidosis. This is what I want you to remember, right? So this is going to be our approach to the ABG. So once we are done with the ABG, let's go now to the rheumatology. Okay. Now, what are the important topics in rheumatology? Most of the questions in rheumatoid come from either SLE or rheumatoid arthritis. Rheumatoid arthritis will be covered in ortho with all the deformities. You are expecting an image-based question on the deformities. From medicine, we are expecting questions on SLE. In the SLE, most questions come on the antibodies and their correlation. Antibodies and their correlation, or maybe some organ complications. Then the scleroderma. Again, in the scleroderma also, most of the questions are about antibodies and their correlation, or sometimes image-based questions. Okay. And then rheumatoid arthritis and mixed connective tissue disorder, right? These are the important topics from rheumatology. So let's start with the SLE first. All the rheumatological disorders, the MCQ templates are pretty simple. Number one, all these are autoimmune disorders, right? So there will be antibodies, we should be aware about antibodies. But apart from that, to cause the organ inflammation and damage, some inflammatory cytokine is involved. So they will ask which is the principal cytokine. For example, rheumatoid arthritis, it is TNF alpha, which is causing the joint damage. So in case of SLE, it is going to be interferon 1. interferon 1 is the principal cytokine which is responsible for all the organ inflammation. Okay. Then they will also ask you what are the most common manifestations of SLE. So if you have to talk about the most common manifestations, SLE is a multi-organ disease. So most common cutaneous manifestation is going to be malar rash. Malar rash, the butterfly rash with the nasolabial fold sparing, which is photosensitive, is the most common skin manifestation. SLE also affects the heart. The most common cardiovascular system manifestation is going to be pericarditis. Pericarditis is the most common serious manifestation of SLE. Okay, but beyond pericarditis, the SLE affects all the components of the heart. So it can cause endocarditis, it can cause myocarditis, it can cause valvulitis. So when it causes endocarditis, it is not infective endocarditis. The inflammation is because of SLE. So we will call this is a sterile endocarditis, and we will call this as Libman-Sachs endocarditis. It is called as Libman-Sachs endocarditis, a sterile endocarditis that you encounter in SLE. Okay. It also increases the risk of ischemic heart disease. Ischemic heart disease. The most common cause for death in SLE patients is still ischemic heart disease. Okay. Then it can affect the central nervous system. What it causes to the central nervous system? Cognitive dysfunction. The patients of SLE generally have their thought process very slow. Like if I am having SLE, then I may be repeatedly getting stuck while teaching, like, okay, what am I supposed to say next? What am I supposed to say next? What do we call it as? We will call that as brain fog, which is a form of cognitive dysfunction. Brain fog. It also affects the respiratory system. What it causes to the respiratory system? The most common manifestation in respiratory system is pleuritis. Pleuritis is the most common respiratory system manifestation of SLE. Okay. Apart from that, SLE can also lead to shrinking lung syndrome, means a type of restrictive disorder where the lung starts shrinking. Its total lung capacity decreases. We will call it as shrinking lung syndrome. So in shrinking lung syndrome, the total lung capacity and forced vital capacity decrease. Okay, so it can also involve the musculoskeletal system. The most common musculoskeletal system manifestation is going to be polyarthritis, multiple joint inflammation. These are the organ manifestations. Now when it comes to the diagnosis of SLE, we need to have ANA positivity plus a score of more than or equal to 10 points on ACR Euler criteria. You don't have to by heart the ACR Euler criteria, unlikely that they will ask in detail, but you just be aware that we need at least 10 points on the ACR Euler criteria plus ANA positivity should be there. Okay, we will discuss more about the antibodies because that is where we are expecting the questions, but before that, one quick understanding of management. SLE is a multi-organ autoimmune inflammatory disorder, right? So we have to reduce the inflammation by trying to target the underlying inflammatory cytokines. The drug of choice for management of SLE is hydroxychloroquine. It's a blanket treatment. It is given for all patients of SLE if there is no contraindication. But for patients with advanced disease, this may not be enough. We might have to think of more advanced drugs. So what else we can use? We can also add steroids to the patients along with hydroxychloroquine. Hydroxychloroquine is for all cases if no contraindication. What else we can use? We can use a drug called belimumab, and there is one more drug called as anifrolumab. So from Pharmac you do get questions about them. Belimumab is a B lymphocyte stimulant inhibitor. B lymphocyte stimulant inhibitor. So if you inhibit the B lymphocytes, then B lymphocytes are the ones which are producing antibodies. So if you suppress them, antibody production comes down. And what is this anifrolumab? Anifrolumab is a very specific targeted therapy for SLE. It is an interferon 1 blocking monoclonal antibody. This is an anti-interferon 1 monoclonal antibody. It's there in the name, right? Anifrolumab, anti-interferon 1 monoclonal antibody. Okay, so these are the drugs that we have for the management of SLE. Now coming to the antibodies and their correlation. The first MCQ they will ask you is what is the most sensitive antibody? Most sensitive is the most common antibody. Most sensitive and most common antibody. So most sensitive and most common antibody is going to be ANA. In the ANA they might also ask you what is the method that can be used for ANA detection, because there are so many methods and all of them are not comparable or reliable. So preferred method of ANA estimation is going to be indirect immunofluorescence. Preferred method for ANA estimation is going to be indirect immunofluorescence. Indirect immunofluorescence, that too using Hep2 cells. Immunofluorescence using Hep2 cells. More of a pathology point, but you should be aware. And to call it as positive, the titer should be more than or equal to 1:80. A titer of 1:40 is positive in 5% of the general population, even when they don't have any symptoms related to SLE. Okay. Then if they're asking you what is the most specific, ANA is not most specific because of course, as I have already told you, more than 5% of the general population has some weak ANA positivity. So that doesn't make it very specific at all. The most specific is anti-Smith antibodies. Anti-Smith antibodies is the most specific. Okay. Then the second most specific and second most common is same. Second most specific after anti-Smith in terms of specificity, and also second most common after ANA. That is going to be anti-DS DNA, anti-double stranded DNA antibodies. Okay, and when we are talking about anti-DS DNA antibodies, they can ask you what is the preferred method of assessing anti-DS DNA. The preferred method is Cryptidia immunofluorescence. Preferred method of estimating anti-DS DNA is Cryptidia immunofluorescence. Immunofluorescence. Okay, now anti-DS DNA we need to know a little more because it is the most valuable antibody when it comes to SLA. What makes it most valuable? Anti-DS DNA antibodies are the ones which correlate with disease activity. Correlate with disease activity. Now what do I mean by that? Whenever the SLA disease activity or inflammation flares up, anti-DS DNA titers are increased. If the disease is a low active, the anti-DS DNA titers are decreased. I can't say the same for the ANA. That's why once we use ANA for initial diagnosis, we never repeat it again and again. We don't check the titer whether it is increasing or decreasing. It doesn't correlate with the disease activity. But I can use anti-DS DNA titers to understand whether it is increasing or decreasing, right? Then number 2, they also correlate with risk of kidney involvement, risk of lupus nephritis. Higher the titer you have, higher risk of lupus nephritis. If the titer is rapidly increasing, you can expect that, oh, this patient is likely to come back now with the lupus nephritis. Okay, that's the value of anti-DS DNA titers. Okay, beyond that, the next thing is the anti-Rho antibodies. Anti-Rho antibodies. These antibodies are the ones which correlate with risk of Sjogren's syndrome. Means SLE patients can also develop Sjogren's syndrome, keratoconjunctivitis sicca, dry mouth. So its risk can be assessed by the presence or absence of anti-Rho antibodies, and they also correlate with They correlate with risk of neonatal lupus. Now, what do you mean by neonatal lupus? If the mother is having SLE, transplacentally these antibodies, especially anti-Ro antibodies, can be transferred to the fetus and it can cause the problems in the fetus. That's what we call as neonatal lupus. Especially neonatal lupus can lead to heart block, AV blocks in fetus because of these antibodies. So if I have two SLE patients, both are pregnant, one of them is having anti-Ro antibodies, the other one is negative. So the one with anti-Ro antibodies is the one who is likely to give birth to a baby with the neonatal lupus. Well, it is transient. Neonatal lupus is not permanent. The baby is not going to retain these antibodies forever. Antibodies were produced by mother, not the baby. So they have their half-life. After that, their levels decline and the patients would show recovery. Only thing is that during that period of transient lupus, heart block can be life-threatening. We have one more antibody that is called as anti-La antibody. These only correlate with Sjogren syndrome. They do not correlate with the risk of neonatal lupus. In fact, they often coexist along with the anti-Ro antibodies. Okay. Then we have this anti-histone antibodies. Anti-histone antibodies, they are usually encountered in drug-induced lupus. Drug-induced lupus. The drugs which are known to cause, there is a long list. Important examples I want you to remember that are like commonly used are hydralazine for treatment of hypertension and D-penicillamine that we use for treatment of Wilson disease, copper chelating agent. They can cause drug-induced lupus. Okay. So these are the important antibodies and their correlations that we should be aware of. Okay. Now from the SLE, let's move to the next rheumatological disorder, that is scleroderma. Okay. So what is scleroderma? This is basically an autoimmune disorder where you have the skin and organ thickening or fibrosis. So if I have skin fibrosis plus organ fibrosis, then we will call it as scleroderma. If there is only skin fibrosis, it is called as morphia. Another term for scleroderma is systemic sclerosis, because it is not only affecting the skin but causing the sclerosis or fibrosis of the systems or organs. There are two subtypes under it. One is limited cutaneous and another one is diffuse cutaneous. But before that, the principal cytokine involved in pathogenesis of scleroderma, why the skin and organs are becoming fibrosed. Fibrosis of an organ or fibrosis of any tissue simply means excess abnormal collagen deposition. So who does that collagen deposition? Fibroblast. So basically fibroblast overactivity. So there must be someone stimulating the fibroblast, and the one who is stimulating the fibroblasts is nothing but transforming growth factor beta. Transforming growth factor beta. So in SLE we had this interferon 1. In case of rheumatoid arthritis, the main inflammation is by TNF alpha. And in case of systemic sclerosis, we have transforming growth factor beta. That's why if you go back and now look at the management of rheumatoid arthritis, we have a lot of anti-TNF alpha drugs used for RA treatment. And we had created anifrolumab to treat SLA. Unfortunately, as of now, we don't have very effective therapy that can target the TGF beta. That's why scleroderma treatment is not specific yet. We just try to manage the symptoms, right? So please remember, we have transforming growth factor beta as the principal cytokine here. Now, based on the extent of skin involvement, scleroderma or systemic sclerosis is further classified into two groups, the limited cutaneous and diffuse cutaneous. Now, what is the basis? Extent of skin involvement. So let us say there are two individuals with both of them will have organ involvement. Okay, both of them will have organ involvement. If only skin is involved, it is called morphia. But we are looking at the extent of skin involvement in fibrosis. So if the skin involvement is restricted to body parts distal to elbow in the upper limb and distal to the knee joint in the lower limb. If the skin involvement is only restricted to the distal body parts, then we will call it as, in both the cases you will have facial involvement, then we will call it as the limited cutaneous. The skin thickening does not generally progress beyond the elbow joint in the upper limb, beyond the knee joint in the lower limb. This is typical limited cutaneous. And what happens in diffuse cutaneous? You also have involvement of the proximal body parts, not restricted to the elbow joint and beyond and knee joint and beyond. The proximal body parts are involved. So if it extends beyond the elbow joint proximally, it extends beyond the knee joint proximally, then we will call this as diffuse cutaneous. Face is involved in both cases. So here skin thickening restricted to distal parts. Here skin thickening extends to proximal parts. So does that mean it's only about skin thickening? No, it's beyond that. These two sets of patients behave totally different. The disease behavior is totally different. So what are the differences and can we clinically recognize them, or do we also have lab tests? Well, when we talk about the differences between them, so if we are talking about limited cutaneous versus diffuse cutaneous, there is something called Raynaud's phenomenon. Which will be present in both the cases. But in case of limited cutaneous, along with Raynaud's phenomenon, you will have the digital fingertip ulcers. You will have fingertip ulcers. And calcinosis cutis, calcification of the skin. Here generally only Raynaud's phenomenon, and there is no or lower risk of fingertip ulcers and calcinosis cutis. Patients with limited cutaneous variant are at increased risk of developing pulmonary hypertension. Relatively lower risk of developing pulmonary hypertension if I have diffuse cutaneous. And then renal crisis. Patients can develop sudden onset severe hypertension. We call it as renal crisis. The risk is low here in case of limited cutaneous, and the risk is high in case of diffuse cutaneous. High risk of diffuse cutaneous. So these are the basic differentiating features. In fact, if you want, you can call this limited cutaneous as crest syndrome. I'll tell you what are the components. Crest syndrome is in limited cutaneous. It's not seen in diffuse cutaneous. So what is this crest syndrome? Crest syndrome refers to C for calcinosis cutis. Calcinosis cutis. Calcification of the skin, especially the fingertip skin, you will see calcific spicules. Then R for Raynaud's phenomenon. Raynaud's phenomenon. Then E for esophageal dysmotility, because there is abnormal collagen deposition in the esophagus also, so you will have esophageal dysmotility. Okay, S for sclerodactyly. Fibrosis and thickening of the skin of the fingers. And T for telangiectasia, small abnormal blood vessels in the skin, telangiectasia. So collectively you call it as crest syndrome. Crest syndrome, everything coming together. See, these features do, some of them do occur in the limited cutaneous also, but everything coming together we call it as crest syndrome. That is your limited cutaneous. Now, is it all about these differences? Yeah, the disease behavior, as we know, varies significantly. So these patients tend to develop more localized symptoms. These patients tend to develop more systemic symptoms like high risk. One more thing I forgot to address, the interstitial lung disease. There is low risk, while there is high risk of interstitial lung disease in case of diffuse cutaneous. So can I predict how this disease is going to behave? Yes, we can predict by looking at the antibodies, not just the extent of skin involvement. So the antibody that we get in limited cutaneous is going to be your anti-centromere antibody. Anti-centromere antibody. And the antibody that you get in diffuse cutaneous is anti-SCL70 antibody, which is also known as anti-DNA topoisomerase antibody. Anti-DNA topoisomerase antibody. So if I have a scleroderma patient with anti-SCL70 antibody, the disease is going to behave like diffuse cutaneous. That means this patient is at high risk of developing scleroderma renal crisis and high ILD, but relatively low risk of developing the crest syndrome and the pulmonary hypertension. Pulmonary hypertension. Okay. On the other hand, if I have a scleroderma patient with this anti-centromere antibody positive, then he has high risk of developing pulmonary hypertension and crest syndrome and relatively low risk of developing ILD and renal crisis. So we can predict the disease behavior. How do I remember these antibodies? In limited cutaneous, as I have already told you, we will have anti-centromere. And in diffuse cutaneous, we will have anti-DNA topoisomerase, which is also called as anti-SCL70. SCL is scleroderma, SCL is scleroderma. Anti-topoisomerase antibodies. So how do I remember it? The simple trick is, if you think of a cell and you have to tell me where do I find centromere and where do I find DNA? Well, you would say, sir, in the nucleus, because in the nucleus you have chromosomes. That is where the centromeres are there. That is where the DNA is there. Well, if I have to find the centromere, it's only in the nucleus. Can I find it anywhere else? No. So centromeres have a limited presence inside the cell. Inside the nucleus only they are present. They are not present elsewhere. But what about DNA? Yes, DNA is there in the nucleus, but can I find DNA outside the nucleus? Yes, why not? Because outside the nucleus you have mitochondria, and inside the mitochondria you do have circular DNA. So DNA has more diffuse presence. It is not restricted to the nucleus. It is there outside the nucleus also. While centromere has a limited presence, only inside the nucleus. So that way you can remember. If you think about centromere, it is limited cutaneous. And you think about DNA, DNA has more diffuse presence inside the nucleus, outside the nucleus. So that way you can remember it as the antibody for diffuse cutaneous. Okay. So now once we know these differences, if you ask me about the management of scleroderma or systemic sclerosis, it is always supportive or symptomatic. We don't have any specific therapy available yet. We have methotrexate and anti-TNF alpha drugs for the treatment of rheumatoid arthritis. We have hydroxychloroquine, belimumab and anifrolumab for the SLE, but scleroderma we don't have anything much to offer. So it is supportive or symptomatic. For example, if you have pulmonary hypertension because of the SLE, you can try to treat them with phosphodiesterase 5 inhibitors, which will cause the pulmonary artery dilatation and reduce the pulmonary artery pressure, or endothelin receptor blockers like bosentan, ambrisentan, endothelin receptor blockers. I'm sure all of you know the phosphodiesterase 5 inhibitors. We can also add endothelin receptor blockers like bosentan, ambrisentan. Or prostanoids like epoprostenol. These can be used. Okay, now if I have developed ILD, you can try to treat with antifibrotic agents like perfenidone or nintedanib. So these are going to be the drugs I can use for ILD treatment. So there's nothing specific to do for the systemic sclerosis. Whatever problems patients are facing, you can treat it. Like if they're having Raynaud's phenomenon. So for Raynaud's phenomenon, you can, because vasoconstriction is responsible for Raynaud's phenomenon, you can use vasodilators like the calcium channel blockers. Okay, so that completes the important rheumat topics. One small bit, that is mixed connective tissue disorder. Basically, the mixed connective tissue disorder refers to presence of more than one rheumatological disorder in the same patient. Example, rheumatoid arthritis plus Sjogren's syndrome. That's more than one, right? The two rheumatological disorder now, Sjogren's syndrome. Or rheumatoid arthritis plus SLE. Or rheumatoid arthritis plus SLE. In addition to that, so this is one component of the criteria to say this is mixed connective tissue disorder. Plus, you need to have one antibody. This antibody is anti-U1 RNP antibodies. Anti-U1 RNP antibodies. So if both of them are there in that patient, two or more than two rheumatological disorders in the same patient simultaneously plus this antibody, then we will call this as mixed connective tissue disorder. So if they ask you what is the hallmark antibody of mixed connective tissue disorder, that is anti-U1 RNP antibodies. Okay. So from rheumat, now let's move to the pulmonology. So in the pulmonology, of course, there are only three important topics from which they keep asking questions. One is asthma, another is COPD, and most of the times the questions are about differentiating the asthma, COPD from from each other by looking at the PFT, whether it is obstructive and restrictive, and if it is obstructive, whether it is reversible or persistent. Beyond that, sometimes some image-based questions can come from COPD. ILD, again recognizing the restrictive pattern on the PFT and then recognizing whether it is idiopathic pulmonary fibrosis or NSIP. Okay. And the third important topic is Light's criteria to understand whether it is exudative pleural effusion or transudative pleural effusion. So let's address them. So we'll begin with the interpretation of PFT itself. PFT interpretation. So what do they ask in the PFT? See, in the PFT, we are interested in mainly one parameter, that is the ratio of FEV1 by FVC. The normal ratio is more than 0.7, more than or equal to 0.7. If it is less than 0.7, you clearly have an obstructive airway disorder. Less than 0.7 is equal to obstructive disorder. The examples for obstructive disorder are asthma and COPD and bronchiectasis. These are typical obstructive disorders. If the ratio is more than or equal to 0.7, it's not restrictive disorder always. It means either you have no respiratory disorder, it's perfectly normal, just like the ABG that we were talking about, or you have a restrictive disorder. So in the ABG, what did we do? When we got the pH normal, we saw PaCO2 and bicarb. If they were also normal, we call it as normal. But if they were abnormal, then we labeled it as fully compensated acid-base disorder and we proceeded further. So same thing we will do here. If the ratio is less than or equal to 0.7, we will see what is happening with the FVC. If FVC is normal, that means ratio normal, FVC normal, then you don't have major respiratory disorder, neither obstructive nor restrictive disorder. But if the FVC is low, that means you have restrictive disorder. Restrictive disorder. This is going to be your approach to any PFT question. You look at FEV1 by FVC ratio. If it is low, it's clearly obstructive disorder. If it is normal, it need not always mean there is normal. Either you may be having a hidden restrictive disorder or normal. So you see the FVC. If FVC also turns out to be normal, then no respiratory disorder, but if FVC is decreased, it is restrictive disorder. The examples for restrictive disorder, something that can restrict the expansion of the lungs. One is ILD, like fibrosed lungs cannot expand well. So ILD is a classical example. Pneumonia is also a restrictive disorder. ILD, pneumonia, pleural effusion, pneumothorax, these are all restrictive disorders. Examples for obstructive asthma, COPD, bronchiectasis. So if I encounter a restrictive disorder, my next move is to go ahead with imaging. If I do an HRCT or a chest X-ray or ultrasound, I can detect ILD, pneumonia, pleural effusion, pneumothorax. So diagnosis gets sorted easily. If it is obstructive disorder, I have to differentiate between asthma and COPD mainly, and we can differentiate that by looking at what you call as, we basically go for a test called as bronchodilator reversibility test. We give a bronchodilator and see whether FEV1 improves now or not. If FEV1 significantly improves after bronchodilator, it was a reversible obstruction, classical asthma. If it does not show significant improvement, then it is persistent obstruction, classical COPD. The test is called as bronchodilator reversibility test. So in the bronchodilator reversibility test, what we do, we administer a short-acting beta agonist to the patient and we repeat the FEV1. So if the patient's post-bronchodilator FEV1, which pre-bronchodilator we have already calculated for the ratio. Now I have given a beta agonist and we will repeat the FEV1. That FEV1 will be called as post-bronchodilator FEV1 and we will see how much increase has occurred. If there is more than 12%, more than or equal to 12% and more than or equal to 200 ml increase occurs, then we will call it as reversible obstruction. And reversible obstruction, for all practical purposes, it is asthma. And if there is less than 12% increase, then it is persistent obstruction. And in case of persistent obstruction, you think about mainly COPD. Right? This is going to be our approach to PFT. You may also get some flow volume loop based questions. I think sir might have addressed in physiology. I will just take 5 minutes to give you a quick recap of the flow volume loop based questions. Akhilesh, absolutely right. So what is this flow volume loop? So what we do is we ask the patient to take deep inspiration and then do a deep exhalation, and we will take a graph. On that graph, we will have a y-axis and we will have a x-axis. So on the x-axis, we will plot how much air is going into or coming out of the lungs. How much air is going into or coming out of the lungs on the x-axis. So on x-axis, we have volume of air in liters. But when I am inhaling or exhaling, from the beginning of inhalation to the end of inhalation or from the beginning of expiration to the end of expiration, the flow rate will not be same. So when I start, it is slow. Somewhere middle, we reach the high flow rate, and then again the flow rate starts coming down to end the inspiration at 0 flow rate. Finally, it becomes 0, and then expiration starts. So expiration also starts with 0 flow, then reaches the peak flow, and then the flow again drops down to 0. That's how the expiration ends. So on y-axis, we are actually plotting the flow rate in liter per second. So now how the normal graph looks like. When I start taking the inspiration, remember if this is 0, on the x-axis 0 begins like Urdu, 0, 2, 4, 6, 8. But on the y-axis it follows the traditional English, means you are not writing from right to left, you are following the left to right only, top to up. So let us say 2, 4, 6, 8. That is the flow rate. It's like, to give you an example, on x-axis what I'm plotting is, imagine Shoaib Akhtar is bowling, okay. So he takes a long run up and then bowls. So when he bowls, the distance that the ball traveled, that is what we are plotting on the x-axis. So when you inhale, the amount of air you are inhaling, the quantity is what we are plotting on the x-axis. But by what speed Shoaib Akhtar bowled to reach that distance, that speed is what we are plotting on the y-axis. So total amount of air that gone in is your x-axis, but at what flow rate it went in, that velocity is the y-axis. So here bottom is negative, 4, 6, 8, 10, like that. So what we do is, inspiration is it is plotted on the bottom. Inspiratory flow rate is plotted on the bottom and expiratory flow rate is plotted on the top. The simple reason for that is, while doing this procedure, we are blowing the air into a machine and inhaling from the machine. So when I am blowing the air into the machine is gaining the air. So it will take it as a positive gain, and that's why that flow velocity will be counted as positive. And then when I am inhaling, I am literally sucking the air from the machine. So machine is like losing it. So it will count it as a negative gain. That's why we will plot it as negative flow rate. So when we start taking an inspiration, the inspiratory rate is 0. Remember, this is our 0. So my inspiration will start somewhere here. And when we start inspiration, we will always have some amount of air in the lungs. So that is my residual volume. So I will have residual volume in my lungs. It can never be cleared. So my inspiration starts from there, right? Already some amount of air is there in the lungs. So I start inspiration from, let us say, here with a 0 rate. I reach some peak flow rate, and then eventually when I complete the inspiration, the rate becomes 0. After that we start the expiration. Again, when I am starting the expiration, the flow rate is 0 because flow has stopped, inspiration is just over, flow has stopped. Now I start the expiration. So as I start exhaling, the velocity starts going up, we reach the peak velocity, and then slowly the expiratory rate flow rate starts coming down, eventually expiration stops. So this is how the flow loop looks like. And in this flow loop, the highest flow velocity that I achieved, like in this graph, it is 10. It need not always be 10 for everyone. This is our peak expiratory flow rate, and the highest flow rate that I could achieve here, and according to the graph, around 6.5 liter per second, that is my inspiratory flow rate, peak inspiratory flow rate. And as I've already told you, on the x-axis we are plotting the amount of air going into the lungs or out of the lungs. So here I have taken 8 liters of air into my lungs. So that becomes my total lung capacity. Because if I take a deep inspiration, that means I can hold around 8 liters of air in my lung. And when I exhale, I can't exhale the residual volume. It will always remain in the lung. So I could only exhale this much air. So this is total lung capacity. Out of that, this much remained in the lung, this much was exhaled. So this exhaled volume is called as forced vital capacity. So this is going to be your forced vital capacity. This you already know is the residual volume. Like this is your residual volume. This you cannot exhale. That's your residual volume. And forced vital capacity plus residual volume put together is your total lung capacity, right? This is the shape of your normal graph. Now they will ask you image-based questions and you have to recognize abnormal graphs. So how the images are going to look like? Okay, let me sketch it here itself. We will use different colors so that we can relate to it. Now in case of the obstructive disorders like asthma and COPD, we are not able to exhale the air out easily. So air getting trapped inside the lungs. So what happens in the obstructive disorders is, in obstructive disorders, your residual volume increases, and because air is getting trapped, you are not able to throw it out. So the amount of air remaining in the lungs is increasing. And if residual volume increases, total lung capacity also increases. So in that case, what will happen to the graph? So here, till this was the residual volume, but now that I have developed asthma, the residual volume is increased. It's not going to be Earlier we had 1 liter, I guess. Now it will be more than that. So let us say this much is going to be my residual volume now. In that case, the graph begins from here. This is my new residual volume. The graph begins from here. So total lung capacity is increased now. Okay. And then when I start exhaling, because obstruction is there, I will not be able to exhale with the same speed that a normal individual can exhale, because my airway are narrow, asthma, bronchoconstriction. So my exhalation speed comes down. So my peak expiratory flow rate comes down. So I will have decreased peak expiratory flow rate. Okay. So what this will result in is the graph which is now shifted to the left. Graph which is shifted to the left. And during the expiration, this expiratory limb becomes little scalloped. So this is the picture you get if you have the obstructive disorder. Graph shifted to left and scalloping of the descending limb of the expiratory arm. So this is a typical picture that we are getting in obstructive disorder. So you have this scalloped expiratory limb. Scalloped expiratory limb and shift to left. Shift to left is because of the increased residual volume and total lung capacity. As the residual volume increases and total lung capacity increases, the graph has to shift this side. This is obstructive disorder, asthma and COPD. Now what will happen in restrictive disorder? If you have restrictive disorder, something is restricting the expansion of the lungs. Maybe fibrosed lung, pleural effusion, pneumothorax, it is restricting. So the amount of air I can hold in my lungs is less. So my residual volume and total lung capacity will be decreased. And total lung capacity decreases. Other parameters don't get changed, but my residual volume and total lung capacity is decreased. So what will happen to the graph now? The graph will shift to the right, because the residual volume earlier I was getting this much was my residual volume. Now let us say instead of 1 liter I am developing only half liter residual volume. So graph shifts here. And lungs ability to hold air is less. Total lung capacity is less. And this is how the graph is going to look like now. Why? Because the graph is now shifted right, because total lung capacity and residual volume are reduced. So graph gets shifted to right. And if the total lung capacity is less, the overall size of the loop becomes small. So we can say that in restrictive disorder there is miniaturization of the normal looking loop but shifted to right. Shape wise it is same as normal, but it has become small and shifted to right. So that is the picture we will get if you have the restrictive disorders. You have lower residual volume, lower total lung capacity, and the graph will be shifted to right. Otherwise shape wise it looks almost like the egg shape that we get normally. So this is going to be your restrictive disorder. Clear? So in restrictive disorders, graph is shifted to right and you have no scalloping. You have normal shape but miniaturized, but small or miniaturized. Okay, so you should be able to recognize these flow volume loops as well by just looking at the shape. If there is scalloped appearance, it is obstructive disorder. Looks like normal but loop is small, it is restrictive disorder. Beyond that, one more image they ask, not of medicine concern, primarily ENT concern, but anyway we should be aware about this graph as well. Again, a flow volume loop I am talking about. The flow volume loop normal shape was, as we know, it looks like this, right? This is the normal shape that we are looking at. This is your normal shape. But if you have fixed upper airway obstruction like the laryngeal stenosis, or there is a goiter compressing the larynx, not moving it, in that case the amount of air coming in and going out both comes down and this loop becomes flattened totally. So if I get such a flat loop like this indicates fixed upper airway obstruction. We're talking about upper airway, so it's in the territory of ENT, but we should be aware. Fixed upper airway obstruction. Actually, if they are asking a flow volume loop question, the higher chances are that they will ask this image, fixed upper airway obstruction. Example, your subglottic stenosis or laryngeal stenosis are examples. Okay, so that completes our flow volume loops as well, right? Shape is what you will quickly recognize. Scalloped, obstructive, looking like normal but small, shifted right is restrictive, and flattened from top and bottom both the sides, it is fixed upper airway obstruction. Okay, so now let's get into the two major respiratory disorders, asthma and COPD. Asthma, we already know how to make the diagnosis. In asthma being an obstructive disorder, asthma is an obstructive disorder with reversible obstruction. You will get FEV1 by a FVC ratio of less than 0.7, but on bronchodilator reversibility test, you will notice more than 12% or equal to 12% and more than or equal to 200 ml increase in FEV1 after giving a bronchodilator. Okay, so that is how we establish the diagnosis of asthma. Once we have made the diagnosis of asthma, we should also know the type of asthma. There are two types of asthma, type 2 and non-type 2. So we will do the markers for non-type 2. If the markers for non-type 2 are elevated, then it is type 2 asthma. If markers of non-type 2 are not elevated, then it is, type 2 are elevated, type 2. If markers of type 2 are not elevated, it is non-type 2 asthma. So markers of type 2 asthma are mainly eosinophils, absolute eosinophil count, okay. Okay, good. So next, fractional exhalation of nitric oxide more than 50 parts per billion, absolute eosinophil count more than 300, and then third one is serum IgE levels increased. These are markers of type 2 asthma. So if they are present, then it is type 2 asthma, and if they are absent, not present, then it is non-type 2 asthma. It's simple. We don't do any specific markers for the non-type 2. Just do the markers for type 2. If they are elevated, type 2. If it is not elevated, non-type 2. Okay. Once we have diagnosed the asthma, we know that these patients will experience frequent attacks of bronchoconstriction. They wheeze, cough, have shortness of breath. We need to manage. Now, when it comes to management, we are following the GINA guidelines. Okay, what GINA guidelines say is, some patients require daily inhalers. Some patients can be managed with as and when required inhaler. So we have to decide whom to give daily inhaler, whom to give as and when required inhaler. So the decision depends on whether patients are having asthma attacks on more than or equal to 4 days per week, or whether they are getting nighttime attacks of asthma more than or equal to 1 time per week. This is a deciding factor. If any patient has asthma attacks on 4 days a week or more, like Monday, Tuesday, Wednesday, Thursday, Friday also, that's more than 4 days. So if this patient had 4 days or more than that of asthma attacks per week, or let us say he has, like every Monday he gets an asthma attack, and beyond that daytime attack of Monday, he also get Tuesday night attacks. So if he's getting even one attack of asthma in the night per week, that also begs for daily inhaler. So if you have these present, then that patient needs daily inhalers, daily inhaler, and if no, then no need for daily inhaler. Now the daily inhaler that we are giving today, the treatment has evolved, and what we do is we give one inhaler which has a combination of a beta agonist and the steroid, and the same inhaler can be used for the prevention of asthma so that you don't get the attacks, and the same inhaler can be used to relieve an attack. If you are having an asthma attack, you can relieve with the same inhaler. That's only possible if I have a beta agonist which can act quickly so that it can relieve an asthma attack. At the same time, it has a long duration of action so that it can prevent. And we have one such drug which is the formoterol. So we now combine formoterol, which is a LABA but rapid onset LABA, plus inhaled corticosteroid, and because now this combination can be used as a regular maintenance medication for prevention, and it can also be used as a reliever because of its rapid onset of action. We call it as MART. MART stands for maintenance and reliever therapy, all combined into one. So these patients need MART because they need daily inhaler. These patients don't need MART. No need for maintenance treatment, only reliever therapy is enough. So how do I treat these patients who are getting less than 4 days of asthma attacks per week? As and when required, SABA along with ICS. So let us say there is an individual who is getting 2 attacks of asthma per week, no night attack at all. That means this patient does not require maintenance therapy. All I have to do for him is give an inhaler which contains SABA and ICS and tell him whenever you have an asthma attack, take it, it will relieve you. Right? But if let us say there is another individual who says, sir, in last 1 month, I've had at least 8 to 10 times where asthma attacks occurred at night. So on an average per week, how much it comes? 2. It's more than 1. So that means this patient requires daily inhalers so that he doesn't have to go through those attacks in the night. So I have to start him on the combination of formoterol and inhaled corticosteroid, where he will be taking it regularly, morning, evening. In addition to that, if there is an asthma attack in between, he can use the same inhaler to relieve the attack. So maintenance and relieving, both combined into one. That's what we mean MART. Here only a reliever was required, no need for maintenance medication. SABA is a reliever. When you get an attack, use a reliever. Now when I start the MART, whether I start with low dose or medium dose is another question that we need to address. So that is decided based on the post bronchodilator FEV1. So after administering bronchodilator, how much FEV1 we are getting? If that is less than 30% of the predicted value for that particular person, or whether it is more than 30% of the predicted value. So if it is less than 30% of the predicted value, it's pretty bad. So in that case, I have to start with the medium dose MART. We start with the medium dose MART. So I will be using the medium dose of the formoterol and the inhaled corticosteroid. But if it is 30% plus, then we will start with low dose MART. Start with low dose MART. This is our initial treatment. And if the initial treatment does not respond, what choices we have? According to 2026 GINA guidelines. So if the patient does not respond to initial treatment, then if no response to initial treatment, we go for the step ladder pattern of escalation. Step ladder pattern of escalation. Now what do we mean by step ladder pattern of escalation? So in this ladder pattern, on the bottom of the ladder we have as and when required SABA plus ICS, inhaled corticosteroid, as and when required. That is, SOS means cis super cis, as and when required. Then next maintenance therapy in the form of low dose MART. Next, medium dose MART. Next choice is to go with high dose MART or biologicals, or adding a long acting antimuscarinic agent. So this step ladder pattern means you don't always start here and then keep jumping. We already know what we start initially. So based on the patient's current situation, some patients are started as and when required inhaler. These are started with as and when required inhaler. Some patients are started on the low dose MART. If the FEV1 was good, some patients are started here. And some patients who had pretty bad condition at presentation, they are started with the medium dose MART. So some patients start their journey here. No matter where they start the journey, if they don't respond, we always go to the next step. So if I had started with as and when required inhaler, if they are not responding, then I step to low dose MART. If I had started with low dose MART and then they are not responding, I jump up to medium dose MART. If I had started with medium dose MART, if they are not responding, then I jump up to these options. Okay. So if medium dose MART is like last ditch, after that we have to think of high dose MART or other choices. Other choices include biologicals. And they do ask MCQs on the biologicals. So what are the biological agents or monoclonal antibodies that we can use in the asthma? The biologicals that we can use in the asthma include number 1, we have omalizumab, dupilumab. Omalizumab is a monoclonal antibody against IgE. Dupilumab is a monoclonal antibody against, this is anti-IgE monoclonal antibody. Dupilumab is anti-interleukin 4 receptor monoclonal antibody, anti-IL-4 monoclonal antibody. Then we have mepolizumab, reslizumab, benralizumab. Reslizumab and benralizumab. So these are anti-interleukin 5, and we have a new drug called tezepelumab, which is a anti-TSLP monoclonal antibody, anti-thymic stromal lymphopoietin monoclonal antibody. So these are all the biologicals that are available. So any patient who is not responding to medium dose MART, high dose MART is one choice, but in addition to that we have other choices like biologicals. Now in the exam they will mainly ask you the mechanism of action or target antigen for these monoclonal antibodies. So for omalizumab it is anti-IgE. So how do I remember them? Well, I will give you some clues to remember. The first and the easiest to remember is the dupilumab and tezepelumab. Tezepelumab is easy because T for T. Anti-TSLP is tezepelumab, T for T. Dupilumab is easy to remember because D is the fourth letter of the alphabet. So dupilumab, D is against the fourth letter of the alphabet, interleukin 4. Omalizumab is easy to remember because O and E both are vowels, A, E, I, O, U. They come together. So they are always coming together. So here also they are coming together. Whatever is remaining is for your interleukin 5. Now what else they can ask? They can ask you which monoclonal antibody is suitable for which type of asthma, because there are two types of asthma, type 2 and non-type 2, right? So this anti-TSLP can be used for both type 2 and non-type 2 asthma, while the others that we have listed, the omalizumab, dupilumab, mepolizumab, reslizumab, benralizumab, these IL-4 and IL-5 drugs and IgE drugs, they can only be used for type 2 asthma. They can't be used for non-type 2 asthma. So they might ask you which of the following drug can be used in patients who are refractory to standard treatment irrespective of the type of asthma. Then your answer is going to be tezepelumab, because tezepelumab can be used in type 2 as well as non-type 2 asthma. So that completes our asthma. Okay. Now let's also learn a little bit about COPD. So now in 2026, the COPD diagnosis guidelines have slightly changed. We will learn that. I am expecting a question on that. So first thing is COPD. What is the most common cause? The most common cause is smoking. But if they're asking what is the most common cause for COPD in non-smoking females, then our answer is going to be burning of biomass fuel. Means for cooking the wood and the cow dung patties and whatever they use, that smoke can also lead to COPD, right? Apart from that, there is also genetic cause, that is alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. These are causes for COPD. COPD have two subcomponents. What are those subcomponents of COPD? One of them is called as chronic bronchitis. Chronic bronchitis. The other one is called as emphysema. We should be aware of both of their definitions and then some more details. So first let's start with chronic bronchitis. Chronic bronchitis. Can anybody tell me how do you define chronic bronchitis? Chronic bronchitis. Yes, the tracheal stenosis involving the extrathoracic trachea comes as a fixed upper airway obstruction. Chronic bronchitis is defined as the presence of cough with sputum or productive cough for more than or equal to 3 months per year for 2 sequential years. This is the definition of chronic bronchitis. Now, chronic bronchitis patients are also known as blue bloaters. They are also known as blue bloaters. Why are they called as blue bloaters? Because there are two reasons. The chronic bronchitis leads to cyanosis. Because there is cyanosis, the word blue comes. Bloater because chronic bronchitis also increases the risk of developing right heart failure. Because in chronic bronchitis there is hypoxia and that causes pulmonary vasoconstriction, causes pulmonary hypertension and right heart failure. And when right heart fails, you develop the raised JVP, ascites, hepatomegaly, pedal edema. So your body gets bloated with fluid. That's where the term bloaters comes into picture. Okay. Now, in chronic bronchitis patient, there is excess sputum production. That's why these patients are having this productive cough. The definition includes the excessive sputum production in it, right? Why there is excessive sputum production? There are two reasons for it. It is due to, number one reason, there is hyperplasia of goblet cells. Goblet cell hyperplasia. They produce a lot of mucin. And number two, there is also hyperplasia of submucosal glands. Submucosal glands. In the pathology, this hyperplasia of the submucosal gland is like they calculate some ratio to confirm whether you have chronic bronchitis or not. So can anybody tell me what is the name of that ratio that is used to detect the hyperplasia of these submucosal glands and thus confirm that patient has got chronic bronchitis? So if I take the biopsy of the bronchi in patients with chronic bronchitis and give it to Dr. Ranjit, what he will do is, if I give him the information that I am suspecting the possibility of chronic bronchitis, this is the bronchi, right? This is the epithelium of the bronchus, right? There will be epithelium inside. This is the epithelium, and just below the mucosa, right, they will have submucosal glands. This is the region of the submucosal gland layer. Okay, so there will be a layer of submucosal glands. So what they do is they take the ratio of the whole thickness of the bronchial wall and the submucosal gland layer ratio. So this is the whole thickness of the bronchial wall. So let me label this as B. B is the full thickness of the bronchial wall, and then this submucosal gland layer thickness, let me label it as A. This is your submucosal gland layer. Okay. Normally, and when we take that ratio of submucosal gland layer thickness by whole thickness of the bronchial wall, we will call it as Reed index. We will call it as Reed index. And this Reed index is normally less than 0.4, less than 0.4. And if it is more than, in case of chronic bronchitis, it turns out to be more than 0.45. More than or equal to 0.45, you have chronic bronchitis. Basically, it means that more than 45% of the thickness of the bronchial wall is now taken up by the submucosal glands because they are hyperplastic. That's what the meaning of Reed index. Okay, so this is about your chronic bronchitis. Patients have goblet cell and submucosal gland hyperplasia, so they produce a lot of sputum, they cough a lot. That's why definition says 3 months per year for 2 years. We're calling it as chronic bronchitis. And because the bronchi are inflamed, the inflammation makes the airway lumen narrow, and because of the narrow lumen, less oxygen goes into the lungs. So they develop cyanosis. That's why we're calling them as blue. And eventually, less oxygen going to the lungs, the pulmonary capillaries constrict, and the pulmonary vasoconstriction causes the right heart failure. That's why we're calling them as bloaters. The next component we have is emphysema. Emphysema. Yeah, I will address the ARDS also. Okay, so what is emphysema? Emphysema refers to irreversible dilation of acini. So what are these acini? Acini are the parts where the gas exchange occurs. So when we look at the airway, we have the trachea. We have the trachea. Let us say this is the trachea that we are looking at. Trachea bifurcates into two main bronchi, right? These are main bronchi. Main bronchi goes through generations of divisions, right? Generations of division. Finally, it becomes what you call as terminal bronchiole. The 16th generation of division is terminal bronchiole. And from the terminal bronchioles, you have origin of something called as respiratory bronchioles. So from terminal bronchioles, respiratory bronchioles origin. Okay, so these are respiratory bronchioles. Respiratory bronchioles lead to what you call as alveolar ducts. They lead to alveolar ducts. And alveolar ducts lead to acin alveoli or alveolar sacs. So if I have to label them, this is going to be my respiratory bronchioles. These are going to be my alveolar ducts, and these are going to be my alveoli. So if you catch hold of any one respiratory bronchiole, let us say I am catching hold of this respiratory bronchiole, it would have led to 3, 4, 5, whatever number of alveolar ducts it leads to, and whatever number of alveoli it leads to collectively becomes one acinus. So this is going to be one acinus. This is going to be another acinus. So when these acini become irreversibly dilated, like this becomes dilated, then we will call it as emphysema. Okay, clear? So this is collectively one acinus. So when they become irreversibly dilated, we call it as emphysema. And we have further classified emphysema into pan-acinar and centri-acinar. Centri-acinar is where respiratory bronchiole is dilated, because the center of this acinus is the respiratory bronchiole. And you will call it as pan-acinar if everything is dilated. So you have two subtypes of this emphysema in that case. Let us say this is a respiratory bronchiole, leading to the alveolar ducts, them leading to the alveoli. This is one acinus if we are counting it as. Now, okay, let me label it so that when you see the notes you don't get confused. Respiratory bronchiole, alveolar ducts and alveoli. Respiratory bronchiole, alveolar ducts, alveoli. If only respiratory bronchiole becomes dilated and rest of the structure remains unaffected, then we will call it as centriacinar. This is centriacinar emphysema. Centriacinar emphysema is typically encountered in smokers. This is encountered in smokers. So where dilatation is mainly of the respiratory bronchiole. This is that segment which is dilated. But if everything becomes dilated, then we will call it as panacinar. Respiratory bronchiole is dilated, alveolar ducts are dilated, alveoli are dilated, then it is panacinar. Pan means everything, it's pretty simple. This is typically encountered in patients with the alpha-1 antitrypsin deficiency. So panacinar is in alpha-1 antitrypsin deficiency, centriacinar in smokers. This is panacinar in alpha-1 antitrypsin deficiency. We should also be aware that the smoking induced emphysema is more commonly affecting upper lobes, while alpha-1 antitrypsin deficiency induced emphysema predominantly more commonly affects lower lobes. So lower lobe predominant panacinar is alpha-1 antitrypsin deficiency, upper lobe predominant centriacinar is smoking induced emphysema. Okay. Now what problems emphysema leads to? Once the alveoli dilate or these acini dilate, you know there is something called Boyle's law that you study in physio and chemistry as well as physics. According to that, pressure and volume have inverse relationship. So if they dilate, their volume increased, pressure in them decreases. And if the pressure in the alveoli decreases, it becomes easy for the air to come from high to low pressure zone. So air comes in these acini easily, but it will not be able to leave, because for the air to leave the acini and go back to the environment, pressure in the acini have to be high in comparison to the alveoli, in comparison to the atmosphere. Normally, during inspiration, lungs expand, lower the pressure, air comes into the lungs. During expiration, the lungs recoil. So as the volume of the lungs decreases, pressure increases, and that's how we throw the air back into the atmosphere. But here these are dilated irreversibly, so they can't recoil back. So if they are not able to recoil, you will not be able to send the air trapped in these alveoli out. Right? So you start trapping the air, and that's why, because you start trapping the air in the lungs, your residual volume increases. If your residual volume increases, total lung capacity increases. And once that happens, the graph that we saw in the flow volume loop, it becomes shifted to left, right? So patients of this emphysema struggle to exhale the air out, and they do make certain physical adaptations to make their exhalation easier. What are those physical adaptations? By pursing the lip and taking a tripod position, when they sit and lean forward, the diaphragm gets pushed up. So when, let us say here, these acini are all dilated, they're trapping the air, but if I make the diaphragm get pushed up, this diaphragm squeezes this dilated acini and pushes the air out. So it makes it easier for us to exhale, right? So emphysema patients can have, so emphysema patients are often having pursed lip breathing, and they will have tripod position. These are basic physiological adaptations that help them to exhale the air out, right? And because in emphysema there is air trapping, and thus there is increased total lung capacity, the lungs are expanding in size. Now to accommodate that expanding lungs, I have to increase the size of the thorax. Horizontally, thorax cannot increase in size, so it increases anterior-posteriorly. So what generally appears as relatively flat from front to back now expands and the shape of the chest becomes barrel shaped. So you can have barrel shaped chest. Barrel shaped chest. So these are the basic findings you can get in patient with COPD. Chronic bronchitis, in emphysema, because there is no cyanosis, we will call them as pink puffers. Puffers because the lungs are trapping the air and they are becoming puffed, like how veg puff or egg puff, they get puffed once they go into the oven. So that's why we call them as pink puffers. Okay, so if patients present with a history of smoking and then pursed lip breathing, tripod position, struggling to exhale the air, it's predominantly emphysema. If they have cyanosis and right heart failure features, chronic bronchitis. So we are suspecting COPD in that case. So for diagnosis, I have to rely on the PFT. PFT being like COPD being an obstructive disorder, the FEV1 by FVC ratio will be less than 0.7. But when I give a bronchodilator, I will not see significant improvement in FEV1. In asthma, 12% and 200 ml increase was occurring. Here, you will not see that. And until now, the diagnostic guidelines would say that if you have obstructive disorder ratio less than 0.7, administer the salbutamol, and after that, if it is not showing 12% increase, then you will say persistent obstruction and it is COPD. What 2026 guidelines says, let's keep it simple. We will directly look at the post bronchodilator FEV1 by FVC ratio, means ratio itself after the bronchodilator. And after the bronchodilator also, if the ratio is coming out low, that means it is persistent obstruction, right? If it was asthma, post bronchodilator FEV1 by FVC ratio should have come normal. But here the ratio is still remaining low even after the bronchodilator. That is sufficient evidence to say that you have the persistent obstruction. You don't have to sit and calculate, is it 12% or less, is it 200 ml or less, all that is not required. If the post bronchodilator ratio itself is low, then it is persistent obstruction. Persistent obstruction is equal to COPD. Persistent obstruction is equal to COPD. Okay. Once you have diagnosed the case as COPD, when it comes to management, a few things to do extra. So in case of COPD management, there is gold grading of COPD or gold staging. We should be aware what are the vaccines that are administered and categorization. These three things. I will just take 3-4 minutes to address that. So starting with the gold grading. Which is based on post bronchodilator FEV1. Post bronchodilator FEV1. So if the patient's post bronchodilator FEV1, let us say, is post bronchodilator FEV1 is more than or equal to 80%, or whether it is less than 30% of the predicted value. If it is less than 30% of the predicted value, we will call it as gold grade 4 or gold stage 4 or very severe COPD. Very severe COPD. If it is 30 to 50%, you will call it as gold grade 3 or severe COPD. Okay. If it is 50 to 80%, you will call it as gold grade 2 or moderate COPD. And if it is more than or equal to 80% of the predicted value, then you will call it as gold stage 1 or mild COPD. Okay, so this is the gold grading. They have asked MCQs on it, so you should be aware about it. Less than 30% is something that you can't forget, because even when we spoke about asthma, the post bronchodilator FEV1 of less than 30% is what we have counted for counting it as severe, and we had started with a medium dose directly, right? So same here, if it is less than 30%, we will count it as bad, and that is where our pyramid begins. Less than 30%, very severe. 30 to 50, severe. 50 to 80, moderate. More than 80, you're pretty close to normal, so we will count it as mild. Okay, that is one thing. The next thing that I want you to know is the vaccines recommended for COPD, because COPD patients often develop respiratory infections and that worsens the COPD. So there are vaccines that are recommended. Vaccines that are recommended. What are the vaccines recommended? Number one, the most common infection that exacerbates COPD is going to be pneumococcal infection, and we have the vaccine for it. So we do give pneumococcal vaccine. Like Pneumovac 23. Then second, influenza virus is one of the exacerbators. So influenza vaccine is available. So we can give influenza vaccine. Third, COVID can worsen COPD. So at least during COVID pandemic, we did give COVID-19 vaccines. Fourth, recent times, the pertussis is now considered as an exacerbator of COPD, and we have vaccine. Though not available as a standalone vaccine, we have a combination of diphtheria, pertussis, tetanus vaccine. So you can give diphtheria, tetanus, pertussis vaccine. Okay. And then shingles or herpes vaccine. Now herpes, actually, like herpes zoster is not going to exacerbate COPD, but most COPD patients are in that age range where herpes zoster is very common, so that's why we give it for them. Not primarily meant for COPD mitigation, but rather because same patient is also at risk of developing shingles or herpes zoster reactivation, we give it. These are the vaccines recommended. Okay. After vaccines, we have the categorization of COPD to decide the management into 3 categories. Slight change in the updated guidelines. So those who have followed me from the older lectures, you need to be updating yourself right now. So the current gold guidelines, what it says is, any patient of COPD, you have to see in the last 1 year how many times there were exacerbations. So a patient had more than or equal to 1 moderate or severe exacerbation. Previously, 2 moderate exacerbation or 1 severe exacerbation, but the current revision, 1 moderate or 1 severe exacerbation in last 1 year. This is what we are looking for to categorize the patient into different categories. If the history is saying yes, in last 1 year patient had 1 moderate exacerbation, or last 1 year patient had 1 severe exacerbation, or both, okay. If yes, patient goes to exacerbation category, that is category E. E means exacerbation category. If you say no sir, patient did not have even a single moderate or severe exacerbation in last 1 year, so in that case the patient can go into 2 categories, A or B. That is decided based on the dyspnea severity, how badly patient is breathless. Dyspnea severity can be assessed using the MMRC grade. MMRC grade. If patient is having MMRC grade of 2 to 4, then it is severe dyspnea, and if it is 0 to 1, then it is mild dyspnea. So for mild dyspnea patients, we will put them in category A, and for severe dyspnea patients, we will put them in category B. This is how the categorization is done, and once the categorization is done, we have to decide the initial treatment. So what's going to be my initial treatment for category E and category B? Category E patients, we start them with LAMA plus LABA. And you can consider triple therapy. Triple therapy means LAMA plus LABA plus steroids plus inhaled corticosteroids if the eosinophil count is high, count is more than 300. If eosinophil count is low, then you are only sticking to the dual therapy of LAMA plus LABA. For category B patients, again you start treatment with LAMA plus LABA. But category A patients, see, category E patients' main problem is they are going through recurrent exacerbations, need to be treated aggressively. B patients, they don't have much of exacerbation, but they do have severe dyspnea, again need to be treated aggressively. But A patients neither have much exacerbation nor have much dyspnea, so they are like on the milder side of the COPD, so we don't treat them aggressively. We can use either LAMA or LABA, one of them is enough, you don't need to give 2. So these are treated with any bronchodilator, LAMA or LABA, any bronchodilator, LAMA or LABA. Okay, this is going to be the initial treatment. What choices we have for refractory cases? Those who are not responding to treatment. Refractory cases can be treated with one. We have this drug called roflumilast, which is a phosphodiesterase 4 inhibitor, or you can also add azithromycin, regular azithromycin. Okay, this is basics of COPD management. Now coming to some extra treatment. Okay, so one of them is called long-term oxygen therapy. The other one is called as lung volume reduction surgery. So long-term oxygen therapy, because we know chronic bronchitis patients can develop hypoxia, pulmonary hypertension, right heart failure and die. We can prevent that by avoiding hypoxia itself. If you give oxygen, hypoxia reduces, pulmonary hypertension risk comes down, right heart failure risk comes down, right? So it is indicated if patient has SpO2 of less than 88%, which corresponds to PaO2 of less than 55 millimeters of mercury, or SpO2 of less than 89%, which corresponds to PaO2 of 55 to 60 millimeters of mercury, with right heart failure, raised erythropoietin, or pulmonary hypertension. So if you have the evidence of already some degree of right heart involvement, in that case you can start oxygen at slightly higher oxygen levels. If not, when the saturation drops to less than 88% or PaO2 drops less than 55%, we start them on long-term oxygen therapy. So they can ask you what are the indications for long-term oxygen therapy, potential MCQ zone. So please remember, don't forget. The second thing is lung volume reduction surgery. If you are having emphysema, these patients are struggling to bring the air out from those dilated acini. So what if I remove the dilated part of the lung? Then they don't struggle to exhale, right? So we can do that for upper lobe predominant emphysema. We can't cut the lower lobe out. So if you have alpha-1 antitrypsin deficiency which causes lower lobe predominant emphysema, this is not suitable, but upper lobe can be chopped out. So if you have upper lobe predominant emphysema, so indication for lung volume reduction surgeries, if you have upper lobe predominant emphysema with exercise limitation, patient is not able to do physical activities, then we can go for this lung volume reduction surgery. So basically what we do in lung volume reduction surgery is we chop off the part of the lung which is emphysematous. So if this is one lung we are looking at and this is another, if this part is emphysematous, we will chop it out. We will remove that part of the lung which is emphysematous, and this is what we call as the lung volume reduction surgery. Removing the emphysematous part of the lung is lung volume reduction surgery. Okay, so that completes the COPD. We will address the ARDS for now and then we will wind up. Okay, so some of you were asking me to cover ARDS. So what is ARDS? Acute respiratory distress syndrome. That's the full form. But exactly what is it? It is the pulmonary edema without cardiac problem. Normally pulmonary edema occurs because of the left heart problems. But here you have non-cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema. Basically in the alveoli there is collection of fluid. But what is the reason for that? If you have inflammatory event anywhere in the body, it could be anything. Few examples I can quote are like if I have sepsis, body is under tremendous inflammation, right? Or if I have polytrauma, multiple body parts are crushed, polytrauma. Or if I have wrong blood transfusion, transfusion associated lung injury, TRALI. Or let us say if I have snake bite, at the site of bite there is intense inflammation. So all these are inflammatory events. The problem may be restricted to the inflammation, but sometimes what happens is the inflammatory event means there is increased production of inflammatory cytokines. Inflammatory cytokines like interleukin 1, interleukin 6. These are all inflammatory cytokines. These inflammatory cytokines are harmful to the alveolar epithelium. So they will, through circulation, they will reach, like let us say I have urinary tract infection and that has resulted in sepsis. So body starts making a lot of IL-1, IL-6. These IL-1, IL-6, they will reach the alveoli and they will cause damage to type 1 pneumocytes. These are alveolar cells which are involved in gas exchange. There are two types of pneumocytes, type 1, type 2. Type 2 produces surfactant and it is also acting as a stem cell. It can repair the type 1 damaged cells. Type 1 are for the gas exchange. So gas exchange cells get damaged. That's one thing. Second, the inflammatory event will also have neutrophils involved. So the neutrophils can also cause the damage to the type 1 pneumocytes. Okay. And the neutrophils and inflammatory cytokines both can deactivate surfactant. Now the problem with the deactivation of the surfactant is once the surfactant is not active, surface tension increases, the alveoli collapse. Collapse of alveoli. Can a collapsed alveoli participate in the gas exchange? No. And within those alveoli, some of the pneumocytes are also damaged. So what will happen now? Some alveoli are collapsed, some have damaged pneumocytes, they are not participating in the gas exchange, patient will develop hypoxia. Patient will develop hypoxia. Okay. And all these inflammatory exudates now accumulate in the alveoli. So that produces the pulmonary edema that we are talking about. So these inflammatory cytokines, dead neutrophils is nothing but pus. They all accumulate in the alveoli causing pulmonary edema. This is not because of the pressure rise in the pulmonary capillaries. In case of heart, the pressure build-up in the pulmonary capillaries was causing pulmonary edema. Here, it is the inflammatory exudate, the dead inflammatory cells and the proteins or the cytokines are all putting together, they are accumulating in the alveoli. That's pulmonary edema. There is also collapsed alveoli that has resulted in hypoxia. So this is a summary of ARDS. So in the ARDS, lungs need not always be the primary problem. The primary problem is elsewhere. If you had some inflammation somewhere, you sent IL-1, IL-6 to me, and as a lung, now I am suffering. My alveoli got collapsed because surfactant got deactivated by inflammatory cytokines. My type 1 pneumocytes got damaged, so I am not able to participate in gas exchange. And all these inflammatory debris is accumulating in alveoli, creating alveolar edema or pulmonary edema. So this is the picture. Okay, so now in terms of causes, sepsis is right now the most common cause. Sepsis is the most common cause overall. And you can also have causes inside the lung, that is pneumonia. Pneumonia is the most common intrapulmonary cause or intrinsic cause. Pneumonia is the most common intrapulmonary or intrinsic cause. Within the lung, pneumonia also inflammation. Inflammation can lead to interleukin 6 production. Most common intrapulmonary or intrinsic cause. Okay, so the story is known to us now, the causes are known, what is the outcome. Now, when it comes to diagnosis, what criteria will follow? So remember, once an inflammatory event occurs, from that patient should develop hypoxia within 7 days. Then only you can call it as ARDS. Because otherwise, today I develop blood transfusion and 5 years later I come back and say now that there are some opacities on the chest X-ray, it is ARDS and your blood transfusion is responsible. No, there has to be a temporal correlation, right? So this is what we are going to prove in the diagnosis. So for a diagnosis, we are following a criteria which is called as Berlin criteria. Berlin criteria. by looking at this pathophysiology, we can predict what all is required for diagnosis. There needs to be hypoxia, there needs to be pulmonary edema, right? Hypoxia should be there, pulmonary edema should be there, and then there should be evidence of an inflammatory event, and there should be a correlation between the inflammatory event followed by development of symptoms. And because it is non-cardiogenic, I have to prove that heart function is normal. So when I establish all of this, diagnosis is done. Now how will I prove hypoxia? So for hypoxia, we are not looking at the SpO2 because we know it is not reliable. Rather, we are looking at PaO2 by FiO2 ratio. PaO2 by FiO2 ratio. What is FiO2? Fraction of inhaled oxygen. How much oxygen I am inhaling, and out of it, how much is appearing in the blood. That's what the ratio predicts. PaO2 by FiO2 ratio. Normal PaO2 by FiO2 ratio is more than 400. Is more than 400. If it is less than 300, now we will call it as ARDS. And we can also use the same thing for the severity classification. So when it is in the range of 200 to 300, less than 300 is ARDS. 200 to 300, you will call it as mild ARDS. And then 100 to 200, you will call it as moderate ARDS. And less than 100, you will call it as severe ARDS. Severe ARDS. Okay. So that is first criteria. Hypoxia should be there. Second, this hypoxia should be because of the alveolar collapse and accumulation of inflammatory fluid inside the alveoli. So that should be visible on the chest X-ray as pulmonary edema. So you should have bilateral opacities on chest X-ray suggestive of pulmonary edema. Third, there should be a temporal correlation between the cause and onset of symptoms, right? So onset of symptoms within 7 days of the inflammatory event, within 7 days of inflammatory event, whatever it is. If I get snake bite today, within 7 days, if I become short of breath and X-ray shows bilateral opacities and PaO2 by FiO2 ratio is less than 300, now you can say this is ARDS. But if I get snake bite now and 1 month later I get this picture, snake bite cannot be blamed for it, right? So there should be a 7-day correlation. Fourth one, we should rule out the cardiac abnormalities. There should be normal cardiac function. Because if cardiac function are abnormal, that explains pulmonary edema, then it becomes cardiogenic pulmonary edema. Normal cardiac functions can be proved by normal echocardiography or cardiac MRI. Mostly echo is enough. So if the echo is normal, we'll say now it is ARDS. Once we have diagnosed, then it is about management. How will I manage the ARDS? See, the issue here is there is an inflammatory event. We have to treat the underlying event for sure. If there is sepsis, I have to give antibiotics. If there is snake bite, whatever ASV I need to use. If there is pneumonia, I need to give antibiotics. Polytrauma, the fractures and the stuff need to be fixed. Underlying cause need to be treated. But the problem here is the hypoxia that also needs to be addressed. Merely giving oxygen does not solve the hypoxia because the alveoli are collapsed, type 1 pneumocytes are damaged, and there is fluid in the alveolar space. So if I want to get the normalized blood oxygen levels, I have to at least open the collapsed alveoli. Edema will slowly resolve. Type 1 pneumocytes that are damaged will be replaced by healthy type 1 pneumocytes because of the action of type 2 pneumocytes as stem cells. They will repair. But for now, the way to get the better oxygen is to open the collapsed alveoli. And you can open the collapsed alveoli only when you put the patient on mechanical ventilator. You can put little higher pressure into the lungs to make the collapsed alveoli open. Okay. So that's why when it comes to the treatment of ARDS, the treatment of choice is nothing but mechanical ventilator. Apart from treating underlying cause. From the perspective of ARDS, it is mechanical ventilator. I can't say that I will put the patient on mechanical ventilator and I will not treat the underlying cause. So even if he doesn't die from ARDS, the underlying cause can kill. Sepsis can kill, snake bite can kill, urinary tract infection can kill. So underlying cause should be treated. But if you ask me purely for ARDS, what is your treatment? It is going to be mechanical ventilator. Now they do ask questions about the settings on the mechanical ventilator. So we should be aware about the tidal volume setting that we follow, PEEP setting that we follow, and we should be aware about the plateau pressure. The tidal volume strategy currently recommended to prevent the lung injury because of ventilator, because here the alveoli are all inflamed, they are very fragile, friable, so they can rupture easily, and if the alveoli get injured further, more inflammatory cytokine production, ARDS worsens even more. That's why we have to be very cautious about injuring the alveoli. So that's why we are following a low tidal volume, high PEEP strategy, and the plateau pressure should be kept less than 30. These are basic settings that you need to remember. And when you say low tidal volume, how much is low? Approximately around 6 ml per kg is the recommended tidal volume. Don't give more than 6 ml per kg. Normally when we put someone on ventilator, 10 to 12 ml per kg is the tidal volume that we are using. So if I am having a 50 kg person, and if I take 10 ml per kg, then I am giving him 500 ml tidal volume in each breath on the ventilator. But if it is a case of ARDS, I will not be using that much. 6 into 50 becomes 300 ml. So I should set the tidal volume to 300 ml. This is again a repeatedly asked MCQ. Okay. And can I do something for, if patient is having poor oxygenation or target SpO2 is not achieved on ventilator, on mechanical ventilator, what can I offer for them? There are two strategies that we can follow. One of them is prone ventilation. So we can follow two strategies. One of them is prone ventilation. Because whenever you go to the hospital and you see someone on ventilator, you always see them supine, right? They are lying down like this with a tube in. But in supine position, there is some part of the lungs, posterior-basal part of the lungs, which are not well ventilated. Air doesn't reach there. So those alveoli are not participating in the gas exchange. So if that supine position is not giving you the saturation you want, turn them prone. So by putting them prone, we can recruit that part of the lung which was earlier not participating. And at least with that, maybe you will be able to get better saturation. So that is one strategy you can try. The other strategy you can try is going to be ECMO, extracorporeal membrane oxygenation. So if the oxygen is not able to enter the blood through the lungs because the lungs are all damaged, alveoli are all collapsed, in that case put the oxygen directly into the blood, like similar to dialysis. Like in case kidney is not able to work, we remove the urea, creatinine from the blood through machine. Similarly, we can put the oxygen into the blood through a machine and remove the carbon dioxide through a machine. Process is same as the dialysis. We make the patient's blood run through a chamber in a machine, and in that chamber oxygen gets added to blood, carbon dioxide gets cleared, and then the blood comes back to the patient's body. We will call this as extracorporeal membrane oxygenation. Why is it called as extracorporeal? Because the oxygenation is occurring outside the corpus is body, outside the body. And for gas exchange in that machine, they are using a diffusible membrane. That's where the term extracorporeal membrane oxygenation comes from, right? So that's all we have for the management of ARDS. So that brings us to the end of discussion of the important topics. So I will be handing over the baton to Siraj Sir. I think he will start at 6 o'clock. So join with him. Medicine and pharmac are usually the subjects that go together. So whatever drugs names we have thrown today, there may be extra questions from those drugs, like the mechanism of action, side effects and all. Naturally, sir will address them as well. So hopefully at the end of the day, you would have covered a reasonable chunk of the subjects, and maybe 10 to 15 marks can be addressed from what we have covered in medicine and pharmac together. So I will be wishing you all the best, and I'll see you in the next class. Till then, have a good time, guys. See you. Bye-bye.
All right, hi guys, very good evening to all of you. Welcome to our today's review class of pharmacology. I'm Dr. Siraj Sir, the faculty of pharmacology, and we'll be starting with the pharma review फॉर ऑल ऑफ यू गाइस. तो अगले 3.5 से 4 घंटे आपके और मेरे अनइंटरप्टेड होने वाले हैं, जहाँ पे हम अल्ट्रा इंपॉर्टेंट टॉपिक्स की बात करेंगे. इस पर्टिकुलर सेशन का बहुत सारे स्टूडेंट्स को बहुत दिनों से इंतज़ार था. तो जैसा कि आपको इंतज़ार था, मुझे भी इंतज़ार था आपसे मिलने का. और देखिए, रिवीजन तो होता ही रहता है और हर जगह पे हो रहा है, लेकिन उस चीज़ का रिवीजन करना जो कि एक्चुअल में मायने रखता है, वो सिर्फ और सिर्फ एक पर्टिकुलर ग्रुप ऑफ क्वेश्चन पेपर को सॉल्व करके, एनालाइज करके, या एक सीरीज को जब हम फॉलो करते हैं, तब हमको एक्चुअली समझ में आता है कि यार ये पर्टिकुलर जो टॉपिक्स है ना, ये बार बार एग्जामिनर पूछ रहा है, इसलिए इन टॉपिक्स को हमें बार बार स्टूडेंट्स को रिवाइज कराना ही पड़ेगा. राइट, निकी एंड ऑल माई अदर स्टूडेंट्स, वेरी गुड इवनिंग टू ऑल ऑफ यू. हाँ, वो एक मिनट. ये जो कॉन्फ़िगर्ड पाथवे वाला जो इशू था, जिसमें वो सेव नहीं हो रहा है, उसको एक बार सही करिए ना. वो आपको दिख रहा था जो. तो मैं कनेक्ट कर रहा हूँ. ऑन हो गया. हुआ. हाँ जी. चलिए, मैं खोल दे रहा हूँ, देख लीजिए. आई थिंक स्ट्रीम हो रहा है ऑलरेडी. उसका उसका डन है. चेक. डन है. चेक. Alright, hi guys, welcome back once again. So there was a small glitch. I think that glitch is sorted already. So we'll be beginning the pharmacology revision. As I told you, that the next 4 hours, you and me will remain in an uninterrupted situation where we wanted to discuss the ultra important topic. And as I was telling earlier, that revisions are happening, and maybe rapid revision also you guys are going from places to places. But when we talk about revision platform here, when we are talking about revision platform with me, revision series with me, we actually analyze previous 10 to 12 papers, and on the basis of that we come up with one of the very finest workbook, and that workbook will be mainly utilized for all of you guys for deciding what is going to be the ultra important topic for all of you guys. So for the next, as I told you, for the next 3.5 to 4 hours, we are going to stay in an uninterrupted situation. I am Dr. Siraj Sir, faculty of pharmacology, and I'll be helping you in revising the ultra important topic of pharmacology very rapidly for all of you. First and foremost, a topic which are often left out is called Autacoids. So I'll be first discussing this topic only. Autacoids is the topic which is often left out by many number of times, even with me also. So I'll try to finish this first, then we'll go with the any other topic, right? So first and foremost, in Autacoids we have histamine and serotonin. Histamine, the very first question that you know is about antihistaminics, their important use, their important side effect. Now let me tell you a very important point here, that whenever we talk about histamine, histamine is mainly going to work via different receptors. Histamine is mainly going to work via, let's say, 4 receptor. Histamine will be mainly acting via 4 receptor, like histamine receptors, and there are 4 histamine receptor, H1, 2, 3, 4, H1, 2, 3, 4. And whenever you are going to look at the H1, histamine 1, it is this H1 which is mainly involved in the allergic pathway. It's mainly involved in the allergy, histamine. It is this one that is, if present in the CNS, they are going to maintain the wakefulness. You have to understand that histamine 1, they are going to act via RAS, reticular activating system, and they are going to cause what? Wakefulness. That is why whenever we give antihistaminic drug, they actually lead to sedation as a very, very important side effect. And whenever we say antihistaminic, always do remember antihistaminics mean what? Whenever we say antihistaminics, antihistaminic usually mean we are talking about H1 blocker, right? And these H1 blocker is further going to be divided into two. That is going to be first generation antihistaminic, and other one is called your second generation antihistaminic. First generation and other one is called your second generation antihistaminic. I hope so far it's okay for all of you guys. Histamine, antihistaminics we are going to discuss, and whenever we talk about antihistaminics, these are the one that is utilized mainly in the management of the allergic condition, right? So these on the top here we have the first generation antihistaminic, and on the down here we know as the second generation. Always to remember it is the first generation that is also having additional anticholinergic property, right? So they have additional anticholinergic property as well, acetylcholine blocking property as well. And because of this anticholinergic property, they can cause anticholinergic side effect like dryness of mouth, blurring of vision, urine retention. All those anticholinergic side effect is going to be seen. So the first generation antihistaminic drug, what are the drugs that we know? Chlorpheniramine. See, all the first generation antihistaminic drug, they are having anticholinergic. Yes, chlorpheniramine chuta acting hai, right? So can they cause sedation? Because they are actually maintaining wakefulness. And when you give antihistaminic drug, they will actually be associated with sedation as a side effect. Sedation as a side effect is always and always going to be seen there. So this is going to be among the first generation. First generation are always more sedative, because there is going to be more blood brain barrier crossing capacity. There is going to be more blood brain barrier crossing, and therefore there will be more and more sedative. But among the first generation, if the examiner is specifically asked, among the first generation which is less sedative, the chotu acting drug chlorpheniramine, it is among the first generation. Although all of them are sedative, but they are less sedative. Pheniramine, doxylamine, diphenhydramine, promethazine, buclizine, cyclizine. Please remember, promethazine is the one that is having maximum antihistaminic with maximum anticholinergic property. Another very important question: maximum antihistaminic with the maximum anticholinergic property, right? Then we have doxylamine doxinate. It is considered as a drug of choice in patient with the morning sickness. Doxinate, very famous drug, morning sickness, early morning nausea and vomiting in the first trimester of pregnancy. Along with this, we also add vitamin B6. इसके साथ हम what do we add? Vitamin B6. Buclizine, cyclizine, we can utilize them in the management of the vertigo. We can utilize them in the management of the seasickness as well. Seasickness, vertigo, for all this scenario we can utilize, right? Then we are now going to talk about the second generation one. The second generation ones. And what are the second generation ones that we know? Under the second generation ones, if you are going to see, we have olopatadine, alcaftadine. Olopatadine, alcaftadine, ocular uses or aankhon wala. Ocular uses or aankhon wala. So we have olopatadine, alcaftadine, ocular uses. So they are mainly utilized as an eye drop. इसको किस फॉर्म में हम यूज कर सकते हैं? We can utilize them as an eye drop form. और आई ड्रॉप के फॉर्म में where can we use them? As an eye drop form, where can we use them? We can utilize them in allergic conjunctivitis. We can utilize them where? Allergic conjunctivitis. So in ophthalmology, I think ophthalm का revision हो चुका है. A very famous condition that was taught to you was spring catarrh, where the patient is presenting with the ropey discharge. No sound. Anyone else who is having problem with the no sound? Let me check. Sound is quite good. Kaivalya 12. Sound is quite good. There is good sound. Audio is good. I just checked. Please check your system or your headphone if you are using. Yes, everything is fine. All right. So we have olopatadine, alcaftadine. Please do remember it is utilized in allergic conjunctivitis, also given the name as a spring cutter. Loratadine, cetirizine. Cetirizine actually is an isomer of, it is an isomer of first generation antihistaminic drug. This is very, very important. It's an isomer of the first generation antihistaminic drug, and that is why even if the second generation are supposed to be less to non-sedative in nature, second generation is supposed to be less to non-sedative in nature, cetirizine is always going to be sedative. If you have ever taken cetirizine, you remember after that बढ़िया नींद आती है, you sleep well, right? So it is actually an isomer of a first generation drug. Cetirizine is an isomer of first generation drug, right? First generation antihistaminic drug. Levocetirizine, this is considered as an isomer of, cetirizine. It is considered as an isomer of cetirizine, so they are going to be less sedative. Estemizole, terfenadine, now these two we don't use only. Estemizole, terfenadine, it is actually not used because they are associated with QT prolongation, right? In the notes wherever I have I will make a cross, that means they are not clinically utilized. Estemizole, terfenadine. Next that we know fexofenadine. Fexofenadine is an isomer of, terfenadine. So terfenadine was what? Why was terfenadine banned? Because of the QT prolongation, and the risk is further going to increase with the enzyme inhibitor. Remember, inducer will induce, it can cause failure. Inhibitor will inhibit, it can cause toxicity. I will help you in remembering and recalling inducer and inhibitor when we go to general pharma section. As of now, just remember estemizole, terfenadine is clinically not used, right? Okay, right? So isomer of terfenadine is going to be fexofenadine. Do remember this, fexofenadine, a very, very important question. Fexofenadine, a very, very important question. It is going to be overall least sedative antihistaminic drug. And see, it is least sedative antihistaminic drug. That explains the fact that why this agent, fexofenadine as an agent, should be preferred in anyone who require constant attention. जैसे कि my dear student, those who are watching me, if they will take any antihistaminic and after that they will start attending the class, they will start sleeping. Sir ने क्या बोला? What did sir say? I could not hear, right? Because I was sleeping. I was under antihistaminic, right? Influence of the antihistaminic, right? So they are overall least sedative, and therefore these are the one that is going to be preferred in someone who require constant attention, like for example pilots, truck driver, pilot, heavy machine operator. So for example, if let's say there is going to be a pilot who is on antihistaminic drug which is highly sedative, so he will sleep, along with him many other people will sleep forever, right? Truck driver, again on the road, what will happen? You can understand. Heavy machine operator, if he is operating, let's say, and along the process he fell asleep, he could not operate it well, so again what can happen? And again I can say, why not students? Because even students also, those who require constant attention, they should be given this fexofenadine. So this is very, very important for all of you guys, and this was a very recent question as well. Fexofenadine is the overall least sedative. So when we talk about antihistaminic drug, the drug that is used for the allergy, but in addition to allergy, do we have some other uses? Yes, for example, we can use them in morning sickness, seasickness, vertigo, and for all this condition we can utilize. Now, let me just quickly summarize other as well. For example, we have H2, histamine 2. It is mainly present at the gastric parietal cell. And they are going to increase the acid secretion. That explains the fact that why you should use H2 blocker. A very good example of this is going to be ranitidine, right? A very good example, ranitidine. It can be utilized in the treatment of peptic ulcer disease. You all know that. And there is one very famous drug in the same by the name of cimetidine. Why it is very famous? Because of the two very important reasons. Cimetidine is famous for two very important reasons. Reason number one, it is associated with lots and lots of enzyme inhibition, and therefore the drug interaction will be very, very high. Second reason why it is very, very important is it is associated with the gift. They are associated with the gift of gynecomastia. Due to some reason, I don't know, the power failure today in our place is very recurrent, and we are just praying that there is no major failure and we continue and finish the class for all of you guys. Okay, So cimetidine is having a lot of drug-to-drug interaction, and they are also associated with the gynecomastia. Then we have S3. The next very important is going to be your S3 and H4. Please do remember this S3 and H4, both of them are going to act via GI. H2 that we know is acting via GS. H1 ka activity mainly mediated by GQ. G protein GQ here. H2 GS. And S3 and H4, both of them are going to mediated, their action is mediated by GI. S3, always do remember they are present in the CNS, and if they are working in CNS via GI, so in the CNS they will always and always decrease the histamine. I want you to understand this. What was the role of histamine in the brain? What was the role of histamine in the brain? Histamine always maintain wakefulness. Is it clear to all of you guys? Histamine maintain the wakefulness. But there is one receptor which is present that actually reduces the histamine level in the brain. So decrease in the histamine in the brain, will it cause wakefulness or sedation? S3 itself causes what? Are you all with me? S3 itself causes what? S3 itself causes what? Sedation. S3 itself causes sedation. This was one very important question that you should know. S3 itself causes sedation. And remember, we have to use something called your S3 ka inverse agonist. We have to use something called your S3 inverse agonist. Inverse agonist means they will act ulta. So S3 causes what? Repeat with me. S3, it is decreasing histamine level. So normally S3 whenever work, they will be causing sedation. But when we use S3 inverse agonist, the drug name is called tiprolisant, pitolisant. So they are not going to cause sedation, rather there will be ulta, opposite action to the sedation, right? So that will maintain wakefulness. So we can utilize them in the management of the narcolepsy. S4 ke liye we don't have any drug. Remember, they are present at the WBC. And they are involved in the chemotaxis. We do not have drug yet, right? So these are the four important receptors. The most important receptor in the histamine is going to be H1, and all the antihistaminic drug. Whenever we say antihistaminic drug, we are actually talking about the anti-allergic medication, and we are talking about your H1 blocker. Are we all good here? ठीक है? Histamine, important points. I'll help you revising all over again. एक बार फिर से हम revise करेंगे, and we'll revise in a way that you are going to remember it now and forever, because this is the last time that you are going to touch pharmacology. After this, you'll be just flipping the page once more, maybe tonight or maybe tomorrow, right? In a day or two, you will just flip the pages all over again. Now, serotonin, a few important points about serotonin that I would like to summarize for all of you guys. Serotonin is also going to act by the serotonin receptor, 5-hydroxytryptamine, 5-HT, and this serotonin is also going to act via, 5-HT receptor, serotonin receptor. How many 5-HT receptor that we know? So we know we have 5-HT1 receptor. We also have 5-HT2 receptor, 5-HT1, 5-HT2. Then we have 5-HT3 receptor, and we also have 5-HT4 receptor. So very quickly, I'll just summarize. Examiner asks, all the serotonin receptor act by G protein except, very first question, all the serotonin receptor act by G protein except which one of the following? Which does not act by G protein? So remember, 5-HT1 act via what? 5-HT1, one looks like letter I, so they are working by GI. 5-HT2 is acting via GQ. 5-HT4 acting via GS, G protein couple receptor GS. 5-HT3 is the one that does not act via G protein. They are going to mainly act via ion channel receptor or ligand gated receptor. They are mainly going to act via ion channel receptor or ligand gated receptor. So this is the only one that does not act via G protein. So you see, first question is sorted. Which of the following serotonin receptor does not act via G protein? The answer to this question is 5-HT3, right? Now, quickly we are going to summarize the other points. For example, which one is working by GS, that is 5-HT4? Where is this 5-HT4 receptor located? So 5-HT4 is mainly located at the GIT, and they are mainly involved in the increase in the GI motility. They are mainly involved in the increased GI motility. That means they have prokinetic property. They are having which kind of property, guys? Prokinetic property. GIT pe they are going to have prokinetic property. All right, now listen to me very carefully. The next thing that I'm telling you, there is something called 5-HT4 agonist. There is something called 5-HT4 agonist, and this 5-HT4 agonist is called your prucalopride. 5-HT4 agonist is called your prucalopride. So they have lot of pride in themselves that I am going to increase the GI motility. I am going to increase what? The GI motility. Prucalopride. Okay. So where do we use this prucalopride? It can be utilized for constipation that can occur due to diabetic gastroparesis. We can utilize them in constipation due to diabetic gastroparesis. Where else we can utilize them? We can utilize them in constipation due to opioids, right? Or irritable bowel syndrome. Irritable bowel syndrome could be diarrhea dominant or constipation dominant. So if there is a constipation due to irritable bowel syndrome, for all this scenario we can utilize. Mind the fact, a very, very important drug in the same that we have here is called cisapride, mozapride. Cisapride, mozapride, tegaserod. Again, these agents are clinically not used because these are also associated with QT prolongation as a very important problem. They are also associated with the QT prolongation. Cisapride, mozapride, tegaserod. Now, there is a question that, okay, if you are saying prucalopride is used clinically among 5-HT4, yes, it is utilized. So does it not have any kind of side effect? Is it free of all kind of side effect? The answer is no. It is having a very important side effect, and that important side effect could be a part of MCQ at any given point of time. Remember this one, that prucalopride is a drug. This prucalopride is a drug. It is actually associated with increase in the suicide ideation. They are actually associated with increase in suicide ideation. So which of the following prokinetic drug can increase the suicide ideation? There you go, the answer is in front of you. As I told you that revision is everywhere, but when you target directly the topic that are going to be very favorite for the examiner, that is the kind of revision that we need at this point of time. And I want you guys to be very, very vigilant with the topics or with the areas which are marked with important, ultra important stars or some keywords during the session. Make sure that you at least look at them once. Okay? These are very, very important for all of you. 5-HT3 that we know, 5-HT3, they are acting by ion channel and they are mainly present at the chemoreceptor trigger zone and they can induce nausea and vomiting. Therefore, to counter this nausea and vomiting, we have to use 5-HT3 antagonist for the treatment of nausea and vomiting. Chemotherapy induced nausea and vomiting. CINV is chemo induced nausea and vomiting. The name of the drug here is going to be drugs like cetron, like ondansetron, granisetron, palanosetron, dolasetron. All of them are going to be cetron. They are the drug of choice in nausea and vomiting, drug of choice for chemo-induced nausea and vomiting. Ondansetron, right? We have drugs like your granisetron, palanosetron. All these are going to be cetron. All right. Then we have 5-HT2. 5-HT2 is present, they're having multiple roles. One of the very important role that 5-HT2, it is mainly involved in your serotonergic pathway and also modulate the dopamine in the brain. This 5-HT2 is mainly involved in your psychosis. So we are mainly going to use 5-HT2A blocker as an atypical antipsychotics. I will discuss antipsychotics as well in the CNS chapter, but right now in the Autacoids chapter, atypical antipsychotic drug like your olanzapine, quetiapine, right? Clozapine. All these are example, right? All these are example of atypical antipsychotic. A very risky drug in the same is called risperidone. Very, very risky drug. It's the most potent atypical antipsychotics. It is the most potent atypical antipsychotics, right? So these 5-HT2A blocker are going to be olanzapine, quetiapine. They are all going to be atypical antipsychotics. Okay. All right. 5:2. Then we have other agents as well in the same. Other agents that we have in the same. There is going to be drugs like your cartanserine, ritanserine, ritanserine, right? They are going to utilize in the management of they are having action on the peripheral vessel. They are 5:2A 2C blocker. They are going to be utilized in peripheral vascular disease and hypertension, like third line, right? Third line drug in hypertension, cartanserine, ritanserine, right? That is going to be very, very important. एक और drug है which is not utilized clinically is called your methisergide. Earlier we used methisergide. Guys, remember this very, very important thing. Methisergide was used earlier in the prophylaxis of migraine, but we do not use it clinically now. So putting a big cross again, right? Putting a big cross again. They are mainly going to be associated with pleuropulmonary fibrosis. Again, very, very important point. I want you to write it down. Pleuropulmonary fibrosis. So 2-3 point in Autacoids is very, very important. One of which will be your cisapride, mosapride, that is causing QT prolongation. Before that, I told you already, other drug that is causing QT prolongation in the histamine is going to be estimizole terfenadine, is causing QT prolongation. Methisergide is associated with the pleuropulmonary fibrosis. Then we are going to have 5-HT1. 5-HT1 is mainly present in the CNS and they're involving the anxiety pathway. We are going to use partial agonist of 5-HT1A. 5-HT1A ka partial agonist. We have drugs like your buspirone, jepiron, ipsapiron. Buspirone, jepiron, ipsapiron. So I always say rone wala. Rota kaun hai? Anyone who is anxiety. So they are going to utilize in the treatment of anxiety. They are partial agonist of 5-HT1A, right? Buspirone. And then we also have something called your 5-HT1B by D agonist. Remember, B by D agonist we are using. 1 ka we use agonist, 5-HT1B by D agonist. And this 1 by D, B by D agonist that we have here is going to be drugs like triptans. We have drugs like your sumatriptan. We have drug like what? Sumatriptan, right? Sumatriptan, rizatriptan, naratriptan, right? All these are going to be frovatriptan. All these are going to be triptans, and these triptans are considered as a drug of choice for migraine. Drug of choice for migraine, or if the word is like acute severe migraine, drug of choice for migraine or acute severe migraine, in that we can utilize them. Triptans, 5-HT1B by D agonist. A very important question that was asked. I will just quickly summarize that as well. That these triptans are actually working 5-HT1B oblique D, B by D. They are also associated with vasoconstriction. They cause vasoconstriction and therefore they can increase the MI risk. That means cardiac risk will be very, very high. Triptans can increase the MI risk, right? That is very, very important. Therefore, you should be avoiding them in patient with MI, because 5-HT1B by D, they will inhibit CGRP release. Okay, agreed. But at the blood vessel, this 5-HT1B is causing vasoconstriction. So they are associated with the vasoconstriction that can increase the MI risk. इसको काउंटर करने के लिए we have something also called, that is called your 5-HT1F agonist, that is also present at the presynaptic neuron, and they say I will not give my F to the blood vessel, therefore I will not give any MI risk. 5-HT1F says I will not give an F, I will not give my F I will not give to whom? To the blood vessel, and therefore there will be no vasoconstriction and there will be no MI risk along with 5-HT1F agonist. Therefore it says less MI deta hai. Less militant is going to be less MI deta hai. Please do remember, this has been asked in question many number of times. It can be asked all over again. Migraine is all-time favorite question for the examiner. Acute migraine we can definitely use NSAID, but acute severe migraine, patient with the disabling nature of migraine, you can utilize triptans. But if the question says that there is a history of MI, then avoid triptans, and always remember the first option itself will be triptan if they want you to make this question wrong. In a history of MI patient, migraine history will be given. They will ask, okay, which of the following drug will be least preferred? You will always try to ignore sumatriptan, because sumatriptan should be least preferred in this case scenario. Remember this. So that is your 5:1. Now there is a rule, that is serotonin का एक rule होता है, and I always say that is called rule of 5. Rule of 5 says receptor number 1 and receptor number 4. So 1 and 4 will become 5. 1 and 4 ka we have to use agonist. So sometimes it is also asked whether you are using agonist and antagonist. The middle one, 2 and 3, receptor number 2 and 3 ka we have to use antagonist. We have to use antagonist. So we have 1 and 4. 1 and 4 will become 5. So rule of 5 is just a mnemonic to remember. We have to use agonist like 5:1A, 5:1B by D, that is agonist. 5:4 ka also we are using agonist. Prucalopride. What was the prucalopride, right? What was the prucalopride causing? Prucalopride was causing a very important problem. Yes, Lasmiditan look like a country. Yes, it look like a country. है ना, कोई स्थान जैसे कि हिंदुस्तान, Lasmiditan, less mi देता है, right? What was the problem with prucalopride? Who can tell me? And then we are done. We are done here. We are done here. What was the problem with prucalopride? There was one problem with the prucalopride. Although it was not causing QT prolongation, but it currently causes another problem, that is called suicide ideation. So if a person after intake of the drug having those ideas, है ना, then you always counsel the patient ahead of time, right? So quickly we'll see what all question that has been asked for all of you guys. Inverse agonist of H3 that is used in narcolepsy. Who can give me the correct answer for this one? What is the inverse agonist of H3? What is the inverse agonist of H3? 3, right? That is used in narcolepsy. That is called tiprolisant. That is called your tiprolisant, and other one is called your pitolisant. Tiprolisant and other one is called your pitolisant. Are we good here? Inverse agonist of H3. H3 itself causes sedation, and we have to use inverse agonist. Now, which antihistaminic drug has maximum antihistaminic and anticholinergic property? Which antihistaminic drug has maximum antihistaminic and anticholinergic? Now, all these I have already taught. If you have been listening to me since beginning, you already know the answer to this question. So this was again a revision mein revision kara rahe hain. We are already doing a revision session. In that session also we are having another revision session for all of you, right? So that again the idea is you have to go through the ultra important topic again and again. Tell me, maximum antihistaminic and anticholinergic property, the name of the drug is called your promethazine. What is the name of the drug, boys and girls? The name of the drug is called your promethazine. It's one of the antihistaminic drug that is having maximum antihistaminic and anticholinergic property, promethazine, and that is why promethazine is also utilized in extrapyramidal symptom management. Extrapyramidal symptom management may we can use also extrapyramidal symptom, and we can also utilize them in the management of motion sickness. Due to their excess anticholinergic property, we can utilize them. Okay, very good. Peaceful warrior. Least sedative antihistaminic drug. So least sedative overall is going to be fexofenadine, right? Estamizole, terfenadine, they were banned because of what? QT prolongation. Antihistaminic that is used for allergic conjunctivitis, that is going to be olopatadine, and a newer one that is called your L-caftadine. Olopatadine and L-caftadine, right? Olopatadine and L-caftadine. 5-HT2C agonist that is used for the obesity. Which 5-HT2C agonist can be used for obesity? Now see, what was the rule of 5 says? The rule of 5 says 1 and 4 ka we are going to use what? The rule of, according to rule of 5, 1 and 4 ka we have to use agonist. 2 and 3 ka we have to use what? We have to use 2 and 3 ka antagonist, right? So now tell me, what is the answer to this question? Who can tell me the answer to this question? अब ये थोड़ा exception to the rule है. This is going to be exception to the rule, right? I'll give you a hint. ये आपके body के load को कम करता है, right? Load को कम करता है. Body के load को कम करता है. So the name of the agent here, it's exception to the rule. Usually 5:2 का we use antagonist like atypical antipsychotic, but there is one agent that will actually suppress the appetite. It's called your lorcaserin. As I told you, आपके body के load को कम करता है. That is going to be lorcaserin. It's going to be lorcaserin. Triptans act on which receptor? That is going to be 5-HT1B by D agonist. It's 1B by D agonist. Please remember, it's not antagonist, it's going to be agonist. Chemotherapy induced nausea and vomiting, it's actually going to be 5-HT3 antagonist. Drugs like your ondansetron, granisetron, planosetron, these are all going to be setron. So these are again very easy question that has been derived from the topic that I just discussed for all of you guys. Methisergide, what was the problem? Why did we even stop methisergide? What was the reason with the methisergide? They were causing what? Pleuropulmonary fibrosis. Pleuropulmonary fibrosis. Methisergide. What is the precursor of prostaglandin? Now, this is a very easy question. And this is, I think you have read also in pathology as well, that prostaglandin, if you know prostaglandins, remember, we have phospholipid, and with the help of an enzyme, phospholipase A2, they are getting converted to arachidonic acid. And with the different enzyme, for example, 5-LOX and COX enzyme, 5-LOX enzyme will be leading to leukotriene, and COX enzyme will be causing prostaglandin. So the question is, right? So the question is, what is the precursor of prostaglandin? So immediate precursor of prostaglandin is going to be arachidonic acid. What is the rate limiting enzyme? That is going to be cyclooxygenase. The rate limiting enzyme is cyclooxygenase, COX enzyme. What is the effect of prostaglandin in the fetus, intrauterine life? So it actually maintain the ductus arteriosus patency. This is very important question. Ductus arteriosus patency, and it is actually also discussed in your pediatrics as well. They maintain the ductus arteriosus patency, prostaglandin, and that explains the fact that why in a patient with the patent ductus arteriosus, we have to cut down the supply of prostaglandin by giving COX inhibitor. In a patient with the patent ductus arteriosus, in a patient with the PDA, patent ductus arteriosus, you have to give COX inhibitor like ibuprofen, right? You have to give a COX inhibitor for the patent ductus arteriosus to cut down the supply of prostaglandin. A prostaglandin analog that is utilized for the cervical ripening. So this is going to be misoprostol. It's going to be what? Misoprostol. It is utilized for cervical ripening, right? Misoprostol. Misoprostol is a very famous drug along with antiprogestin, that is RU486, right? Or antiprogestin, that is mifepristone. It is a highly effective drug for the first trimester MTP. Multiple time repeated question. This one, misoprostol and mifepristone. Which prostaglandin E1 analog is utilized for IBS with constipation? Irritable bowel syndrome with constipation, right? So prostaglandin E1 analog, the name of the agent is called lubiprostone. It lubricates the bowel. Lubiprostone, prostaglandin E1, lubiprostone. So this lubiprostone is one of the prostaglandin E1 analog. They are going to open the luminal chloride channel. And because of that, there will be more and more chloride in flux, and because of that, there will be excess passive water drive. Will be there, and this excess water drive inside the intestinal lumen, they will give you relief from the constipation, right? So constipation, irritable bowel syndrome, that is dominance, where there is dominance of constipation, we can use lubiprostone. Lubricate कर देता है lubiprostone. All right. Some points about gout and rheumatoid arthritis. This was again quick points about histamine, serotonin, migraine. All this ultra important topic we have covered for all of you guys. Some important points about gout and rheumatoid arthritis, that is again frequently asked for all of you guys. Acute gouty arthritis, the drug of choice is always going to be NSAIDs. We can use NSAIDs, right? NSAIDs like your indomethacin, ibuprofen, right? Exception to the rule, NSAIDs can be used except your aspirin. Aspirin itself inhibit the uric acid excretion and they increase the level of uric acid. So aspirin should be avoided in acute scenario. If it is non-responsive to this, then in this case scenario, we will be adding steroids. We will be adding systemic steroids. We will be adding systemic steroid like methylprednisolone. Systemic steroid will be adding. If it is further non-responsive, then we can now add colchicine. Colchicine, please remember, is a very, very specific drug for gout. And in the very recent examination, they asked what is the mechanism of action of colchicine. It's a very specific drug for gout. What is the mechanism of action? So remember, colchicine inhibits the C for colchicine, C for chemotaxis. That was the question that was asked. Colchicine. Now, since it's a very specific drug for gout, colchicine is very, very specific drug for gout. Why are we not giving this the first place? Why are we waiting for NSAID, then steroids, and then we are going with the colchicine? The reason being that colchicine is actually associated with lot of side effects like nausea, vomiting, diarrhea, abdominal pain. These are the very, very important side effects. In addition to that, it can also lead to bone marrow suppression, hypersensitivity reaction, right? Bone marrow suppression, hypersensitivity reaction. Colchicine block the chemotaxis migration. Yes, chemotaxis का मतलब ही हो गया migration of leukocyte. The meaning of chemotaxis itself is same, right? So we are having this acute gouty arthritis के लिए we are having the drug that is called NSAIDs. If it is non-responsive, we can give steroids as well. In cases of chronic gout, when inflammation is subsided, now you have to make sure that you are now going to target the uric acid level. See, the main problem in gout is the uric acid, but in acute scenario, we are not actually worried much about the uric acid level. We are not much worried about the uric acid level. We don't bother much about the uric acid level because we want to get make sure that patient should get rid of the pain. है ना, patient को pain से हमें relief देना है. So we give anti-inflammatory drugs mainly, right? For chronic gout, we have to target the uric acid level now, and we are now going to decrease the uric acid level. Decrease the uric acid production by giving xanthine oxidase inhibitor, and xanthine oxidase inhibitor drugs are going to be allopurinol. Xanthine oxidase inhibitor is going to be allopurinol, and other one is called your febuxostat. Xanthine oxidase inhibitor, febuxostat, allopurinol, and other one is called your febuxostat. They decrease the uric acid production, right? These are considered the drug of choice for chronic gout. Drug of choice for chronic gout. Next is we can give a drug that can increase the uric acid excretion, and we call these drugs that can increase the uric acid excretion, that is called uricosuric. We can give this, and they are known as your uricosuric drug. Uricosuric drug means what? They increase the uric acid excretion. Uricosuric means they increase the uric acid excretion. The name of the drugs here are going to be drugs like your probenecid, lesinurad, benzbromarone, sulfinpyrazone, sulfinpyrazone. These are all considered as a uricosuric drug. Very good. Uricosuric drug. Uricosuric drug. Other agent that we can use is going to be increase the uric acid metabolism. Increase the uric acid metabolism. We don't have any enzyme for causing metabolism of uric acid, so we make a recombinant enzyme, and that is called recombinant uricase. That is called what? Recombinant uricase. And what does this recombinant uricase does? It mainly convert the uric acid into water soluble metabolite that is called allantoin. It is this allantoin, that is water soluble metabolite, that can easily be excreted. So this recombinant uricase drugs, what are the drugs under recombinant uricase that we know? Who can tell me recombinant uricase? Who can tell me the name of the recombinant uricase? Uricase will be an enzyme that is called RAS buricase, P-glotticase, RAS buricase, and another one is called P-glotticase. Okay, so they are the drug that is going to be utilized for the management of the chronic gout. So we have three important class of drug for the management of the chronic gout. Drug number one that we have is the one that is going to decrease the production by giving the xanthine oxidase inhibitor. Drug number two that we have, increasing the uric acid excretion, that is known as your uricosuric drug. You're going to inhibit the reabsorption of uric acid. And drug number three is a drug that can increase the uric acid metabolism, and we call this one as a recombinant uricase drug, right? RAS buricase, P-glotticase. right? Remember, they are very fast acting, and that is why rapid reduction in the uric acid level in tumor lysis syndrome is done by which one? That is going to be the same, that is recombinant uricase also. So we can also use them in tumor lysis syndrome as well, right? So again, a quick summary of gout. Due to some reason that is not well understood, the bina gout ke the exam paper does not feel complete. है ना? So examiner usually asks this question, some question on the gout, where they can give you history of a patient where he went some party, and then early morning 4 or 5 a.m. they can give you an image of a great toe, and they will say ki pain and the patient got up from the sleep due to excess pain, and they might give you even the x-ray as well, where there will be swelling of the areas or soft tissue swelling may be seen. Okay, so this is about gout. Next is rheumatoid arthritis. If you're going to look at the rheumatoid arthritis, what are the drugs for the rheumatoid arthritis? So we have slow acting anti-rheumatoid drugs. Earlier it was DMRs, that is disease modifying anti-rheumatoid drugs. So we have methotrexate, sulfasalazine, D-penicillamine, leflunomide, azathioprine. They are some of the important drugs. Methotrexate is one of the drugs, that is dihydrofolate reductase inhibitor. Whenever they will ask you a case of rheumatoid arthritis, they will never use the term rheumatoid arthritis. Remember, examiner ka mindset understanding is very, very important. They'll give you a history of young female. They'll give you history of what? History of young female, early morning joint stiffness. These are the words that you'll be seeing. Early morning joint stiffness, right? Early morning joint stiffness. Or maybe they can give you some image. For example, one image of, let's say, swan neck deformity. One image of what? Swan neck deformity. One image of swan neck deformity may be seen, right? One image of swan neck deformity may be there. Swan neck, right? Or maybe there is another image of boutonniere deformity, usi ka ulta. Or other one is called Z deformity. All right, Z deformity. This is called boutonniere deformity. Z deformity is also there at the level of wrist. At the level of wrist, there is also called Z deformity. Ulnar deviation, right? Ulnar deviation at the wrist ka. So we call them Z deformity. So all these feature may be given in your question. A claw hand, see, claw hand is this. This is claw hand, right? Claw hand different hota hai. Then partial claw hand. These are the different things that will be taught to you during anatomy, right? Here it will be I'm not able to draw, I'm not able to make it exactly, but swan neck deformity will be something like this, right? Something like this will be there, where there is flexion of the DIP, distal interphalangeal joint. Ka kya hota hai? F for flexion. This is extension. है ना? This is your distal interphalangeal joint. This is your proximal interphalangeal joint. PIP and DIP. Okay. So drug of choice for rheumatoid arthritis is going to be methotrexate. Other agent that we can use, sulfasalazine, D-penicillamine. Leflunomide. Leflunomide is a very fast acting anti-rheumatoid drug. It's a very fast acting. Azathioprine, right? Calcineurin inhibitor that is causing gum hypertrophy. Now, there are two important calcineurin inhibitors that you should know, one of which will be causing gum hypertrophy and hirsutism, and this is all-time favorite question. Calcineurin inhibitor, they inhibit the interleukin activation. This calcineurin inhibitor is called cyclosporine. Although gum hypertrophy is a side effect of phenytoin, and gum hypertrophy is also a side effect of your nifedipine as well, but mainly agar puche calcineurin inhibitor, then remember the answer to this question will be cyclosporine. They can even ask you image based question on the same basis as well, right? Fastest acting anti-rheumatoid drug that is going to be leflunomide. TNF alpha inhibitor that can also be utilized not only in rheumatoid arthritis but also other autoimmune conditions. So TNF alpha inhibitor, I say, remember by a very simple mnemonic that is called ice and AG, right? In the party we require ice, right? Why do we need ice? Ice is required because it's too hot nowadays, and ice is required for having some cold water. Excess cold water sometimes may cause too much chilly environment, so you need some AG. You know better why do we need AG. So we need ice and AG. That stand for your infliximab. ICE and ARG stand for your infliximab. What happened? Infliximab, that is one of the chimeric monoclonal antibody. Certolizumab, humanized monoclonal antibody. Etanercept, adalimumab, and other one is called golimumab. Golimumab, a fully humanized, fully human monoclonal antibody, right? So these are considered as a drug that is known as TNF alpha inhibitor. It has multiple roles. We can use the rheumatoid arthritis, inflammatory bowel disease. In all this condition, we can utilize. Interleukin 1. 1A is the first letter. So here we have drug like your anakinra, rheumatoid arthritis. Interleukin A stands for the 1. Interleukin 2 inhibitor, we have 2 से D से 2 होता है. That is going to be drugs like your daclizumab. And B is the second letter, that is called basiliximab. Daclizumab, basiliximab, right? Daclizumab, basiliximab. You see, we are not talking about that you do the entire notes, the main notes that we have, that you have to do. That is no doubt in that. But given the time that we have to be very, very focused. As soon as you see the question, the answer should come. Now we have done this in past as well, we are doing it now as well, and we expect good amount of question from your rapid revision. So you have to trust on what we are discussing. Along with us, you just revise, try to flip the notes all over again, and do not panic, do not worry at any given point ki I am not able to remember like sir. See, sir has lot of, any sir or any ma'am that is coming to teach you, that is their bread and butter. They are teaching this day and night, so they already know their subject very well. You will be able to crack the question once you see the question on the screen in the examination, given that if you have flipped the pages. एक बार जब आप pages को flip करोगे, notes को देखते हुए चलोगे, so you will develop the memory of that particular kind of question, and you will be able to rule out very, very easily. Take and believe me, and believe yourself also on that. Interleukin 6. So my student never say it as a 6. They say interleukin 6 will be, the name of the drug is called tocilizumab. What do they call them? Tocilizumab. So remember, this is not tocili, this is called rather tocilizumab 6. Look at this. This is going to be tocilizumab. No. I call it as a tocilizumab. When I say, even my student also say the same, tocilizumab. There is another drug in the same, that is called sarilumab. S for 6. Sarilumab. Tocilizumab and sarilumab. Sari, right? Tocilizumab and sarilumab. Sari. तो 6 लोग मिलके साड़ी पहनते हैं. This is just again a silly way to remember, है ना? Sari, tocilizumab. 6 S से 6 और S से सारी, है ना? तो यू कैन रिमेंबर, है ना, इन दैट वेज. 6 लोग मिलके सारी पहनते, सारी. सो tocilizumab and S for 6, sarilumab. Co-stimulation inhibitor, that is inhibiting the T cell activation, that is going to be abatacept, belatacept. Abatacept and belatacept, they are going to be co-stimulation inhibitor between CD80 and CD28 at the T cell, right? Yes, as I told you, they are immunomodulatory agent. They are going to counter the cytokine storm. They are having anti-inflammatory property. Interleukin 6, interleukin 1, they are very pro-inflammatory cytokines, no? TNF, ये सारे pro-inflammatory हैं. तो कोविड के टाइम में इन्फ्लेमेशन ही तो हाई था. Cytokine storm was mainly causing inflammation. Okay. Calcineurin inhibitor, they are going to inhibit the interleukin 2 activation. Now there are two very important things that you should know. Interleukin 2 inhibitor is different from interleukin 2 activation inhibitor. I hope it is making sense to all of you guys. The name of the drug is going to be, calcineurin inhibitor is going to be cyclosporine, tacrolimus. So we can utilize them in many conditions, including, it can also be utilized in post-organ transplant as well. We can utilize, mTOR inhibitor is going to be sirolimus, everolimus. These are just good to know, sirolimus and everolimus, because I just wanted to cover this important immunomodulatory drug, anti-inflammatory drug. We have covered this all for all of you guys. The fastest acting being the leflunomide, the cyclosporin inhibitor that is causing gum hypertrophy and hirsutism. The name of that drug is called your cyclosporin. We also have tacrolimus, but tacrolimus is not mainly associated with that, because they have already asked this question in past. They may ask this question even in the upcoming examination by just giving some important images. So maybe the image would be given in the exam and they can ask you which of the following drug could cause this. So as I told you, there is one anti-epileptic drug that could cause this one, that is called phenytoin. And in upcoming days, if they are going to ask you this question, they may ask this one, right? So which of the following agent can cause this one? So this is again you gum hypertrophy image. Which immunomodulatory agent, which calcineurin inhibitor can cause? That is going to be cyclosporin. So image based question could also be one of the very important question in your examination that you can always expect. Okay, now coming to the next part. So we are done with the Autacoids, histamine, serotonin, migraine, and immunomodulators also we have covered. So जो हमारे something called your orphan topics, we have covered that. Now we are going to talk about something that is called poisoning and management. And लिख के ले लो, एक question इससे रहता ही रहता है out of the poisoning that I am going to discuss in the next 7 to 8 minutes. I have dedicated the next 7 to 8 minutes for this. So different poisonings. A patient of organophosphate poisoning, or maybe the case of carbamate poisoning, organophosphate carbamate poisoning, they both will be having almost similar symptom, because they both are actually irreversible acetylcholine esterase inhibitor. They both are irreversible acetylcholine esterase inhibitor, and there will be increase in the level of acetylcholine. So patient will have lot of cholinergic symptom. In your class, I have discussed with all of you guys sludge, salivation, lacrimation, urination, diarrhea, GI distress, emesis, fasciculation, bradycardia, pinpoint pupil. But today I will not discuss that. I will be telling you how to pick the question. You see the question, you pick the question, right? How will you pick the question? See, you always start from the eyes. And according to my language, I say, eyes never lies. आंखें कभी झूठ नहीं बोलती हैं. Eyes never lies, right? So first, you are going to look in the eyes. उनकी आंखों में देखिए, है ना? उनकी आंखों में देखिए, because of the acetylcholine, है ना? आंखें झूठ नहीं बोल रही हैं, तो एस्टाइलकोलिन की वजह से आंखों में क्या हो जाएगा? मायोसिस होगा. एक्सेस मायोसिस कैन एक्चुअली लीड टू समथिंग कॉल्ड योर पिन पॉइंट प्यूपिल. इट कैन लीड टू व्हाट? पिन पॉइंट प्यूपिल. उसके बाद से ओरल कैविटी को देख लीजिए, या आइज के भी ग्लैंडुलर सिक्रीशन को देख लीजिए. ओवरऑल ओरल कैविटी या आइज का सिक्रीशन वुड एक्चुअली बी secretion would be increased, and because of this even sometime the body temperature, अगर body का temperature बढ़ा होगा, body का temperature अगर देखा जाए तो body temperature may be normal to decrease, कम हो सकता है ना? तो pinpoint pupil, है ना? Constriction, body temperature may be normal or low, always to remember, because of the excessive secretion. After that, you are going to look at the heart rate. Because of the acetylcholine, the heart rate will also be lesser. The heart rate will be lesser. There will be decrease in the heart. There is going to be decrease in the heart rate. Organophosphate carbamate poisoning, remember, they are all going to be the cholinergic symptoms, right? What is the antidote for this case? What is the antidote? How are you going to manage? The antidote for this case is going to be atropine. After atropine, even in organophosphate poisoning, we can even give oximes that are known as your acetylcholine esterase reactivators. इनको क्या बोलते हैं? acetylcholine esterase reactivators. What are they going to do? What are the drugs that we know? The name of the drugs here are going to be drugs like your pralidoxime, obidoxime. नाम में ही देखिए oxime आ गया. Pralidoxime, obidoxime, and other one is called your diacetyl monooxime, right? Pralidoxime, obidoxime, diacetyl monooxime, they are known as DAM. So they are acetylcholine esterase reactivator. They are going to bind at the anionic site, and they will activate, they will dissociate, the organophosphate from the esteric site which has occupied, right? Always do remember, there are two very important site, anionic and esteric site. Both the sites should be vacant in an acetylcholine esterase enzyme. right? If any or both of them are occupied, they will not be able to metabolize the acetylcholine. So because of that, organophosphate and carbamate, they will inhibit the acetylcholine esterase irreversibly, and therefore there will be excess level of acetylcholine. Patient will always present with the cholinergic symptom. Similarly, if other patient is coming, if the other patient is coming with the history of consuming fruit of a plant, or he has consumed something, another patient is coming here, atropine. I always say it's not atropine, you call it as a atopine. Everything here will be on the top. Atropine, or other name of the same, is going to be datura. Atropine or datura poisoning, atropine or datura poisoning, everything will be on the top. So where did I ask you to look? पहले कहाँ देखना है? आंखों में, right? So because of atropine, the pupil size will be on the top. So remember this, pupil size on the top means there will be mydriasis. There will be mydriasis. Then I want you to look at the body secretion. See, anticholinergic hai na? They are the non-selective muscarinic antagonist. So because of that, the secretion will be low. And remember this, because of this, the body temperature, hai na? When you look at the body temperature, that will be hot. Body temperature will be hot, right? बड़ी बड़ी आंखों वाली बड़े बड़े टेम्परेचर के साथ आती है, या आता है, सॉरी, बड़ी बड़ी आंखों वाली बड़े बड़े टेम्परेचर के साथ आता है. When you look at the heart rate will also be on the top. So everything is going to be on the top. Pupil size on the top, body temperature on the top, heart rate on the top, है ना? तो देखिए इससे बेहतर क्या होगा, एटोपिन, एवरीथिंग इज ऑन द टॉप. ऐसे कंडीशन को कैसे मैनेज करेंगे? आई थिंक आपसे बेहतर कौन जानता है. एट्रोपिन और दतूरा पॉइजन के लिए क्या देंगे? दैट इज गोइंग टू बी physostigmine. That is going to be physostigmine. Very good, right? Physostigmine. So whenever you're going to look at a farmer, or you're going to look at a person from the field, he consumed some fruit, it is going to be atropine or datura. Farmer, ध्यान रखिएगा, छोटी छोटी आंखों वाला, छोटी छोटी कमाई करने वाला, बॉडी टेम्परेचर भी कम रहेगा, हार्ट रेट भी कम रहेगा, बेचारा फार्मर क्या करे? व्हाट विल द फार्मर डू, है ना? छोटे छोटे काम करने वाला, आंखें भी छोटी छोटी हो जाती हैं, है कि नहीं? बॉडी टेम्परेचर कम है, बेचारा फार्मर, है ना, पसीने में लथपथ है, तो अगेन फार्मर ड्यू टू एक्सेस एसिटाइलकोलिन. हार्ट रेट देखोगे हर चीज़ कम है, उसकी उम्मीदें भी कम है ना? तो हार्ट रेट कम है, उम्मीदें कम है, बॉडी टेम्परेचर कम है, आंखें छोटी छोटी हैं फार्मर की. अगेन एवरीथिंग ऑर्गेनोफॉस्फेट कार्बामेट, ध्यान रखिएगा. एट्रोपिन, एटोपिन, एवरीथिंग विल बी ऑन द टॉप. आप याद कर सकते हैं इसमें अपने ख्वाबों ख्यालों की जो क्रश है उनको याद कर लीजिए, बड़ी बड़ी आंखों वाली, बड़े टेम्परेचर वाली, बड़े हार्ट रेट वाली, है ना? तो ये हो गया आपका एटोपिन और दतुरा. ठीक है. नाउ अब आते हैं एक अगला केस, वेयर द पेशेंट इज ब्रॉट फ्रॉम रेलवे ट्रैक और पेशेंट इज ब्रॉट फ्रॉम सम रोड साइड. ऐसे हिस्ट्री रहता है एंड डेफिनेटली द सेम लाइन वाज आस्क्ड. एक पेशेंट को रेलवे ट्रैक से लाया गया, रोड के साइड से लाया गया, और दे हैव बीन ब्रॉट फ्रॉम सम नाला. So this is going to be a case of opioid poisoning, opioid or morphine. So again, a case of drug addict. Whenever they say patient is brought from some side, they are actually talking about a drug addict. ठीक है. So in that case scenario, where will you look first? What did I tell you? What is the trick? कहाँ देखना है सबसे पहले? आंखों में. फार्मर का सब कुछ छोटा छोटा है तो ऑर्गेनोफॉस्फेट कार्बामेट, लेकिन ड्रग एडिक्ट का सब कुछ छोटा छोटा है तो देयर इज गोइंग टू बी अ प्रॉब्लम. मतलब वो इतना खर्च कर चुका है कि हर चीज छोटा छोटा हो चुका है. यू विल लुक इन द आईज, अगेन आईज मायोसिस. मेरी कहानी को ध्यान से याद रखना, है ना? और आप एग्जाम में इस बात को लेके बहुत प्राउड फील करोगे कि मैंने एक जीवन में अच्छा डिसीजन लिया था कि मैंने इस सेशन को देख लिया था और ये याद किया था कि ओपियोइड पॉइजनिंग वाला, इट्स अ ड्रग एडिक्ट, इतने खर्चे कर दिया, आंखें भी छोटी छोटी हो गई. मायोसिस, दैट इज गोइंग टू बी पिन पॉइंट प्यूपिल. ओके, देन मैंने बोला था इसके बाद कहाँ देखोगे? यू कैन लुक एट द हार्ट रेट भी क्या होगा इसमें? हार्ट रेट कम होगा. बीपी इवन विल ऑल्सो बी लेसर, है ना? तो सब कुछ खर्च कर चुका है. A very specific symptom that could be seen here in the opioid poisoning could also be with respect to GI. GI में there will be feature of constipation as well. अगर drug addict में ब्रेडिकार्डिया, पिन पॉइंट pupil के साथ पेशेंट आ रहा है तो this will be opioid poisoning, and the specific antidote that you can always give will be known as your naloxone. Specific antidote क्या दोगे? naloxone. एक नंबर की दवाई है naloxone. No, they are IV 0.4 to 0.8 milligram will be given, or 0.4 to 0.8, or even higher dose, even 1 can also be given. All right. Now cocaine. What is cocaine actually? Cocaine is one of the norepinephrine transporter inhibitor that will increase the level of catecholamines. It will increase the level of catecholamines. Up, because of the catecholamine that is going to be high, because the catecholamine that is going to be high, here the eyes will have again, just like atropine, mydriasis. देखिए drug addict में mydriasis है, so there will be possible chances of cocaine poisoning, right? In addition to that, I'll tell you, if you're going to look at this, the heart rate increase, BP also increase because of the high catecholamines, plus there can also be black tongue. Some additional symptom could be black tongue or tactile hallucination, है ना? Something insect crawling under the skin, है ना? So you can also find this tactile hallucination, or scratch mark may be given. Scratch mark may be given. Tactile hallucination, isme we don't have any specific antidote, but you have to treat the patient symptomatically. If the BP is very high, you treat it by giving beta blocker, right? Heart rate is very high, you give it beta blocker or calcium channel blocker. So you have to treat the symptom. Whatever symptom the patient is coming with, try to treat the symptom, है ना? So this is again a case of 4 important poisoning and their important management. So you have to recognize, सिर्फ एंटीडोट याद करने से नहीं होगा, you have to recognize that whether this is a case of organophosphate carbamate or it's a case of atropine or datura. And I think the way that we have covered, you are not going to miss this question. Believe me, you always get a question from here. Because I'm discussing this chapter of poisoning and management, I will also be quickly discussing these. If the patient is coming with the aspirin poisoning, or let's say acidic drug poisoning, barbiturate, chloropropamide, TCS, the case will be given like this: if antidote is not available, acidic drug poisoning and antidote is not available, this is the case. Antidote is not available, NA is not available, then the management will be done by forced alkaline diuresis. You have to make the urine pH more alkaline because it's an acidic drug. If the drug and medium is same, the drug will be absorbed, so they will keep on rotating in the body, right? So you have to do forced alkaline diuresis using soda bicarbonate. Forced alkaline diuresis using soda bicarbonate, NaHCO3, right? Or you can even use simple carbonic anhydrase inhibitor. Forced alkaline diuresis using soda bicarbonate, this is called your acidic drug poisoning. This is called your acidic drug poisoning. Then for basic drug poisoning, all the basic drug, how will you recognize the basic drug, boys and girls? How will you recognize the basic drug? Basic drug is about quinidine. The name of the drug is going to always end with the "ine." Quinidine, atropine, morphine, strychnine. All these drugs, their name is going to end with the "ine." All the drugs, their name is going to end with the "ine." And again, see, atropine ka we have antidote, that is physostigmine. Morphine ka we have antidote, that is going to be naloxone. The case is, if antidote is not available, then in that case scenario, the management will be done by forced acidic diuresis. Forced acidic diuresis using ammonium chloride, right? Or if nothing is there, you can simply use ascorbic acid or vitamin C. And ascorbic acid, vitamin C, कुछ नहीं, नींबू पानी, right? कंसंट्रेटेड नींबू पानी भी हम यूज कर सकते हैं, कुछ भी नहीं है तो, ठीक है? सो वी आर मेनली हैविंग एसिडिक ड्रग पॉइजनिंग. एसिडिक है तो यू हैव टू चेंज द यूरिन पीएच टू अल्कलाइन बाय गिविंग सोडा बाइकार्बोनेट, एंड दिस क्वेश्चन हैज आल्सो बीन आस्क्ड एन नंबर ऑफ टाइम्स. If there is a basic drug like morphine, atropine ka we have a specific antidote. The question is, antidote is not available, then we are going to give forced acidic diuresis. The strychnine, quinidine we don't have. Amphetamine also is one of the, basic drug. Amphetamine, the name ending with the "ine." Amphetamine. So we will be using forced acidic diuresis. Remember that. "ine" hai to basic hoga. "ine" hai to basic hoga, and we have to change the urine pH to acidic. That is what you have to remember. Paracetamol poisoning, what is the specific antidote? You all know. The antidote is called N-acetylcysteine. अब मैं बार बार बताता था, N-acetylcysteine replenishes the glutathione store. स्टूडेंट बोला सर इससे क्या फर्क पड़ता है, आप बस इतना बताओ ना एंटीडोट क्या है. आई सेड नो, द एग्जामिनर इज नॉट विलिंग टू नो दैट इवन. एग्जामिनर इज विलिंग टू नो फर्दर, एंड वी गॉट सो लकी दैट 2 questions were asked 2025 January 2025 FMG examination में, the same question. what is the antidote? Okay, they have asked n number of time, but this time they ask, okay, what is the purpose? So they replenish the glutathione store, है ना? So that was the time when a student got straightened up. हाँ भाई कि ठीक है, अब हमें एप्लीकेशन बेस्ड क्वेश्चन देखना है, सिर्फ रटिफिकेशन से काम नहीं चलेगा, राइट? Then we have digoxin. Digoxin के लिए we are going to use the drug that is called digibine. Benzodiazepine, we can utilize the drug that is called flumazenil. Benzodiazepine, flumazenil, beta blocker, that is caused severe bradycardia. We can use glucagon, that will maintain the heart rate. Methanol or ethylene glycol, that is country made liquor, right? So here we can utilize the drug that is fomepizole, and this fomepizole, how does this work? How does the fomepizole work to next examination? Because they've already asked this question in 2024. A patient bought alcohol from a local liquor shop. They have already asked this. So we are not expecting this question. This time, the question will be like this. A patient bought alcohol from a local liquor shop. Everything is same. He was given a drug that is acting by inhibiting an enzyme. What is the name of the enzyme? So fomepizole, it is one of the drug. You have to understand the mindset of the examiner, and you have to listen to me every time that I say, understand the mindset of the examiner. It's very, very important. Alcohol dehydrogenase inhibitor. Fomepizole, alcohol dehydrogenase inhibitor. Similarly, we have disulfiram, that is the aldehyde dehydrogenase inhibitor, that is utilized for the aversion therapy. That's a different thing. Disulfiram, we are going to see this drug, aldehyde dehydrogenase inhibitor. It is mainly utilized for alcohol aversion therapy. Please do remember, it do not reduce the craving. They will produce aversion. In presence of disulfiram, if you consume alcohol, there will be accumulation of acetaldehyde that can cause lot of reaction, lot of symptom, and all those symptoms collectively are called disulfiram-like reaction. Okay. Iron poisoning, if it is going to be a case of emergency, then we can utilize the drug that is called deferoxamine. We have covered this previously as well. Deferoxamine injectable. But if it's a chronic, let's say there is a patient with the prolonged blood transfusion, so oral chronic cases में we are having per orem or oral iron chelator. Oral iron chelator is going to be deferiprone and deferasirox. Deferiprone, deferasirox, deferiprone, deferasirox, ferri, right? So do remember this. Another very important thing, that here the question will be like this. A thalassemia patient, the case line will be like this. Thalassemia patient with a recurrent blood transfusion. So whenever there is case of recurrent blood transfusion, there will be high risk of blood, iron overload. So in that case scenario, which is the oral iron chelator, that is the line of the case, which is the oral iron chelator. So we can use deferiprone, deferasirox, deferiprone oral, deferasirox oral. Then we have copper. I think all of you guys are already aware about that. Copper ke liye we have D-penicillamine, copper chelator agent. Lead poisoning, BAL or EDTA. Now below this we are having something called hematologic antidotes. Because I'm discussing a lot of antidotes here, I will take this opportunity very quickly to summarize this hematology antidote as well, and I think all of you guys are already aware about this as well. Like for example, heparin is treated with the protamine sulfate. That is one of the chemical antagonists of heparin. Warfarin, we can utilize vitamin K1. If the bleeding is present, then we can use prothrombin complex concentrate, PCC, prothrombin complex concentrate. Rivaroxaban 10A पे बैन लगाने वाला, we can use andixanet alpha, andixanet 10A को न्यूट्रलाइज करने वाला andixanet alpha. Dabigatran, that is one of the directly acting thrombin antagonist. So we have dabi, daba ke, kya daru, that is going to be edarucizumab, dabigatran, edarucizumab, streptokinase, that is one of the tissue plasminogen activator. टिश्यू प्लाज्मिनोजन एक्टिवेटर, फ्रेश फ्रोजन प्लाज्मा पहले यूज करते थे, इफ इट इज नॉट देयर देन ब्लीडिंग में हम फ्रेश फ्रोजन प्लाज्मा भी यूज कर सकते हैं, ये प्रोथ्रोम्बिन कॉम्प्लेक्स कंसंट्रेट इज नॉट देयर, वी कैन यूज फ्रेश फ्रोजन प्लाज्मा एज वेल, दैट इज येडला रेड्डी, येडला अखिल रेड्डी, अखिल, ओके। स्ट्रेप्टोकाइनेज ओवरडोज में टिश्यू प्लाज्मिनोजन एक्टिवेटर स्ट्रेप्टोकाइनेज, we can utilize the drug that is called epsilon aminocaproic acid, EACA, epsilon aminocaproic acid, right? So this was again a quick overview of the important poisonings and their antidote. You always expect, as I told you, in 8 to 10 minutes whatever I will discuss, you will always be getting 1 marks, and if you're lucky you can get even more than 1 marks as well, right? Because these are the ultra important areas for all your examination. Moving on to the next one, that is going to be general pharma ANS. So far so good. Are you guys okay with me so far? ठीक है, are we good here? आगे चलें। नाउ जनरल फार्मा एएनएस में अगर आप मुझसे पूछते हैं सर रुक जाओ, बहुत पढ़ा दिया आपने, थोड़ा रेस्ट करो, अब बताओ मुझे जनरल फार्मा इतनी सारी चीजें, फार्माकोकाइनेटिक्स, डायनामिक्स, क्लिनिकल ट्रायल, ग्राफ्स हैं, बहुत सारी चीजें, आप मुझे एक टॉपिक बताओ फ्रॉम वेयर एग्जामिनर इज वेरी फॉन्ड ऑफ आस्किंग क्वेश्चन। आई ऑलवेज से try to read about drug interaction, and that is what I have also done. I am going to discuss the very first topic in general pharma, that is called topic of drug interaction, where I'll be discussing about when you give enzyme inducer and enzyme inhibitor, what could be the outcome, because there are a lot of clinical questions that is possible on these topics, right? So in this one, the first one that I'll be discussing will be enzyme inducer and enzyme inhibitor. Learn pharma in my style, inducer and inhibitor, it will be clear to all of you guys. Even if you have not read before, it will be clear to you with a single click. See, drugs like grisofulvin, phenytoin, right? These drugs are GPRS. You all know this. Grisofulvin, antifungal drug; phenytoin, anti-epileptic; rifampicin, anti-TB drug; smoking St. John's wort. St. John's wort is a plant product having anti-inflammatory and anti-epileptic property. Carbamazepine, phenobarbital, that is anti-epileptic. Barbiturate, another anti-epileptic. DDT is a pesticide. सो व्हेनेवर वी ट्राई टू यूज जीपीआरएस सेलफोन, जीपीआरएस सेलफोन यूज करने से हमारी बैटरी डेड हो जाती है, इंड्यूस हो जाती है, खर्च हो जाती है। जीपीआरएस सेलफोन यूज करने से और बैटरी इज इंड्यूस्ड, है ना, बैटरी इज डेड। बैटरी क्या हो जाता है, बट नहीं है, बैट है, बैटरी, बैटरी इज डेड, ऑलराइट। सो इंड्यूसर इंड्यूस करेगा, इंड्यूसर क्या करेगा, इंड्यूस करेगा, and because of the too much induction there will be increase in the metabolism rate, there will be rapid metabolism, there will be rapid metabolism, all right? And because of the rapid metabolism rate, or I would say if there is a rapid metabolism, there will be more rapid inactivation of the drug, and this can actually lead to something called your treatment failure. It can actually lead to what, treatment failure. So inducer induce करके fail करा देता है। जैसे कि मान लीजिए you guys are sitting in my class and you are attending a pharmacology class and someone is messaging you, where are you, it's been 8 p.m, I am waiting for you since 7:30, we have to go for a coffee, don't you remember? As soon as you saw the message, you thought, okay, YouTube का ही तो class है, I can watch YouTube class later, close the class, let's go, है ना, today I am getting lucky, है ना, I am going on a coffee with my so-called crush, right? And there, after going there, you are being crushed because you left the pharma class and you went there. As soon as you got the message, you got induced. Let's say tomorrow there is another important class. Let's say my friend Ashwini is coming and other ophthalmology ma'am is coming and anatomy sir is coming. So another important classes are going to be scheduled tomorrow, and the next day also evening may you are attending the class. Same kind of message you got. Where are you? Today I am waiting for you. I have to give you a nice surprise. And for that surprise, you close the phone again and you went again. So every time you're trying to do something for the exam, you're getting a message and you're getting induced. And when you get too much induced, सोचिए क्या होगा, एग्जामिनेशन पास आ रहा है या आपका ग्रैंड टेस्ट, चलिए एग्जामिनेशन नहीं बोलेंगे, आपका ग्रैंड टेस्ट बोलेंगे, आपका ग्रैंड टेस्ट आप देने जाओगे तो क्या होगा, क्या होगा ग्रैंड टेस्ट में, क्या रिजल्ट आएगा, फेलियर का रिजल्ट आएगा। इसलिए मैं बोलता हूँ इंड्यूस नहीं होना है ना। और जाकिर खान की बात सुनिए, जाकिर खान बताता है ना कि सख्त लौंडे बने, वो ऐसे नहीं बोलता है, वो अपनी एक्सपीरियंस के बेसिस पे बोल रहा होता है भाई, है ना, कि सख्ती के साथ रहो, क्योंकि देखो जिसका जितनी बार कटा होता है वो उतने हिसाब से बता रहा होता है। मैं अपने हिसाब से बिल्कुल कुछ नहीं बता रहा हूँ, आप मेरे ऊपर बिल्कुल मत सोचिएगा कि सर अपने एक्सपीरियंस से बता रहे हैं, बिल्कुल भी नहीं। मैं जाकिर खान की एक्सपीरियंस से बता रहा हूँ, द स्टैंड अप कॉमेडियन, कि सख्त लौंडे बनो, है ना, बुलाती है पर नहीं, बोलो कि नहीं फार्मा का रिवीजन क्लास कर रहा हूँ, नहीं आऊंगा, ब्लॉक कर दो, है ना, बोल दो गो टू हेल है ना, है ना, ब्लॉक कर दो ऐसे लोग। देखो हमारे पास एक लड़का भी है, पीसफुल वॉरियर, बोलता है आई ब्लॉक सच पीपल, है ना, बिल्कुल सख्त लौंडे बनो, ब्लॉक करके दिखाओ अभी, है ना, है ना। एग्जाम बाद भले ही अनब्लॉक करो, रिजल्ट लेकर आना, रिजल्ट हाथ में लेकर जाना, है ना, कि देखो, है ना, मैंने तुम्हें ब्लॉक किया, फायदा देख रहे हो ब्लॉक करने के बाद मजे ही मजे हैं लाइफ में, है ना। तुम्हारे जैसे क्या, ये देखो 4 में लोगों को डेट कर सकता हूँ, है ना, निकाह कर सकता हूँ, डेट नहीं बोलूंगा मैं है ना, 4 तक की इजाजत भी है अगर आप इफ यू नो व्हाट आई मीन ठीक है, चलिए सबके लिए नहीं, बाय द वे ये लग्जरी सबके साथ नहीं है ना। तो अगर आप में से कोई है जिसके पास लग्जरी है तो वो समझ रहा है, बाकी लोग तो नहीं है ना। चलिए आगे चलते हैं। I'll give you an example which is also there in the textbook. And let's say there is a person who is taking OCP. And I remember this is a case, I always tell this case in my class as well, that this was a case actually happened in front of us. There was a case, a person who is taking OCP, and if he started on rifampicin, that is one of the very important enzyme inducer. What this rifampicin is going to do, it's a first line anti-tubercular drug, very potent enzyme inducer. They will increase the rate of metabolism of OCP. So OCP will be rapidly metabolized. They will not be able to provide the contraceptive benefit. And they can lead to something called your contraceptive failure. They can lead to something called your कॉन्ट्रासेप्टिव फेलियर। ये क्या कर सकता है, कॉन्ट्रासेप्टिव फेलियर करा सकता है। तो व्हाट काइंड ऑफ एडवाइस आर यू गोइंग टू गिव, ऐसे पेशेंट को क्या एडवाइस दोगे, ऐसे पेशेंट को क्या एडवाइस दोगे। देखिए एडवाइस तो ये है कि देखिए ओसीपी इफ शी इज टेकिंग रिफाम्पिसिन यू कैन नॉट स्टॉप, तो यू कैन एडवाइस दैट यूज एन ऑल्टरनेटिव मेथड ऑफ कॉन्ट्रासेप्शन, यूज एन ऑल्टरनेटिव मेथड ऑफ कॉन्ट्रासेप्शन, like for example barrier method, right, barrier method like condom, right, male female whichever they are comfortable, right. So use an alternative method of contraception. That's very important question. Now the case that I was telling that happened with us, the patient was on OCP and she was recurrently getting UPT positive. Listen to me carefully, she was on OCP and very good brand of OCP, and she was recurrently getting OCP, UPT positive. Doctor, what kind of drug are you giving? Hannah, I am newly married, I don't want to use any barrier method, you have prescribed me OCP, but what is this? Hannah, I am taking regularly, I take it with same precision, same time, but still look at this. So you ask, do you take any drug? She says no, she denies any kind of drug intake, any kind of drug intake she denies, right, but still she is getting contraceptive failure. Then in one of the subsequent visits आपने प्यार से पूछा उनका पर्सनल एंड सोशल हिस्ट्री, ये बताइए कुछ और हिस्ट्री है कि नहीं, कभी कभी स्मोकिंग चलता है क्या? तो उन्होंने बोला यस, आई डू स्मोक, आई वर्क इन अ कॉर्पोरेट सेटअप, आई डू स्मोक एंड द स्मोकिंग इज समटाइम 10 to 15 स्टिक्स अ डे, मतलब ऑलमोस्ट मोर देन हाफ पैक पर डे, है ना। अब सोचिए मोर देन हाफ पैक पर डे, प्लस वो तो वर्किंग आवर में है, घर जा करके मान लीजिए न्यूली मैरिड हैं तो अगेन हो जाता होगा 2-3-4 हो ही जाता होगा, तो ऑलमोस्ट लेट से 1 पैक पर डे, 1.5 to 1 पैक पर डे। सो नाउ स्मोकिंग इटसेल्फ इज अ वेरी पोटेंट एंजाइम इंड्यूसर। स्मोकिंग का भी क्या होता है, इंड्यूसिंग प्रॉपर्टी होता है। सो क्या स्मोकिंग की वजह से भी कॉन्ट्रासेप्टिव फेलियर हो रहा था? यस। तो वहां पे स्मोकिंग सेसेशन को एडवाइस किया जा सकता है, लेकिन वो बोलेगी नहीं मैं नहीं छोड़ूंगी, मैं डॉक्टर बदल दूंगी, तब आप बोलोगे नहीं रुको है ना। तुम्हारे आने से जो चीजें समझ में आ रही हैं वो ये कि देखो अगर नहीं छोड़ना है तो दूसरा बेस्ट तरीका ये है कि यू हैव टू यूज एन ऑल्टरनेटिव मेथड ऑफ कॉन्ट्रासेप्शन। सो यू हैव टू काउंटर द बेस्ट क्या है, यू अवॉइड स्मोकिंग। यहां पे क्या, यू कांट सी अवॉइड रिफाम्पिसिन, रिफाम्पिसिन इज वेरी इंपॉर्टेंट फर्स्ट लाइन एंटी ड्रग, ठीक है। एक और एग्जांपल मैं बता रहा हूं, वार्फरिन इज वन ऑफ द warfarin is one of the anticoagulant. हाँ, बट शी इज अ यंग पेशेंट, देयर इज नो हिस्ट्री ऑफ फाइब्रॉइड। देखिए स्मोकिंग तो कई सारे जगह में प्रोटेक्टिव बताया गया है ना, लेकिन बेहतर ये है कि प्रोटेक्टिव ना बताया जाए, वरना पता चले कि बच्चे खुद ही लेना शुरू कर दें कि मैं तो अपने प्रोटेक्शन के लिए यूज़ कर रहा हूँ जी, फ्यूचर में फाइब्रॉइड्स ना हो, फ्यूचर में मुझे है ना इन्फ्लेमेटरी बाउल डिजीज ना हो, है ना, इसलिए मैं ये स्मोकिंग ले रहा हूँ, है ना। चलिए, तो warfarin is one of the anticoagulants, and along with warfarin, let's say the person consumed any of the enzyme inducer like rifampicin. So once again, warfarin will be rapidly metabolized, and they can lead to the failure of the warfarin. Now think and tell me, warfarin was supposed to work in the body for, let's say, 8 hours or 10 hours, but after rifampicin, it is rapidly metabolized. It is rapidly getting metabolized in 3 to 4 hours only. So in that case scenario, what will happen? The body is free of warfarin. What will be the outcome? Can you guys tell me? ये आपका क्विज हो रहा है. Can you guys tell me? Along with warfarin, if enzyme inducer is given, तो again warfarin failure will happen. So warfarin failure will present as what? OCP failure is presenting with the contraceptive failure, urine pregnancy test is positive. Here, if warfarin failure is there, then what will happen? Warfarin, someone was taking as an anticoagulant, maybe there is some hypercoagulable disorder. So in this case scenario, there will be increase in the risk of coagulability, increase in the risk of coagulation. Hypercoagulable state will actually increase. Hypercoagulable state is actually going to increase. All right. So ऐसे patient को what is the advice are you going to give? देखिए, the best advice is, best advice, do you know what? The best advice is don't give 2 drugs if they're fighting with each other. Don't give 2 drugs if they're having interaction with each other, right? But examiner don't want to know that, because even a non-medico knows that if 2 drugs are having problem with each other, don't give both of them together. What is the question there? So you have to understand the mindset of the examiner, and see examiner will ask what kind of dose adjustment you would like to do. Rifampicin, you want to give this because it's a first line anti-TB drug, very very important. So you can change it to rifabutin, but the problem is rifabutin के लिए आपको separately rifampicin लेना पड़ेगा, वो fixed dose combination वाले के साथ नहीं होगा. वारफरिन के साथ क्या आप डोज एडमिनिस्ट्रेशन, डोज एडजस्टमेंट करोगे, तो यू आर गोइंग टू इंक्रीज द डोज ऑफ वारफरिन. इंक्रीज द डोज ऑफ वारफरिन कुड बी वन ऑफ द स्टेप दैट यू कैन टेक. ठीक है. Peaceful Warrior says one of the guy tried to introduce me with ganja saying I will not have TB in future. है ना. तो ऐसे दोस्तों से आप बच के रहें, जो ऐसे दोस्त आपको मीठा मीठा बोल के और मीठी मीठी चीज़ें जो पिला रहे हैं, खिला रहे हैं, तो आई डोंट नो कि उस दिन आपको कैसा लगा. अच्छा ही लगा होगा, है ना, लेकिन कोशिश करिए कि ऐसे दोस्तों से दूर रहें, है ना. तो हम सबके पास ऐसे दोस्त होते हैं जो मीठा मीठा बोल के आके देते हैं कि एक ले लो, एक लेने से क्या होता है, कुछ नहीं होता एक लेने से, लेकिन शुरुआत वहीं एक से होती है ना. हम सबके पास वो एक दोस्त हैं. मैं अभी किसी एक ने दोस्त को याद कर पा रहा हूँ. अगर वो दोस्त मेरा ये वीडियो देख रहा होगा तो भी हंस रहा होगा, है ना, कि ऐसे दोस्त होते हैं हम लोग के पास, जो आते हैं मीठी मीठी बातें करते हैं और मीठा मीठा बोल के एक 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 देते जाते हैं. ठीक है. अब आते हैं एंजाइम इनहिबिटर पे. इंड्यूसर इंड्यूस करके आपको आउटकम क्या करा सकता है, फेलियर करा सकता है. एंजाइम इनहिबिटर, टू मच इनहिबिटर, राइट. सो वी हैव HIV protease inhibitor ending with the navir, like for example indinavir, ritonavir, erythromycin. Another one from the same family is called clarithromycin. Erythromycin, another one from the same family is called clarithromycin. Then we have amiodarone, one of the very important class 3 antiarrhythmic drug, ciprofloxacin, omeprazole, cimetidine, ketoconazole, and valproate. So all the anti-epileptic drug like phenytoin, carbamazepine, phenobarbital, barbiturate, they are all enzyme inducer, but there is one anti-epileptic drug that is known as inhibitor is called valproate. Valproate, very very important. And all the enzyme inhibitor you can remember with the very simple mnemonic, which I always say, inhibitor is going to be remembered as the mnemonic PEACOCK, पीकॉक वाला. और मैं चाहता हूं कि मेरे साथ एक बार रिपीट करिए और बहुत ही रिदम के साथ बोलिएगा. मैं बोलूंगा आधा, आप बोलना आधा. जहां कहीं भी हो कस के बोलना, तेज बोलना. अगर लाइब्रेरी में हो तो कोई दिक्कत नहीं, मन में तेज बोलना, है ना. चलिए बोलिए. ये क्या है, पीकॉक, राइट. तो मैं बोलूंगा पीकॉक वाला, आप बोलना पीकॉक वाला, मेरे साथ रिपीट करना, राइट. सो पीकॉक वाला आएगा, बोलिए पीकॉक वाला आएगा, इनहिबिट करके जाएगा. पीकॉक वाला क्या होता है? इनहिबिटर होता है। रिपीट करेंगे एक बार, मैं आधा बोलूंगा आप आधा बोलना, ठीक है? पीकॉक वाला आएगा, सुना नहीं दिया, आपकी ऑडियो का एक्सेस है मेरे पास, आप बोलिए वहां पे। पीकॉक वाला आएगा, वाला पे ज्यादा जोर दे रहा हूं मैं, ध्यान रखिएगा, वाला इज वाल्प्रोएट। सुनिए, पीकॉक वाला आएगा, इनहिबिट करके जाएगा, आपको एक नंबर दे के भी जा रहा है, ध्यान रखिएगा ये। पीकॉक वाला एरिथ्रोमाइसिन, क्लेरिथ्रोमाइसिन, सिप्रोफ्लॉक्सासिन, ओमेप्राजोल, ऑल दिस कीटोकोनाजोल, वाल्प्रोएट। अब देखिए, ये इनहिबिटर है, टू मच इनहिबिशन, टू मच इनहिबिशन, टू मच इनहिबिशन। अगर आपको मान लीजिए इस रिलेशनशिप में आप बहुत जल्दी इंड्यूस हो जा रहे थे, तो मैंने बोला इफ यू आर गेटिंग टू मच इंड्यूस्ड, इफ यू आर गेटिंग टू मच इंड्यूस्ड, द आउटकम वुड बी फेलियर। बट if you are trying, let's say after result, now you are trying, if you are getting inhibited again and again, every time you're trying you are not getting any reply, and she's blocking you now. So if you are getting too much inhibited now, अगर आपको बहुत ज्यादा inhibition होगा तो उस कंडीशन में क्या होगा, आपके अंदर क्या होगा? You will have so much toxicity against that person, है कि नहीं? यार मैं बार बार उसको मैसेज कर रहा हूँ, उधर से मेरा फ्रेंड मुझे रिप्लाई नहीं कर रहा है, कैसा दोस्त है या कैसी दोस्त है, जो भी है ना? तो इंड्यूसर इंड्यूस करके फेल करा सकता है, एंड टू मच इनहिबिशन विल लीड टू एक्यूमुलेशन ऑफ टॉक्सिसिटी इनसाइड, है ना? और जो टॉक्सिसिटी किसी ना किसी दिन फटता ही है, ज्वालामुखी की जैसे, बूम, है ना? मतलब जाओ, गो टू हेल, मुझे तुम्हारे जैसे दोस्त नहीं चाहिए, है ना? मैं ढूंढ लूंगा इतनी बड़ी दुनिया में किसी और को, राइट? तो पीकॉक वाला आएगा, इनहिबिट करके जाएगा, टू मच इनहिबिशन विल इंक्रीज द रिस्क ऑफ टॉक्सिसिटी, टू मच इनहिबिशन विल इंक्रीज द रिस्क ऑफ टॉक्सिसिटी। अगर बहुत इनहिबिट हो जाएगा तो टॉक्सिसिटी का रिस्क बढ़ जाएगा। जैसे कि आई कैन गिव यू द एग्जांपल, लेट्स से आवर पेशेंट हु वाज ऑन वार्फरिन, लेटर he self medicated or another physician started him on clarithromycin, right? Clarithromycin, that's exactly what we are doing, Dr. Akhil Reddy. Clarithromycin, now look at this, clarithromycin is a very very potent enzyme inhibitor. They will slow down the metabolism of warfarin, so warfarin ka metabolism will be slowed down, right? So let's say warfarin was supposed to last in the body for 10 hours, but now they are not metabolized, or the metabolism is so slow that they are available in the body for 20 hours, and you have taken the next dose, again there is accumulation, you are taking the next dose, again there is accumulation. So too much accumulation will lead to increase in the risk of toxicity. So okay, so warfarin toxicity will present as what? This warfarin toxicity will increase the risk of bleeding, so they will present as bleeding, जहां पे आपका PTINR बढ़ जाएगा, right? They will increase the risk of bleeding. So in that case scenario, the best advice that is given, don't give two drugs that are having problem together. क्लेरिथ्रोमाइसिन को मत दो, राइट? बट अगेन एग्जामिनर विल नॉट बी विलिंग टू नो दैट, ही वांट्स टू नो व्हाट काइंड ऑफ डोज एडजस्टमेंट यू वुड लाइक टू डू। अगर ऑप्शन में है डोंट गिव दिस टू टुगेदर, अगेन दैट्स द बेस्ट चॉइस, राइट? बट व्हाट काइंड ऑफ डोज एडजस्टमेंट यू वुड लाइक टू एडवाइस टू दिस पेशेंट? Remember this one, you have to actually reduce the dose of warfarin. Whatever dose of warfarin that was there, you can reduce the dose of warfarin. So again, this was one of the very very important question that is always asked, and I'll repeat all over again. Inducer induce करके आपको फेल कराने के लिए हमेशा तैयार रहता है, तो इंड्यूस नहीं होना है, सख्ती के साथ रहना है। और बहुत ज़्यादा इनिबिशन आ जाए तो टू मच इनिबिशन, इट कैन लीड टू टू मच टॉक्सिसिटी, टू मच इनिबिशन विल लीड टू टू मच टॉक्सिसिटी, है ना? इनिबिशन विल इंक्रीज द रिस्क ऑफ टॉक्सिसिटी, ठीक है? सिंपल सी बात है, ये हमारा टॉपिक एक नंबर हमारा तैयार हो गया, ठीक है? अब मेटाबॉलिज्म की बात, आई वाज डिस्कसिंग मेटाबॉलिज्म अगेन, माइक्रोसोमल एंजाइम्स, फेज 1 फेज 2, यू ऑलरेडी नो दैट the important microsomal enzyme that is mainly involved in the metabolism of the phase 1. For the phase 1 metabolism, mainly these microsomal enzymes are mainly involved, and it is this microsomal enzyme only, that can be induced or inhibited. It is them that can be induced or inhibited. Non-microsomal enzyme cannot be induced or inhibited. They will have very less chance, they will have high risk. For example, the most common microsomal enzyme is called CYP3A4, that is taking care of nearly 50% of the drug metabolism, right? Nearly 50% of the drug metabolism, CYP3A4. Now the CYP3A4 is not very important, but just good to know that CYP3A4 mein CYP stand for that they are going to be cytochrome P450, 3 is the family, A is the subfamily, and 4 last number is the gene number, right? 4 last number is known as your gene number, last number is the gene number. For example, the other member of the cytochrome P450 family is going to be CYP2D6. So if I ask you CYP2D6 mein what is the gene number, so you already know the gene number is 6. This is taking care of 20 to 30% of drug metabolism. D stand for depression wali dawaiyan, and your 6 again anti-arrhythmic drug except the amiodarone. Amiodarone is being metabolized by CYP3A4. Okay. CYP2C19, another very important. If you're asking one microsomal enzyme that you should never miss, I would say CYP2C19. CYP2C19, it is responsible for the metabolism of PPI like omeprazole and clopidogrel. Clopidogrel is a prodrug, remember. What is the meaning of prodrug, guys? They are inactive, and after metabolism only they will get activated. But omeprazole is an inhibitor of that. Let me just make it very simple. You see, there is something called clopidogrel, which is one of the P2Y12 inhibitor. It's an antiplatelet drug, P2Y12 inhibitor, and they are activated mainly due to microsomal enzyme CYP2C19. Normally, as I was telling to all of you guys, that clopidogrel क्या होता है, ये एक prodrug होता है. You already know the inactive substance after metabolism only they will become active. But if the person is consuming omeprazole, among PPI, not all PPI, only the omeprazole, that is the prototype drug of the PPI, it is having inhibiting property at the CYP2C19. So let's say if the person is consuming early morning before breakfast a drug by the name of omeprazole, and in later part of the day if he is consuming a drug like clopidogrel, which is supposed to get activated with the help of CYP2C19, because omeprazole has already inhibited CYP2C19 in the morning, do you think clopidogrel, if it is taken in the later part of the day, will get activated? The answer is no. Clopidogrel will not get activated. Or if there is any genetic abnormality in CYP2C19, it is said if there is any genetic polymorphism in CYP2C19, then again clopidogrel will not get activated. In fact, this was a question in somewhere around 2019 MLE also. काफी पुरानी बात हो गई अब. So genetic polymorphism, if there is in the CYP2C19, clopidogrel will not be working, and the patient will have higher risk of, platelet plug formation. Okay, that's very, very important. Then we are going to talk about the important receptors and their location. Some of the receptors are, you see here, ionotropic or ligand gated receptor, ion channel dependent like sodium, potassium, calcium, they're ion channels, and these are considered as the fastest acting receptor. They are the fastest acting receptor like GABA, A and C. I say put their name in the Guinness Book of World Record. They are the fastest acting receptor. इनके नाम को गिनीज बुक ऑफ वर्ल्ड रिकॉर्ड में हमें रिकॉर्ड करना चाहिए बिकॉज दे आर वेरी फास्टेस्ट एक्टिंग. GABA, A and C, NMDA, nicotinic receptor, all the nicotinic receptor like nicotinic receptor that is going to be NN and nicotinic receptor that is going to be NM. 5-HT3, ये वही 5-HT3 है that was used for nausea and vomiting, right? So put their name in the Guinness Book of World Record. These are the one that is working by ion channel receptors. Enzymatic receptor, the most common enzyme is going to be tyrosine kinase, right? And some of the important tyrosine kinase dependent will be insulin or insulin like growth factor 1, other growth factor like VEGF or HER2. A variant of insulin kinase, tyrosine kinase is going to be known as Janus kinase. So certain cytokines and hormones that we are having like interleukin, interferon, TNF, TGF, growth hormone and prolactin. So they are the certain hormones that are also working by this enzymatic receptor. So examiner actually asked to do the match the following. This is one of the recent INI question, INI PYQ, where they were asked to do the matching kind of question was asked, where you have to choose which one is ion channel, which one is working by enzymatic. Okay. So insulin like growth factor or VEGF or HER2, they are working by the enzymatic tyrosine kinase. A variant of that same is called Janus kinase. So that is going to be certain cytokines, interleukin, interferon, TNF, TGF, and hormones like growth hormone and prolactin. Repeat करिए मेरे साथ, अभी याद हो जाएगा. Fastest acting, मैंने बोला इनके नाम को कहाँ लिखवा दो. Put their name where in the Guinness Book of World Record. ऐसा क्यों Guinness Book of World Record पे नाम डालना? Because they are the fastest acting receptor. बहुत fast है ये. Enzymatic tyrosine kinase. So again, tyrosine kinase mediated activity is noted with the insulin like growth factor or vascular endothelial growth factor, cytokines and hormones like interleukin, interferon, TNF, TGF, growth hormone, prolactin. The most commonly utilized drug receptor, right? Most commonly used by majority of the drugs. Majority of the drugs are going to act by G protein coupled receptor. which is further three subtype GS, GI, and GQ. GS, GI, and GQ. They are the most commonly utilized receptor by majority of the drugs. Right? S, there are many, but important ones is B, D, S, H, A, बादशाह है ना. बादशाह मेरे पास बीटा है, डोपामीन है, हिस्टामीन है, सेरोटोनिन है, तुम्हारे पास क्या है ना. तो GS में स्टिमुलेंट है. रिमेंबर दिस GS इज मेनली गोइंग टू स्टिमुलेट your adenylate cyclase enzyme. Adenylate cyclase enzyme that will actually increase the level of secondary messenger, which is known as cyclic AMP. Okay, so we have beta, all the beta 1, beta 2, beta 3. In fact, this was a question in recent INI exam as well. Okay, dopamine 1, 5-HT4. 5-HT4 ये वही है प्रोकालोप्राइड वाला. Histamine 2, ranitidine वाला. ADS 2, vasopressin. Then we have GI mediated, so they are working by inhibiting, they inhibit the adenylate cyclase that will actually decrease the cyclic AMP. Plus, they are also going to open the acetylcholine sensitive potassium channel. They are also going to open the acetylcholine sensitive potassium channel. Whenever potassium channel is open, they will always and always lead to potassium efflux. So they lead to potassium efflux, right? So the GI mediator will be ADOMS, ADOMSH, ADOMS. So we have बादशाह और बादशाह का नाम है एडोम्स. एडोम्स एक बार क्विकली रिकैप करते हैं. अल्फा 2 इज द फेवरेट वर्ड हियर. अल्फा 2, डोपामिन 2, ओपियोइड, M2 M4. देन वी हैव 5HT1 एंड H स्टैंड फॉर हिस्टामिन 3 and 4. एडोम्स. तो वी हैव बादशाह और उस बादशाह का नाम है एडोम्स. बादशाह एडोम्स. रिपीट करिए, ये क्वेश्चन रहता है इसमें. बादशाह एडोम्स. और ये बातें भी मैंने आपको थोड़ी देर पहले बताई थी. M1 M3 M5, M1 M3 M5, ऑल द ऑड नंबर हियर GQ. ज्यादातर इनके साथ 1 इज द फेवरेट वर्ड, लाइक M1, AT1, अल्फा 1, H1, राइट. सो वी हैव बादशाह एडम्स का MAATHS. रिपीट, बादशाह एडम्स का मैथ्स इज क्वेश्चनेबल. ऐसा क्यों कि उसका मैथ्स क्वेश्चनेबल है? मे बी उसको मैथ्स नहीं आता था. बादशाह एडम्स का मैथ्स इज क्वेश्चनेबल का मतलब होता है मैथ्स वाले क्यू के थ्रू काम करते हैं. मैथ्स वाले क्यू के थ्रू काम करते हैं. दैट इज GQ, दैट वी नो इट इज ऑलवेज एंड ऑलवेज गोइंग टू स्टिमुलेट एंजाइम दैट इज कॉल्ड phospholipase C. Here it was adenylate cyclase, here it's called phospholipase C, that will be actually causing breakdown of PIP2 into IP3 and DAG. So what is the name of the secondary messenger? Let's repeat. The secondary messenger is here is IP3 DAG. The secondary messenger is GS will be cyclic AMP. Here cyclic AMP level is decreased and potassium channel is open, therefore potassium is going out. So GQ का action IP3 DAG के through हो रहा है, which is also causing more cyclic, which is also causing more calcium influx. ठीक है. Math M1 M3 M5, AT1, alpha 1, TSH, right, H1 and 5-2. H1 and 5-2. This will be working GS and GQ both. TSH, DS and GQ both. ठीक है. TSH, GS and GQ both. Where to get the PDF? Usually the PDFs are getting added on the Telegram, but due to some regulatory announcement, Telegram is banned. So I think some of my team member will announce here where you can actually get, I think from WhatsApp, maybe WhatsApp का कोई ग्रुप क्रिएट करके वहां पे आपको प्रोवाइड कर दिया जाएगा. ठीक है. आप अगर या तो इंस्टा पे फॉलो करते हैं तो आप इंस्टा पे फॉलो कर लीजिएगा. वहाँ पे आपको मैं अनाउंस कर दूंगा जैसे ही मुझे पता चलेगा मेरी टीम के थ्रू कि कहाँ पे अवेलेबल रहेगा. वहाँ पे आप वहाँ से आप ले सकते हैं आराम से. ठीक है. PDF आप ही के लिए PDF आपको मिल जाएगा, बस मेरे साथ आपको रिवाइज करना है. इंट्रासेलुलर रिसेप्टर, तो सेल के भीतर में हमारे न्यूक्लियस भी हैं और साइटोप्लाज्म भी है. सो इन द इंट्रासेलुलर रिसेप्टर, इफ यू आर गोइंग टू टॉक अबाउट साइटोप्लाज्म, some of these are going to located at the level of cytoplasm. Some of these are located at the level of cytoplasm. So at the level of cytoplasm, the glucocorticoids, mineralocorticoids like aldosterone, sex steroids, glucocorticoids, mineralocorticoids, sex steroid like androgen, progesterone, estrogen, all these are acting by the cytoplasmic receptor. Remember, all these intracellular receptors are also given the name as a nuclear receptor. इन सभी का नाम है न्यूक्लियर रिसेप्टर. दे ऑल एक्ट बाय अंडर द न्यूक्लियर ट्रांसक्रिप्शन, and this nuclear transcription nuclear receptor is considered as the slowest acting receptor. They are considered as the slowest acting receptor. Nuclear transcription definitely takes some time, so they are known as slowest acting receptor. Okay, cytoplasm. Next, it is going to be some of them are present in the nucleus. The nuclear receptor that are present in the nucleus, nuclear receptor present in the nucleus, that is going to be thyroxine, right? रेटिनोइक एसिड रिसेप्टर, रेटिनोइक एसिड, अच्छा यहाँ पे विटामिन डी भी है बाय द वे. रेटिनोइक एसिड रिसेप्टर, रेटिनोइक एसिड is again a receptor for vitamin A, other name. Then we have aryl hydrocarbon receptor, aryl hydrocarbon receptor, aryl hydrocarbon receptor, and we have PPAR, peroxisome proliferator activator receptor, alpha and gamma, PPAR alpha and gamma. Alpha के through the drug that is going to work are known as fibrates. So alpha fibrate, alpha fibrate, gamma g se glucose. So the drug that will be acting by this will be pioglitazone. The class of the drug is called thiazolidinediones. So the name of the drug is pioglitazone. So gamma glucose diabetics में बढ़ा रहता है, fibrate alpha fat जिसमें ट्राइग्लिसराइड बढ़ा रहता है, राइट. तो फैट लोगों में ट्राइग्लिसराइड बढ़ा रहता है, तो विल बी हैविंग अल्फा. तो यू हैव टू से एंड रिपीट विथ मी, अल्फा फा पी. बोलिए फा पी, है ना, फा पी. फूफा नहीं, फूफा अलग होता है, फूफा वो नाराज होने वाले फूफा अलग होते हैं. ये फा, अल्फा एंड फी. देन वी हैव गामा, गामा से होगा ग्लूको, है ना, ग्लूकोज, पायोग्लिटाजोन, है ना, फा फी. याद रखिएगा, फूफा मत याद रख लेना. एग्जाम में पता चला कि आप भी नाराज हो रहे हो, फिर आपका एग्जामिनर भी आपके बाद नाराज हो रहा है कि ये क्या चीज़ है ना. ये तो अच्छी बात है कि आपके एग्जाम में ऑब्जेक्टिव टाइप क्वेश्चन यू जस्ट हैव टू मार्क आंसर. अगर रिटन बेस्ड आंसर होता तो जरूर आप कुछ ना कुछ ऐसा लिख कर आते, एग्जामिनर सच में फूफा के रूप में आता. और मेरे पास अगर हम लोग कभी कॉपी चेक करते हैं MBBS वाले बच्चों का, तो ऐसे पेपर आते भी, ऐसे कॉपी आते भी हैं, है ना, पूरी कहानी लिखी रहती है. ठीक है. सो ये हो गए आपके इंपॉर्टेंट रिसेप्टर्स. एक क्वेश्चन आपके रिसेप्टर से भी रहते हैं, तो हम वही डिस्कस कर रहे हैं जो आपके एग्जामिनेशन के लिए अल्ट्रा इंपॉर्टेंट है. एज आई टोल्ड यू बिफोर एज वेल दैट रिविजन्स आर हैपनिंग मेनी प्लेसेस एंड यू गाइस हैव रिवाइज्ड, बट our revision which is mainly targeted and very much focused towards something that is very high yield is something that is this, right? It is mainly made on the basis of the NEET PG and FMGE PYQs. Okay, it's okay. Fufa Fafi may, if you did not understand Akhil Reddy, you will not miss anything. Fufa is a relation. I don't know what do you call Fufa in your language. If anyone knows what is Fufa, please explain, Akhil Reddy. If you know what you call Fufa in Hyderabadi language. ठीक है, फूफा को क्या बोलेंगे आपके लैंग्वेज में, आई डोंट नो. So that was again receptors and important microsomal enzyme and your drug interaction. The next one is going to be about vasomotor reversal of Dale. Vasomotor reversal of Dale, or also given the name as the Dale's reversal phenomena. It is given by a scientist by the name of Henry Dale, right? So question number 1, vasomotor reversal of Dale is caused by which type of drug? So remember, it is going to be caused by epinephrine in presence of alpha blocker. So when you give alpha blocker in presence of alpha blocker, if you give epinephrine, then there is only and only going to be fall in the blood pressure. We call this one as the vasomotor reversal of Dale. So this question was also asked in the examination, only fall in the blood pressure. Normally, if I ask you what will happen if I give epinephrine to my patient, epinephrine is one of the drug. I hope all of you guys are with me. Right, all attention on screen please. If I give you epinephrine that act on the every receptor of the sympathetic nervous system, alpha 1, alpha 2, beta 1, beta 2, beta 3, that is clinically non-significant, so I'm not writing that. So because of their action on the alpha 1, alpha 2, beta 1, beta 2, remember alpha 1 is always more in number and beta 2 is considered as a sensitive receptor. At this point of time, let's say this is one of the blood pressure of the patient 120, and at here if you're going to expose your patient with the epinephrine, because alpha 1 is more in number, that will be causing vasoconstriction and blood pressure will shoot, BP will increase. I hope all of you guys are listening to me. छोड़ दीजिए, फूफा जी को छोड़ दीजिए, फूफा जी को नाराज रहने दीजिए, आप मेरी तरफ ध्यान दीजिए, ठीक है? हाँ, फादर की सिस्टर का हस्बैंड, तो वो भी तो हिंदी में लिख दिया ना आपने, फादर की सिस्टर का मतलब भी समझाना पड़ेगा, दैट इज ऑल्सो इन हिंदी. तो फॉरगेट फूफा जी, है ना? लिसन टू मी, अदरवाइज आई विल बिकम फूफा जी. है ना? चलिए, a patient who is having a normal blood pressure, he is exposed on epinephrine. Now, epinephrine can act on every receptor. Alpha 1 is always more in number. Because of that, there will be vasoconstriction, and vasoconstriction will increase the blood pressure. So from 120, maybe this blood pressure is reached to 160, 170. Once the drug concentration fall down, remember at the lesser plasma concentration, beta 2, which is considered as a sensitive receptor. Sensitive means someone who is going to have their action at the lesser plasma concentration. Even at the lesser dose, they will be showing the action. So at the lesser plasma concentration now, the beta 2 will be active, and because of this beta 2 activity, the BP may further fall down to, let's say, 90. Once the drug is completely washed out, then they will go back again to the normal 120. So whenever we are going to give a blood epinephrine to my patient, or in an experimental setup, whenever we exposed experimental setup with the epinephrine, there is always going to be biphasic response. Are you guys following me here? Please say yes. Are you guys following me, right? Are you guys following me, right? Biphasic response. Biphasic response means, एक जल्दी से मुझे confirmation दीजिए. Yes, we got biphasic means first increase then decrease. First increase then decrease. I need confirmation from you that yes, we understood, because I know many number of times students, they just go with the flow, है ना? बाद में फिर उनको लगता है ये क्या था. Normally when you give epinephrine, remember the usual concept is epinephrine will always increase the blood pressure, but remember it is having biphasic response. What is the meaning of biphasic response? Whether increase, decrease, or decrease then increase. The answer is first increase. Why first increase? Because alpha 1 is more in number, so first alpha will always take. So first increase and then the BP will decrease. So this is biphasic response. At the second scenario, when I am going to expose my patient here, let's say in the morning itself or in the very beginning, alpha blocker has been exposed to the patient, alpha blocker like phentolamine or prazosin, and because of this the BP is now normalized. Because of this the BP is now normalized, right? So let's say BP is 120 because of the alpha blocker. And at this point of time, if now I expose epinephrine, what you are going to expect, normally I told you that you will be expecting something like this. This is what you are going to expect, whatever I have discussed here. But that is not going to happen. Why? Because alpha receptors are already blocked. So even if you are going to expose epinephrine, the BP will try to increase, but it cannot. Right? This diastolic blood pressure will not increase. Why? Because your alpha receptors are blocked. So now the entire epinephrine will now be working on the beta, and this will actually lead to fall in the blood pressure. So BP may further fall down, let's say to further 80, and after the drug completely washed out, it will go back again to the 120. So if you can see here, there is only going to be fall in the blood pressure. We call them uniphasic response. We call them uniphasic response. So again, there are two questions that I asked, and many number of times student will make mistake. Listen to me, where do you make mistake? Question will be asked like this: vasomotor reversal of Dale is elicited by. Vasomotor reversal of Dale is elicited by option A, alpha blocker, then beta blocker. सबसे पहला, the first, place where you are having high chance of making mistake, right? So this is the first trap: alpha blocker then beta blocker. Don't fall in the trap. Option B, epinephrine then norepinephrine. Again, a second trap. Don't fall for that. Third option, beta blocker then alpha blocker, right? Something like this can be given. Or the fourth option may be alpha blocker then epinephrine. So you'll have to be very, very careful. Alpha blocker then epinephrine. This is the one that is going to elicit vasomotor reversal of Dale. And we actually utilize this concept in the management of the pheochromocytoma. That explains the fact that why along with the alpha blocker you have to use beta blocker. Otherwise, beta, if it is left unblocked, they will again drive the heart crazy. They will not allow the better BP control. So vasomotor reversal of Dale, how will you elicit? Alpha blocker followed by epinephrine. What kind of response? Uniphasic response. The clinical application is going to be utilized in the treatment of pheochromocytoma. Pheochromocytoma. Okay. Now next. Drug of choice in cheese reaction. Cheese reaction. Who can tell me what is the drug of choice in cheese reaction? Come on, guys. Phentolamine. How will you elicit cheese reaction, and when can you see the cheese reaction? When you are going to give tyramine rich food like wine, beef, banana, cheese, milk product, any milk product, they all have tyramine rich food. Tyramine rich food intake in presence of MAO inhibitor. In presence of MAO inhibitor, they can actually lead to increase in the blood pressures, right? So that is called phentolamine. Phentolamine is the drug of choice for cheese reaction. Phentolamine is the drug of choice for cheese reaction. Drug of choice for BPH. What is BPH? Benign prostatic hypertrophy. So BPH drug of choice is going to be tamsulosin. That is going to be tamsulosin. Or alternative to this is going to be silodosin. The weaker analog of the tamsulosin is silodosin. Other drugs for BPH is going to be, let's say, drug like your prazosin. Remember, if there is a patient with a BPH with the hypertension, in that case scenario, they are the preferred agent. If there is a BPH with the hypertension, right? Do you know any other drug that we can prefer in the treatment of the benign prostatic hypertrophy? Do you know any other drug that we can prefer in benign prostatic hypertrophy? Tamsulosin, prazosin, any other drug that you know? Have you heard about finasteride? Right? Finasteride, that is 5-alpha reductase inhibitor, that can also be utilized. They are going to decrease the activated androgen. Okay? So they are the important drug that can be utilized in the treatment of BPH, benign prostatic hypertrophy. Drug of choice being tamsulosin. Always do remember, tamsulosin ka very good advantage as compared to prazosin is that tamsulosin do not cause postural hypertension. Okay? The next question, which beta blocker is having antioxidant property? A beta blocker that is having antioxidant property, one of which is called carvedilol, a third generation, and there is another one that is called nebivolol. Nebivolol is the same, that is also going to increase the nitric oxide release. So these are all PYQs. Beta blocker having antioxidant property, carvedilol, third generation beta blocker. Beta blocker that is preferred for glaucoma in asthmatic patient. Now, glaucoma in asthmatic patient, asthma somehow is very, very favorite for the examiner, and they always give you asthma wala case. So non-selective beta blocker are always going to be avoided. So timolol we will not be giving. So we will be giving what? Bitaxolol. It's one of the beta blocker. That is a cardioselective one. They will not cause precipitation of bronchial asthma. What is not given? Timolol is not given. टिमटिमाते हुए आंखों के लिए we should not give timolol, right? Timolol. Otherwise, your patient will also become twinkle twinkle star. टिमटिमाता हुआ तारा को in English we say twinkle twinkle star. So don't give in asthmatic patient. Otherwise, your patient will also become twinkle twinkle star. Okay. Labetalol, alpha beta. Mechanism of action. This was also asked in somewhere around 2023, 2024. So this is one of the third generation beta blocker with alpha blocking property, labetalol. Labetalol is also considered the drug of choice for hypertension in pregnancy or hypertensive emergency in pregnancy. It's a drug of choice. Benzaxol, benztropine, they are centrally acting anticholinergic drug. So they can lead to side effects like dryness of mouth, blurring of vision, constipation. Wala question was asked. Constipation and urine retention. These are the important side effects associated with the benzaxol, benztropine. They are the centrally acting anticholinergic drug. ED50, LD50, they are the parameters that are utilized in the assessment of therapeutic index. Effective dose in 50% of the responder and lethal dose in 50% of the experimental population. Okay. So therapeutic index, if I am going to see, it is equal to LD50 divided by ED50. Please remember, LD50 is the measure that we use mainly in the animal model. In the human model, you don't want to kill the human, so we use the parameter that is called TD50, a dose that can create toxicity in 50%. है ना? So therapeutic index generally is a measure of safety. Always do remember, if it is going to be wide therapeutic index, it is very, very safe drug. If it is narrow therapeutic index, normally we should not give. If you have to give only, you need to do therapeutic drug monitoring. You need to do therapeutic drug monitoring. So therapeutic index is always going to be a measure of safety. Therapeutic index is going to be a measure of what? Safety. Ritodrine, other drug in the same, is going to be isoxsuprine, another very, very important question. In fact, any beta 2 agonist could have the same side effect that I'm going to discuss next. Ritodrine, isoxsuprine, and terbutaline, they are all beta 2 agonists. Rita thera, isolated uterus, ritodrine, isoxsuprine, terbutaline, right? So they are important. See, beta 2 in the high dosage, they will also be acting on the beta 1, and they can increase the heart rate. They can increase the heart rate, and they can even cause palpitation. So whatever beta 2 that is present on the heart, they behave like beta 1. They act like beta 1. So it can cause tachycardia and palpitation. That is side effect number 1. Beta 2 is also present on the skeletal muscle, that will lead to what? Tremors. Beta 2 that is present on the skeletal muscle, that will lead to what? Tremors. Beta 2 on the liver, it will cause gluconeogenesis, glycogenolysis. See, beta 2 agonist we are using, if it is going to cause gluconeogenesis, glycogenolysis, what will happen to the glucose? It will always increase the glucose. Never mark hypoglycemia. Always choose it is can cause. Never mark hypo. It can cause hyperglycemia. Why it is causing hyperglycemia? Because beta 2 on the liver will lead to gluconeogenesis, glycogenolysis. Okay, so they can lead to hyperglycemia. Right now, beta 2 agonists, they can also increase the activity of sodium potassium ATPase, so more potassium will be kicked inside, so they could lead to hypokalemia, right? They can also lead to development of the pulmonary edema because of the decrease in the capillary tone. There will be also a risk of pulmonary edema. So ritodrine, isoxsuprine, systemic routes we are mainly using. Remember, tachycardia, palpitation, tremor, hyperglycemia. Mark my word, hyperglycemia I have written here, very, very important. Hyperglycemia, hypokalemia, pulmonary edema. I have not just told you the side effect, I have also given you the underlying reason for that side effect. I have also given you the underlying reason for the side effect that you have to remember. So, आप सिर्फ इसको रटिए मत, try to understand that as well. There was a question, low dose dopamine effect on the blood vessel. So low dose dopamine, when we say less than 2 microgram per kg per minute, it can cause vasodilatation. Low dose dopamine will cause vasodilatation. Okay, it will be working mainly at the D1. It will be mainly working at the D1. Okay, the simple mnemonic was DABBA, D1, beta 1 and alpha 1. I would just write it here, right? DABBA, D1, beta 1, alpha 1. So this is again dopamine. I will take this opportunity very, very quickly because they have already asked the D1. So clinical case-based scenario will be like this. A patient is presenting with a congestive heart failure. Which of the following dose should be given? So I think you all can understand, if the patient is having congestive heart failure, you have to give beta agonist. So which dose? Middle dose, because less than 2 microgram per kg per minute, it will be having D1. Then we have 2 to 10 microgram per kg per minute, beta 1, and more than 10 microgram per kg per minute, alpha 1. So this will be mainly causing vasodilatation. This is going to increase the heart rate and it will also increase the force of contraction. So in a patient with a congestive heart failure, you will be using this dose. Because this is already asked in around 2023, this will be asked, this may be asked in the upcoming examination. If there is a patient with a shock with oliguria, we are going to utilize this one. This can increase the blood pressure. So this will be utilized in the patient with the shock. As a matter of fact, if there is a patient with shock with oliguria, dopamine is the drug of choice. Shock with oliguria, dopamine is the drug of choice, right? So कहाँ से सवाल पूछेगा? आप इतना रिवाइज करके जा रहे हो कि कोई क्वेश्चन छूटना ही नहीं है आपका. आपको बस यहाँ से स्ट्रॉन्ग रहना है, मेंटली स्ट्रॉन्ग रहना है, सख्ती के साथ जाना है आपको. आपने पढ़ा है, यू आर गोइंग टू गेट थ्रू दिस वन, राइट? थोड़ा सा मामला गड़बड़ तो नहीं हो रहा है, राइट? बिकॉज थोड़ा पानी नहीं पी लीजिए आप लोग भी, राइट? बिकॉज जैसे कि मैंने बोला कि 4 घंटे आपके और मेरे, और उस 4 घंटे में कितना समय हो गया? आई थिंक 2 घंटे हो गए, मतलब हम हाफ वे हैं, वी आर ऑलरेडी हाफ वे। 2 घंटे और आपके चाहिए, राइट? तो आपके और मेरे 4 घंटे आज बिल्कुल भी मिस नहीं होने चाहिए, बिकॉज ये 4 घंटे कुछ बेहतर डिसाइड कर सकते हैं। इस उम्मीद के साथ वी आर प्रोसीडिंग। आर वी ऑल ऑन द सेम पेज? हाई एवरीवन। यस, सो वी हैव लो डोज डोपामिन इफेक्ट ऑन द ब्लड वेसल। अच्छा, मुझे पता भी नहीं चला, अगर मैं टाइम देखता नहीं तो मुझे पता भी नहीं चलता कि 8:30 हो गया, 2 घंटे हो भी गए, है ना? 8:30 नहीं हुआ, 8:40 हो गया रहा था, 2 घंटे से थोड़ा सा ज्यादा हो गया, बट एनीवेज। विच सिंपैथेटिक एजेंट इज कॉजिंग रिफ्लेक्स ब्रेडिकार्डिया? चलिए स्टार्ट करते हैं दोबारा, ठीक है, ब्रेक ओवर। विच सिंपैथेटिक एजेंट इज कॉजिंग रिफ्लेक्स ब्रेडिकार्डिया? चलिए जल्दी बताइए। देखिए, sympathetic drug, they can cause tachycardia, but the reflex bradycardia is only and only caused by norepinephrine. Very very important. So norepinephrine, it can increase the blood pressure and it can decrease the heart rate, but this decrease in the heart rate is called reflex bradycardia. It is called reflex bradycardia. 5 मिनट का क्या? पीसफुल वॉरियर गौरव बाइसला, 5 मिनट का क्या ब्रेक? लाइव क्लास में ब्रेक तो ले पाना मुश्किल है, बट अगर आपके कुछ सवाल हैं तो वी कैन कंटिन्यू। अगर आप पढ़ते पढ़ते थक गए हैं तो वी कैन कंटिन्यू, थोड़ी बहुत कुछ और बातें कर लेते हैं, है ना? यूजुअली आपके एग्जामिनेशन में क्या होता है ना कि आई हैव सीन सम स्टूडेंट्स, दे आर एबल टू सॉल्व द डिफिकल्ट क्वेश्चंस, but they are having problem in solving the easy ones sometimes. Like for example, the graph of this reflex bradycardia causing agent, है ना? तो you be very careful, है ना? You guys are good at doing very difficult question, very important question. Sometimes it is asked in NICT, but easy ones you guys are making lot of mistake, है ना? तो बी केयरफुल विद दैट कि डिफिकल्ट क्वेश्चन ठीक है, सही हो रहे हैं तो अच्छी बात है, बट इजी वंस गलत नहीं होने चाहिए, ठीक है? तो बड़ा जो समंदर जैसा क्वेश्चन है उनको आप सही कर ले रहे हो, और छोटे छोटे जो फुदू से क्वेश्चन वो आप गलत कर दे रहे हो, है ना? तो इसलिए आपको इन सब पे बहुत ध्यान रखना है ना? एक शायर ने बहुत अच्छी बात कही भी है उसमें कि एक समंदर है जो मेरे काबू में है। सुन रहे हैं आप लोग? ब्रेक चल रहा है आपका? है ना? एक समंदर है जो मेरे काबू में है, और एक कतरा है जो मुझसे संभाला नहीं जाता। तो ये कतरा वाले क्वेश्चन है, आपसे संभलते नहीं है ना? इस लाइन में आगे जो राइटर हैं वो बोले हैं कि एक समंदर है जो मेरे काबू में है, और एक कतरा है जो मुझसे संभाला नहीं जाता। एक उम्र है जो बितानी है उसके बगैर, है ना? सुन लीजिए। है ना? एक उम्र है जो बितानी है उसके बगैर, और एक लम्हा है जो मुझसे गुजारा नहीं जाता, है ना? तो छोटी छोटी चीज़ों को आप गलत ना करें, और इस बात का यकीन रखें, आपने पढ़ाई करी है, आपने रिवाइज किया है, एंड यू आर गोइंग टू गेट थ्रू दिस। आई एम प्रिटी श्योर अबाउट दिस। जब भी आएगा आप इसको आसानी से करके लेके जाओगे। आई एम प्रिटी श्योर अबाउट दिस, ठीक है? चले आगे। एक ये ऐसा क्वेश्चन है दैट इज गोइंग टू बी द क्वेश्चन ऑन योर पोटेंसी एंड एफिकेसी। वी यूज लो डोज, डॉक्टर रेड्डी, वी यूज लो डोज। लो डोज मतलब हम लेस देन 2 वाला यूज करते हैं ओलिगोरिया वाले केस में। We are proceeding further now. So this type of question, they will be asking whether you have to identify which is the potent drug. So potency order. Potency order, you always go from left to right. Potency order, you always go from left to right. This is called the dose line, log dose, and this is the response line. Okay. So potency order, when you are going to see which is the most potent, so you go from left to right. So A is followed by B, followed by C, followed by D. So potency is power. P for potency, P for power. Anything which is very powerful will be working at a very lesser dose. Next, it is going to be efficacy. Next, it is going to be efficacy. Efficacy sounds like Eiffel Tower. Efficacy ko I always compare with the Eiffel Tower, and you already know why is Eiffel Tower very famous, because of its height. Eiffel Tower is very famous because of its what? Because of height. So anything that is very, very tall will be highly efficacious. Clinically, efficacy is very, very important. So B is equi-efficacious to C. B is equi-efficacious to C, followed by A, followed by D. This is one of the same questions that has been asked in the examination. Okay? Yes. Many students do forget this one, but not after our today's class. What did I say? Potency is power. So something which is very powerful will be working at the very lesser dose, right? Efficacy sounds like Eiffel Tower. Efficacy, how efficacious is the drug? How effective is the drug? It is the efficacy which is going to be clinically it is more important. Clinically, it is going to be more important, right? So I say efficacy Eiffel Tower. So anything which is highly efficacious, Eiffel Tower kitna uncha hoga, right? So that is going to be this one. Another way to remember this, if you ever forget this one, never hesitate to take help from the help mnemonic that we discussed. Height will be telling you about efficacy, left wala will be telling you about the potency. Height, जो सबसे ज़्यादा height पे होगा, that will be, जो सबसे ज़्यादा height पे होगा वो बहुत ज़्यादा efficacious होगा. Left in the graph will be most powerful, left potency, right? Left in the graph will be more powerful, more potent. So let's ask a question. All my dear student will be giving your reply in the comment section. For causing sedation, two drugs were used. One caused sedation at 0.5 milligram, other caused sedation at 5 milligram. Which one is very powerful? For causing sedation, one caused sedation at 0.5 milligram and other caused sedation, let's say very high sedation, you can say. We are not going to talk about high or low. Other caused sedation at 5 milligram. Which is more potent, which is more powerful? Can you guys tell me? Just comment your answer. 0.5 or 5? Which one is more powerful? Very easy question. It's not very difficult even. One caused sedation at 0.5, other caused sedation at 5. Which is more powerful? Very obvious, 0.5, right? So if you're going to look at the graph, this is going to be 1, 2, 3, 4. So if the drug is working at the very first dose, they are very powerful. If they're working at the little lesser dose, they are lesser powerful, right? So this one image could be a source of many type of question. Same image could be a source of many kind of question. How is it possible? Let's see. Potency, it is talking about the dose. Lesser dose, if it is working, they are more powerful. Always do remember that this potency can be affected by a competitive inhibitor. If a competitive inhibitor is given, in presence of a competitive inhibitor, remember, you require a high dose to achieve the same response. In presence of competitive, let's say there was one drug that was causing sedation at 0.5 milligram, but another drug that is also competing for the same site, then next time it might not cause a sedation at 0.5, so you might require a very high dose, let's say 1 milligram or 2 milligram. So competitive inhibitor will actually require a high dose. So whenever you require a high dose, you will always move more towards the right side. And as you move more towards the right side, what is happening with the potency? This is more potent, this will be less potent, this will be further less potent, this will be further less potent. So competitive inhibitor will always and always decrease the potency. That is very, very important. Non-competitive inhibitor, they do not compete for the same site. They will work at a different site. A non-competitive inhibitor, if it is given, no matter how much dose you give, it can never bring the same kind of effect. So non-competitive inhibitor, it will actually decrease the efficacy. Non-competitive inhibitor will decrease the efficacy. Let me just give you a simple example of biochemistry. Remember, competitive competing for the same site, non-competitive binding at a different site and changing the structure of the receptor, and therefore no matter how much dose you give, the response is not coming. So non-competitive, and for non-competitive, and for graph will be coming niche. A very good example that I can give you, if I ask you which of the following two drugs are example of competitive inhibitor? So I can say which of the two drugs are example of competitive inhibitor. So I can say, see, दोनों का height same अगर है तो they are showing the example of competitive inhibitor, because at the higher dose same response can come. At the higher dose same response can come. So B and C could be an example of competitive inhibitor. Then I can ask you, which could be the example of non-competitive? Even if you are increasing the dose, the response is not coming. So I can say these two. So non-competitive, niche aa gaya. So C and D could be an example. As I told you, same graph can be asked for multiple concepts. Potency, efficacy, competitive and non-competitive inhibitor also. Non-competitive graph will be coming niche aa gaya, right? So C and D are the example of non-competitive inhibitor. Very, very important concept. Which one is most competitive, which one is most efficacious, clinically which is more important, competitive inhibitor में क्या हो रहा है, non-competitive inhibitor में क्या हो रहा है, everything has been summarized. Also, if you guys are little more open to discussion, I would just discuss one more point here, which because when I think myself like an examiner, maybe your examiner has also asked a similar kind of question in past. You can check out 2024 question. That which one is an example or showing the action of agonist. What is the meaning of agonist? What is the meaning of agonist? Drug after binding with the receptor producing maximal activity. So let us say this is the maximal response, 100 or maximal response. And any number below that will be submaximal activity. So if I ask you, out of these graph, see, I told you single graph but multiple concept. Out of these graph, which one could be an example of agonistic activity? Which one is showing 100% activity? So which one is an example of agonistic activity? So agonist ka example will be B and C. Agonist ka example will be B and C could be example of agonist, because they are showing 100% response. But any response that is less than that will be partial agonist. So which one will be example of the partial agonist? Partial agonist. So this could be A हो सकता है partial agonist and D हो सकता है partial agonist. A and D are the example of partial agonist because the response after binding the receptor is not 100%. So that is lesser. Again, let me repeat all over again. It's a single graph, but multiple concept I have explained in the same graph. Okay, let's repeat again. Potency A, B, C, D. A, B, C, D from left to right. It could be 1, 2, 3, 4 also in your examination, right? Efficacy, you go from high to low. Efficacy, Eiffel Tower. सबसे ऊंचा, सबसे efficacious, right? उससे नीचे आता जाएगा. Efficacy will keep on decreasing. Non-competitive inhibitor is the one that will actually decrease the efficacy. So if 100% is with the C, then non-competitive D, or B and D are also the same. B and D are also example of the non-competitive, but B and C are example of competitive inhibitor. Competitive, if you give high dose, same response can be achieved. Competitive inhibitor at the higher dose, same response can be achieved. Remember that, competitive inhibitor. I think in your biochemistry also it was taught to you Km, Vmax, ये वाला concept आपने पढ़ा होगा. Same concept is applied in the pharmacology here. ठीक है? Help mnemonic that I told you, height will be telling you about the efficacy, left in the graph will be telling you about the potency. Another concept is the concept of agonist. So any drug after getting the, after binding with the receptor, if it is producing 100% response, they are agonist. So what two drugs are showing 100% response? B also is showing 100% response. C also is showing 100%. So two drugs given at two different time. If it is showing 100% response, it is known as agonist. Partial agonist, after binding with the receptor, any response lesser than the 100 will be known as a partial agonist, right? So I hope all of you guys have got this concept. These are very, very important. And if you are solving FMG solution, you must have seen this question. It was a PYQ as well, and 4 concept was asked in one single graph. Which one is a competitive inhibitor, which one is an example of non-competitive inhibitor, and which one is example of agonist, which one is most potent, ऐसे करके. Snake bite के लिए in forensic medicine also it was taught to you. We have to utilize polyvalent anti-snake venom, and after that we are going to utilize neostigmine. Along with neostigmine, we will also be adding atropine. In forensic medicine, they always teach you something called do it right approach. In forensic medicine, they will teach you something called your right approach. So first and foremost, you will be reassuring the patient. reassure. Then other one is called immobilize, reassure, immobilize, go to hospital, GH, go to hospital and tell the doctor, do it right. ठीक है, all right, tell the doctor. So this is going to be do it right, reassure, immobilize. So the question that was asked, a patient is brought in the hospital, ठीक है, immobilize, go to hospital, tell the doctor what was the snake looking like, है ना, was it very beautiful, was it wearing lipstick or not, है ना, when it bite, how was the marks, was there pain or not, blood आया कि नहीं आया, सारी चीजें आपको एक्सप्लेन करनी पड़ेगी डॉक्टर को, ठीक है. पोटेंसी एफिकेसी वाला अगर आप मुझे पूछ रहे हो तो मैं फिर से बता रहा हूँ, P for potency, P for power. Just try to watch it out, all this section that I have explained you will always be able to get 1 marks from this, and it's all time favorite question of the examiner, है ना. Competitive inhibitor, see if two drugs are competing at the same site, and when you give high dose, the same response can be achieved. So if the same response can be achieved, that means they are competitive inhibitor. Always remember, competitive inhibitor में हमेशा दोनों का हाइट बराबर रहेगा, तो कंपटीशन बराबरी के लोगों में होती है, हमेशा ध्यान रखिए. योर कंपटीशन विल बी विद द नीट पीजी, नॉट विद द नीट यूजी. नीट यूजी कंपटीशन होगा नीट यूजी वालों के साथ, है ना. हालांकि उन लोगों का कंपटीशन हो नहीं पा रहा है, बेचारे पेपर लीक से परेशान है, और आपके साथ भी पहले हो चुका है. हालांकि ये बात बहुत ज़्यादा बाहर आई नहीं थी, लेकिन पहले 2023-24 में आपको पता है कि कभी पेपर का डेट आगे जा रहा है, कभी पीछे आ रहा है ना. तो कंपटीशन बराबर के लोगों में होता है, जो नॉन कंपटीशन होता है ऊपर नीचे के लोगों में होता है. तो नॉन कंपटीटिव में ऊपर नीचे हो जाता है ग्राफ, है ना, नॉन कंपटीटिव वाला नीचे रह जाता है, ठीक है. कंपटीशन बराबर के लोगों में होता है, इतना बस याद रखिएगा. स्कॉर्पियन बाइट के लिए वी विल बी यूजिंग द ड्रग दैट इज कॉल्ड प्राजोसिन. Varenicline, it's one of the anti-smoking drug, very, very important anti-smoking drug, partial agonist at the nicotine receptor. Bupropion, it's one of the anti-smoking drug. It's a preferred anti-smoking drug in patients with the history of depression. In patient with the history of depression, right? In patient with the history of depression, तो उसको प्यार से बोलिए भाई साहब पियो नहीं, है ना. Alpha blocker that we know, let's say alpha 1 blocker, if you are going to talk about, we have drugs like your prazosin, terazocin, alfuzosin, है ना, prazosin, terazocin, alfuzosin, all these are going to be zosin. They are associated with important side effect like your postural hypotension, retrograde ejaculation. This is another very important side effect, postural hypotension, retrograde ejaculation. Okay, postural hypotension, retrograde ejaculation, this is very, very important side effect, right? In the eyes, what they can cause, alpha causes mydriasis, so eye may they can lead to meiosis. Always remember, this postural hypotension is a very important problem with alpha 1 blocker, and that is why when we use 5-HT alpha 1A blocker like tamsulosin, examiner asks, okay, what is the advantage of tamsulosin over prazosin? The advantage of tamsulosin is that they do not cause postural hypotension. They do not cause postural hypotension. Very, very important. Okay? Yes, examiner loves the drug prazosin, clonidine, है ना, वेसामिकॉल, ये सब पुराने वाले जो ड्रग है, जितने सीनियर एग्जामिनर है, दे लव दिस. ठीक है. So important shocks, for example, anaphylactic shock, we will be using adrenaline 1:1000 intramuscularly. We will be injecting 0.5 ml to the patient. Septic shock, norepinephrine only shock जहां पे हार्ट रेट बड़ा होता है. Norepinephrine causes reflex bradycardia. Cardiogenic shock with the fall in the blood pressure, again we can utilize norepinephrine. But cardiogenic shock with normal blood pressure अगर है, तो in that case scenario we can utilize dobutamine. Cardiogenic shock because dobutamine is the selective beta 1 agonist. Neurogenic shock we can utilize norepinephrine. नहीं है तो वी कैन ऑल्सो यूटिलाइज न्यूरोजेनिक शॉक में फिनाइलेफ्रिन, अल्फा 1 एगोनिस्ट, alternatively phenylephrine alpha 1 agonist. Vasovagal shock we can utilize atropine. अगर आता है शॉक विथ ओलिग्यूरिया, तो आई थिंक ये बात मैं आपको पहले ही बता चुका हूँ, शॉक विथ ओलिग्यूरिया वी कैन यूटिलाइज डोपामिन, हाई डोज वाला. बट अगर ये भी आ जाए शॉक विदाउट ओलिग्यूरिया, देन वी कैन यूटिलाइज द ड्रग डोब्यूटामिन, राइट. सबसे कॉमनली जो इसमें पूछा जाता है दैट इज गोइंग टू बी एनाफिलैक्टिक शॉक, स्पेशली आफ्टर बी स्टिंग और आफ्टर पेनिसिलिन इनटेक, है ना. तो उसमें कितना देंगे, 1:1000. 1:1000 मीन्स 1 ग्राम इन 1000 ml NS, 1 ग्राम इन 1000 ml फ्लूइड. तो उसको हम इंट्रामस्कुलरली 0.5 ml देते हैं. 0.5 ml whenever we inject, we are injecting 0.5 milligram of the drug. The cardioselective beta blocker, these are going to be A2 B2 या A से N तक आप याद करते हैं, A से N तक कार्डियोसेलेक्टिव होता है, आप वैसे याद कर लो, A से N तक वाला, राइट. मैं बोलता हूं A2 एटेनोलॉल एसिबिटोलॉल, B2 बिटैक्सोलॉल बिसोप्रोलॉल, लैंडायोलॉल दैट इज गोइंग टू बी लव्स, सेलिप्रोलॉल, देन वी हैव मेटोप्रोलॉल, एस्मोलॉल, नेबिवोलॉल, है ना. तो मेरे साथ एक बार रिपीट करिए, क्या है A2 B2, या तो ऐसे याद कर लिए, या A से लेके N तक ये सब कार्डियोसेलेक्टिव में आ जाते हैं. एंड दीज ड्रग्स आर फाउंड सेफ इन द ब्रोंकियल आस्थमा, they are very safe in the bronchial asthma. Asthmatic patient में non selective beta blockers are always avoided. Please remember a very important concept here, that the non selective beta blockers are always going to be contraindicated in bronchial asthma and COPD. Very important question. Bronchial asthma and COPD, peripheral vascular disease like Raynaud's, and also in diabetic mellitus they will mask the hypoglycemic symptom, right. So remember, नॉन सेलेक्टिव बीटा ब्लॉकर वाला जो क्वेश्चन है ये ऑल टाइम फेवरेट क्वेश्चन है, आजमाटिक वाला ऑल टाइम फेवरेट क्वेश्चन है. BPD इसमें कॉन्ट्राइंडिकेटेड होता है. एंड सेलेक्टिव बीटा ब्लॉकर A2, बोलिए क्या है, A2 B2 लव्स, C फॉर सेलिप्रोलॉल, एंड देन मेन. जल्दी जल्दी पढ़िए एक साथ, एक बार पूरे लाइन को ठीक से पढ़िए. A2 B2 लव्स, सेलिप्रोलॉल, मेन, मेटोप्रोलॉल, एस्मोलॉल, नेबिवोलॉल. याद रहेगा. तो कुछ रिसेंट क्वेश्चन आए थे, माउंटेन सिकनेस, देखिए ये भी क्वेश्चन आपके एग्जाम में आता रहता है. क्या सवाल पूछ रहे हैं, माउंटेन सिकनेस बार बार आते हैं. पहले पूछे, इसका मैं इवोल्यूशन बता रहा हूं, है ना, जैसे ह्यूमन का इवोल्यूशन होता है, एमसीक्यूज का भी इवोल्यूशन होता है, बिकॉज यूजुअली वी सी टॉपिक्स आर सेम, थोड़ा लाइन चेंज हो जाता है. पहले पूछे माउंटेन सिकनेस का ड्रग ऑफ चॉइस क्या है. ठीक है, स्टूडेंट्स ने बोला ठीक है, फला इज द ड्रग ऑफ चॉइस, इट इज कॉजिंग दिस काइंड ऑफ प्रॉब्लम, दिस लेवल ऑफ CSF, है ना, ये चेंजेस कर रहा है, इस तरह से हाइपर वेंटिलेशन होता है, ऑल दिस दे हैव अंडरस्टूड. तो पूछा क्या है, तो स्टूडेंट सेड द ड्रग ऑफ चॉइस क्या है. फिर पूछा अगली बार में, ठीक है, एट विच साइड डज इट वर्क. सो स्टूडेंट सेड ओके दे आर वर्किंग एट दिस पर्टिकुलर साइड. देन इन द रिसेंट एग्जामिनेशन, इन द रिसेंट आई थिंक 2025 ओनली, दे गिव अ ट्यूब्यूल का इमेज और पूछा इस ट्यूब्यूल में कहाँ काम करेगा. पेशेंट लद्दाख गया, और लद्दाख गया तो उसको ऐसे सिम्टम आने लगे. अब उसको दवा दिया गया, इट इज वर्किंग ऑन सम पॉइंट इन दिस ट्यूब्यूल, किस जगह पे काम करेगा बताइए. तो अगेन देयर इज इवोल्यूशन ऑफ द क्वेश्चन, राइट. सो अगला एग्जाम का क्वेश्चन क्या हो सकता है, अब यहीं से हम डिराइव करेंगे. ड्रग ऑफ चॉइस फॉर माउंटेन सिकनेस क्या होगा, बिल्कुल सही जवाब आपने बोला, क्या, एसिटाजोलामाइड. व्हाट इज द मैकेनिज्म ऑफ एक्शन, दे आर गोइंग टू बी कार्बोनिक एनहाइड्रेज इनहिबिटर वर्किंग एट द लेवल ऑफ प्रोक्सिमल कन्वोल्यूटेड ट्यूब्यूल. इतना तो क्लियर हो गया. सेम सवाल पे देखिए कैसे कैसे, सेम टॉपिक पे कैसे कैसे सवाल पूछा. नाउ द नेक्स्ट पोटेंशियल MCQ कुड बी, आई मे बी रॉन्ग, कुड बी that how is it actually working. So carbonic anhydrase inhibitor, they always cause loss of bicarbonate, and because of that there will be acidosis. So they can lead to metabolic acidosis, and they can even lead to CSF acidosis. This CSF acidosis can actually induce hyperventilation. So whenever you are going to cause hyperventilation, because of hyperventilation there will be washout of what, hyperventilation की वजह से there will be washout of CO2, है ना. तो hyperventilation की वजह से there is going to be CO2 washout, hyperventilation की वजह से there will be CO2 washout. ठीक है. माय डियर स्टूडेंट्स, मैंने आपको पहले भी बोला था इसके बाद आप फार्मा नहीं पढ़ोगे, इसलिए ठीक से मेरे साथ पढ़ लो. डू नॉट स्टडी लाइक एक बर्डन की तरह. इत्मीनान से सिट बैक, रिलैक्स, ट्राई टू रिवाइज ऑल दिस स्टफ्स आर देयर इन योर नोट्स. You will be getting a PDF also of the same, but I want you to I want you to learn with me like your, let's say, study buddy. कि मेरा एक फ्रेंड आया है ना, और मेरे साथ बैठ के रिवाइज कर रहा है, बिकॉज हो सकता है इसके बाद मुझे दोबारा फार्मा पढ़ने का जरूरत ना पड़े. तो इसलिए आई वॉन्ट यू टू बी वेरी ओपन फ्रॉम ईयर. बर्डन लेके नहीं पढ़ना है. किस तरह क्वेश्चन आएगा इसी तरीके से अपने दिमाग को खोल के पढ़िए, है ना. दिमाग को खोलिए, खिड़की को खोल दीजिए, है ना. ओपन ऑल काइंड्स ऑफ बैरियर एंड देन लर्न विथ मी. ठीक है. आई होप कि सारी चीजें खुली हुई हैं, सारे सिस्टम्स खुले हुए हैं आपके. ठीक है, कोई ब्लॉकेट नहीं है थॉट प्रोसेस में. मोशन सिकनेस बता दीजिए क्या होगा. What is the drug of choice in motion sickness? What's the drug of choice in motion sickness? Anyone? तो बोला कि पेशेंट को ट्रैवल करना है. केस बेस्ड सिनारियो विल बी देयर. ऑलवेज एक्सपेक्ट केस बेस्ड सिनारियो. Scopolamine. Now when this question was asked, scopolamine was not in the option. Next option will be promethazine, again the same antihistaminic drug having anticholinergic property. If it is also not there, we can even use diphenhydramine. Diphenhydramine. Please do not don't consider all of them. You use any one. Scopolamine is the drug of choice. The drug of choice is going to be scopolamine. बाकी अगर नहीं है तो we can use other first line drug which is promethazine having antihistaminic drug. An antihistaminic drug having anticholinergic property. Morning sickness के लिए we'll be using doxylamine, a first generation antihistaminic drug. इसके साथ we'll always be adding vitamin B6. Penicillin mediated hypersensitivity reaction, that is going to be type 1 hypersensitivity reaction, Ig mediated. We are going to use adrenaline 1:1000. Intramuscularity will be giving 0.5 ml. My dear students, एक अगला क्वेश्चन जो इसके साथ होता है, the most preferred antibiotic in penicillin allergy, the most preferred antibiotic in penicillin allergy is going to be your macrolides. It is going to be macrolides. The most preferred antibiotic in penicillin allergy is going to be macrolides. ठीक है, क्लियर है. Macrolide like erythromycin, azithromycin, they are going to be the most preferred antibiotic. Okay, erythromycin, azithromycin, they are the most preferred. Alternative to this is going to be, ये although antibiotic का है, but again revision है तो सारी revision हम कर लेंगे. We will to do revision of everything. Alternative to this is going to be monobactams. Under monobactam we have only one drug. Under monobactams we are having only one drug, and the name of the only drug under monobactam is called as Trionam. Under monobactams we have only one drug, that is known as your as Trionam. है ना. monobactam इकलौता है ना. आज से मेरा जीवन तेरे नाम है ना. Next is going to be which mydriatic and cycloplegic agent is preferred in the pediatric population because they have very stronger ciliary muscle tone. We'll be using 1% atropine ointment. We are going to use 1% atropine ointment. 1% atropine ointment, right? Because they are their ciliary muscle tone is much stronger. I have not seen the paper which is not having this kind of question. Mydriatic cycloplegic. For example, if I am going to review 10 papers, 6 out of the 10 paper will have one question from mydriatic cycloplegic in the eyes. So remember this one, because I am telling you about the kid here. अगर ये same question about adults आ जाए और elderly आ जाए, तो we can utilize either tropicamide. If it is not there, then we can even utilize cyclopentolate. So we have many other drugs like atropine, scopolamine, homatropine, है ना. cyclopentolate ये भी नहीं है, तो you can even use homatropine. So multiple drugs are there. Preferred one is going to be tropicamide. If it is not there, you can give cyclopentolate. If you want a stronger one, if you deliberately want to give a stronger one, then you can use even homatropine. Right? So adults or elderlies में the ciliary muscle tone is much weaker. So in that case scenario, we will be using tropicamide. Tropac, कई बार Tropac P आता है, Tropac P जिसमें phenylephrine भी रहता है. So phenylephrine is alpha-1 agonist. We will not be using phenylephrine, especially in the patient with history of blood pressure, hypertension वाले history में phenylephrine नहीं use करेंगे, ठीक है. But these are anticholinergic drugs, so we are mainly discussing about anticholinergics here, ठीक है. Yes, atropine तो है, atropine, clonidine, they are all time favorite. All right, so we are done with again 5-6 topics are done. So एक और topic है, next we are going to discuss about seizure, right? बताइए सब ठीक है, ऑल गुड. मैंने आपसे मांगा था 4 घंटे और 2.5 घंटे हो गए, 1.5 hour मोर, और 10 मिनट ऊपर नीचे अगर हो जाए तो आप हमें माफ करिएगा, थोड़ा आगे पीछे हो जाता है मामला. तो सब ठीक है अभी तक. आपसे लिए जो भी टॉपिक्स अभी तक डिस्कस किया गया है, हाई यील्ड टॉपिक्स हैं, इनको बेसिकली आपको एक बार देखना ही देखना है, ठीक है. एनी क्वेश्चन सो फार, एनीथिंग दैट इज बॉदरिंग? सीजर तो ऐसा क्वेश्चन यार कि जिससे क्वेश्चन मतलब रहता ही रहता है. सीजर में भी कुछ कुछ बातें बताऊंगा, स्पेशली विद रेस्पेक्ट टू 3 दवाइयां हैं जिसमें मैं फोकस करता हूँ, फेनेटोइड, वेलप्रोएट, कार्बामाजेपिन, है ना. इन सबसे एक सवाल रहता ही रहता है. तो आपके एग्जामिनेशन के सवाल को बहुत ध्यान से देखिएगा. सॉरी, ये क्या हो गया? हाँ, शुरू करेंगे. अब हम सीएनएस के बारे में बात करें. सीएनएस कार्डियो, तो अगर ये मतलब मेन टॉपिक हमने डिस्कस कर लिया तो समझ लो आपका अच्छा खासा काम हो गया. सबसे पहले ड्रग ऑफ चॉइस वाले केस देख लेते हैं. फॉर एग्जाम्पल, ये सारे यूजुअली आप देखोगे सवाल पेशेंट और बोलेगा चाइल्ड, है ना, एक पीडियाट्रिक एज ग्रुप का रहेगा विथ पुअर स्कोलेस्टिक परफॉर्मेंस. ये क्लिनिकल बेस्ड सिनेरियो रहेगा. कभी भी आपके एग्जाम में अब एब्सेंट सीजर वर्ड नहीं देगा. पीडियाट्रिक विद द पुअर स्कोलेस्टिक परफॉर्मेंस, pediatric with the poor scholastic performance. EG finding shows 3 Hz per second spike and wave pattern. पीडिया में भी पढ़ाते हैं. और पूछेगा व्हाट इज द ड्रग ऑफ चॉइस या व्हाट ड्रग इज नॉट गिवन. एब्सेंट सीजर में द ड्रग ऑफ चॉइस इज गोइंग टू बी इथोसक्सिमाइड. Mind the fact, ethosuximide, it's one of the drug, it's one of a kind, that is T-type calcium channel blocker, ethosuximide. Myotonic, myoclonic, atonic, Lennox-Gastaut syndrome, Dravet syndrome, इन सभी के लिए द ड्रग ऑफ चॉइस इज गोइंग टू बी सोडियम वैल्प्रोएट. द ड्रग ऑफ चॉइस इज गोइंग टू बी सोडियम वैल्प्रोएट. पार्शियल और फोकल सीजर के लिए कार्बामाजेपिन इज द ड्रग ऑफ चॉइस. एज अ मैटर ऑफ फैक्ट, दे आर ऑल्सो द ड्रग ऑफ चॉइस इन पेशेंट विद द TNGN. Who can tell me the full name of TNGN? Trigeminal neuralgia and glossopharyngeal neuralgia. Trigeminal neuralgia and glossopharyngeal neuralgia, that the drug of choice called carbamazepine. Then the next that we are having is called your generalized tonic-clonic seizure. Generalized tonic-clonic seizure. Generalized tonic-clonic seizure, the drug of choice is going to be lamotrigine. Mind the fact, अगर valproate option में, अगर ये lamotrigine नहीं है और valproate option में है, तो we can go ahead with that, है ना. Valproate is also among the first line drug. Febrile seizure, intranasal midazolam, intranasal midazolam. Earlier we were also using per rectal diazepam, that can also be utilized. Per rectal diazepam can also be utilized. Status epilepticus, IV lorazepam is the drug of choice in status epilepticus. Again you will be having case based scenario in this कि patient को fever हुआ, उसके बाद से usually ये 5-6 year तक बच्चे के लिए होता है, and later on this same will be converted into generalized tonic-clonic seizure as well, that is febrile seizure. Status epilepticus नॉन रेस्पॉन्सिव केसेस है तो लोराजिपैम, फिर भी नहीं है तो later on we can even try to give even general anesthesia as well. Barbiturate से भी नहीं respond किया तो general anesthesia can also be utilized. Infantile spasm, we can utilize ACTH as the drug of choice. But if there is infantile spasm with the tuberous sclerosis, we can give the drug that is called vigabatrin. Mind the fact, vigabatrin, important mechanism of action, they are going to be the GABA transaminase inhibitor. GABA transaminase inhibitor. Vigabatrin is also associated with visual side effect. A very important point, visual side effect, that is called tunnel vision. Tunnel vision or tubular vision. Tunnel vision, tubular vision. Anti-epileptics during pregnancy. The drug that is safer is going to be levetiracetam. Levetiracetam safest है. अगर ये नहीं है तो we can even go for lamotrigine. We can even go for lamotrigine. Levetiracetam, remember guys, SV2A inhibitor होते हैं. SV2A inhibitor. Levetiracetam SV2A inhibitor. If you have ever attended my class of SV2A inhibitor, I always give you the story of a BV. SV, LEV sounds like a BV, and all the BV वाले side effect is coming with the levetiracetam. BV means wife, है ना? तो all the wife वाले side effect will be there, like usually angry, mood, temperament changes, irritability, and all the BV वाले side effect is there with the levetiracetam. Eclamptic seizure, eclampsia induced seizure, we have magnesium sulfate, that is the drug of choice. And in fact, in the recent examination, they also ask कि magnesium sulfate whenever we are giving, how much is the loading dose? And so a total of 14 gram is given. The loading dose is given 4 gram, and then the maintenance dose, right? Maintenance dose will be given 5 plus 5 on each buttock, and 5 plus 5 on each buttock we are going to give. That is called maintenance dose. Loading dose हम IV देते हैं, maintenance dose हम IM देते हैं, ठीक है? Now another epilepsy में non-epileptic use of this anti-epileptic drug. Non-epileptic use of this anti-epileptic drug, another very important thing. So valproate का non-epileptic use. Valproate, it can be utilized for the prophylaxis of migraine. That is point to be noted, number 1. It can also be utilized for bipolar disorder. As a matter of fact, they are the drug of choice in rapid cycler. They are drug of choice in rapid cycler. Lamotrigine can also be utilized in bipolar disorder, depressive phase of bipolar disorder. Phenytoin is mainly utilized as an anti-arrhythmic drug. Anti-arrhythmic drug. It is one of the class 1B anti-arrhythmic drug. Carbamazepine, it's the drug of choice for TNGN, trigeminal neuralgia, glossopharyngeal neuralgia. So they are all non-epileptic use. They are all non-epileptic use. Okay, carbamazepine can also be utilized in bipolar disorder. They have mood stabilizing property, but phenytoin does not have any mood stabilizing property. Therefore, phenytoin is never used in bipolar disorder. This was the question. Phenytoin is used as an anti-arrhythmic drug. Topiramate मेरा favorite drug है. टोपी पहनने वाला, right? टोपी पहनने वाला जो favorite drug है मेरा. तो ये टोपी पहनता है और सारे holistic काम करता है. For example, it's an anti-epileptic drug. It can be utilized in bipolar disorder. It will also be decreasing the craving of alcohol. Decrease the craving of alcohol. It's utilized in the obesity management. They cause weight loss, so they are utilized an anti-obesity drug. A, B, COM. Then it is also utilized for the migraine prophylaxis. So anti-epileptic drugs that are used in migraine, one is valproate, other one is topiramate. So टोपी पहनने वाला ड्रग देखिए तो मेरा फेवरेट क्यों है? बिकॉज ये एपिलेप्सी में, बाइपोलर में, क्रेविंग ऑफ एल्कोहल को भी कम करता है. आप कुछ भी खाइए, ओबेसिटी, वेट लॉस कराएगा, एंड इट इज ओबेसिटी के ट्रीटमेंट में यूज करेंगे बिकॉज दे आर कॉजिंग वेट लॉस, एंड इट इज ऑल्सो नॉट गोइंग टू अलाउ फॉर हेडेक. आई मीन माइग्रेन के प्रोफिलैक्सिस में भी वी कैन यूटिलाइज. तो है ना मेरा फेवरेट ड्रग टोपिरामेट, टोपी पहनने वाला ड्रग, है ना. कुछ इंपॉर्टेंट बातें. फॉर एग्जाम्पल वेल्प्रोवेट, रिमेंबर हाईली हिपैटोटॉक्सिक ड्रग. ऑन द राइट हैंड साइड जो मैं लिख रहा हूँ थोड़ा सा ऐड कर लीजिएगा. हाईली हिपैटोटॉक्सिक ड्रग है, हाईली हिपैटोटॉक्सिक ड्रग. इट्स एंजाइम इंड्यूसर, इट्स एंजाइम इंड्यूसर. हाईली हिपैटोटॉक्सिक ड्रग, वेरी वेरी पोटेंट, सॉरी इनहिबिटर, ऑल ऑफ देम आर इंड्यूसर. दिस इज इनहिबिटर, एंजाइम इनहिबिटर. पिकॉक वाला आएगा, इनहिबिट करके जाएगा. हाईली हिपैटोटॉक्सिक ड्रग. Valproate as a drug, they are going to cause other side effects like weight gain, tremor, alopecia, all these important side effects. तो अपने फैमिली का ग्रैंडफादर जैसा ही है, मतलब सारे कंडीशन में यूज कर सकते हैं और ग्रैंडफादर वाले सारे साइड इफेक्ट भी हैं. वेट गेन करा दिया, एलोपेशिया करा दिया, ट्रेमर करा दिया, है ना. और जब अपनी समय में है तो मजे ले रहे हैं, मान लीजिए अल्कोहल के शॉट्स चल रहे हैं तो लिवर और पैंक्रियाज दोनों जवाब देते हैं, राइट। तो ग्रैंडफादर के जैसा है, लिवर टॉक्सिक, पैंक्रियाटोटॉक्सिक, वेरी वेरी इंपॉर्टेंट ड्रग, राइट। तो वैल्प्रोएट इज लाइक द ग्रैंडफादर ऑफ द फैमिली, एपिलेप्सी फैमिली का ग्रैंडफादर जैसा है। ऑलमोस्ट सारी जगह पे यूज कर ले रहे हैं, हेडेक में यूज कर ले रहे हैं, बाइपोलर डिसऑर्डर में यूज कर ले रहे हैं, है ना। प्लस ग्रैंडफादर वाले साइड इफेक्ट। लेमोट्रिजिन का वेरी इंपॉर्टेंट साइड इफेक्ट जो मैं आपको चाहता हूँ याद करिए, दैट इज गोइंग टू बी रैश स्टीवन जॉनसन सिंड्रोम, वेरी वेरी इंपॉर्टेंट साइड इफेक्ट, जो कि अभी रिसेंट 2026 में भी आया हुआ था। पेनिटोइन, इट विल बी कॉजिंग गम हाइपरट्रॉफी, एटलीस्ट गम हाइपरट्रॉफी का इमेज तो मैंने आपको दिखाई दिया था, जहाँ पे कैल्सिन्यूरिन इनहिबिटर दिखाया था, वहाँ पे गम हाइपरट्रॉफी बताया था। एटलीस्ट को याद रखिए, बहुत सारे साइड इफेक्ट है, लेकिन एटलीस्ट एक मैं चाहता हूँ कि ये ब्लैक वाले में जितना मैं लिख रहा हूँ ये सारे साइड इफेक्ट वाले हैं, इनको आप एटलीस्ट एक बार देख ही लेना, ठीक है। गम हाइपरट्रॉफी, फेनिटोइन के बड़े सारे साइड इफेक्ट हैं, है ना। दे कैन डिक्रीज द कैल्शियम एब्जॉर्प्शन, दे कैन ऑल्सो इंक्रीज द रिस्क ऑफ बोन फ्रैक्चर, इंक्रीज द फ्रैक्चर रिस्क, ये सब भी साइड इफेक्ट है ना। दे कैन डिक्रीज द डीप टेंडोन रिफ्लेक्सेस ड्यू टू न्यूरोपैथी दैट दे कैन कॉज, दे कैन डिक्रीज द डीप टेंडोन रिफ्लेक्सेस, है ना, न्यूरोपैथी की वजह से। कार्बामेज़ेपिन, दे कैन कॉज बोन मैरो सप्रेशन, aplastic anemia, अदर ड्रग कैन ऑल्सो कॉज, लेकिन ये बड़े सीवियर होते हैं, बोन मैरो सप्रेशन, aplastic anemia, ठीक है। एंड डाइल्यूशनल हाइपोनेट्रीमिया, माइंड द फैक्ट दिस डाइल्यूशनल हाइपोनेट्रीमिया वाला जो साइड इफेक्ट है ये 3-4 बार रिपीटेड क्वेश्चन है, मैं इसको फिर थोड़ा सा मेंशन कर दे रहा हूँ। Dilutional hyponatremia is a very very important question. It has been repeated multiple times. I need different ink. So this dilutional hyponatremia is very very important because of excessive ADS secretion that is coming. Dilutional hyponatremia ox carbazepine के साथ ज्यादा होता है compared to carbamazepine. ऑक्स कार्बाजेपिन के साथ ज्यादा होता है कंपेयर टू कार्बामेजेपिन। तो जैसा कि मैंने आपको बोला बहुत सारी चीजें हैं, लेकिन क्या उन सारी चीजों को अभी रिवाइज करना पॉसिबल है, याद कर पाना पॉसिबल है? नहीं, लेकिन ये अल्ट्रा इंपॉर्टेंट, उनमें से मैंने फिल्टर करके आपको एक एक दो दो पॉइंट बता दिया जिससे आपका क्वेश्चन निकल जाएगा, राइट। तो गम हाइपरट्रॉफी, अगर रिस्क ऑफ फ्रैक्चर बढ़ रहा है, डीप टेंडोन रिफ्लेक्स कम हो रहा है ना, तो उस कंडीशन में कौन सा एंटी एपिलेप्टिक ड्रग हो सकता है, या पूछेगा कि डाइल्यूशन हाइपोनेट्रीमिया ऑक्स कार्बाजेपिन ज्यादा करेगा एज कंपेयर टू कार्बामेजेपिन, राइट। Rash Stevens-Jones syndrome is very very important with the lamotrigine, enzyme inhibitor and weight gain, tremor alopecia, grandfather वाले side effect again with the valproate. Topiramate, टोपी पहनने वाले ड्रग है। Topiramate is mainly associated with, let's say, weight loss, and they can also lead to development of the renal stone and can cause development of the angle closure glaucoma. They can precipitate the angle closure glaucoma. Topiramate can precipitate the angle closure glaucoma. Topiramate can precipitate the angle closure glaucoma. Okay. Zonisamide can also cause important side effect like weight loss, but these are statistically non-significant and they can also lead to development of the renal stone. Zonisamide is one of the anti-epileptic drugs. So anti-epileptic के बारे में देखिए, इंपॉर्टेंट साइड इफेक्ट जितना मैंने बताए थे, आप एग्जाम के बाद आके मैच कर लीजिएगा, आपके कुछ ना कुछ टॉपिक्स यहाँ से जरूर रहेंगे आपके एग्जामिनेशन में. So these are ultra important, not because of any other reason, but only because of the whatever the question that has been asked in the past. We are just telling you that the next potential MCQ could be from these areas only. ठीक है. एंटीसाइकोटिक्स, साइकोसिस की बात करेंगे. Whenever you solve the question, please remember you have to read the question very very carefully. Oftentimes, whatever we are discussing, whatever that you have read in your notes, the answer will be in front of you. You just have to look at the option carefully. पहली बार में नहीं है, कोई दिक्कत नहीं है, सेकेंड टाइम पढ़िए, दूसरी बार हो सकता है ऑप्शन को नीचे से पढ़िए. यू विल बी एबल टू गेट थ्रू दिस, बिलीव मी, है ना. आपको सवाल और जवाब एग्जामिनर दोनों साथ में देता है, आपको बस बोलता है कि इसमें से सेलेक्ट कर लो कौन सा सवाल है ना. आप उसके बारे में सोचोगे, आपको उसका जवाब मिल ही जाएगा, है ना. जैसे एक शायर ने बहुत अच्छी बात बोली है, मैं बार बार बोलता हूँ क्लास में, कि ख्याल जिसका था मुझे ख्याल में मिला मुझे, ख्याल जिसका था मुझे ख्याल में मिला मुझे, और सवाल का जवाब भी सवाल में मिला मुझे. तो आपके सवाल का जवाब भी आपके सवाल में ही होगा, है ना. अब इसको थोड़ा सा पूरा कर देते हैं. कि ख्याल जिसका था मुझे ख्याल में मिला मुझे, सवाल का जवाब भी सवाल में मिला मुझे। किसी को हम अपने अमाल का हिसाब क्या देते, अमाल मतलब अपने कर्म, है ना। किसी को हम अपने अमाल का हिसाब क्या देते, सवाल सारे गलत थे, जवाब हम क्या देते, है ना। तो ये आज के सिनेरियो पे भी लागू होता है अगर देखा जाए तो। एक तो दूसरा सिनेरियो इसका होलिस्टिक अप्रोच भी है, और दूसरा आज का सिनेरियो, आपका एग्जामिनर क्वेश्चन और आंसर दोनों दे रहा है, और कुछ एग्जामिनर सवाल सारे गलत थे, जवाब हम क्या देते, पेपर को लीक भी करा रहे हैं, है ना। तो क्या जवाब दोगे, आपको पता ही है ना, कि गड़बड़ हो चुका है। That is a teratogenic effect. That is a teratogenic effect. Okay, that is one of the teratogenic effect. Spina bifida, वो सब teratogenic effect आते हैं. Cleft lip and palate with the phenytoin, teratogenic effect. Antipsychotics में typical antipsychotics, they are the D2 blocker. Atypical antipsychotics, they are going to be the 5-HT2A blocker. ठीक है. Plus they also have D1, D2, D3 blocking property, antihistaminic property, anticholinergic property. All these properties are also noted here. ठीक है. All right. So typical antipsychotics are mainly going to be drugs like haloperidol, droperidol, है ना, फ्लूपेंथिक्सोल, जुक्लोपेंथिक्सोल, फ्लू और जुकाम एक साथ आ रहे, देखिए फ्लूपेंथिक्सोल, जुक्लोपेंथिक्सोल, क्लोरप्रोमाजिन, थायोडाजिन, these are considered as a low potency drug. बाकी ऊपर वाले हाई पोटेंसी में आते हैं. Most potent will be haloperidol, they are known as HP high potency drug. All these typical antipsychotics, they are mainly going to be associated with hyperprolactinemia. हाइपरप्लेटनीमिया, बिकॉज वी नो फॉर श्योर, एक चीज तो हमें जो पता है वो ये कि डोपामीन नॉर्मली कीप द प्रोलैक्टिन इन द इनहिबिटेड फॉर्म. PRL is prolactin. When you inhibited D2, now the prolactin, when you inhibited D2, prolactin level will be high, hyperprolactinemia. And this hyperprolactinemia in the male, hyperprolactinemia in the male will present to you with the gift of gynecomastia. गिफ्ट मिल गया, गायनेकोमास्टिया मिल गया. अब आप क्या करोगे, गायनेकोमास्टिया मिल गया, अब आप क्या करोगे, अनुभव अवस्थी जी, पेशेंट को गायनेकोमास्टिया हो गया, या मान लीजिए चलिए आप ही को हो गया या किसी को हो गया, आपके जानने वाले में हो गया, आप क्या करोगे, मेल को. फीमेल को क्या हो सकता है, दैट इज गोइंग टू बी एक्सेस प्रोलैक्टिन की वजह से गैलेक्टोरिया, एमेनोरिया, इनफर्टिलिटी, गैलेक्टोरिया, एमेनोरिया, इनफर्टिलिटी. ठीक है. हाइपरप्लेक्टिनीमिया is one of the important side effect. Plus another important problem is going to be extra pyramidal symptom. ठीक है, एक्स्ट्रा पिरामिडल सिम्टम. मुझे अभी भी एक जवाब हमेशा याद रहता है. एक स्टूडेंट था क्लास में, और मैं पहले भी बोल चुका हूँ अगर आपने क्लास अटेंड किया है, कि आई थिंक कहीं मैंने पढ़ा रहा था, मैं पढ़ाया हाइपरप्लेक्नीमिया मेल में गायनेकोमास्टिया हो गया. एक स्टूडेंट बैठा किनारे, स्माइल कर रहा था. मैंने पूछा अगर गायनेकोमास्टिया हो जाएगा तो क्या करोगे, स्माइल कर रहा था. हमने बोला क्यों इतना स्माइल कर रहे हो भाई, क्या ऐसा सोच रहे हो कि स्माइल कर रहे हो. तो थोड़ा सा मतलब बाद में आपको समझ में आएगा, जब क्लास का लेक्चर आप बंद करोगे तब आपको उसका जवाब समझ में आएगा. उस हंसते हंसते बोला सर अगर मुझे गायनेकोमास्टिया हो जाएगा तो मैं घर पे जाके देखूंगा. ठीक है. तो जैसे कि मैंने आपको बोला कि आपको बाद में समझ में आएगा, घर जाइएगा जब नोट्स बंद करके और जब आप सोचोगे इसके बारे में तब आपको इसका समझ में आएगा कि वो लड़का क्यों स्माइल कर रहा था. ठीक है. अगेन, हेलोपेरिडोल, ड्रोपेरिडोल, फ्लूपेंथिक्सोल, जुक्लोपेंथिक्सोल, क्लोरप्रोमाजिन, थायोडाजिन, they are going to be the important typical antipsychotic. They can cause extra pyramidal symptom. Atypical antipsychotics is going to be risperidone. इट्स अ वेरी वेरी रिस्की ड्रग, और जो रिच है वो रिस्की होता है, जो रिच है वो रिस्की होता है, ध्यान रखिएगा. सो दिस इज गोइंग टू बी द मोस्ट पोटेंट एटिपिकल एंटीसाइकोटिक्स, मोस्ट पोटेंट एटिपिकल एंटीसाइकोटिक्स, है ना. तो इसकी कहानी भी मैं बताता हूँ यूजुअली क्लास में. समय तो नहीं सारी कहानियां बता सकूं, लेकिन आपको बताए बिना मैं रहा भी नहीं जा रहा, क्योंकि एग्जाम में आपको कहानियों से ही आप सवाल का जवाब सही कर पाओगे. ये कहानी है एक बहुत ही रिच क्वीन की, बहुत ही रिच क्वीन, है ना. और मैंने बताया था जो रिच होता है वो रिस्की भी होता है. तो दिस इज अ स्टोरी ऑफ अ वेरी रिच क्वीन who was always very closer to old people with lot of money. Old people with lot of money को हम यूजुअली बोलते हैं एक होता है मिलेनियर, बिलियनियर, ट्रिलियनियर, और उनसे भी ज्यादा पैसे वाले हैं जिनको बोलते हैं जिलेनियर. जैसे मान लीजिए अरब के शेख, है ना, या इंडिया के पॉलिटिशियन, है ना. बाकी डॉक्टर के बाद पैसे तो है नहीं, बात सबको पता है ना. तो ओल्ड, है ना, रिच क्वींस आर क्लोजर टू ओल्ड जिलेनियर्स, और उनके क्लोज जाके उनसे वो थोड़ा प्यार मांगती थी, बोलती थी आई नीड सम प्यार, आई नीड सम लव, आई नीड सम सिंपैथी। उसको थोड़ा प्यार और थोड़ा सिंपैथी चाहिए होता है ना। तो वो थोड़ा प्यार और थोड़ा सिंपैथी मांगती है, किससे? ओल्ड जिलेनियर से। मैंने बोला जो सबसे ज्यादा पैसे वाले है ना, सबसे ज्यादा पैसे वाले लोग हैं, जैसे मैंने बताया कौन है, अरब के शेख या इंडिया के पॉलिटिशियन, पता ही है। और कभी कभी मुझे लगता है कि हमारे इंडिया के पॉलिटिशियन के पास अरब के शेख से भी ज्यादा पैसा है। ये बात अलग है कि वो दिखता नहीं है ना। सो दिस इज एक्चुअली गोइंग टू बी अ स्टोरी ऑफ अ रिच क्वीन। जो रिच है वो रिस्की है, मैंने बताया था। तो दिस इज द मोस्ट पोटेंट। और ये रिस्की इसलिए है बिकॉज ये है तो एटिपिकल, है तो इस साइड, लेकिन साइड इफेक्ट करता है ये वाला, बिकॉज इट इज ऑल्सो हैविंग D2 ब्लॉकिंग प्रॉपर्टी, इट इज ऑल्सो हैविंग D2 ब्लॉकिंग प्रॉपर्टी। तो मैंने बताया था जो रिच है वो रिस्की भी है। सो रिच क्वींस आर क्लोजर टू ओल्ड जिलेनियर्स, रिच क्वींस आर क्लोजर टू ओल्ड जिलेनियर। जिलेनियर पता ही, मैंने बताया था बड़े पैसे वाले लोग। और उनसे जाके क्या बोलती थी? आस्किंग फॉर लव, आस्किंग फॉर लव, मैंने बताया था लव और सिंपैथी। ये एमेनोरिया मैं यहां कर दे रहा हूं, आस्किंग फॉर लव एंड सिंपैथी। अपने सुविधा के अनुसार आप थोड़ा बहुत चेंजेस इसमें कर सकते हैं जिससे आपको याद रहे, है ना। यहाँ पे मेरे अकॉर्डिंग तो मैं सिंपैथी पे ही जाऊंगा, आप देख लीजिए आपको क्या करना है। रिच क्वींस आर क्लोजर टू ओल्ड जिलेनियर्स, आस्किंग लव एंड सिंपैथी। ठीक है। अब जो क्वीन थी वो बूढ़े बाबा के पीछे क्यों जाती थी, आपके पीछे क्यों नहीं आती थी? मान लीजिए हमारे पास अनुभव है, पीसफुल वॉरियर है ना, आई होप पीसफुल वॉरियर इज बॉय, है ना, दीपक है, सब लोग हैं, तो इन लोग के पास क्यों नहीं आती थी? तो बोला क्या तुमको दिखाई नहीं दे रहा है मैडम, आपको दिखाई नहीं दे रहा है क्या, आर यू ब्लाइंड? तो बोली पता नहीं, मुझे सच में दिखाई नहीं देता। तो दे टुक हर टू द ऑफ्थेल्मोलॉजिस्ट, और चेक कराया तो सच में पता चला कि उस क्वीन को दिखाई नहीं देता था। लेकिन देखिए, कम दिखाई देने वाले आंखों से भी ये ऐसी क्वीन थी जो रिच लोगों को ही पकड़ती थी, रिच जिलेनियर को ही पकड़ती थी, आपको मुझे या किसी और को नहीं पकड़ती थी, है ना। तो देखिए, है ना, हाँ, विजन कहीं और है। तो अगेन कमिंग टू द स्टोरी, रिच क्वीन, उसको दिखाई नहीं देता था, क्यों? चेक कराया गया तो आंख में निकला कैटरैक्ट। सो क्वीन को कैटरैक्ट था, तो मैं बोलता हूं अंधी रानी। मैं क्या बोलता हूं? अंधी रानी। लर्न फार्मा इन माय स्टाइल, यू विल बी एबल टू डेफिनेटली मार्क द करेक्ट आंसर। एंटी साइकोटिक कॉजिंग कैटरैक्ट, अंधी रानी सर ने बोला था। और जो रिच होता है वो रिस्की होता है, रिस्की इज रिस्क पेरिडॉन, इट्स द मोस्ट पोटेंट एटिपिकल हैविंग टिपिकल वाला साइड इफेक्ट, इट्स द मोस्ट पोटेंट एटिपिकल हैविंग टिपिकल वाला साइड इफेक्ट। ठीक है। एरिपिप्राजोल, ब्रेक्सिप्राजोल, ओlanzapine, क्लोजापिन, जिप्रासिडोन, एसिनापिन इज अवेलेबल बाय द सबलिंगुअल रूट, है ना, ल्यूरासिडोन, सर्टिनडोल, है ना, राइट। So again, remember this, these are the important areas that you should know about atypical, and atypical antipsychotics are mostly associated with the important side effect that is known as your metabolic syndrome. And under metabolic syndrome, anything and everything will come. For example, weight gain, dyslipidemia, insulin resistance, all these are going to be the important साइड इफेक्ट। ठीक है, चलिए। सो टिपिकल और एटिपिकल को ध्यान में रखिएगा। टिपिकल के साथ सबसे इंपॉर्टेंट प्रॉब्लम क्या है, क्या हम जल्दी से रिवाइज कर लें, है ना। सवाल का जवाब भी सवाल में मिला मुझे। बताइए टिपिकल का इंपॉर्टेंट साइड इफेक्ट, एक्स्ट्रा पिरामिडल सिम्टम। नाउ द क्वेश्चन इज, मैक्सिमम रिस्क ऑफ एक्स्ट्रा पिरामिडल सिम्टम इज नोटेड विद द टिपिकल और एटिपिकल। Typicals, especially with the drugs like haloperidol, droperidol, flupentixol, all these kind of drug. Least risk overall is always going to be atypical, specifically clozapine. Clozapine is least or no risk of extrapyramidal symptom. Clozapine is going to be least or no risk of extrapyramidal symptom. That is confirmed, question. Atypical antipsychotic that can cause arrhythmia. Now there are many atypical antipsychotic that can cause arrhythmia. Many antipsychotics, जैसे कि मैं आपको बोलूं, जो क्वीन है वो भी करा सकती है, क्यूटियापिन, जिप्रासिडोन, क्यूटियापिन, जिप्रासिडोन, क्यूटियापिन, जिप्रासिडोन, इवन सर्टिनडोल, मॉडरेट रिस्क होता है, सर्टिनडोल, मॉडरेट रिस्क होता है, ठीक है। They can cause arrhythmias like QT prolongation. Side effect of clozapine. Now, clozapine किस ग्रुप का ड्रग है? Remember, it is the one that is having least or no extrapyramidal symptom. This is one point to remember. It is the first anti-suicidal drug. It is the first anti-suicidal drug. In one of the examination, they said that clozapine increase the risk of suicide. No, it does not. Rather, it is having anti-suicidal property. So the important side effect, I will write it here. One of the important side effect is going to be A granulocytosis. देखिए आपका फ्रेंड बोला क्लोज आप पीने चले, A granulocytosis, you will lose all the counts including your bank account. सेल का काउंट तो जाएगा भी। जैसे ही दोस्त ने बोला क्लोज आप पीने चले, आपको तुरंत क्या होने लगा? ड्रूलिंग, सेलिवेशन, है ना, सेलिवेशन, दैट इज कॉल्ड वेट पिलो सिंड्रोम. साइलोरिया इज गिवन द नेम एज द वेट पिलो सिंड्रोम. एंटीसाइकोटिक में अगर कोई ड्रग पूछता है कि सेलिवेशन को बढ़ा रहा है, वेट पिलो सिंड्रोम, थिंक अबाउट क्लोज़ापिन. दोस्त ने बोला मेरे क्लोज आ पीने चलेंगे, और दोस्त के क्लोज रहोगे तो आपको हमेशा एंटी सुसाइडल इफेक्ट आएगा, कभी मतलब कुछ बुरा ख्यालात नहीं आएगा, है ना. मेरे क्लोज आओ पीने चलें, है ना. रिमेंबर दिस वन, वेरी वेरी इंपॉर्टेंट. वेट पिलो सिंड्रोम, साइलोरिया, sedation, seizure, and it can even lead to myocarditis, है ना. तो that is again going to be very very important side effect. क्लोज आप पीने चले, सारे काउंट्स चले जाएंगे, सेलिब्रेशन होने लगा, सीडेशन एंड सीजर होने लगा, एंड मायोकार्डाइटिस. पीने गए तो क्या हो सकता है, दिल पे भी इसका असर जरूर आएगा. मायोकार्डाइटिस इज ऑल्सो वन ऑफ द रिपोर्टेड साइड इफेक्ट विद द क्लोजापिन. क्लोजापिन इज वन ऑफ द atypical antipsychotics, and remember they are the one that is first antisuicidal drug, and it is also among the drug that is having high risk of weight gain. अब आते हैं हमारे एक्स्ट्रा पिरामिडल सिम्टम पे. इस बात का बहुत समझदारी से जवाब दीजिएगा, सोच समझ के, जल्दीबाजी मत करिएगा. एक्स्ट्रा पिरामिडल सिम्टम टिपिकल करते हैं. आर यू ऑल एग्री विथ मी? ठीक है. एक्स्ट्रा पिरामिडल टिपिकल करते हैं. आर यू ऑल विथ मी हियर? यस, अगर ऐसा होता है तो उस कंडीशन में आपको स्टॉप करना है. अनुभव अवस्थी, ठीक है. यस, and now the question is earliest onset extrapyramidal symptom, that is going to be acute dystonia, earliest onset, and most common extrapyramidal symptom is called akathisia, dystonia, tone has been altered, tone has been altered. Look at this, dystonia, it is the tone which has been actually altered. Dystonia, tone has been actually altered. Dystonia, the tone has been altered. Okay. What is the drug of choice for dystonia? The drug of choice for this one is called your benzhexol, benztropine, or promethazine. Anticholinergic drug we can utilize. Akathisia, the drug of choice is going to be propranolol, the non-selective beta blocker propranolol. The dangerous extrapyramidal symptom, boys and girls, is going to be neuroleptic malignant syndrome. This will be treated mainly with the bromocriptine, a specific antidote, and along with this we will be adding dantrolene. Earlier we were only using dantrolene. Actually dantrolene is the drug of choice for malignant hyperthermia. Are you all with me? Dantrolene is the drug of choice for malignant hyperthermia, which can be caused by haloperidol. Anesthesia वाला problem भी हो गया. Haloperidol, succinylcholine is having maximum risk of malignant hyperthermia. Now ये हो गया हमारे extrapyramidal symptom. एक आता है which of the following is called late onset extrapyramidal symptom, that is called tardive dyskinesia. Tardive dyskinesia is called late onset extrapyramidal symptom. Tardive dyskinesia. NMS means neuroleptic malignant syndrome. All right, now coming back to this one, इसके नीचे वाले में एरिया में देखिएगा which atypical, because atypicals are mainly associated with the dyslipidemia. Repeat. Typicals are mostly causing extrapyramidal symptom hyperplaquemia because they are blocking D2. Now एक और question, this extrapyramidal symptom is due to blockade of which pathway? So it is mainly due to blockade of nigrostriatal pathway, Nigrostriatal pathway, another very important question. Nigrostriatal pathway, multiple pathway are there for dopamine, like mesolimbic, mesocortical, tuberoinfundibular, nigrostriatal. So nigrostriatal pathway blockade can actually lead to extrapyramidal symptom where there will be more involuntary movements. And now the atypical, the newer one will be mostly causing newer wala problem. For example, the newer generation is having which problem? They don't want to go anywhere, they don't want to go for shopping, they don't want to buy anything, they just want to take a phone and they want to order from Amazon, Flipkart, और उससे भी बड़ा आजकल आ गया वो Blinkit, है ना? So they usually get, all the newer one, they get metabolic syndrome, right? So newer antipsychotic also causing metabolic syndrome. So atypical, that can cause metabolic syndrome. So something that is causing more metabolic syndrome, weight gain among atypical is, weight gain is maximally associated with drugs like your olanzapine, O figure 0, है ना, O figure 0. Then we have क्यूटियापिन, अगेन देखिए इसमें भी फिगर 0 आ गया, वो वाला 0 नहीं जो मॉडल्स का होता है, ये आलू वाला फिगर 0 है ना, जो हम लोग को होता है, और एक क्लोजापिन, दे ऑल आर गोइंग टू कॉज वेट गेन, they all are going to cause weight gain. So among atypical, weight gain will be caused by many, but maximum weight gain will be caused by these. Now the question that has been asked here is, which atypical is having least weight gain? Olanza, O जैसा बन गया, क्यूटियापिन अगेन फिगर 0, पोटैटो जैसा बन गया, क्लोजापिन इंडियन पैटर्न ओबेसिटी, लुक एट दिस, एक C ऐसे आ रहा है. But least weight gain is caused by a drug that is called aripiprazole. सब लोग का वेट बढ़ रहा था, लेकिन एक इन्हीं ग्रुप में से न्यूअर थी जिनका वेट नहीं बढ़ रहा था, तो सबने मीटिंग किया और बोला, अरे शिप्रा को देखा क्या, शिप्रा तो बड़ी स्लिम है, उसका तो वेट बिल्कुल नहीं बढ़ रहा है, शिप्रा ऐसा क्या कर रही है, तो किसका वेट नहीं बढ़ा, शिप्रा. अरे शिप्रा को देखा, शिप्रा इज नॉट गेनिंग वेट, एरिपिप्राजोल जिप्रासिडोन, एरिपिप्राजोल जिप्रासिडोन, एरिपिप्राजोल जिप्रासिडोन, है ना, शिप्रा का वेट नहीं बढ़ेगा. नो एंटीसाइकोटिक कैन कॉज वेट लॉस, लेकिन एक ड्रग से देखा गया है, मोलिनडोन मिसलेनियस ग्रुप में आता है. हाइपरप्लेटनीमिया अमॉन्ग एटिपिकल, देखिए हाइपरप्लेटनीमिया इज अ साइड इफेक्ट ऑफ टिपिकल, लेकिन अमॉन्ग एटिपिकल इफ समवन इज कॉजिंग देन दैट बिकम्स अ न्यूज. तो मैक्सिमम रिस्क ऑफ हाइपरप्लेटनीमिया अमॉन्ग एटिपिकल दैट विल बी कॉज्ड बाय whom? याद है मैंने बताया था, जो रिच होता है वो रिस्की होता है, रिस्क पेरिडोन, है ना. सो इट इज एक्चुअली गोइंग टू बी अ ड्रग दैट इज कॉल्ड अ वेरी रिस्की ड्रग, और मैं बड़े प्यार से इसको रिस्क पेरिडोन पढ़ता भी, मैं बोलता भी हूँ इट इज रिस्क पेरिडोन, है ना. कॉर्नियल ओपेसिटी एंड रेटिनल पिगमेंटेशन, corneal opacity and retinal pigmentation, these both are actually caused by thyroidazine. It is actually causing brownish retinal pigmentation. Thyroidazine को clinically use नहीं करते हैं, they can cause sudden ventricular sudden heart block and death, है ना. तो thyroidazine को clinically we don't use. Antipsychotic that is causing cataract, अंधी रानी, ये तो आप सभी को पता है, अब तो ये कभी गलत नहीं करोगे, अंधी रानी, है ना. एक की जो मैं आपको पहले ही पढ़ा चुका हूँ, डाइसल्फिराम लाइक रिएक्शन, कौन सा एंजाइम इनहिबिट होगा, तो दैट इज बी एल्डिहाइड डिहाइड्रोजनेस, ये हो चुका है बात ऑलरेडी, है ना. दैट इज गोइंग टू बी गवर्नमेंट मेडिकल कॉलेज ऑफ मध्य प्रदेश एंड छत्तीसगढ़, दैट इज वेरी वेरी सिंपल निमोनिक. ग्रेसिफुलविन मेट्रोएडाजोल, ये वाला क्वेश्चन बार बार आता है, ये वही पार्टी में गया एंटी मेबिक लेकर के, ये बातें हमने बता रखी है आपको ऑलरेडी, ठीक है, वी हैव डन दैट. नाउ एक टॉपिक जहां से अगेन क्वेश्चन आता रहता है आप सभी के लिए, which is methadone or opioids. Methadone is one of the very long acting opioid. Methadone is one of the long acting opioid and it is utilized in opioid de-addiction therapy. कहाँ पे यूज करते हैं, opioid de-addiction. Always do remember whenever we do opioid de-addiction therapy, हम कभी भी opioid बंद नहीं करते हैं, याद है कि नहीं, हम कभी भी opioid बंद नहीं करते हैं, हम उसको रिप्लेस कर देते हैं. जैसे आई एम नॉट श्योर आजकल के बच्चे और शाहरुख खान की वो मूवी देखें कि नहीं जिसमें माधुरी दीक्षित और ऐश्वर्या राय दोनों रहते हैं, वेयर शाहरुख खान इज ड्रंक एल्कोहलिक, बड़ा फेमस सा नाम है उसका, देव बाबू से रहता है नाम, बहुत बहुत फेमस नेम है. नाम बताइए आप लोग, थोड़ा सा हेल्प करिए मुझे. मूवी का नाम देखिए, ड्रग का नाम नहीं बोल रहा है लेकिन मूवी का नाम बोल रहा है. द हिंट इज शाहरुख खान की मूवी है वेयर ऐश्वर्या राय एंड माधुरी दीक्षित बोथ आर एक्ट्रेस. डोला रे डोला उसमें गाना आता है ना, देवदास मूवी का नाम है देवदास. देखो मुझे याद आ गया, आपने भी लिख भी दिया, देवदास है ना, देवदास, वेरी गुड, देवदास है ना. तो देवदास मूवी में आपको बताया गया होगा कि वो एक एडिक्शन जो हो जाता है तो उसको बंद, ये नहीं कहा जाता है कि वो ये नहीं करता है कि तुरंत बंद कर देता है. वो अगर ऐश्वर्या राय समहाउ नहीं हो पा रहा है तो वो क्या कर रहा है, सब्स्टिट्यूट कर दे रहा है किसी और के साथ. बिकॉज अगर सडन बंद कर दोगे तो देयर विल बी रिस्क ऑफ विड्रॉल सिम्टम एंड कंट्रोलिंग द विड्रॉल सिम्टम विल बी वेरी वेरी डिफिकल्ट. तो इसलिए ऐसा बोला जाता है कि भाई if you want to treat opioid addiction, do not suddenly stop opioid, do not stop. You are supposed to substitute on a longer acting opioid by the name of methadone. So we call this therapy as methadone substitution therapy, है ना. So they are known as your methadone substitution therapy, methadone substitution therapy. So we usually substitute, है ना, substitute. Tramadol, it's actually a mu opioid receptor agonist with SNARI. SNARI stands for serotonin noradrenaline reuptake inhibitor that will increase the level of serotonin and noradrenaline. ये अपने आप में क्वेश्चन है. Tramadol increase the level of serotonin and, तो आंसर था noradrenaline. फिर एक में था tramadol is opioid receptor agonist and सेरोटोनिन रीअपटेक इनहिबिटर, नॉरएड्रेनालिन रीअपटेक इनहिबिटर, और एक में था सेरोटोनिन नॉरएड्रेनालिन. दोनों क्वेश्चन नीट पी और एफएमजी में रेस्पेक्टिवली आए हुए हैं. एज इट इज जाके चेक कर लीजिएगा, ठीक है. अब बिकॉज ट्रामाडोल पे सारी बातें हो चुकी हैं, प्लीज रिमेंबर द नेक्स्ट पोटेंशियल एमसीक्यू, टापेंटाडोल. टापेंटाडोल वेरी फेमस ड्रग नाउअडेज. इट्स अ म्यू रिसेप्टर एगोनिस्ट विद नारी. नारी स्टैंड फॉर नॉरएड्रेनालिन रीअपटेक इनहिबिटर दैट विल ओनली इंक्रीज द लेवल ऑफ नॉरएड्रेनालिन. ट्रामाडोल, टपेंटाडोल, अगेन दे आर यूटिलाइज एनाल्जेसिक, है ना. तो कहीं पे भी माइल्ड टू मॉडरेट पेन, पोस्ट ऑफ पेन, पोस्ट ऑपरेटिव पेन, बॉर्न पेन. बट ऑलवेज रिमेंबर कहां पे नहीं देंगे. इतनी जगह पे तो दे दिया, कहां पे नहीं देंगे. सो एनी ओपियोइड्स आर ऑलवेज कॉन्ट्राइंडिकेटेड. Opioids are always contraindicated in multiple conditions. Opioids are contraindicated always like any colicky abdominal pain, like biliary colic, renal colic, कोई भी colicky abdominal pain, smooth muscle spasm है तो वहां पे नहीं देंगे. We will also be not giving them in bronchial asthma and COPD, है ना. They can cause smooth muscle contraction, therefore we will also not be giving in patient with the BPH, benign prostatic hypertrophy, risk of urine retention, and they can increase the risk of sphincteric tone. BPH पेशेंट को नहीं देंगे, बेबीज में नहीं देंगे, है ना. हेड इंजरी या ब्रेन इंजरी अगर हुई है, ब्रेन इंजरी हुई है तो वहां पे नहीं देंगे, है ना. हाइपोथायराइड वाले केस को भी नहीं देंगे. तो मल्टीपल कंडीशन है जहां पे ये ओपियोइड नहीं देते हैं. तो यू शुड नो द इंपॉर्टेंट कॉन्ट्राइंडिकेशन. तो केस कैसा आया था, इंटर्न पोस्टेड इन वार्ड 2022-2023 समवेयर अराउंड दैट. इंटर्न पे हर चीज डाल देते हैं, है ना. इंटर्न पे हर चीज डाल देते, कुछ भी प्रॉब्लम हुआ इंटर्न पे. इंटर्न पोस्टेड इन वार्ड gave a drug to a patient who complained of biliary colic. After intake of the drug or after injecting the drug, the pain further got aggravated. Which drug was possibly given, right? So कौन सा ड्रग दिया गया था. तो अगेन उसका जवाब था ट्रामाडोल, है ना. ट्रामाडोल मैंने बताया था, आ भी गया, ठीक है. ख्याल जिसका था मुझे ख्याल में मिला मुझे, सवाल का जवाब भी सवाल में मिला मुझे. आपको भी आपके सवाल का जवाब आपके सवाल में मिलेगा. यहाँ से स्ट्रॉन्ग रहना है, फोकस रहना है. 50% ऑफ द गेम इज मेंटल स्ट्रेंथ, 50% ऑफ द गेम इज योर नॉलेज एंड योर एटीट्यूड ऑन द दैट डे ऑफ द एग्जामिनेशन, ठीक है. तो आपको बहुत ही सोच समझ के और बेहतर रणनीति के साथ उस दिन को प्लान करना है. और उस दिन का प्लान उस दिन नहीं होगा, मैं आपको बता दूं, बीच बीच में मैं थोड़ा सा बता दूं. उस दिन का प्लान, दैट डे शुड नॉट बी प्लान्ड ऑन दैट डे. मतलब एग्जाम डे शुड नॉट बी प्लान्ड ऑन द डे ऑफ एग्जाम. इट शुड बी प्लान्ड फ्रॉम टुडे. इनफैक्ट इट शुड हैव बीन started by now. If you have started, well and good, pack your bag. If not, you have to start it now. Try getting up early in the morning. No matter what happened, try to go off to sleep 11, 12, कुछ भी हो जाए. If you are not feeling asleep, you will fall asleep. Just try avoiding any daytime nap. slowly and slowly apparently you will fall asleep. There are multiple sleep techniques that I have told in some of my previous classes as well. You can see it from YouTube, or we can discuss it on my social media, where you can ask me, sir, what are the sleeping technique that I can use where I can fall asleep early without taking any drug. There are multiple techniques that you can use. In fact, I use that also. And whenever I am having longer days, longer class in between, if I'm having a time, I can take a 20-30 minutes nap, and that will give me very nice refreshment, right? I learned from somewhere, I can impart it to you guys as well. So you guys have to start developing that day ka preparation even from today. It should have been started by now, but if not, you have to start early morning, getting up, try to solve more MCQs in the morning, try to revise more theory, and try not to inculcate anything new in your syllabus, and try to stay away from any people who says you don't know this also, and you don't know that. Oh, that's very easy. Try to stay away from all that kind of people. You have read it, you have revised it, give your GT, try to repeat and revise your GT. Avoid GT at least 5-6 days prior to exam. Just whatever you have given, just try to revise that. So you have to be prepared for your examination from now. Your brain should be highly functioning in the morning. Make sure it's not in the drowsy state. Don't think कि exam के दिन मैं सुबह उठ के चला जाऊंगा. That's not going to happen. Or even if it is going to happen, it will definitely have a lot of difficulty. So you try to practice it now. And the best way, someone has said that prayer ka sign they have given. The best thing is that if you are a morning person, try to get up in the morning prayer. No matter which religion you follow, it doesn't matter. You get up and go for the prayer. Put your phone a little far. Put an alarm and try to get up at least, let's say, if not 4 a.m. I'm not telling even to get up at 4 a.m. but at least try to get up by 6 a.m. somehow. 6 or 7 a.m. से पहले उठ जाओ. ठीक है? Now, most potent opioid क्या है? That is going to be sufentanil. It's around 1,000 times more potent as compared to morphine. Loperamide, it's the drug of choice for chemo-induced diarrhea, chemotherapy-induced diarrhea. The drug of choice is going to be loperamide. Okay? Naloxone, it's the antidote for opioid poisoning या morphine overdose. Naltrexone क्या? What is naltrexone? Naltrexone, remember, it's a orally effective. It's a orally effective, right? Orally effective opioid antagonist. Orally effective opioid antagonist. It is given mainly to prevent relapse, right? It is mainly added after the MST. MST is methadone substitution therapy. MST is methadone substitution therapy. Yes, even in normal diarrhea also you can use loperamide. The non-infective diarrhea you can use loperamide. In any other non-infective diarrhea also you can use. Not in the infective diarrhea, non-infective diarrhea you can use. मैंने कहा drug of choice वो बता दिया. Non-infective diarrhea में also we can use. Nalmefene, it can also be utilized in opioid overdose, alternative to naloxone. Opioid overdose we can use. And they can also be utilized for another condition that is called cholestatic pruritus. Cholestatic pruritus, in that also we can utilize. Okay. Elvimepan, nalmefene, they are considered as a peripherally acting mu opioid receptor antagonist. So we can utilize them for the treatment of opioid induced constipation. Now opioid ke saath the main problem is constipation is a very important problem. So if you are going to treat your patient with the opioid, constipation will be a very important problem. Now constipation is an immediate problem. Maybe you are giving opioid for osteosarcoma, that may be a lethal problem after 6 months, after 1 year, but constipation is a problem for today. If you are going to give naloxone, you can give, but the problem with the naloxone is they are always associated with high risk of withdrawal symptom, right? So in that case scenario, you have to give peripherally acting. Elvimepan, nalmefene, Elvimepan, they are peripherally acting mu opioid receptor antagonist. First drug of choice for OCD, obsessive compulsive disorder, panic disorder, or PTSD, they are all going to be drugs like SSRI, drugs like citalopram, escitalopram, they are all going to be your escitalopram, citalopram, they are all going to be your SSRI. Among benzodiazepine, which is a date rape drug, they are odorless and tasteless benzodiazepine, तो उसको बोलते हैं फ्लूनाइट्राजिपाम. डेट पे गया, रेप करके फ्लू कर गया नाइट्रोजन की स्पीड से. They are odorless and tasteless. Flunitrazepam. Flunitrazepam. This was the question of FMG, I think, quite some time ago, 2015-16, somewhere around that. It's mentioned in FMG solution. Flunitrazepam. डेट पे गया, रेप करके फ्लू कर गया. फ्लू मतलब भाग गया नाइट्रोजन की स्पेस से. Which is the drug that can be used in both prevention and arrest of convulsion? Both. Inverse agonist is going to be beta carbolin, but antagonist is going to be flumazenil. Diazepam, it can be used for prevention also and acute attack as well. Acute alcohol withdrawal. Now this is something very good. Acute alcohol withdrawal में you can use diazepam, lorazepam plus vitamin B1, thiamine. Which anti-emetic drug that is showing disulfiram-like reaction? I think you already know the answer to this question, which we have already covered. Metronidazole, that is having aldehyde dehydrogenase inhibiting property. Opioid poisoning, naloxone, ये बार हो चुका है, 3-4 बार हो चुका है, right? So again, very important question that is always going to be asked. ठीक है? So this was another very important point. Now let me just quickly summarize this as well. Metoclopramide, again with the domperidone. Metoclopramide, it's a D2 blocker. It can actually cross the blood-brain barrier. And metoclopramide is associated with extrapyramidal symptom, or we say abnormal posture. Abnormal posture. With respect to that, domperidone, they do not cross blood-brain barrier. Domperidone, they do not cross blood-brain barrier. है ना? Domperidone, it can be utilized in nausea and vomiting. It can be utilized in treatment of nausea and vomiting, or it can also be utilized, preferred in levodopa-induced nausea and vomiting. उसका तो ड्रग ऑफ चॉइस होता है. लीवोडोपा इंड्यूस्ड नॉजिया एंड वोमिटिंग का ये ड्रग ऑफ चॉइस होता है. ओके. मैनिया, ड्रग ऑफ चॉइस इज गोइंग टू बी लिथियम. It is one of the IMPase inhibitor. Because of this, they will actually decrease the level of IP3 and DAG, the secondary messenger, which are mainly involved in the neurotoxicity and manic symptom development. Lithium side effect. It is always remembered the mnemonic lithium side effect by the simple mnemonic of lith. Lithium side effect is remembered with the mnemonic lith. What does lith stand for? Leukocytosis. Insipidus. What is insipidus? Diabetes insipidus. Tremors. Right? Fine tremor initially, followed by coarse tremor. In toxic dose, it can be coarse tremor. It is the most common side effect. They are highly teratogenic as well, and they can lead to a very important side effect that is called Epstein anomaly. It can lead to a problem that is called your Epstein anomaly, and they can also lead to hypothyroidism. So lithium side effect will be LITTH. Insipidus means what? Diabetes insipidus. Examiner asks, what is the drug of choice for lithium-induced diabetes insipidus? So it is going to be epithelial sodium channel blocker by the name of amiloride, because lithium is coming in the body with the help of this epithelial sodium channel only. Okay? So the drug of choice is going to be amiloride, lithium-induced diabetes insipidus. Most common side effect is tremor. Teratogenic side effect will be Epstein anomaly, right? Hypothyroidism. Epstein anomaly में इसका जब चेस्ट एक्सरे करते हैं तो इसका भी एक सवाल आया हुआ है. चेस्ट एक्सरे करते हैं तो इसमें मिलता है आपको टिन, एप्स्टीन. टिन से हम बनाते हैं बॉक्स, तो इट विल बी बॉक्स शेप हार्ट, राइट? सो बॉक्स और बूट में कंफ्यूज मत होइएगा. Preferred treatment for lithium overdose, we will be doing hemodialysis. Hemodialysis preferred. In one of the question they asked, hemodialysis contraindicated in lithium? No, that is wrong. It's preferred. Depressed patient with smoking, ये भी क्वेश्चन बार बार आ चुका है. That is going to be bupropion. So this is about your quick सेंट्रल नर्वस सिस्टम में क्या क्या डिस्कस किया. एपिलेप्सी डिस्कस कर लिया, साइकोसिस डिस्कस कर लिया, मैनिया, बाइपोलर डिसऑर्डर, इंपॉर्टेंट एंटी एपिलेप्टिक के साइड इफेक्ट, और ओपियोइड, बार बार ओपियोइड भी आता है, ओपियोइड भी हमने क्विकली कवर कर लिया. लास्ट पॉइंट जो मैं डिस्कस करूंगा आप सभी के लिए, दैट इज गोइंग टू बी एंटी डिप्रेशन के साइड इफेक्ट. तो ऐसा कुछ भी नहीं है जो आपके नोट्स पे नहीं है, बट हम क्या कर रहे हैं, वी आर डूइंग ए वेरी लेजर पॉइंट, है ना, लेजर कट रिविजन. एकदम अल्ट्रा इंपॉर्टेंट पॉइंट्स को क्विकली हम एक बार ब्रशअप कर रहे हैं और साथ में कुछ चीजें और भी देख ले रहे हैं, बिकॉज आपका जो नोट्स का जो कॉन्सेप्ट है वो हिलना नहीं चाहिए, ठीक है। एंटी डिप्रेसेंट लाइक SSRI, SNRI, TCA, SSRI शेफ ड्रग, मेरे साथ रिपीट कर लिए क्विकली, अभी मेरे साथ रिपीट कर लिए, याद आ जाएगा। शेफ सिटालोप्राम, एसिटालोप्राम, CEFFPS, सिटालोप्राम, एसिटालोप्राम, फ्लुओक्सेटिन, फ्लुओक्सेमीन, पैरोक्सेटिन, सर्ट्रालिन। SNRI सेरोटोनिन नॉरएड्रेनालिन रिएप्टेक इनहिबिटर। SNRI का फुल नेम क्या है? सेरोटोनिन नॉरएड्रेनालिन रिएप्टेक इनहिबिटर। तो आई से वेनिला डुअल्स, डेस वेनिला फैक्सिन तो उसी का है, वेनिला डुअल्स माई लव। वेनिला मेरे प्यार को दुगना कर देता है। मैंने ट्राई भी किया था, आप भी ट्राई करना, आपके प्यार को भी दुगना करेगा, है ना। वेनिला डुअल्स माई लव, ठीक है। First, let me talk about the side effect of SSRI, which is the drug of choice in major depression, mild to moderate case में। severe में we can use even SNRI, right? So depression के अलावा SNRI can also be used in fibromyalgia. TCA has multiple uses. Important side effect of SSRI, I always say SSRI का side effect को याद कर लिए SSRI से। SSRI का side effect कैसे याद करिए? SSRI that stand for serotonin syndrome. One of the side effects is called serotonin syndrome, where the patient will have nausea, vomiting, diarrhea, agitation, anxiety, रंगीन सपने भी आएंगे, vivid dreams, nausea, vomiting, agitation, BP का फ्लक्चुएशन भी होगा, ऑटोनॉमिक इंस्टेबिलिटी की वजह से there will be BP fluctuation. Next is going to be sexual dysfunction. This sexual dysfunction is going to be, one is happy, one is unhappy. What is the meaning of happy? What is the meaning of unhappy? One is happy, that means unhappy जिसको हम बोलते हैं एनऑर्गेज्मिया। तो एनऑर्गेज्मिया नाम में ही सब कुछ है, एनऑर्गेज्मिया, डिक्रीज इन द लिबिडो, लिबिडो की कमी। तो इसमें कोई हैप्पी तो नहीं होगा, अनहैप्पी साइड इफेक्ट होगा। हैप्पी साइड इफेक्ट क्या होगा? जिसको हम बोलते हैं डिलेड इजैकुलेशन। वाई इज इट हैप्पी? किसके लिए हैप्पी है? हु इज गोइंग टू बी वेरी हैप्पी? अनुभव अवस्थी, कैन यू टेल मी हु विल बी वेरी हैप्पी आफ्टर हैविंग डिलेड इजैकुलेशन? someone who is having problem of the premature ejaculation. That is why it is one of the FDA approved drug for premature ejaculation. It is one of the FDA approved drug for premature ejaculation. As a matter of fact, this sexual dysfunction was maximally noted with the paroxetine. Sexual dysfunction is maximally noted with the paroxetine. और इसी का एक डेरिवेटिव है जिसका नाम है डेपोक्सेटिन। इसी का एक डेरिवेटिव इसका नाम है डेपोक्सेटिन, which has got approval for premature ejaculation. है ना। तो लोग हमारे इंडिया में तो लोग पागल हो गए, है ना। पागल मतलब वैसे पागल नहीं, खुशी के मारे पागल, है ना। पहले तो दे वर टेकिंग समथिंग लाइक लेट्स से सिल्डेनाफिल। अभी फार्मास्यूटिकल कंपनी ने क्या किया, सिल्डेनाफिल को ऐड कर दिया डेपोक्सेटिन के साथ। सिल्डेनाफिल फॉर इरेक्टाइल डिसफंक्शन, एक प्रॉब्लम सॉल्व हुआ। अब दूसरा प्रॉब्लम क्या था? प्रीमेच्योर इजैकुलेशन, है ना। प्रीमेच्योर इजैकुलेशन अगेन ज्यादातर कंडीशन में साइकोजेनिक होता है। तो अब उन्होंने डिलेड इजैकुलेशन के लिए डेपोक्सेटिन देना शुरू कर दिया। देयर आर सो मेनी प्रिपरेशन of this premature ejaculation that is available in the market, है ना, including even local anesthetics as well. आप सोचिए, लोकल एनेस्थेटिक वो बेच रहे हैं और वो खरीद भी रहे हैं। अब बोलोगे कौन बेच रहा है कौन खरीद रहा है, तो ये आप समझ सकते हो, आप समझदार हो, है ना। कौन बेच रहा है कौन खरीद रहा है, ये मत समझना कि है ना मैं बेच रहा हूँ या मैं खरीद रहा हूँ, बिल्कुल भी नहीं। ये सिर्फ बुक के नॉलेज की बेसिस पे बता रहा हूँ। एनॉर्गेस्मिया, डिक्रीज इन द लिबिडो, डिलेड इजैकुलेशन इज वन ऑफ द important happy side effect for someone who is having premature ejaculation. And maximum sexual dysfunction is noted with the paroxetine, and one of the derivative of the paroxetine is depoxetine. तो उन्होंने बोला यार छोड़ो ना, डिप्रेशन तो होता रहता है, पहले मेन प्रॉब्लम सॉल्व करते हैं ना, दैट इज प्रीमेच्योर इजैकुलेशन। तो डेपोक्सेटिन का क्या किया, फिक्स डोज कॉम्बिनेशन बना दिया, किसके साथ? सिल्डेनाफिल के साथ। दबा के बिक रहा है ना। केमिस्ट शॉप पे जाके लोग बोलते हैं हमारी वाली दे दीजिए। पहले तो सिंपल था सिल्डेनाफिल, है ना। उसका बड़ा फेमस नाम भी था, वायग्रा के नाम से बहुत फेमस था, है ना। इनफैक्ट एक मूवी भी बनी है इस पे, लव एंड अदर ड्रग्स। जब ये नई नई बनी थी, इट्स एक्चुअली ड्रग ऑफ पल्मोनरी हाइपरटेंशन, है ना। तो पल्मोनरी हाइपरटेंशन वाला पेशेंट लेता था मेडिसिन, है ना, और खुशी किसी और को मिल रही होती है। तो उन्होंने बोला ऐसे थोड़ी होता है ना, कि तुम दवाई ले रहे हो, तुम्हें तो ज़्यादा फायदा यहाँ नहीं हो रहा है, फायदा कहीं और हो रहा है, तो खुश कोई और हो रहा है। तो उस कंडीशन में दे डिड द ट्रायल एंड दे फाउंड दैट ओके द सेम एंजाइम फॉस्फोडाइस्टेरेस 5 इज फाउंड इन द कॉर्पोरा कैवर्नोसा ऑफ द पेनाइल टिश्यू, और इसके वजह से ब्लड फ्लो टू द पेनाइल टिश्यू इज इंक्रीज एंड देयर इज गुड इंप्रूवमेंट इन द इरेक्शन। तो इरेक्टाइल डिसफंक्शन ट्रीट कर दिया सिल्डेनाफिल के साथ, और ये जब आ गया डेपोक्सिटिन तो बोला बस मजे ही मजे, डेपोक्सिटिन को साथ उसके साथ ऐड कर दिया, राइट। सो अगेन ये रैशनल कॉम्बिनेशन नहीं है, बट स्टिल नॉट एवरीथिंग दैट इज सोल्ड इन द मार्केट इज रैशनल। नेक्स्ट इज गोइंग टू बी रेस्टलेसनेस एंड इंसोम्निया। रेस्टलेसनेस एंड इंसोम्निया, तो एसएसआरआई के साइड इफेक्ट, एसएसआरआई देखिए इससे आसान क्या होगा, शेफ ड्रग हो गया एसएसआरआई, और एसएसआरआई के साइड इफेक्ट एसएसआरआई, ठीक है। एसएसआरआई के साइड इफेक्ट इज एसएसआरआई, दैट इज गोइंग टू बी सेरोटोनिन सिंड्रोम्स, सेक्सुअल डिसफंक्शन, रेस्टलेसनेस एंड इंसोम्निया। संतोष पाटिल सर, वेलकम टू द क्लास। यस डेफिनेटली भेजना शुरू करते सर, ऑर्डर प्लेस करना शुरू करिए सर। हमारे अपने ग्रुप के लोग ही इतने हैं कि हम यहीं बेच के मिलियनेयर हो जाएंगे सर। स्पेशल डिस्काउंट। डेपोक्सिटिन इज अ स्पेसिफिक ड्रग फॉर प्रीमेच्योर इजैकुलेशन, इट्स अ डेरिवेटिव ऑफ पैरोक्सिटिन ओनली, ठीक है। अब एसएनआरआई का जो साइड इफेक्ट है, इट इज गोइंग टू बी सेम एज एसएसआरआई, प्लस इट इज ऑल्सो हैविंग सम कार्डियक साइड इफेक्ट। कार्डियक साइड इफेक्ट व्हाई? बिकॉज दे आर हैविंग सेरोटोनिन नॉरएड्रेनालिन रीअपटेक इनहिबिटर, सेरोटोनिन नॉरएड्रेनालिन रीअपटेक इनहिबिटर, बिल्कुल सर। है ना, पैसा ही पैसा होगा, ठीक है। देखिए हमारे मेडिसिन वाले सर भी हैं, आप लोग को मोटिवेट कर रहे हैं कि आप लोग देखिए एटलीस्ट पीजी निकालने, एफएमजी निकालने के बाद कुछ नए नए दवाइयां भी निकालिए। अब टीसीए के बारे में आते हैं। दे आर कंसिडर्ड यूजुअली सेकेंड लाइन ड्रग इन डिप्रेशन, दे आर यूटिलाइज ऑल्सो इन द प्रोफिलैक्सिस ऑफ माइग्रेन, दे आर यूटिलाइज इन द सेकेंड लाइन ड्रग इन डिप्रेशन, यूटिलाइज इन प्रोफिलैक्सिस ऑफ द माइग्रेन, न्यूरोपैथिक पेन में भी यूज कर सकते हैं, न्यूरोपैथिक पेन, एंड वी कैन ऑल्सो यूज देम इन नॉक्टर्नल एनोरिसिस। तो इनके बड़े सारे यूज हैं। तो डिप्रेशन में तो सेकेंड लाइन है, लेकिन अदर यूजेस इनके बड़े सारे हैं। TCA are used as a second line because of their important side effect. You see, they are having alpha 1 blocking property. Because of this, there will be fall in the blood pressure, postural hypotension, and this postural hypotension can actually lead to reflex tachycardia. Right? It is going to cause reflex tachycardia. Then they are also having anticholinergic property. This anticholinergic property की वजह से blurring of vision, dryness of mouth, और मुझे याद है जितने भी पेशेंट को मैंने ट्रिप्टोमर स्टार्ट किया है ना, ट्राइमिप्रामिन, विच इज ऑल्सो वन ऑफ द ड्रग यूटिलाइज फॉर द प्रोफ्लेक्स ऑफ द माइग्रेन, है ना, या न्यूरोपैथिक पेन के लिए, तो उनको ये प्रॉब्लम जरूर हुआ है, दैट इज गोइंग टू बी कॉन्स्टिपेशन। तो वी हैव टू बी केयरफुल अलॉन्ग विद दिस वन, ड्राइनेस ऑफ माउथ, ब्लरिंग ऑफ विजन, ये सारी चीजें होंगी। They are also having antihistaminic property. Because of the antihistaminic property, they can even lead to another problem that is called sedation. This drug has been associated with a side effect that is called metabolic acidosis, which can even induce arrhythmia. You see, metabolic acidosis arrhythmia अगर कॉज करता है, तो सबसे पहला चीज जो टॉक्सिसिटी या ड्रग पॉइजनिंग मैंने पढ़ाया था, कि उस कंडीशन को ट्रीट करने के लिए आपको सिंपल यूज करना है सोडा बाइकार्ब, सोडा बाइकार्बोनेट, दैट इज गोइंग टू कॉज पोस्ट अल्कलाइन डायलिसिस, ठीक है। सो दिस इज एवरीथिंग अबाउट एसएसआरआई, एसएनआरआई एंड टीसीए, ठीक है। ऑलराइट, तो ये हो गया हमारे सीएनएस का कहानी खत्म। अब हमारे पास समय रह गया है लगभग 40 मिनट, है ना। तो 40 मिनट में अब हम बात कर लेंगे कार्डियोवास्कुलर सिस्टम की, और थोड़े बहुत और जो छोटे छोटे टॉपिक उनको फटाफट खत्म कर लेंगे। दिस इज द एंड ऑफ द सेंट्रल नर्वस सिस्टम, वन ऑफ द वेरी वेरी इंपॉर्टेंट एरिया, वन ऑफ द वेरी बिग चैप्टर। तो जनरल फार्मा, एएनएस, है ना, सीएनएस, पॉइजनिंग्स, ये सारी बातें होगी, ऑटोकॉइड, इम्यूनोमोडुलेटर, ये सारी चीज़ें हमने कर ली। आई होप ऑल ऑफ यू गाइस आर विथ मी, आई होप ऑल ऑफ यू गाइस आर अलाइव, हैप्पी एंड अभी भी जान बची है कि नहीं बची है? मैंने सिर्फ 4 घंटे मांगे थे आपसे, थोड़ा बहुत ज़्यादा हो सकता है। क्विक डिस्क्लेमर दे दे रहा हूँ, थोड़ा बहुत ज़्यादा हो सकता है, लेकिन वो जो ज़्यादा होगा वो कहीं ना कहीं बेनिफिट ही लेकर आएगा हम सभी के लाइफ में। शुरू करें अगले पार्ट को। आप लोग रिप्लाई नहीं कर रहे हैं ना, तो मजा नहीं आ रहा है। जब रिप्लाई करिए, जब रिप्लाई करते रहेंगे ना तो लगेगा कि हाँ आपके अंदर भी जान बची है, तो मेरे अंदर जान वैसे ही आ जाएगी, है ना। मैं इस पे काम करता हूँ, अगर आपके अंदर जान बची है तो मेरे अंदर जान ऑटोमेटिक आ जाती है ना। वो पहले वाली बात है नहीं आपके अंदर जो शुरुआत में थी, है ना। मैं अभी भी देखो, अभी अभी भी मतलब हमारे अंदर की एनर्जी उतनी ही है कि अभी भी मैं 4 घंटे और लेके पढ़ा सकता हूँ लगातार लगातार, लेकिन आप सुन नहीं रहे ध्यान से, है ना। बात नहीं हो पा रही आपसे। वो दिन नहीं, वो रात नहीं, है ना, वो पहले जैसे जज्बात नहीं, आपकी जज्बात वो नहीं है ना। वो दिन नहीं, वो रात नहीं, वो पहले जैसे जज्बात नहीं, होने को तो हो जा रही है आपसे बात, थोड़ा थोड़ा होने को तो हो जा रही है आपसे बात, पर बातों में अब वो पहले वाली बात नहीं, है ना। आप अपनी बातों को थोड़ा सा इम्प्रोवाइज करिए, स्टार्ट करिए, है ना। हिंदी नहीं आती, नो प्रॉब्लम, इफ हिंदी नहीं आती इंग्लिश में बात करेंगे। स्टार्ट करें, चलिए, वेरी नाइस। नाउ which anti-hypertensive drug is causing Coombs positive? Now anti-hypertensive drug is causing Coombs positive, that means that drug is actually causing autoimmune hemolytic anemia, and the name of the drug is called alpha methyl dopa. Mind the fact, alpha methyl dopa is going to be alpha 2 agonist, centrally acting anticholinergic drug, है ना, alpha methyl dopa. It can be utilized for chronic hypertension in pregnancy, utilized for chronic hypertension in pregnancy, क्रोनिक हाइपरटेंशन प्रेगनेंसी। बिलीव में जिस लेवल का हम लोग रिवीजन कर रहे हैं ना, अगर मैं आपको बोलूं कि 5 घंटा ले लो, 6 घंटा ले लो और पूरी फार्मा रिवाइज कर लो, अकेले बैठ के करोगे नहीं हो पाएगा, साथ में बैठ के करोगे हो जाएगा। अकेले बैठ के रहोगे आपको समझ में नहीं आएगा कि कौन सा छोड़े कौन सा लेके चले, राइट। इफ आई एम गोइंग टू गिव यू, लेट मी जस्ट टॉक इन इंग्लिश नाउ, if I am going to give you let's say 5-6 hours and I say that okay you guys try to revise the entire pharmacology in 5-6 hours, it will be very very difficult, and but when we are sitting together and talking one on one, right, you are listening to me and making notes also in parallel, or just trying to take mark in your notes or waiting for the PDF that we are going to share at the end of the class, you guys will be able to cover the entire pharma in 5-6 hours. Or let's say even before me, Santhosh Sir came, he also taught medicine in 5-6 hours. So along with us you are able to do, because we are filtering out the high yield topic for you. But if I give you okay you do it by yourself, it will be very difficult. Maybe you can do, but it will be very difficult, believe me. That's why I'm saying along with us try to finish it. Maybe you will not get a more time after this to revise pharma like this. Entire syllabus we are revising, entire syllabus. No problem, we'll proceed. ठीक है, renin release inhibitor. Now there is a question called renin inhibitor, another question called renin release inhibitor. Renin release inhibitor will be drug that is called beta blocker, beta blocker. Another question will be renin inhibitor. So the name of that drug is called your aliskiren. So there are two different questions, renin release or renin inhibitor. The most common side effect of AC inhibitor. So AC inhibitor most common side effect is called dry cough. This dry cough is mainly attributed to the level of bradykinin. This bradykinin is mainly increased due to blockade of ACE enzyme. However, if I am going to talk about the other side effect of AC inhibitor, I always say just write ACE ka side effect, ACE. ACE का side effect minimum angioedema. This is attributed also due to the bradykinin. Cough, which is called dry cough, which is considered as the most common side effect, and elevated potassium level. Elevated potassium level. This is very very important. There are a lot of side effects, but minimum I want you to remember this. ACE का side effect is ACE. ठीक है, ACE का side effect is going to be ACE. Okay, angioedema, cough, that is dry cough, and elevated potassium. They can even cause orthostatic hypotension. They can even cause orthostatic hypotension, right? Cholestasis, dysgeusia, these are the other side effect. Dysgeusia is altered taste. These are the other side effect. ARB, they are blocking AT1 receptor. AT1 receptor is the one that is working by GQ. Remember, AT1 receptor. Which ARB? All the ARB is going to end with the sartan. Which ARB is having anti-aggregant property? Platelet anti-aggregant property. The name of this ARB is called losartan. Losartan. And learn from my style. I say losartan may everything is low. For example, they are going to lower down the blood pressure. Yes, they lower the blood pressure. Agreed. They are also going to lower the uric acid level because of the uricosuric property. Very good. They are also going to lower the platelet aggregation. They are also going to lower the platelet aggregation due to thromboxane A2 inhibiting property. Right. So low sartan, everything is low. How simple it is. How simple it is. Low sartan. It has also the property that it can lower the LDL level. It has also shown to lower the LDL level as well, right? Low sartan, low blood pressure, low LDL, low glucose. Glucose को भी कम करता है ये, है ना? Due to their PPR gamma agonistic property. Although PPR gamma agonistic property is reported with telmisartan, but low sartan is also there, है ना? Which antiarrhythmic drug is causing QT prolongation? Antiarrhythmic drug causing QT prolongation, remember it is going to be class 1A and class 3 antiarrhythmic drug. Class 1A antiarrhythmic drug is going to be drugs like your quinidine. Any drug that is having potassium channel blocking property, it can cause. This is sodium plus potassium blocking, and class 3 is mainly potassium channel blocker. So any drug that is having potassium blocking property, it can cause QT prolongation. Quinidine, procainamide, and other one is called disopyramide. So these are class 1A antiarrhythmic drug. Class 3 very important drug, that is going to be amiodarone. Class 3 very important drug is amiodarone. Other drugs are also there, like for example ibutylide sotalol. They are actually going to be your QT prolongation causing drug among antiarrhythmic, right? Among antiarrhythmic drug. And if you want to recognize which one is which, for example, let's say if I'm going to talk about, this is one, and then there is going to be two normal action potential I have drawn here in front of all of you. If there is going to be delayed slope of depolarization, and there is also going to be increase in the action potential duration, or you are only and only going to get increase in the action potential duration. So here, if you are going to see here very clearly, this will be class 1A antiarrhythmic drug, because there is decrease in the slope of depolarization, sodium blocking property, plus there is also increase in the action potential duration. They are also causing QT prolongation. Here there is only and only increase in the QT interval, no decrease in the, there is slow repolarization, there is no effect on the potassium, no effect on the sodium. So this is class 3 antiarrhythmic drug mainly, right? Class 3 like amiodarone. So sometime even they can give the image and they can ask you which drug is that. You have to recognize the drug. You can recognize the drug easily. Amiodarone, important side effect. Amiodarone is one of the class 3 antiarrhythmic drug. It can cause the important side effect. One is very important, that is QT prolongation. They are also causing liver toxicity, hepatotoxic drug, right? QT prolongation, liver toxicity. They can also lead to thyroid abnormality. This thyroid abnormality is very, very important. इसमें दो हो सकता है, hypo or hyper. Out of these, hypothyroidism is going to be the more common as compared to hyper. Hypo is more common as compared to hyper. Thyroid abnormality, it could be hyper or hypo both. More common is going to be hypo, right? Then it can even lead to pulmonary fibrosis. Mind the fact, this pulmonary fibrosis is going to be most serious kind of side effect. So most serious or most dangerous kind of side effect, if they're asking, that is going to be pulmonary fibrosis, corneal microdeposits, which is also given the term as the cornea verticillata, and they can even lead to photosensitivity. So this photosensitivity is given the name also as all the sun exposed part will be turn out to be bluish. So it is given the name as a blue man syndrome. Blue man syndrome. Okay, dangerous or serious will be pulmonary fibrosis. Remember this. Okay, and dangerous side effect is most thyroid abnormality more common क्या हो? Hypothyroidism is more common, right? Levosimendan, it is one of the phosphodiesterase 3 inhibitor. They also increase the calcium sensitivity. They are also going to be increasing calcium sensitivity, increase in the patient with the congestive heart failure. This is coming from the phosphodiesterase 3. The name of the drug, other drug is called your ambrinon, milrinone, levosimendan. They are coming from the same group. Ambrinon, milrinone, and they are given the name as a inodilator. they are given the name as the ionodilator, matlab inotropic plus vasodilating property both, and they are utilized in the congestive heart failure. They are utilized in the congestive heart failure. Digoxin is another drug that is utilized in the congestive heart failure. Yes, vancomycin is causing Redman syndrome. Absolutely correct. है ना? और अनुभव अवस्थी, ठीक है. Mechanism of action of digoxin is a drug for heart failure. They are acting by sodium, potassium, ATPase inhibitor, right? Sodium potassium ATPase inhibitor. Peaceful warrior. I have taken multiple, made multiple reels. You can just search it out on the Insta if you, or YouTube if you are looking for. There are multiple videos I have made how to quickly remember the antiarrhythmic drug. If time permit, today also I can just tell you that there is a story that I have told, that is Queen Prince Dasi, right? They like to phone me, that is the class 1B, and all this I have given through a story that you can remember. Given the time frame that we have, we'll just quickly go through this one. And if you want to just know the entire thing, if you have the access to the lecture, you can even go through this in the RR may I have given all the story. Most common side effect of digoxin. Digoxin is again a plant derivative, so nausea and vomiting is the most common side effect. But if they ask you most specific side effect of digoxin, remember the specific side effect is called xanthopsia. Xanthopsia is called yellow vision. Xanthopsia is called yellow vision. Trimetazidine, ranolazine, so they are fatty acid oxidation inhibitor, FOX inhibitor, fatty acid oxidation inhibitor. They will actually increase fatty acid oxidation inhibitor. They inhibit the fatty acid oxidation, and because of this, they will increase the glucose, right, metabolism for generating ATP. For generating ATP, they inhibit the fatty acid oxidation. These drugs are mainly utilized in the management of angina. So I always say, if you want to burn your fat, then listen to me carefully. What you have to do, you have to try running from today. Trimetazidine ranolazine. Fasi dil sounds like fasa hua dil. Matlab trapped heart. Fasa hua dil, it cries. So it is rho kinase inhibitor. Both these drugs are going to be utilized in the management of angina, right? They are going to utilize the management of angina. Rho kinase, फंसा हुआ दिल क्या करता है, रोता रहता है. Fibrate having uricosuric property. The name of the fibrate is called phenofibrate. Therefore, they are going to be preferred in the gout patient. In gout patient, they are going to be the preferred. Antidyslipidemic for child and pregnancy, it is going to be colesevelam. Remember, it is one of the bile acid sequestrant. Their site of action is mainly in the intestine. Resistant hypertension के लिए we can utilize the drug that is called spironolactone or aldosterone receptor blocker. And renoprotection in diabetic patient, the preferred one is going to be ACE inhibitor. All these are preferred questions that has been asked. And treatment of choice for severe hypocalcemic, so we can give calcium gluconate. IV infusion करेंगे, calcium gluconate का IV infusion. All right, calcium gluconate का IV infusion we are going to do here. Okay. Next, it is going to be antihypertensives in pregnancy. Antihypertensives in pregnancy, if we are going to see, there are two type of question. One is what is safe, other one is what is unsafe. What is safe, other one is what is unsafe. Antihypertensive in pregnancy, the safe will be labetalol, that is the drug of choice. Hydralazine, labetalol, hydralazine, alpha methyl dopa and clonidine, and cardioselective beta blocker, and also calcium channel blocker. Any calcium channel blocker that is ending with dipene are safe, right? So we remember them by the very simple mnemonic of Lady Harding Medical College. LHMC, Lady Harding Medical College, is very safe for the females. Lady Harding Medical College is very safe, but I say that you always avoid DNB colleges. Lady Harding Medical College is safe hai, but avoid DNB college. All the ACE inhibitors and ARB. Remember, ACE inhibitor ending with the prils, ARB are ending with the sartan. ये हमेशा पूछे जाते हैं. They are always asked question. D stand for diuretics. All the diuretics are also avoided. They can lead to oligohydramnios, renal dysgenesis. Non-DHPs are also avoided, guys. Non-DHPs like verapamil, diltiazem are always avoided, just like non-selective beta blocker. So beta blocker are also avoided. Beta blocker, especially non-selective beta blocker, are also going to be avoided. So see what is safe, all-time favorite, labetalol being the drug of choice. Lady Harding Medical College, Anna, and if you don't want to use beta blocker, the next preferred answer will be your calcium channel blocker. Remember which calcium channel blocker we'll be using? Something that is working in the periphery, that is ending with a dipine, right? Dipine are going to be the preferred one. ठीक है, तो हमारा कार्डियो भी क्विकली कवर हो गया. डायरेटिक्स वाला जो क्वेश्चन आया था, मैं क्विकली इसको एक बार ब्रश अप कर दे रहा हूँ आप सभी के लिए. कार्बोनिक एनहाइड्रेज इनहिबिटर, दे आर वर्किंग एट द पीसीटी. Their name is called carbonic anhydrase inhibitor, acetazolamide, dorzolamide, brinzolamide, methazolamide. Furosemide, torsemide, they are working at the thick ascending limb of loop of Henle. Thick ascending limb of loop of Henle. They act by blocking sodium, potassium 2 chloride. So you have to see the image, right? Thick ascending limb of loop of Henle, NAK2Cl blockade. Hydrochlorothiazide, indapamide, metolazone. Hydrochlorothiazide, indapamide, metolazone, chlorothiazide, right? Chlorothiazide. All these are the drugs. All these are the drugs that are mainly coming under the thiazide diuretics. They are the drugs mainly coming under what? Under the thiazide diuretics. Now thiazide diuretics, they are working mainly at the early part of DCT. Thiazide diuretics are mainly working at the level of early part of DCT. Early part of DCT by blocking NaCl cotransporter. They are working mainly at the early part of DCT by blocking NaCl cotransporter. Sodium chloride, NaCl cotransporter. Yes, osmotic can work on all the side and maximum action will be noted at the PCT and loop of Henle. Spironolactone, eplerenone, they are known as your collecting duct पे काम करने वाले drug. They are aldosterone receptor blocker. Triamterene and other one is called amiloride. They are also collecting duct पे काम करने वाले. Collectively they are all called potassium sparing diuretics. They are given the name as a ENaC, epithelial sodium channel blocker. Epithelial sodium channel blockers. So again, just identifying the site, because they have asked this question many number of times. They give the tubule and they ask that which diuretic is working at which site. Acetazolamide, dorzolamide, brinzolamide, remember they are the drug that is going to cause loss of bicarbonate in the urine. So they lead to urinary alkalosis. They lead to a problem that is called urinary alkalosis. But ये तो बाहर निकल गया, तो इसको तो हम assess नहीं करते. The main problem that is going to be seen is called hypokalemic, hyperchloremic metabolic acidosis. ये बात को ध्यान से देखिएगा. Hypokalemic, hyperchloremic metabolic acidosis. Metabolic acidosis is noted why? Because there is loss of bicarbonate, right? Metabolic acidosis. They can also lead to other side effects like paresthesia, especially when you are going to use the systemic route. Paresthesia, increasing the risk of renal stone, bone marrow suppression, because they are one of the drug coming from the sulfur drug. Loop diuretics बोलते हैं. These are given the name as a loop diuretics. Furosemide, torsemide, right? Early DCT पे काम करने वाले drug, these are known as thiazide diuretics. The important side effect that is noted with the loop diuretics, definitely all of these loop diuretics, they can cause hypokalemia, hyponatremia, hypokalemia, hyponatremia. Loop diuretics. Loop also causes loss of calcium, so they can even lead to hypocalcemia. सारे electrolyte का loss करेगा, including calcium. They lead to other problem that is called metabolic alkalosis. Thiazide, on the other hand, they can lead to hypokalemia, hyponatremia, but they increase the level of calcium reabsorption. They promote calcium reabsorption, so they can lead to hypercalcemia. They can also lead to something called metabolic alkalosis. Now यहाँ पे जो क्वेश्चन आता है, मैं डायरेक्टली क्वेश्चन ही लिख दे रहा हूँ जो क्वेश्चन आपके एग्जाम में बार बार रिपीट होता है. क्वेश्चन नंबर 1, because they are causing loss of calcium, loss of calcium, remember, they are going to be avoided in patient with the history of hypocalcemia, point number one, patient with the history of hypocalcemia, and they are also avoided in patient with the history of renal stone. Why? Because this excess calcium that is being excreted is from the renal tissue only, renal parenchyma only. So more calcium, if they are getting saturated at the level of calcium at the renal parenchyma, they can increase the size of the renal stone. Because they are causing reabsorption of the calcium in the body, so hypercalcemic condition, they are going to be the preferred diuretic in osteoporosis. That is point to be noted, number one. Which is the preferred diuretic in osteoporosis? That is this. It is also considered as the preferred diuretic in the patient with the history of hypocalcemia. So we do not need to stop them. You can continue, but you need to stop loop diuretics because they are very fast acting diuretics. This will be preferred also in history of hypocalcemia, and this will also be preferred in patient with the history of renal stone. So again, let's repeat: thiazide diuretics, we can give them in renal stone. Loop diuretics, you don't give them in renal stone. You should avoid them in renal stone. तो ये दोनों क्वेश्चन बार बार आते हैं आपके एग्जाम में. Drug like spironolactone can cause hyperkalemia, and one of their metabolite is having anti-androgenic property. Therefore, they can also lead to the gift of gynecomastia. Eplerenone do not cause. Only the spironolactone will be causing gynecomastia. They can also lead to hyperkalemia. Cardiovascular system में one topic that is n number of time repeated is known as your mortality reducing drug. Let me repeat all over again. यहाँ पे 2-3 क्वेश्चन आते हैं. क्वेश्चन नंबर 1 डायरेटिक्स में, which diuretic can be used as a urinary alkalinizer? Which diuretic can be used as a urinary alkalinizer? That is carbonic anhydrous. That is why we use them in acidic drug poisoning. Which diuretic can be used in the treatment of mountain sickness? Again, acetazolamide, because they are causing metabolic acidosis. CSF acidosis can also be there, that can lead to hyperventilation, washout of the CO2. Which diuretic is avoided in patient with a history of hypocalcemia and renal stone? Hypocalcemia renal stone में हमेशा avoid करिएगा loop को. Loop should not be taken in hypocalcemia renal stone. So what is preferred in hypocalcemia renal stone and osteoporosis? That is going to be thiazide diuretics. Thiazide ठहर के काम करता है, बहुत ही ठहराव है उसमें. हाइपोकैल्सियम में भी ठहर के काम करता है ना थायजाइड. रीनल स्टोन में भी ठहर के काम करता है, आराम से दे सकते हैं, और ऑस्टियोपोरोसिस है उसमें भी दे सकते हैं. तो थायजाइड में काफी ठहराव है. लूप डायरेटिक्स वो लूप करता रहता है, इधर उधर भागता रहता है ना. तो हाइपोकैल्सिमिया रीनल स्टोन में नहीं देंगे, थायजाइड को दे सकते हैं. ठीक है. One question that is all time favorite is mortality reducing drug in patient with the congestive heart failure. So one of the drug is going to be your ARNI, which is a combination of ARB, that is called valsartan plus neprilysin inhibitor by the name of sacubitril. तो अगर combination देखा जाए तो they are having very nice outcome. Next is going to be AC inhibitor, all the prils, ARBs, all the sartans. Then we also have aldosterone receptor blocker like spironolactone. Then we have beta blocker. Please remember, always start with low dose. Option में होगा start beta blocker at optimal dose. Never choose that. Never start beta blocker at optimal dose. Always start at the low dose. And the preferred beta blocker that we have is going to be bisoprolol, metoprolol, carvedilol. They are having mortality reducing property. And SGLT2 inhibitor, drug like your empagliflozin and all. Drug like your empagliflozin, ठीक है. Which new combination? Yes, ARNI of course का इतना new भी नहीं है, काफी पुराना है. So I always say if you want to reduce the mortality, then you should have 4-pack wala apps, not like Indian pattern obesity single pack apps which we all have. 4-pack wala apps. नॉट सिंगल पैक एप्स, 4 पैक वाला एप्स। तो बहुत आसानी से याद रहेगा, मोर्टेलिटी रिड्यूस करना है तो 4 पैक वाला एप्स, दैट इज आर्नी, एस इनहिबिटर, एआरबी। बाकी और भी थे जैसे वैसोपेप्टिडेज इनहिबिटर, वेयर देयर इज अ कॉम्बिनेशन ऑफ एस इनहिबिटर एंड योर नेप्रिडिसिन इनहिबिटर, दैट इज नॉट अप्रूव्ड क्लिनिकली। वो अगेन एस इनहिबिटर वाला साइड इफेक्ट अभी भी था, तो इसलिए उसको अप्रूव नहीं किया गया। ठीक है, एम्फा ग्लिफ्लोजिन, एम्पा ग्लिफ्लोजिन, ठीक है। So this one again, cardiovascular system, renal system, we all have covered this one. Okay. Now quickly, we'll be a little fast now because we are having half an hour time left. तो मेन टॉपिक वी हैव कवर्ड। अब डायबिटीज के बारे में बात कर लेते हैं। इंपॉर्टेंट ड्रग लाइक अल्फा ग्लूकोसिडेज, कौन कौन से ड्रग है? यहाँ पे 2 क्वेश्चन आते हैं, विच ड्रग बिलोंगिंग टू विच क्लास एंड व्हाट इज द इंपॉर्टेंट साइड इफेक्ट। तो वी हैव अकार्बोस, वोग्लिबोस, मिग्लितोल। द इंपॉर्टेंट साइड इफेक्ट इज गोइंग टू बी फ्लैटुलेंस, malabsorption, secretory diarrhea, right? All these GI related side effect will be there, है ना? Flatulence, malabsorption, secretory diarrhea, GLP-1 analog, that is exenatide, liraglutide or lixisenatide, they are all GLP-1 analog. All these are given subcutaneously. Then there is semaglutide. Semaglutide is also available subcutaneously and also available orally. Sema is the only one available orally. Semaglutide can be utilized for diabetes, can be utilized for obstructive sleep apnea, and also आजकल हमारे यहाँ तो मतलब obesity के लिए there is a whole new market that has opened by the semaglutide. People do not like to work out, they like to just take the drug and lose the weight, है ना? Now the important side effect of this GLP-1 analog, important side effect, they can lead to a side effect that is called hypoglycemia. एक मैं आपको ट्रिक बता रहा हूँ, ध्यान रखिएगा। In diabetes, any drug if the name is ending with the I dollar peptide, if the drug is ending with the I dollar peptide, they can cause hypoglycemia. Hypoglycemia, because they are working with GLP-1 analog, they can also lead to pancreatitis. They can reach even to the level of pancreas, so they can cause pancreatitis and increase the risk of MCT, increase the risk of medullary carcinoma of thyroid, ठीक है। एंटी डायबिटिक ड्रग इंक्रीजिंग द रिस्क ऑफ कैंसर, मेडुलरी कार्सिनोमा ऑफ थायराइड, ठीक है। प्लस वेट लॉस इज ऑल्सो देयर। वेट लॉस इज स्टैटिस्टिकली वेरी सिग्निफिकेंट विद द लीराग्लूटाइड एंड सीमाग्लूटाइड। लीराग्लूटाइड और सीमाग्लूटाइड को इसीलिए हम ओबेसिटी में भी यूज कर सकते हैं, वी कैन यूज देम इन ओबेसिटी ऑल्सो। All the gliptins, that is DPP-4 inhibitor like sitagliptin, saxagliptin, elogliptin, linagliptin, vildagliptin, they are associated with the important side effect that is called nasopharyngitis. Sometimes examiners do not use the term nasopharyngitis and use the term upper respiratory tract infection. They can also lead to another side effect that is called headache. They are very safe kind of drug. And a question that was asked, that all these are mainly excreted via renally. Linagliptin is the only one that is excreted via hepatic route, right? They are excreted via hepatic route. Therefore, linagliptin is the only one that is going to be safe in renal failure patients. So लीना कहाँ से निकलता है? लिवर से। Therefore कहाँ पे सेफ होगा? लीना कहाँ से निकलता है? लिवर से। And where it will be safe? It will be considered safe in the renal failure patient. लीना लिवर से निकलता है, लीना लिवर से निकलता है, therefore they are safe in the renal failure patient. Others are usually not considered safe in renal failure patient because they are excreted mainly by the renal route only. ठीक है। Amylin analog, pramlintide, again pramlintide, amylin analog, they are given by the subcutaneous route. They can cause a side effect that is called weight loss, pancreatitis, pancreatitis. देखिए पेप्टाइड वाला आइड है तो they can lead to pancreatitis, weight loss and hypoglycemia. आइड है तो हाइपोग्लाइसीमिया होगा। SGLT2 inhibitor, canagliflozin, dapagliflozin, empagliflozin, ertugliflozin, remogliflozin, there are so many of them. Gliflozin, a very big market. Currently, lot of endocrinologists are preferring SGLT2. I mean, if I am going to talk about 10, 8 out of 10 will definitely be prescribing gliflozin. They are so powerful drug. And they are showing very good result as well. And gliflozin plus new hai to it's having very good margin as well. So again, gliflozin, the most common side effect is going to be UTI. Examiners sometimes use the term urosepsis. Female में it can even cause vulvovaginitis. because of the altered pH due to glucose that is lost in the urine. They can also lead to weight loss. Fournier gangrene के risk को बढ़ाता है. That is a very dangerous side effect. Fournier's gangrene risk is going to be increased. Weight loss, Fournier gangrene. Euglycemic ketoacidosis. पहले बोला जाता था, earlier they used to say that this drug like canagliflozin increasing the fracture risk, but in the 14th edition of Goodman-Gilman they are saying, although the older reports are saying that they increase the fracture risk, but the newer studies do not support this. So this is again a questionable. So I'm putting a question mark. Although they are saying that they increase the amputation risk, वो बात सही है, amputation risk is actually increased, but fracture risk को now they are denying, especially with the canagliflozin in the recent edition of Goodman-Gilman. Sulfonylurea, we have the first generation and we have the second generation. First generation को clinically use नहीं करते. Tolbutamide, reason being they follow zero order kinetics. Tolbutamide follows zero order kinetics, and any drug that is following zero order kinetics, they will have high risk of toxicity. Chlorpropamide is associated with disulfiram-like reaction and SIADH, syndrome of inappropriate ADH secretion. DLR means disulfiram-like reaction because they are having aldehyde dehydrogenase inhibiting property. Because of the aldehyde dehydrogenase inhibiting property, they can cause DLR. I hope all of you guys are already aware about DLR का मतलब क्या हुआ, डाइसल्फिराम-like reaction. कई बार जब रिवाइज करोगे तो भूल जाएगा, मुझे पता है, मुझे यहाँ पे पूरा यकीन है कि आप भूलोगे, इसलिए मैं पूरा नाम लिख दे रहा हूँ. DLR disulfiram-like reaction. Therefore, first generation is not clinically utilized. So we are left with the second generation. All these are glyburide, glipizide, glibenclamide, right? All these are going to be, right? Gly. All these are gly. So name is ending with ide. Can you tell me without looking anywhere, if the name is ending with the ide, what is one important side effect that is known to all of you guys? What is one important side effect that I told you, that is called hypoglycemia? In fact, hypoglycemia is the most common side effect. Hypoglycemia, they are insulin secretagogue. Insulin has fat sparing property, so weight gain will also be one of the side effects. Bone marrow suppression, agranulocytosis. Bone marrow suppression, agranulocytosis, and liver toxicity, hepatotoxicity. So important side effect of sulfonylurea, especially with respect to second generation that are clinically utilized. Most common side effect is hypoglycemia that has been asked. Big one है, that is metformin. Fenformin तो use नहीं करते because they are associated with lactic acidosis. Because of this, fenformin को ban कर दिया गया. Metformin is one of the AMP kinase agonist. AMP kinase activator, and metformin is considered the drug of choice in type 2 diabetes mellitus and metabolic syndrome, PCOS, उन सब में भी यूज करते हैं. AMP kinase activator will actually lead to inhibition of the gluconeogenesis. Boys and girls, gluconeogenesis inhibition is the most common mechanism of action that they are working, and they are also increasing the glucose uptake. So they have insulin sensitizing property as well. They are going to increase the glucose uptake to the muscle. That is going to be big one, metformin, very effective drug and very cost effective as well. Very effective, very cost effective. Associated with the important side effect. क्या side effect cause कर सकता है ये सोचिए. They actually decrease the vitamin B12 absorption, so they can lead to vitamin B12 level that can cause megaloblastic anemia. Peripheral neuropathy. They can also lead to lactic acidosis. Sorry. Lactic acidosis, and they are also nephrotoxicity causing drug. They can cause nephrotoxicity. PPR gamma agonist. Gamma, I think in the general pharma only I told you. Alpha, Pha, Phi fibrate. Gamma will be pioglitazone, troglitazone, rosiglitazone. The class of the drug is called thiazolidine diones. This pioglitazone is a drug associated with side effect that is called sodium and water reabsorption. because of the sodium and water retention, you can easily understand the weight will always be high, so they can cause weight gain. Sodium and water retention can lead to weight gain. This excess sodium and water retention can also lead to macular edema. Pioglitazone, PPR gamma agonist, that is going to act by a nuclear receptor and they increase the insulin sensitivity. Weight gain, macular edema. Pioglitazone is specifically pioglitazone has also been associated with increase in the risk of bladder cancer. Please do remember, कैंसर से रिलेटेड 2 इंपॉर्टेंट ड्रग्स आपके सामने मैंने रखे हैं. I have kept 2 important drugs with respect to cancer. Drug number 1, that is GLP-1 analog. GLP-1 analog is causing which kind of cancer? GLP-1 analog is one of the drug that is causing your medullary carcinoma of thyroid. GLP-1 analog is causing what? Medullary carcinoma of thyroid. Okay, GLP-1 analog is causing medullary carcinoma of thyroid. And pioglitazone, पियोगे, कुछ भी पियोगे तो कहाँ जाएगा? ब्लैडर में जाएगा. Anything you पियो, anything you drink, it will go to the bladder. तो pioglitazone, it is going to cause your bladder cancer. There were other drugs also in the same group, like for example rosiglitazone. It was increasing the MI risk. तो rosiglitazone को clinically कई countries में बैन किया गया, including हमारे country में भी बैन है. कहीं कहीं पे बैन was lifted in 2013, बट हमारे यहाँ भी बैन है. Troglitazone, it is highly hepatotoxic drug, so hepatotoxicity की वजह से इसको भी बैन किया गया. Myxedema coma is a hypothyroid emergency. We have to give IV therapy. IVT4 we have to use immediately, 100 microgram followed by 25 microgram every 6 hours, Q6 hours. Colesevelam is one of the anti-diabetic drug that is utilized, is the bile acid sequestrant utilized for anti-diabetic condition. Dopamine agonist like bromocriptine has also got its approval. Bromocriptine has also got its approval to be utilized in the management of the diabetes. Linagliptin is one of the DPP4 inhibitor जो liver से निकलता है. Hyperthyroidism in first trimester. Now ये hyperthyroidism first और second third trimester all time favorite question है. First trimester में pregnancy है, first trimester pregnancy, तो the preferred is propylthiouracil, which is one of the thyroid peroxidase inhibitor and also inhibit peripheral T4 to T3 conversion. It has dual mechanism. TPO, thyroid peroxidase inhibitor, and peripheral T4 T3 inhibitor. Second third trimester में it is going to be methimazole or the prodrug that is called carbimazole. Carbimazole is the prodrug of the same. ठीक है. Always remember these methimazole, carbimazole, if exposed in the first trimester, these are mainly associated with a teratogenic effect that is called aplasia cutis. किसके साथ एसोसिएट होते हैं? aplasia cutis. वेरी गुड, है ना. तो जैसे रिवाइज आप हम लोग कर रहे हैं ना, वैसे आपको दो तरफ से होना चाहिए, है ना. वी कीप ऑन डूइंग द रिविजन एंड आई एम प्रीटी श्योर यू गाइस विल बी एबल टू ब्रश थ्रू द एंटायर चैप्टर, द एंटायर टॉपिक दैट वी हैव. ठीक है. एक क्वेश्चन आता है इमरजेंसी कॉन्ट्रासेप्शन के लिए. इफ इट इज विद इन 72 आवर्स, द बेस्ट इज ऑलवेज गोइंग टू बी लीवोनॉर्जेस्ट्रेल. यू कैन यूज 0.75 का 1 tablet now and 1 tablet after 12 hours. Total will be 1.5, or you can use 1.5 milligram का सिंगल. ठीक है. 1.5 ये ग्राम होगा. जीरो 0.75 नहीं यार, 1.5 मिलीग्राम है, सही है. 0.75 milligram, 0.75 milligram or 1.5 milligram. That is correct. It's correct. ठीक है. And if it is within 5 days, the best within 5 days is going to be IUCD. The most effective, the best within 5 days is going to be IUCD. Intrauterine contraceptive device is going to be the best within 5 days. ठीक है. That is actually going to be in case of thyroid supplement. अगर hypothyroidism, ये देखिए, ये क्या हाइपरथायरॉइडिज्म है. दिस इज एक्चुअली हाइपरथायरॉइडिज्म. व्हाट यू हैव सेड एक्चुअली, आई विल टेक योर नेम. अनटेम्ड मोमेंट्स. अगर पेशेंट आपके पास आती है प्रेगनेंसी में, इन द केस ऑफ hypothyroid in pregnancy, then in that case scenario you will continue the T4 जो आप per orum दे रहे थे, whatever dose that you are giving, you will increase the dose by 25%. You will increase the dose by 25%. 25 to 30% is the 20 to 30% is the range. On an average, you will increase the dose by 25%. For example, if you are giving 100 microgram, so you will be giving 125. Lanreotide, pasireotide, these are considered as a somatostatin analog. कहाँ पे यूज करेंगे? Who can tell me? Somatostatin analog कहाँ यूज कर सकते हैं? We can utilize for acromegaly और gigantism, secretory diarrhea, ये सब इनके अलग यूजेस हैं, ठीक है. Esophageal variceal bleed, esophageal varices, there also you can utilize. VI poma, these are the other uses of this somatostatin analog. Somatostatin analog, they are going to act against the growth hormone, है ना, growth hormone inhibitory hormone. Somatostatin का दूसरा नाम होता है GHIS, growth hormone inhibitory hormone. GHIS, growth hormone inhibitory hormone. All right. So this was again about, quickly we have brushed up about our endocrine as well. छोटे छोटे टॉपिक ये जो बच गए. ट्रिपल थेरापी. ट्रिपल थेरापी का नाम ट्रिपल इसलिए बिकॉज वी आर यूजिंग 3 drugs here. We are going to give 2 antibiotics, and this was the question that was asked in 2026 only, 2025 mid-year. 2 antibiotics out of CAM. CAM stand for, we will be giving a macrolide by the name of clarithromycin, a high dose amoxicillin, and next is called metronidazole. So out of these 3 we'll be using any 2. In addition to that, we'll also be giving PPI. So overall, we are having CAMP, cyclic AMP, 2 antibiotics and 1 PPI. 2 antibiotics and 1 PPI. So total of 2 antibiotics plus PPI, total of 3 drugs that we know is called triple therapy. Be it a case of triple or quadruple therapy, the total duration of therapy is going to be for 10 to 14 days. Quadruple, the name is given because we are going to give 4 drugs here. So because triple is already asked in 2025, 2026, the next question is going to be asked about quadruple. है ना? Quadruple is going to be 4 drugs. So I say TMC party जो 4 लोग की पार्टी थी, अब वो 4 लोग की पार्टी नहीं रही, अब वहां पे कोई और आ गया. TMC, तृणमूल कांग्रेस, कितने लोग की पार्टी थी? 4 लोग की पार्टी थी, है ना. So we say it's a tetracycline based therapy. So we have tetracycline, metronidazole, tetracycline, metronidazole, colloidal bismuth subsalicylate. So this is one of the bismuth compound. In addition to this, we will also be using PPI. So what did I say? Trinamool Congress, TMC party 4 है ना, 4 लोगों की पार्टी, जो कि अब नहीं रही 4 लोगों की पार्टी. 4 लोग चारों दिशा में चले गए. पेप्टिक अल्सर डिजीज के लिए, whenever the examiner the drug of choice, you can give proton pump inhibitor that is going to act as a hydrogen potassium ATPase inhibitor. Peptic ulcer disease, if the examiner is going to ask you drug of choice for NSAID induced peptic ulcer disease, NSAID induced peptic ulcer disease, again the drug of choice is same, PPI, hydrogen potassium ATPase inhibitor. For NSAID induced peptic ulcer disease, if the examiner is going to ask you specific drug, then you can use misoprostol. All right, misoprostol. H pylori kit, H pylori में ही देते हैं बच्चे, उसका नाम ही HP kit. H pylori kit, H pylori में ही देते हैं. Other agents which we can use here will be, let's say, H2 blocker like cimetidine, ranitidine, or we can also give ulcer protector that forms a layer at the base of the ulcer, right? Like aluminium hydroxide, magnesium hydroxide, bismuth compound. ये इसको ऊपर कर दीजिए थोड़ा. Ulcer protector is going to be drugs like your bismuth compound. These aluminum and magnesium hydroxide, they are considered as antacid. Digen जिसको आप जानते हैं, these are the add-on drug that can be given. Aluminum hydroxide, magnesium hydroxide, antacid. Okay. No, here we are discussing H. pylori, right? यहाँ पे हम क्या डिस्कस कर रहे हैं? We are discussing H. pylori. We are discussing our peptic ulcer disease. मैं यहाँ की बात कर रहा हूँ ना आपसे. We are talking about what are the different uses, what are the different drugs that we are having in this case scenario. यहाँ पे कौन कौन से हमारे पास ड्रग अवेलेबल हैं, हम उनकी बात कर रहे हैं. ठीक है, क्लियर है? ओके, ग्रेट. सो दिस इज एक्चुअली ट्रिपल थेरेपी, क्वाड्रुपल थेरेपी. अगर आप इसको डिटेल में पढ़ेंगे तो वी हैव अदर लाइक सीक्वेंशियल थेरेपी ऑल्सो, एंड वी हैव यू नो सीक्वेंशियल थेरेपी भी हमारे पास है, राइट. रेस्क्यू थेरेपी भी हमारे पास है. ठीक है. नाउ एक द न्यू क्लास ऑफ ड्रग जो हमारे पास है, दैट इज कॉल्ड पीकैप्स. पीकैप्स इज पोटेशियम कम्पिटिटिव एसिड ब्लॉकर. PCAPs is potassium competitive acid blocker. So they are mainly going to act like a PPI only, but they'll be mainly targeting potassium side. So these are the new class of drug, that is vonoprazan, tigoprazan. All the PPIs are ending with the prazole. All the PPI are going to end with what? Prazole, like pantoprazole, omeprazole, rabeprazole, right? All of them are prazole. But this is going to be prazan, vonoprazan, tigoprazan, keverprazan. All these are going to be prazan, prazan, prazan. Now, what is the important advantages of giving PCAPs? PCAPs में क्या बेहतर है हमारे पास? So remember, it can be also utilized for erosive gastritis. हम erosive gastritis में इसको utilize कर सकते हैं. इसके साथ another good news is that dosing around meal is not required. जैसे PPI is always given at least 30 to 40 minutes prior to meal. This one is active compound. Dosing around meal is not required. Dosing around meal is not required. These are active compound. They are not PPI, unlike PPIs that are prodrugs. They are active compound. They are active compound, unlike PPIs, which are prodrug activated to form sulfonamide. They are actually active compound, है ना. इनका कभी भी आपको prodrug मीन एक्टिवेशन की जरूरत नहीं है. दे आर एक्टिव कंपाउंड, इसीलिए किसी भी समय दे सकते हैं. डोजिंग अराउंड मील इज नॉट रिक्वायर्ड. दे आर हैविंग बेटर फार्माकोकाइनेटिक प्रॉपर्टी. They are having better pharmacokinetic property and no or less enzyme inhibiting property, unlike omeprazole that was having CYP3A4 inhibiting property. So they do not have enzyme inhibiting property as well. Activation is not required. Why? Because they are already active compound. So we can use them in erosive gastritis also. The good news is that इसका cost भी PPI से कोई बहुत ज़्यादा नहीं है. Like some PPIs are available even 8 rupees to 15 rupees, even 20 rupees per tablet. ठीक है. ठीक है. तो डोजिंग अराउंड मील इज नॉट रिक्वायर्ड. एंड बहुत सारी चीजें होंगी जिसके बारे में अभी आएंगी. इन आवर कंट्री रेडिस लैबोरेटरी एक्चुअली हैज स्टार्टेड द मार्केटिंग ऑफ दिस ड्रग, potassium competitive acid blocker, also for erosive gastritis and all other cases of resistant peptic ulcer disease we can also utilize. Other case of the peptic ulcer disease we can also utilize. Dosing around meal is not required. Active compound with better pharmacokinetic property and no or less enzyme inhibitor, right? So all these are the different advantages of these PCAPs, potassium competitive acid blocker. Potassium competitive acid blocker. Quickly, we are going to summarize our antiplatelet drug. Aspirin is one of the COX-1 enzyme inhibitor, and this COX-1 inhibitor will decrease the thromboxane A2. They are going to be an irreversible inhibitor because platelets are anucleated cell, so they are irreversible inhibitor. Irreversible inhibitor. Aspirin is one of the irreversible inhibitor of the COX-1 enzyme. Ticlopidine, clopidogrel, prasugrel. So these are considered as the P2Y12 inhibitor. P2Y12 inhibitor. P2Y12 का ऊपर वाला are going to be irreversible inhibitor and P2Y12 नीचे वाला is going to be reversible inhibitor. Like clopidogrel is the one that is commonly utilized. Something like clopidogrel, but they are reversible in nature, is cangrelor. Something like clopidogrel, but they are reversible in nature, is called ticagrelor. So we have cangrelor and ticagrelor. Grelor. ठीक है? So remember, can से आपको याद रखना है कि कैनुला से देते हैं, that means they are IV. टिक्का साउंड्स लाइक चिकन टिक्का और पनीर टिक्का, जिसको आप ओरली लेते हो आराम से. चिकन टिक्का और पनीर टिक्का आप आराम से ओरली खाते हो, तो टिक्का IV नहीं लेते हैं. टिक्का, चिकन टिक्का ओरली खाते हैं. कैनुला वाला. Abciximab, tirofiban, they are going to be GP2B3A inhibitor. They are going to decrease the platelet cross-linking. Etopaxar, protease activated receptor inhibitor. इनका दूसरा नाम होता है thrombin inhibitor, right? Thrombin inhibitor. And with respect to bleeding अगर देखा जाए तो ticagrelor will have more risk of bleeding as compared to clopidogrel. Please do remember that, okay? They will have more risk of bleeding as compared to clopidogrel. More risk of bleeding as compared to clopidogrel. ठीक है? टीका orally effective reversible P2Y12 inhibitor. P2Y12 is the receptor for ADP. So saying P2Y12 inhibitor is same as ADP inhibitor. Saying Y2 inhibitor is same, P2Y12 is same as saying ADP inhibitor. Protease activated receptor etopaxar, vorapaxar. Protease activated receptor inhibitor etopaxar and vorapaxar. Some important anticoagulants I'll quickly summarize. और इसमें डायरेक्टली मैं क्वेश्चन के बारे में बात करूंगा. जो क्वेश्चन आए हैं उनको हम क्विकली समराइज करेंगे. So remember, warfarin is one of the drug that is mainly acting as a competitive inhibitor of the vitamin K dependent clotting factor. Competitive inhibitor of the vitamin K dependent